Good morning, one and all. A warm welcome to the second day of ISC Kerala PG Refresher Course 2021. Today we'll have discussions which are chaired by eminent examiners from all over India. With both MD and DNB exams on the corner, we are sure this is the most appropriate time for all of you to refresh through the most important exam cases and to hear expert answers from the top faculty of the country. Without wasting your precious time, we straight on move to the cases. That is, the first case will be the transurethral resection of the prostate.
Good morning all. A warm welcome to our first session. It's a long case presentation on transurethral resection of prostate. This session is chaired by Dr. Gurudat CL, who is the professor and head of the department, JSS Medical College, Mysore, and Dr. Polo Rafael, who is the professor and HOD, Department of Anesthesia, Amala Medical College. Warm welcome to you, chair this session, sirs. And we have two candidates, Dr. Gino Joy and Dr. Safia Sherin, who are postgraduate students from Amala Medical College. We have allocated 1 hour 15 minutes for presenting a long case and 45 minutes for presenting short case. Candidates can take 10 minutes for presenting a long case and 5 minutes for presenting short case. And the last 5 to 10 minutes can be allocated for answering questions from the chat box. So we can straightly move on to the first session. Dr. Gino and Dr. Safia, either of you can start sharing your PowerPoint presentation. Over to Dr. Gino or Dr.
Gino
Safia.
Will be sharing, no? Gino?
Yes, sir. Yes, sir.
Okay, you can start sharing.
Hello, Gino. Gino
Yes,
and
sir.
Safia, good morning.
Good morning, sir.
Good morning, sir.
Yeah, very good morning. And I just wanted to know, you people are have finished your theory exams?
Yes, sir.
Yes, sir.
Okay, very good. How you have done?
It's
Fine.
okay, sir.
Yeah, very nice. Very nice to hear that, because COVID problems, and you may not have enough time to study also. Yes, and
They were
you'll be
into
taking your
COVID ICU also. They had postings in the ICUs.
yeah. That's what. So you'll be taking your practicals in August, isn't it?
Yes, sir.
Yeah, okay. This is a nice thing that you have volunteered to present the case. So let us start with the case, so that actually don't worry even if you don't answer anything. So this is not the examination as such. So examination is still in August, but this is only a rehearsal for your exams. So you should relax. In the exam also, I would like to tell you that once you go there, so always wish the examiner, and then sit in front of the exam, in front of the examiner only if the examiner asks you to sit. Till then you just stand there, let the examiner ask you to sit, and then once he asks you to present, you start presenting. But most important thing there is you have to relax totally, completely. If you have a lot of anxiety, naturally you will be knowing the answers, but you will not be able to come out with the answers. That is one thing. Another thing is, majority of the examiners will be giving you a lot of clues. So you have the presence of mind and then catch the clues and try to answer. Okay. So let us start with today's session. So Ginu, you are presenting?
Yes, sir.
Okay.
Yes, sir.
Okay.
Am I audible, sir?
Yeah, you are audible. You can start presenting. Your slide is also visible.
Okay. 69-year-old male patient hailing from Thrissur who works at a bakery presented with complaints of increased micturition for 3 years, dribbling of urine during micturition 2 years, and with a sense of incomplete bladder emptying and weak urine stream. History of present illness. The patient is a known case of hypertension for the last 10 years on regular medication. He's on tab clinitipine 10 mg OD and tab bisoprolol 5 mg OD, and diabetic for the last 2 years on diet control. He can climb 2 flights of stairs without breathing difficulty, med score more than 4. Patient was apparently normal 3 years back when he noticed increase in frequency of micturition. He had to wake up in the middle of the night with the urge to pass urine. He also complains of weak urine stream and a sense of incomplete bladder voiding post-micturition. He was admitted to the hospital with the above complaints on 28 June and he's been scheduled for TERP on 29th. No previous history of admissions, no history of pain while urinating or blood and urine. No history of significant weight loss or loss of appetite. No history of weight, fever, abdominal pain or vomiting. No previous history of catheterization. Past history, he is hypertensive for the last 10 years on regular medication, on diet control for diabetic for 2 years. No history of angina, syncopal attacks, peripheral arterial disease. No history of ischemic heart disease, dyslipidemia, CBO malignancy. No history of bronchial asthma, thyroid, tuberculosis. No history of snoring, breathlessness, swelling of the feet or cough. Personal history, he is on mixed diet. Sleep is disturbed due to nighttime awakenings to pass urine. Bowel habits normal. He's a non-smoker and non-alcoholic. Drug history, he's on tab clinidipine 10 mg OD and tab bisoprolol 5 mg OD. No non-drug allergy. Surgical history, no history of past surgical procedures or exposure to anesthetic drugs. Family history, no history of any similar illness or significant comorbidities among the family members. General examination.
Okay. No, you have just presented the history. So majority of the times at the end of the history, so we will be asking you just to summarize the history, or probably what do you think about this particular case when he is posted for surgery. So at the end of the history, you should just briefly 2-3 sentences. You should summarize whatever you have taken the history. Can you just summarize the history?
Yes, sir. 68-year-old male patient presented with complaints of increased frequency of micturition, difficulty in micturition, and a weak urine stream and a sense of bladder emptying. He gives no other history of previous admissions or catheterizations. He's not case of hypertensive on regular medication for 10 years on bisoprolol and clinidipine, and diabetic on diet control for 2 years. No relevant history passes.
Okay. Now, this patient is 69 years old. And what is his occupation? You did not mention what is his occupation.
He's working.
Is he working still now?
Yes,
bakery, she said.
Yes, sir.
What is he
Yes,
doing?
sir. He's working in a bakery.
He's working in a bakery. So how far is the bakery from his house?
1 kilometer.
Okay, you asked. Good. That is what is called as the presence of mind.
Yes.
You might not have asked, but in the exam, you should always tell like that. It should be spontaneous. Okay. So how does he go to his bakery?
Walking.
Yeah, walking. So that is very important because, indirectly you can assess the METs. Though you have just said there that he is able to climb 2 flights of stairs. But why did you ask this METs as such? Why do you want to check METs, and what is a MET?
MET is actually a metabolic equivalence of task, which is equal to oxygen consumption of 3.5 ml per kg per minute.
Okay, so who actually introduced this concept of the physical activity?
Duke's activity.
Yeah, very good. So it's a Duke's index of physical activity. Very nice. So why do you want to know about METs? And you specifically, you have said here that he has a METs of more than 4. So why it's important for us to determine the METs during history?
So indirectly, we are assessing the cardiopulmonary reserve of the patient, the functional capacity of the patient.
Okay.
So higher the METs, you expect the patient to be more of a healthier.
Okay.
You don't expect much of complications during a surgery.
Yeah, you said that. Okay, Safia is also there, isn't it? But I'm not able to see Safia on screen.
Yeah.
Can we have Safia also on screen so that she also can? Safia, you are there? Yeah.
Yes, sir. I'm there.
Sir,
yeah, okay. When we say about METs, less than 4 METs is high risk, 4 to 7 is moderate risk, and more than 7 is normal. Low risk patient.
You classify it as more than 10 is excellent METs, and more than 7 to 10 is good METs, 4 to 7 is moderate, less than 4 is poor, isn't it? So it is always above 10 is excellent. So that is what in the latest 2014 AHA-ACC guidelines, it is very clear here. They have divided this also. More than 10, 7 to 10, and 4 to 7, and less than 4. So, okay, let us say that this patient, Gino, has less than 4 METs. So what does it indicate, and anything regarding your anesthetic management?
Less than 4 minutes means he's able to do only the home care activities. That is, he's able to only take care of himself. He's not being exposed to any.
No, that is there. So he has less than 4 minutes.
Yeah. So anesthesia, when he comes to surgery, it's more of a stressful situation. So he'll not be able to compensate.
So
the functional reserve of the person will be low.
no, would you still likely like to go for a, majority of the times TURP means you always go for a spinal anesthesia, isn't it? So still you want to go for a spinal anesthesia in a patient with, METs of less than 4?
He will not be able to tolerate the fluid overload, or if there is any blood loss, the compensatory mechanisms he'll not be able to.
Now, how about spinal anesthesia itself? The sympathetic block.
I think I'll go for GA, sir.
So you can't straight away think of going in for GA, isn't it? So because
he might not able to withstand the hypertension due to the spinal.
Okay. So when do you want to go for GA? Okay, now let us also know that this patient is hypertensive. Okay. Now when the patient is hypertensive, hypertension by itself may not be very important, but the end organ damage is more important, isn't it?
Yes, sir.
So what are the end organ damages that occur because of hypertension? And he is also diabetic. Let us know about the end organ damage by both hypertension and diabetes.
End organ damage, one is peripheral vascular disease. The other one is transient ischemic attack or CV or stroke. Kidney and globular changes, that is GFR will be low, creatinine clearance.
In order of priority for you as anesthesiologist, hypertension and end organ damage.
Hypertensive nephropathy, sir. Hypertensive nephropathy. Then we have to think about hypertensive retinopathy. Then peripheral vascular disease.
Okay, Safia, most important thing is the heart, isn't it? So you should always think about the heart as the first and most important thing for you as the end organ damage. So ischemic heart disease, even the patient may have angina, isn't it? And patient might have even had an MI before, or he might even had a revascularization procedures. So all these things you will have to think about whenever you think that the patient is hypertensive, and that becomes more important for us. Yes, second most important organ is the brain. As you said that the patient has any strokes, and third important organ may be the kidney, and fourth is the peripheral arterial disease. Okay, for diabetes, what all the end organ damages you will think about? The same thing?
Along with that, autonomic dysfunction.
So the macroangiopathy and microangiopathic lesions. Let us say that this patient also gives history of angina. So if he is giving history of angina, Ginu, what are the things you would like to know about the angina and the anesthetic importance? Because he's an old man, he is likely to have ischemic heart disease, and he is also hypertensive, and he is diabetic. The high likely chances that he may also have ischemic heart disease. So what are the important questions he'll be asking regarding angina and anesthetic importance?
So whether it's a stable or an unstable angina.
Very good, very good. So how do you differentiate between stable and unstable angina?
Stable angina, unstable angina, that is he'll complain of pain, that is while he's exercising on strenuous activity.
Is there any Canadian Society cardiologist classification of angina? Okay, Safia?
I'm not sure about it now, sir. I think I'm not sure about it now.
Okay, there is a classification of angina is there, but for exam purpose, what you can tell is, just like NYHA classification only you can talk about. So any patient with the moderate activity or ordinary activity not having angina, you can say class 1, and patient developing angina for ordinary activity class 2. Class 3 can be even with minimal activity class 3, and class 4 angina at rest. Angina at rest can be postprandial angina, nocturnal angina, and these are also considered as angina at rest. So why it's important for us to know And you know that class 1 and class 2 angina are stable angina, class 3 and class 4 angina are unstable angina. Sophia, let us say that this patient has got class 3 and class 4 angina, one of them. Even at rest, he has nocturnal angina. He wakes up in the night, just like paroxysmal nocturnal dyspnea. The patient also can develop angina in the night. It's called as nocturnal angina. So suppose if the patient gives you a history of this unstable angina, what is its importance for you?
If the patient has an unstable angina, it denotes the cardiovascular reserve of the patient. So I will denote the patient to be of high risk category, and I will optimize the patient.
Okay. Now, Safia, can I accept this patient for surgery with unstable angina?
No, sir. I will have to reevaluate further, and only then I will accept the patient for surgeries.
Okay, you have re-evaluated. You have got an echo done, and ejection fraction is low. It is about 35%. But symptomatically, the patient has unstable angina. So why you want to postpone this surgery? Why you don't want to take up the patient? Any patient with unstable angina.
The patient may have a high risk of perioperative MI during the surgery, and he may not withstand the hemodynamic effects because of the anesthesia. And in less than 35%, I would not prefer giving spinal anesthesia also, because he may not tolerate high levels of hypotension. Also in GA also, I will be very careful to give titrated doses, induction doses, and fluid will be optimized. He may not tolerate fluid overload also. And being an elderly patient, he may not have a very good autonomic reserve also to compensate for the with the heart rate. To compensate the hypertension with a higher heart rate. And so I will be very careful, and even if he is not complaining of symptoms, I will still try to refer the patient to cardiology and do stress cardiography or dopamine stress test or
he's already, history itself is, unstable angina. You should never subject these patients for stress, ECG or even anything, isn't it? Because he already has got an unstable angina. But now, instead of going in for such a long answer, what you should do is 2014 guidelines, AHA-ACC guidelines, algorithm is there. You must have all read about this algorithm. It is said that unstable angina is an acute coronary syndrome, isn't it? Any acute coronary syndrome or any active cardiac condition is an absolute contraindication for an elective procedure. So your answers should be in the exam also. It should be very short and very straightforward answers. Like if you had just told that 2014 guidelines says that active cardiac condition or acute coronary syndromes are absolute contraindications. Only unless you bring the patient to a stable condition, then only you can accept the patient for elective surgery. Only life-threatening or limb-threatening surgeries should be undertaken for patients with acute coronary syndromes and or active cardiac conditions. Which is the other acute coronary syndrome other than unstable angina? Recent MI. These are the things: acute MI or recent MI and unstable angina or acute coronary syndromes. So you should never accept these patients for surgery. Okay, now let us move on with this particular patient. Now we know that he is well-controlled hypertensive. He doesn't have any angina. That's a good thing that he is a very stable patient. He has got a MAC of more than 4, fine. And he is not on any drugs for diabetes, isn't it? As you said. So suppose if this patient is also on drugs for diabetes, so what is the effect of these drugs for you when you are taking up for surgery in this patient? What other history you would be taking, Jeenu?
If he's on drugs for medication, for diabetes.
What drugs you can be on?
He can be either on an oral hypoglycemic agent or he could be on insulin.
Okay.
So we should know whether the sugars are being controlled or not, how long he has been taking it.
Okay, right. And regarding oral hypoglycemic agents, would you be specific to know which particular oral hypoglycemic agents? so that you know whether to stop before surgery. Anyway, that will be discussed in detail when we discuss diabetic food. But just because this patient also has diabetes, so it's very important to go for a detailed, history. Let us say that he is on oral hypoglycemics. Again, how do you classify these oral hypoglycemics?
Oral hypoglycemic can be classified as one is sulfonylureas, glucosaminidase inhibitors,
mainly, secretagogues and sensitizers, isn't it?
Yes, sir.
Insulin secretagogues and insulin sensitizers. Why I asked you this question is because now you are not prepared for diabetes. So that's how, in the exam also, suddenly you may be asked other questions other than that particular case. You will have a, straight, always you will be thinking, okay, these are the likely questions I'll be asked and I'll be answering these. Suddenly, in the exam, sudden diversion of the questions can be asked. So you should be prepared for such questions. Okay, let us move on. Now, with this particular history, patient is, well-controlled hypertension and probably well-controlled diabetes also is there. Now, let us go for general physical examination. Okay.
And general examination, patient is comfortably sitting on a chair. He is conscious, well-oriented to time, place, and person. Normal built and nourished. Normal faces. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Height of 173 centimeter, weight of 63 kg, BMI 21. He's febrile, pulse rate 75 per minute, regular rhythm, normal volume character, no vessel wall thickening, no radiofemoral delay or radioradial delay. All peripheral pulses felt bilaterally equal. Blood pressure is 150/80 millimeters of mercury in right brachial artery in sitting position. Respiratory rate 14 per minute, regular abdominal thoracic. Saturation is 98% in room A. JVP is not elevated. Patient is catheterized. Spine, normal alignment, normal curvature. Spinous process is palpable. Interspinous spaces. No hearing aids. Gait is normal. Thyroid not enlarged. Airway examination. No facial dysmorphic features. No loose tooth or artificial dentures. Mouth opening more than 3 finger breadth. Pyromental distance more than 3 finger breadth. Upper lip bitus grade 1. TMJ joint show no ankylosis. Malampati class 1. Neck movement normal in all directions. No prognathism or retrognathia. The nitrourine system, external genitalia normal, pelvis normal, PR not done. All other systems within normal limit. Summary. 69-year-old male patient, non-hypertensive and diabetic, presented with complaints of increased frequency of micturition, dribbling of urine during micturition, and with a sense of incomplete bladder emptying and weak urine stream, being posted for TURB. General condition is fair, airway examination normal, spine normal, all systems within normal limits.
Okay, now with the examination, because this patient is diabetic, isn't it? So if the patient is diabetic, so what are the few other examinations you would have done? One is for airway, what else you would have done?
The prayer sign and palm print test.
And palm print sign, isn't it? So because any diabetic patient, you can just tell about this. Even though, in this patient, it may not be, very important because he is well-controlled diabetic, type 2 diabetic, and that too is not on drugs also. So, but in the examination, you always mention about the prayer sign and also the palm print sign. Okay. Now if the prayer sign is positive, what does it indicate? Is an old man?
That he has diabetic eoarthropathy. Difficult airway can be stiff joint syndrome.
Stiff joint syndrome. So what are the joints that get involved?
Temporomandibular joint, atlanto-occipital joint.
And one more? Cricoartenoid joint. That is very important for us because, in order to select the tube, so we'll have to select a smaller tube. Okay. The other thing is this patient is also on antihypertensives, isn't it?
Yes, sir.
He is on 2 antihypertensives. What antihypertensives he is on?
Tab clinidipine and tab bisoprolol.
Bisoprolol. So what is bisoprolol? What is clinidipine?
Bisoprolol is beta blocker.
Yeah, what type of beta blocker? Selective, non-selective?
Selective beta blocker.
Yeah, you see, that's what again in the exam, you should very clearly answer. There should not be multiple questions to be asked for getting one answer. Okay. If you had said selective beta blocker, is it highly selective? Is it very specific to beta 1 receptor?
So it has some beta.
What's Sophia?
It has some beta 2 action also. It has some beta 2 action also. Sir.
No, no. Bisoprolol is highly selective, whereas the others like metoprolol. Why it's very important is study, POISE 1 study, they used metoprolol. They used a higher dose of metoprolol, 300 milligrams, that had a beta 2 blocking effect. Many of the patients developed strokes, whereas bisoprolol is highly selective. It is mainly selective for beta 1 receptors. That way, you have a lot of advantage with bisoprolol. Okay, the patient is on bisoprolol, and the patient is also on clinidipine, a calcium channel blocker. Now, in the examination, should you have done, when you are recording blood pressure, how did you record the blood pressure, in supine posture or standing posture, or both?
I did in sitting posture.
You did in sitting posture. Should you do in lying down and standing?
Yes,
is
sir.
diabetic also?
Yes, I have to rule out orthostatic hypotension.
Yeah. Okay. Safia, why should you rule out orthostatic hypotension in these patients with hypertension and diabetes?
In orthostatic hypotension, the patients will have a fall of systolic BP more than 20 and diastolic BP more than 10. So the fall will be higher.
Wait. Systolic pressure more than 30 millimeters fall, and diastolic more than 10 millimeters. That is fine. It is 30, not 20, right? Right. So suppose this patient has orthostatic hypotension. Unfortunately, Gino has not examined him in lying down and standing all the time. These old patients with multiple comorbidities, patients on diuretics, patients on peripheral vasodilating drugs like calcium channel blockers, centrally acting drugs, all the time you have to examine them with lying down and standing. So what is the anesthetic importance of patient having orthostatic hypotension, Safia?
The patient will not be able to tolerate, there will be a steep fall in BP. Patient will not be able to tolerate hypotensive stages, anesthetics, especially regional anesthesia, higher levels of spinals and all. Patient won't be able to tolerate.
Okay, how about GA?
GA, the hypotension may be lesser, but we have to give induction as titrated doses and be very careful about, if possible, put an intra-arterial monitoring.
No. Single answers, straightforward answers. Don't go into explain things in the practical exam, because the time will be only 30 minutes. So we'll have to answer many questions. So you can always say, even GA also, you have to be extremely careful, because the drugs like propofol or thiopentone itself, they can produce quite a bit of hypotension, and these patients can go in for refractory hypotension. That is what you should always tell. So even any change of position, for example, suddenly if these patients are put in head-up position, so they may not tolerate this. So that is why in these patients you may have to be very, very careful in putting these patients into any different positions. You have to go into very gradually putting these patients into. You should take your own time to position these patients, and also whether it is spinal or whether it is epidural or whether it is GA, all these can produce problems. So epidural will be better. So, especially the segmental epidural block would be definitely better in such patients. So all these things, just one simple examination, always do, and, BP, recording, the lying down and standing. So these two are very important in your examination. Okay. Now, this patient is now posted for TURP, you said. So why do you say he is being posted for TURP? Any other test that has already been done to prove that he has got a benign prostatic hypertrophy?
Ultrasound abdomen.
Ultrasound abdomen, will it, say whether the prostate enlargement is malignant or benign?
Transrectal ultrasonography.
Now, usually they'll do a prostatic biopsy, isn't it? Has this patient undergone a prostatic biopsy? Because they always do a prostatic biopsy before, because you said that he has not undergone any surgical procedure. So this history always ask about. Okay. And, in one of my students, DNB students had come to me and told me that she had failed actually. In her previous examination, she was asked in the DNB why she has not done a PR examination, per rectal examination. Anyway, you should always tell that per rectal examination has not been done. Whatever you have written, it's fine. Because, you have, the examiner was thinking that you have to prove that it is a benign prostatic enlargement. So these patients would have undergone that you should get the history. Another thing is, he has been catheterized, you said. So when he has been catheterized, that is another
In this
history you should
admission.
always. It's
In
only,
this admission, sir, no previous history of catheterization.
okay, it's only after admission. Why it's important to know when the patient has been catheterized?
So, a recurrent catheterization, it indicates prostatic inflammation. There's more chance of bleeding during the surgery.
Okay.
And more chance of infection also.
So more important thing is, all the problems of enlarged
obstetric
prostate and
uropathy
obstruction
also.
on the kidney are because of the obstruction, isn't it? So especially these patients can have post-renal problems, post-renal obstruction problems. So once the patient has been catheterized for some time, so all these problems would have been solved. Suppose, he has not been catheterized, the obstruction is there, his serum creatinine may be on the higher side. Okay, so then we will have more problems. Anyway, let us listen to what are the investigations you have done. What
For this
investigations
patient,
you would like to go for?
yes, sir. For this patient, I will do hemogram, HPTC-DC, ESR and platelet count, coagulation profile, BT-CT, PAT, INR, serum
Just a
electrolytes.
minute. Safia, she wants to do hemoglobin. So why should you do a hemoglobin in this patient? What is it's important for you as anesthesiologist?
Sir, with hemoglobin, I'll be able to find out the hematocrit value, and from that I'll be able to find the amount of fluid loss, the blood loss that is occurred during the surgery. So the amount of blood lost is equal to preoperative.
No. I'm not asking about all those things. You have just done a hemoglobin estimation. What all the knowledge you'll be gaining by just doing a hemoglobin estimation in this patient?
In this patient, I'll be able to see if there is any anemia, and I'll be able to see calculate the maximum allowable blood loss.
Yes, very good. What your answer should be, because one of the complications of TURP is bleeding, isn't it? So you have to know what is the maximal allowable blood loss in this patient. So Gino, can you just tell me how do you calculate the maximal allowable blood loss?
Yes, sir. So the initial hematocrit, that is what was the patient's hemoglobin, that is into 3 minus the decide. For example, in this patient, I will take it as 8 into 3, 24 divided by the initial into the blood volume of the patient, 70 ml per kg.
No. Why do you want to convert it to hematocrit? You can even use hemoglobin only, because you have got the hemoglobin. Okay. So first of all, you want to know the blood volume in this patient. What will be the blood volume in this patient? He is a male patient.
70 ml per kg.
Yeah, 70 ml per kg body weight. So 70 ml, what is his weight?
8.
Yeah, multiplied by
70, sir. 70 into 68 into the initial hemoglobin minus our target hemoglobin divided by the
what
initial.
Will be your target hemoglobin?
In this patient, 7.
7 or 8?
8.
He doesn't have an but
no. Intraoperative, one thing you should always know about the, whatever the transfusion trigger is always 8 grams. Transfusion trigger you should always think, because why you are calculating the maximal allowable blood loss is, suppose the patient exceeds this blood loss, then you have to transfuse this patient. So the transfusion trigger intraoperatively is 8 grams. So now you know that is why you always minus it by 8. Okay, so hemoglobin is important. So because this patient is likely to bleed, maximal allowable blood loss you have to calculate. And if you think that the patient may have a lower hemoglobin and he may not be able to tolerate that amount of bleeding, so then you have to arrange for blood. So Safia, what may be the amount of blood loss he may incur? Expected blood loss.
Sir, for every minute, he may have a blood loss of around 2 to 5 ml per minute and around 20 to 50 ml per gram of resected tissue.
Okay, around 20 ml, 15 to 20 ml per gram of tissue, isn't it? So that's
Yes,
how that's the reason why you have to know what is the size of the gland, and based on that, you can know the approximate expected blood loss, and based on his hemoglobin, you know whether to arrange for blood or not. Okay, now Gino, you said the total count, differential count. Why it's important?
To rule out if there is any urinary tract infection.
Yeah, is he likely to have urinary tract infection?
Yes, sir. Yes.
Why?
Because obstructive uropathy, they can be pyelonephritis, sir.
Oh, very good, because not pyelonephritis, even the prostatitis.
Okay. A prostate can harbor a large amount of bacteria itself.
Yeah, so why it's important for you?
Because during operative and the post-operative period, there's high incidence of transient bacteremia and septicemia.
Septicemia, isn't it? So preoperatively, how do you know that he may have infection, and how do you correct it?
So one is total counts more than 12,000, and even urine routine will show pustules.
Okay.
And you give prophylactic antibiotics. Aminoglycosides are usually given.
So just like that you will give, or you do some investigation and then
Culture and sensitivity
of yes.
urine.
Yeah, urine. So that's how you should be very specific, isn't it? You just don't go. And you said aminoglycosides. Yes. So any importance, aminoglycosides and anesthesia?
Can prolong the action of the neuromuscular blocking agents if you go for GA.
Neuromuscular blocking agents, depolarizers or non-depolarizers? See, your answer should not be vague. That's what I am trying to tell you.
Yes, sir.
Non-depolarizers.
Yes, sir.
Why non-depolarizers get prolonged? Why?
Because it acts on the presynaptic terminal. That is, it blocks the calcium influx. So acetylcholine release doesn't take place.
Very good. So that should be the answer. Okay. What other investigations?
Serum electrolytes, sodium, potassium, and magnesium.
Okay.
And renal function, serum, urea and creatine, coagulation profile, BT, CT, PTINA, blood group, and cross match.
Okay. Serum creatinine is 2.
Still, I'll go. I'm expecting probably it's because of the obstructive uropathy. Once it is being corrected.
So how long you have to catheterize him before taking up for surgery? If in order to serum creatinine to come back to its normal values. So 3 weeks. That's why I was talking to you the history of catheterization. Okay, serum creatinine is very important. Can you know about this GFR also by creatinine?
Yes, sir.
Safia, what is the equation you use for calculating GFR based on creatinine? Can you name the equation?
Sir, Cockcroft-Gault equation.
Yeah, very good. Cockcroft and Gault equation. As long as you know that, it's fine. So, okay, you want to do an ECG?
Yes, sir. ECG and echo.
Echo, yes, okay. Now, why echo?
So, one is the patient belongs to the geriatric age group.
Very good.
And
hypertensive, diabetic, isn't it? So, ECG also is very important because, silent ischemias can be there, even silent infarctions, especially, the inferior wall infarction can be very silent. The patient may not know. So that's why you have to know. So in this particular patient, because he is geriatric patient, he can be having multiple comorbidities. So all these things, are important. Even, the patients can be on antiplatelet drugs, patients can be on anticoagulant drugs. So these are the questions, commonly asked for you in the exam. Suppose if he is on anticoagulant drugs, would you like to stop both suppose if he is on dual antiplatelet drugs, let us say antiplatelet, dual antiplatelet drugs. Should we stop both aspirin and clopidogrel or only clopidogrel for TURP?
I will continue aspirin, sir, but I will stop clopidogrel 5 days, at least 5 days before the surgery, especially planning for radiation anesthesia.
Yeah, why 5 days before surgery, Safia? Why not 1 day?
Because the duration of the action of clopidogrel is for 5 to 7 days. So minimum, at least we have to stop for.
Okay, Safia, what is the half-life of clopidogrel?
5 to 7 days.
Eh?
5 to 7 days.
Gino?
5 to 7 days.
See, simple question, isn't it? It's just 8 hours. But you know, all the platelets in circulation, when you had given, would have been affected by that. So it takes regeneration of platelets have to occur. It takes about 5 days for new platelets to accumulate. So that is why, because you know the platelet half-life is nearly 7 to 10 days. That is the reason clopidogrel is stopped at least. Before we used to say 7 days. Now we say at least 5 days. Okay. Now, any other investigation you would like to do?
Chest X-ray also.
Chest X-ray, routinely chest X-ray is required. He doesn't have any cough or any other.
Yeah, but I will try to rule out if there is any pulmonary edema or LVH or.
No. See, only indicated test. Chest X-ray is not mandatory. Definitely, you are unnecessarily exposing him to radiation, isn't it? If you are suspecting any, by history, if you have the patient is a smoker, the patient has got chronic respiratory symptoms or acute respiratory symptoms of more than 10 days, or if you think that the patient may have a malignancy because he has got hemoptysis, then only you get a chest X-ray done. Unnecessarily, don't do any investigations. Okay, you have done all these investigations. Okay, so tomorrow morning is the TRP surgery has been posted. Now, how do you go ahead? Okay, Gino.
Yes, sir. And make sure the blood is arranged, kept blood group.
Hemoglobin is 13 grams. Because you did not find any pallor in the examination, isn't it?
No, sir.
So his hemoglobin is 13 grams.
Okay. Okay. Informed consent will be taken from the patient.
Okay.
And NPO status will be ensured.
What informed consent you will be taking? What information you will be giving to the patient?
Okay. Since he is belonging to the geriatric age group, he is hypertensive, diabetic.
Regarding his drugs, that also you'll have to tell about. Anyway, informed consent as such, for this particular patient, you have to inform about what anesthetic technique you would be using. And what are the different options regarding the anesthetic techniques you have, and which is the best technique for him, and how he should cooperate for your anesthetic technique, isn't it? So these are some of the informations you have to talk about, and you have to give a brief information about the surgical technique also. Though the surgeon would be explaining, it is your duty also to give him brief information about the surgical technique, how it is done. It's not an open surgery, it is an endoscopic surgery. These are the things. And should you have to tell him about the complications of this surgery?
Yes, sir.
Yeah, though they are not very common, but you should always tell him briefly about the complications and get the signature of the patient. Okay, you have taken an informed consent, right? Any other instructions you would be giving for the patient?
Yes, sir. Continue the antihypertensives he is taking on the morning of the day of the surgery.
Okay.
And ensure adequate.
Antihypertensive you usually avoid on the day of surgery?
AC inhibitors or ARB blockers.
Why AC inhibitors and ARB blockers?
Because refractive hypertension on induction of anesthesia.
Okay, that is there. Now, how about beta blockers and calcium channel blockers? You want to continue both?
Yes, sir. I'll continue.
Safia, suppose you continue on the day of morning of surgery. Is there any problem you expect in this patient?
Yes, he's supposed to have bradycardia during the surgery. Bradycardia, sir.
Bradycardia, okay. Anything else? He can go for severe hypotension also, isn't it? Because calcium channel blocker, clindapine is a peripheral vasodilator. Beta blocker, it is, beta 1 blocker. So the myocardial depression also will be there. He will not be able to increase his cardiac output. Suddenly, when you give spinal and sudden sympathetic block, so he can develop severe hypotension. So you should be expecting these things when you are continuing these drugs, on the day of surgery. Okay, so you'll be asking him to continue the day of surgery, right? Any other instructions, Gino? Bill per oral status?
And NPO status, and
Yes.
About
What is
6
the NPO
hours.
status you would be giving?
6 hours for solids.
Okay, then?
First for liquids and 2 hours for clear liquids.
Yeah, 2 hours for clear fluids. Okay, okay. So these are the instructions you should be giving. Any drugs you would be giving for him in the night? He is known
Yes.
hypertensive, diabetic.
The antibiotic prophylaxis in the morning.
Why antibiotic prophylaxis? That for everybody you will be giving in the night, I am asking you.
Nights are diuretic.
For anxiety.
Anxiolytic.
So, but the patient is a geriatric age group, so I would avoid an anxiolytic in this
You mean
patient.
to say that geriatric patients will not have any anxiety?
But I'll try counseling the patient, and I'll try
So
avoiding.
what is the concern regarding giving an anxiolytic?
So a respiratory depression.
No, if my mother-in-law is 84-year-old and she is the interstitial lung disease patient, every day she takes 0.5 milligrams of alprazolam. So mild anxiolytics should always be used. So you can definitely give 0.25 milligram alprazolam the previous night. Okay, next morning, right?
So on the morning of surgery, I would ask for investigations, sodium, potassium, serum electrolytes, FPS, as well as urine acetone. Since the patient is diabetic, I'll just want to confirm.
Okay, want to rule out ketosis.
Yes, sir.
Right.
And I'll make sure that the patient has taken his antihypertensives on the day of surgery. His NPO status would be confirmed.
Okay.
On arrival to theatre, I would give a pre-medication of ondansetron, antiemetic, 4 mg IV would be given. And depending upon the patient's anxiety and apprehension level, I might give a titrated dose of midazolam, 0.5 mg IV.
Okay, that is pediatric dose. 0.5.
So I'll titrate and give depending upon the patient's.
You should not worry much about these things, isn't it? Why unnecessarily? Anyway, that is not required as such because you are not giving general anesthesia. For spinal, it's okay. You have already informed him what you gave and regarding the spinal anesthesia itself technique. So usually there may not be any requirement of that. That alprazolam in the night you have given, that will cover the morning also. Okay, you have started an IV fluid. What IV fluid you will be starting?
I would prefer in this patient NS.
Normal saline. Safia, Gino wants to start normal saline. Why you accept or you want to go for balanced salt solution?
Sir, I accept the normal saline because he is predisposed to have hyponatremia. So it will predispose for hyponatremia, sir. So I will accept normal saline.
Okay, okay. Normal saline is fine. How much of sodium will be there in normal saline?
154 milliequivalents per liter.
Okay, 154. Very good. So that is the reason for TURP surgeries, definitely normal saline may be ideal choice of fluid. But in other surgeries, we don't use normal saline. Why? We always go for balanced salt solutions.
Okay, sir. Because of the fear of hyperchloremic metabolic acidosis, sir.
Hyperchloremic metabolic acidosis. Any problems because of hyperchloremic metabolic acidosis? How much chloride is there in normal saline? 154. Yeah, 154 milliequivalents. So it is much higher, isn't it? Normal. What is the normal chloride levels in the body?
112.
90 to 110 milliequivalents.
Yeah, 90 to 110 milliequivalents per liter. So in the exam, you should be telling about the measuring units also. You don't say just 90 to 110 and stop there. 90 to 110 milliequivalents per liter. Okay, so you are giving much higher when you give normal saline. So hyperchloremic metabolic acidosis. Any problems as such because of hyperchloremic metabolic acidosis? What problems?
Delayed awakening from the surgery?
No, you are giving the spinal, isn't it? for this patient.
Okay, but this patient,
Any patient with
sir,
when you
this
give
patient glycine is already, we are using the irrigating fluid as
no,
glycine. So
not
there
this
is no,
patient. I just asked about hyperchloremic metabolic acidosis. In any patient, metabolic acidosis, whether it is high anionic or normal anionic metabolic acidosis, it can produce hyperkalemia because it can bring out potassium from inside the cells that can produce sudden dysrhythmias. That is one thing. Any acidosis will depress the myocardium, so the cardiac output may be affected. And the hyperchloremia itself can reduce the renal perfusion and also can produce direct tubular damage. So these are the things we just remember about. Sometimes you may be asked when you are asked about what fluid and normal saline, if you are telling, then these things can be asked. Okay, now you have started him on normal saline. What is the gauge of IV cannula you have selected for?
18 gauge.
18 gauge, good. Okay, right. Then you have shifted the patient into the OT, right?
Yes, sir.
What
Before
monitors?
I'll make sure that ambient room OT temperature, warm irrigation fluids are available, and the OT temperature with stirrups, with the provision of stirrups, before shifting the patient to the theater.
Okay, right.
Yeah. Once a patient is shifted to the theater, monitors will be attached: pulse oximeter, non-invasive blood pressure, as well as ECG monitoring, and temperature monitoring also.
Okay, okay. Suppose if his ejection fraction is less than 35, any other monitor?
Invasive arterial blood pressure monitoring also.
Invasive arterial blood pressure, depending on the severity of the disease, isn't it? Not for actually the magnitude. There are two things you should always tell about invasive monitoring. One is the severity of the disease and the magnitude of surgery. Suppose if the magnitude of surgery dictates that you should go for invasive monitoring, you should. Like for example, a patient is posted for liver transplant, isn't it? Or any aneurysm clipping. So then definitely for that disease or surgery, definitely a requirement of invasive monitoring. So magnitude of surgery and what is the severity of the disease dictates you to go for invasive monitoring. Okay, this patient does not require now, right? Non-invasive monitors, temperature monitoring.
Yes, sir, required.
Yeah, okay, because he is likely to go for
Hypothermia.
Why he is likely to go for hypothermia, Safia?
Because of excess fluid overload, sir.
Fluid overload, or because of the cold fluids, or
cold fluid,
room temperature fluids, irrigating fluids, isn't it? They themselves irrigating fluids that are used can produce. Okay. Now, Safia, what anesthetic technique you would like to go for?
Sir, this patient, I will go for spinal anesthesia.
Okay.
Block level less than T10.
Why block level less than T10?
Sir, to find the if there is any capsular tear, to find out if there is any capsular tear. If the patient has higher level blocks, then he will not be able to complain of pain.
No, but what is the required level of block for PRP surgery? What is the level of block you require as such?
T10, sir.
Why T10?
Because of the nerve supply of the bladder comes from T10, T11, T12, L1, L2. So we have to block all these levels.
But bladder, you are not doing anything for the bladder. Surgery is at the root of the bladder or the apex of the bladder where prostate is there.
There can be perforation while instrumentation, sir. Capsular tear can happen.
Oh, that you want to detect, isn't it? You said yes, that. So, but why T10 anesthesia?
Bladder distension can cause discomfort with the irrigation fluids.
There will be continuous bladder distension, stretching of the bladder. The patient will be having a lot of discomfort. That is the reason. Okay, okay, right. So you want to have a T10 anesthesia. So, Gino, how do you manage this T10 anesthesia?
Sir, how do you
manage to give only up to T10?
Sir, I'll give a low spinal.
Oh, that's what T10 means low spinal.
Yeah, 2.5 ml, 0.5% bupivacaine heavy.
Okay, 2.5 ml for a geriatric patient is okay?
Yes, sir.
And
they
you want to get a low spinal? Maybe less, isn't it? Geriatric patients, because all the
I can give
changes in geriatrics and the anesthetic importance you should know when you are presenting a case of TURP. I did not go into details because of lack of time. So you should always be knowing. So the requirement itself is less, isn't it? Their CSF volume is less. That is the reason. And also the nerves are more sensitive. The nerve tissue itself is, the quantity of the nerve tissue is also decreased as the age advances. So they are very sensitive to local anesthetic. So just 2 ml. You want to add any additives?
fentanyl 10 or 20 max or morphine 0.1 mg.
Now, which one? Safia, she said fentanyl and morphine. Which one you would like to select?
Sir,
Fentanyl or morphine?
Sir, I'll prefer fentanyl, sir.
Yeah. What is the advantage of selecting fentanyl or morphine?
Respiratory depression is generally lesser. Pruritus is lesser in fentanyl, sir.
No, but you are giving these opiates for prolonged post-op analgesia, isn't it? So when you give fentanyl, what will be the duration of post-op analgesia?
4 to 6 hours.
4 to 6 hours. Fentanyl is highly lipophilic, isn't it? It gets rapidly into the circulation. It may not produce any kind of analgesia longer than the bupivacaine. Bupivacaine itself will produce almost about 3 hours of analgesia. So fentanyl will not produce such a long duration of analgesia. So if you want to have a long duration of analgesia, the gold standard is always morphine. And do you know what is the difference between morphine and fentanyl, in the neuraxial block?
The morphine has got a longer duration of action.
Why?
That is because the systemic absorption is less.
Yes, very good. So it is more,
it stays in the CSF. It stays in the CSF for a higher duration.
Why?
Whereas that is because.
Why
more hydrophilic.
So it is more hydrophilic, less lipophilic. So it remains. So that's why the chances of post-operative respiratory depression is also very less, as long as you keep it to just 100 micrograms intrathecally. So better to go for morphine. Okay, now you have selected 2 ml bupivacaine. Heavy or isobaric?
Heavy, sir.
Heavy. Okay. Okay. Can you use isobaric also?
I can use, but I'll have to put in the.
Any advantage or hyperbaric? Does it move up, isobaric drugs?
Isobaric moves.
Isn't it? Baricity is very important, isn't it? So when you are using hyperbaric, it moves down if you are giving in sitting posture, depending on the gravity. Whereas isobaric drugs, for all things that it should not move, actually, practically speaking, should not move anywhere. It should remain there where you have injected. And that's how isobaric drugs sometimes can be used, and they also have a prolonged duration of action because they don't move up and number of segments blocked will be less. So the number of segments where they are blocked will be a dense block. So definitely an isobaric levobupivacaine also can be tried. But the problem is sometimes they may not act at all. That we have seen practically, unlike hyperbaric drugs. So that is, you don't want your drug not to act. You definitely want the drug to act, so that you don't want to go for GA in this patient. So that is the reason it is always better to go for hyperbaric bupivacaine. Okay. Now you have given, yes, it has acted. You have checked it is come up to T10. So you have made the patient to sit, and then you have given in sitting posture, and you have waited for at least about 2 to 3 minutes before bringing the patient to supine posture. Now next, you proceed.
I'll have to position the patient for lithotomy, sir.
Okay. When do you position him for lithotomy? Immediately?
No, sir. I'll make sure that the blockade is at the level of T10, and I'll take a BP reading also to ensure that
okay,
there is no sudden hypotension in this patient before.
Okay.
How much time?
How much time you will wait for? Because what happens, suppose I have given spinal, I have made him to lie down, immediately the surgeon is in a hurry, so the assistants, OT technicians try to put the patient into lithotomy posture.
The chance that the level of blockade can go higher up?
Yes, isn't it? So that's why at least you should wait for 5 to 10 minutes before putting the patient into lithotomy. Because once you put the patient into lithotomy, the lumbar curvature gets obliterated and the chances of spinal going up will be very high. So you have to wait for 5 to 10 minutes. Okay, you have done that also. And now the patient is in the lithotomy position. Now, what are the irrigating fluids that most commonly used, Safia, for this patient?
The glycine 1.5%, then it's currently the most commonly used. Before
okay, what irrigating fluid that is used in your hospital?
Glycine, sir. Glycine.
Glycine.
1.5.
What percentage glycine?
1.5%.
1.5%. So what is the osmolarity of glycine?
Osmolarity is 220 milliosmoles per liter.
220
1.5. 1.5.
It is hypotonic, isn't it, Safia?
Yes, sir. Yes, sir.
So
it is hypotonic.
Ideally, you should use an isotonic solution, isoosmolar solution, isn't it? It is hypoosmolar. Why do you want to use a hypoosmolar solution then? 1.5%.
Sir, glycine is actually a inhibitory neurotransmitter, so it can have.
I'm asking you see, that's why I told you that straightforward answers you should always give. I asked you, it is 1.5% is 220 is milliosmoles per liter is the osmolarity. What is the isoosmolar glycine? What is the percentage?
I don't know.
Why you are not using?
Yes, sir.
Do you know why? What is the isoosmolar percentage of glycine?
1.2%. No, I don't think.
Your 1.5 itself is 220.
So I think at that, when you use isoosmolar, the hyperglycemia toxicity is more using.
2.1 is isoosmolar glycine, 2.1%, and it is more turbid. So transparency is very, very important, isn't it? For doing PRP surgery, the irrigating fluid should be totally transparent. So 1.5% is totally transparent, 2.1% is slightly turbid. So that's why, though it is isoosmolar, we don't use it. Okay. Now the glycine you have taken. What are the Safia? What are the problems you expect with glycine alone?
Glycine alone we can cause hyperglycemia, then hyperoxaluria, then hyperammonemia.
Very good.
Glycine.
Why
Apart from that,
hyperammonemia?
Because in the body, glycine undergoes oxidative deamination and it becomes ammonia. It releases ammonia.
One of the metabolites of glycine is ammonia. Where ammonia is released? Where it gets metabolized? Glycine?
In the urea cycle, sir.
Where?
So organ he's asking.
Yeah. Liver.
Yeah, liver, isn't it? In the liver, it gets metabolized to ammonia. And what happens to this ammonia later?
This ammonia causes ammonium ions, and it will also cause hepatic encephalopathy. It causes
What happens to this ammonia normally?
Goes into ornithine cycle.
Ornithine cycle to produce what?
Urea.
Yeah, ammonia gets converted to urea and excreted out, isn't it? So that is a normal cycle. So when you can expect hyperammonemia?
When there is arginine deficiency or
yeah,
if there's a hepatic dysfunction.
Isn't it? So because that also you have to keep in mind, though you are not routinely testing these patients for arginine levels, isn't it? But that is a very rare thing, but it can produce hyperammonemia, and all the the CNS symptoms and disturbances can be due to hyperammonemia also. That also you'll have to keep in mind. Okay, Gino, now everything is fine. The surgeon wants to start the surgery. Before that, any precaution you will be taking as far as diathermy is concerned? Because it has to be done under either monopolar diathermy or bipolar diathermy, isn't it? Nowadays, people are doing under bipolar. Let us say your urologist is using monopolar diathermy, underwater diathermy. So as an anesthesiologist, what precaution you will be taking? Monopolar means what?
Monopolar use higher amount of current, and there's a grounding plate where the current has to travel throughout the body and reach the grounding plate. The circuit has to be completed. Whereas a bipolar, it occurs the resection at
grounding plate, otherwise called as a patient plate. Is it an anode or cathode? Where is cathode? Where is anode? What, Safia? So at the site of surgery, it is cathode.
And grounding plate is anode.
Patient plate is anode. Okay. Now, anything precaution you will be taking when putting this patient plate or patient electrode?
So make sure the patient doesn't have any pacemaker.
I'm not talking about pacemaker. This patient doesn't have any pacemaker. Routinely, where it is placed, usually ideally, because you said that it traverses through the body.
It should be placed close to the operative site.
Yeah, close to the operative site. So best position would be where?
Thigh.
Thigh or underneath the buttocks, isn't it? So you should make sure that it is properly,
gelled. Okay, and
properly coming in contact with the skin, isn't it? So because the same amount of current has to come out through this patient electrode. If it is improperly touching, a small part of the patient plate is touching, so it can produce burns. So that is very important. And again, lithotomy posture, no part of the patient should be touching any part or any metal part when you are keeping the patient into lithotomy posture. So these precautions you have to take before allowing the surgeon to start surgery. Okay, the surgeon has started the surgery, and what are the complications you expect in between?
Intraoperatively, TERP syndrome, hypothermia, coagulopathy, as well as bladder perforation, septicemia also.
Okay, so TERP syndrome is more common with glycine or with any other irrigating fluids? Because initially, which was the irrigating fluid the urologists were using?
Distilled water.
Distilled water. What is the osmolarity of distilled water?
0.
0. Very good. Very good. Because that suddenly when we ask, the student will never would have thought about the osmolarity of distilled water, because you have taken all the particles in the distilled water, isn't it? So it's almost 0. So, okay. So because of this, the TERP syndrome was more common. Nowadays, we hardly see the TERP syndrome because we are using glycine. Anyway, so suppose you think that this is one of the complications, and how do you recognize intraoperative?
Usually the first patient will show symptoms of agitation, restlessness, mental confusion, disoriented, nausea, vomiting, sweating, eventually visual disturbances, seizures.
Oh, it always CNS and cardiovascular also, isn't it?
Okay. And cardiovascular, there will be hypotension, tachycardia, arrhythmias, hypertension, tachycardia.
Bradycardia or tachycardia, whenever there is hypertension?
Hypertension, bradycardia, and then arrhythmias, and then hypotension and cardiac arrest.
Okay, Safia, this patient suddenly has become restless. Okay, intraoperatively, everything was fine. Suddenly, after about 20-25 minutes, he has become restless. Now, what are the things you will think about and then manage?
I will first think about TERP syndrome itself. I will ask patient.
Try to look at the blood pressure.
Yes, sir. I will look at the blood pressure. I'll see if there is any hypotension. Also, I will look at the ECG, look for the pulse if there is any reduced pulse pressure and any prolonged PR interval.
Because, you should always think about the most common causes. Any hypotension, cerebral ischemia, especially medullary ischemia. So the patients immediately, suddenly they become restless. Whenever under spinal anesthesia, if the patient becomes slightly restless, you should always look for the blood pressure. So majority of the times there will be hypotension. If you just correct it, it becomes all right. So don't jump to the conclusion that the patient might have developed TERP syndrome. Okay. Now this patient is classically giving you symptoms of TERP syndrome. He is agitated, he is restless, he is having headache, he is having blurring of vision. So now, Safia, how do you proceed?
Sir, I will immediately I'll immediately administer oxygen. I'll ask the
Okay.
patient to stop the aeration and oxygenate first via nasal cannula or facial mask, and then intubate and ventilate if necessary.
Did you ask surgeon something?
I'll ask if there is a lot of bleeding and
No,
difficult
because surgeon cannot stop immediately, isn't it?
Yeah, but
You
the
can
bleeding point
advise him to stop the surgery and go for hemostasis. He should not do more amount of resection. He should immediately get the hemostasis done, so that the patient the lithotomy position can be brought back to supine posture, and then you can take measures, isn't it? So okay, now you have done that, and immediately any investigations you'll be sending for?
Yes, sir. I will immediately send an ABG just to see the osmolarity mainly, and also I will also send samples for sodium.
Sodium
And
that
other
is
electrolytes.
more important, because dilutional hyponatremia is the most common problem. So you'll be sending it for sodium estimation. Okay. Then
I'll also look at the osmolarity, sir. Osmolarity. I will once the sodium comes, if it is less than 120, or if there is a fall of more than 20 to 30 milliequivalents per liter, then
okay.
I will give 3% sodium NS.
Before that, many of the patients do not require hypertonic saline, isn't it? So what is the cause for sodium reduction? It is not because of sodium itself has not come down. It is a dilutional hyponatremia. So once you correct that dilutional hyponatremia, automatically sodium may become normalized, isn't it? So initially you don't straight away jump to going in for hypertonic saline. So usually, what is the drug you give?
Furosemide, sir. Furosemide. I will give furosemide, sir.
Furosemide is the one
20
drug.
mg.
Yeah.
Bolus can be given, and depending on the response, we may have to give for 40 mg also. IV bolus.
Okay. Suppose the patient is already on diuretics, you go for 40 milligrams. Otherwise, 20 milligrams is sufficient. Okay, you immediately get this thing also, sodium estimation also, and it is 115 genome. So patient is restless, 115 sodium. You're also seeing ECG changes, broadening of the QRS complexes are also there.
I'll start the patient on hypertonic saline, sir, 3%.
Okay.
How much amount of hypertonic?
Is sodium will be there in hypertonic saline?
512.
512. How do you get this sodium estimation?
So twice the total body water, 60% of the body weight into 2, twice it. That much amount ml of hypertonic saline will raise the sodium by 1 milliequivalents per liter per hour.
Okay. Otherwise, how do you know that hypertonic saline will 3% will contain 510 milliequivalents? So that is very easy. So you'll have to know the mass of the drug in milligrams. 3% means 3 grams in 100 ml. So 30 grams in 1 liter. 30 grams is 30 into 1000 milligrams divided by the molecular weight of sodium chloride. What is the molecular weight of sodium chloride? Sodium is 23, chloride is 35. So 58. So divided by 58, you get the 510. So that's how you can, any drug you can always calculate the osmolarity. Osmolarity or the in milliequivalents. Okay, now how fast you should give?
Not more than 100 ml per hour. Our aim is to raise by not more than 1.5 milliequivalents per liter per hour.
Yeah. What happens if you try to correct it overzealously?
Osmotic demyelination syndrome. Central pontine myelinosis is my fear.
Central pontine myelinolysis. So you should be very careful about producing central pontine myelinolysis. So it is an irreversible problem. That's why you have to be extremely careful. Okay, this patient also was so much agitated, and he is almost going in for, he developed a convulsion also. And he is also having frank pulmonary edema. So how do you manage?
Short-acting benzodiazepine midazolam, I will give 2.5 mg to 10 mg. And if the patient, if the seizure doesn't stop by it, I can go for phenytoin, 15 mg per kg. Or finally,
don't want to intubate him?
Intubate and
yes,
ventilate.
yes, sir.
Pulmonary edema, I said.
Yes, sir.
Going in for pulmonary edema, cerebral edema, the frank TURP syndrome.
Yes, sir, I will intubate.
Yeah, okay. What drug you will be giving to intubate? He had a seizure also. Which drug? Thiopentone, propofol, etomidate?
Propofol.
Now, which is a better anti-epileptic among these?
Thiopentone.
Thiopentone, isn't it? And
using nowadays. That's why
pardon?
new generation they use propofol.
Yeah, propofol, that is there.
Yeah,
But thiopentone may be an ideal.
Thiopentone.
Yeah, that is there. But in this condition, you can, in the exam, you can always say thiopentone is barbiturates are better anti-epileptics. So you can give. Okay, so you have intubated, and anything else you do for the position of the patient? Pulmonary edema?
I have to make him supine position, sir.
He's already brought to supine posture. You don't intubate
Head and elevated, sir.
Yeah, you
Head
have
and propped up position will be there.
Yeah, then anything you are ventilating the patient with 100% oxygen or with nitrous?
100% oxygen.
Why 100% oxygen for pulmonary edema patient? Any advantage? See, oxygen will dilate the pulmonary vessels, isn't it? It decreases the pulmonary hydrostatic pressure. So once the pulmonary hydrostatic pressure is decreased, so naturally, you know that the pulmonary edema will come down. And you have to use PEEP also, isn't it? So at least 8 to 10 centimeters of PEEP. That's how you manage. Okay. Now, what are the other problems you expect? One, you said bleeding. Another, TURP syndrome. Any other problems?
Hypothermia.
Hypothermia is very good.
Bladder perforation.
Yes, then?
DIC, sepsis.
Sepsis. Then
coagulopathy.
Why DIC?
It could be because of dilution thrombocytopenia, or because of release of active urokinase.
Okay. From
the surgical side, from the prostatic tissue.
Prostatic tissue. Any other complication because of glycine?
Visual disturbances.
Yeah, transient blindness. Okay, these are the ones. Anyway, we have, I think, exceeded 4 minutes. So let me stop at this. So any questions from the listeners or other postgraduates, we can answer. This is for 1.5 hours or 1 hour 15 minutes, Paul?
It is 1.5 hours, sir.
10:30, I think.
Yeah, so another 10 minutes. Now it is 10:19, another 11 minutes. If any questions from you people, both Gino and Safia, both of us are there to answer, or any other questions in the chat box also, we can definitely answer. So somebody has asked any other regional technique for TURP. So, you can go for even epidural, definitely is there. Graded epidural, you can go depending on the patient. But one disadvantage of epidural is that, the sacral fibers may not be blocked properly. Here, it is very important to block the sacral fibers because, the penile urethra is supplied by the sacral fibers, and also the parasympathetic is by the sacral S234. So that is one problem with epidural. Even caudal epidural, I have given caudal epidural also, though it's maybe very difficult in old age people, but I have used in patients who had, left ventricular dysfunction, and also, where they had a lot of problems of other comorbid conditions. So you can even go for a caudal epidural, but I don't advise because it is rarely used as such. Because with caudal epidural, you can just block only those segments which are involved for TURP surgery. So these two, plus, very rarely I've given for one patient. So a regional anesthesia, local anesthesia block. That is prosthetic regional anesthesia block I had given. Along with, lidocaine jelly that is pushed through the urethra. Then what you have to do is the pubic symphysis. Those days, of course, without ultrasound or anything. So nowadays with the ultrasound, you can see probably the prostate, and just on either side of the prostate, with a spinal needle, you just go deep, and your one of the fingers should be in the rectum, so that you should not perforate the rectum with your needle. So just slowly you go. As soon as your needle touches your finger, stop there. You can infiltrate local anesthetics, especially of bupivacaine 0.25%, 15 ml on this side and 15 ml on the other side. So with lidocaine jelly, so in extremely difficult cases wherein they are not fit for any kind of anesthesia, you can still go for this particular technique also. So these are some of the regional anesthesia techniques definitely you can use. So Paul, just to see any in the chat box, any other?
There is about bipolar. When you are using bipolar, which fluid has to be used? Somebody has asked, or I think he's giving the clue.
Yeah. Irrigating fluid, you can still go for even normal saline also when you are using bipolar, no problem. Okay. Any other in the chat box?
Any have asked about the allowable blood loss formulas?
Allowable blood loss formula is, you have to know the blood volume of the patient. So usually in males, it is 70 ml per kg body weight, and females 65 ml per kg body weight. That is multiplied by the patient's measured hemoglobin minus 8 divided by the average of the measured hemoglobin plus 8 divided by 2. Or hematocrit, if you know, you can also go for hematocrit. So you need not have to convert the hemoglobin to hematocrit and then calculate like Gino was trying to do that. If you know the hematocrit, go for hematocrit, or if you know the hemoglobin, also you can go for that.
Good morning, Guru. Can you hear me?
I can hear, but who is it? I don't know.
Dr. Mallikarjun from Bangalore.
Yeah, Mallikarjun, yes, you had presented a TURP case in our PGXL. Anything to add, Mallikarjun?
Yeah, I would like you to, for the sake of the postgraduates, we should have covered obturator spasm, bladder perforations, which can be extra or intra-abdominal, because intra-abdominal will cause your diaphragmatic irritation, whereas extra will not cause. And the ways of preventing a TUR syndrome was not covered, like height of the...
Correct.
And you have to go on lowering it as the procedure goes on from 60 centimeters to as low as possible. Then keep watching the lower abdomen to see that the bladder is not distended. The surgeon is busy operating and he forgets that it is draining. So we should see that it is getting drained to prevent the TUR syndrome. And a few other things like obturator spasm, which can happen even during a TURP, though more common during a TURP. So about the obturator block, and in case you have not given an obturator block, it has failed. Suppose the patient is kicking during the resection, you may have to convert it to general anesthesia for a short period when they are resecting that area. And these patients, elderly, can have a pacemaker, and what you do when you are using a monopolar cautery, you have to disconnect it, and there is always a possibility of having disturbances in the pacemaker. These are few things which I thought are useful for the postgraduates for their exams.
Yeah. So rule of 60, deliberately I did not ask because most of the postgraduates will be knowing about rule of 60. So that is the reason, I did not go into that. Yes.
Problem of lithotomy position.
Yeah. So the total prostate that has to be removed at a particular setting should not be more than 60 grams. So hydrostatic pressure that is less than 60 centimeter, duration of surgery is 60 minutes. Thank you, Mallikarjun. Thanks for reminding me that. And
other thing is, these patients
block is required. And for TURP surgery, usually we don't do. And one more thing, as you said, for preventing, preparing the patient is very important. For example, if the patient is in CCF, many of these patients can be in CCF. So you have to optimize CCF before taking up, because CCF itself, already there will be hypervolemia in these patients. So even slightest amount of fluid, they can develop pulmonary edema. So that's why CCF has to be, corrected. And if the creatinine is high, again, post-renal failure, again, there can be hypervolemia. So that creatinine has to be corrected. That I discussed with them by placing a catheter at least for 21 days so that the creatinine can be brought down. And another very important thing about the surgical technique itself is repeated, bladder evacuation has to be done by the surgeon. So you should not allow the bladder to distend much because, the gradient between the bladder pressure and the prostatic sinuses is very important. If the gradient is high, anything in the bladder that is the irrigating fluid can get into the prostatic sinuses and then it can produce, TRP syndrome. So there are many questions which we could have asked. So provided, we are given 3 hours. That is there. So
3 or even 4 hours.
Yeah, when I take class.
Sir, namaskara.
Namaskara, Paul. How are you?
Yeah, fine. Nice to see you through this.
Other thing, Guru.
Yeah.
One thing I want to tell the postgraduates is when you have a cardiac patient and a renal failure patient combined, usually we come across these patients with prostate who are diabetic, hypertensive with renal failure, CRF, and in addition, IHD hypertension with reduced ejection fraction of even less than 35. I have seen patients developing pulmonary edema in the first 5-10 minutes of the resection. And probably we always have the intention of going in for a spinal or an epidural. I would advise the postgraduates, whenever you have a cardiac patient with low ejection fraction, plan for a general anesthesia. Unless you are so good in controlling your epidural levels, it is always dangerous. And be prepared in these patients to manage this pulmonary edema which develops so quickly. And postoperative renal failure has been one of the problems in these patients because of the prostatic tissue entering the sinuses and resulting in renal tubular blockages and postoperative renal failure in a patient who was without any renal compromise preoperative. They have even gone into dialysis postoperatively for 1 or 2 sessions and then come out of it. That's it.
Yeah, I did not even ask about, the advantages of regional anesthesia over general anesthesia. So usually that is another question that will be asked. But, what has been found with the general anesthesia, they have found out the incidence of TURP is less general anesthesia compared to regional anesthesia. Incidence. Detection is early with regional anesthesia, but incidence may be less with GA because under GA, usually the pressures will be on the higher side. Whereas under region, especially spinal, the pressures will be lower. So the prostatic sinus pressure will be much more negative with spinal anesthesia when compared to general anesthesia. That's why the gradient is much higher with spinal anesthesia when compared to the general anesthesia. So the chances of TURP syndrome may be higher with regional anesthesia compared to GA. So as Dr. Mallikarjun was talking about, so if the patient has got a poor left ventricular function, so it is always better to go for GA rather than spinal anesthesia. So you should never always, never think that, okay, I will always go for only spinal or only epidural in TURP patients. You can also go for GA also. There is absolutely no contraindication for GA. Only advantage with regional is early detection. But of course, these geriatric patients will be on multiple drugs. So polypharmacy is a rule in geriatric patients. So in GA, again, you can have a lot of interactions with your general anesthetic drugs and this polypharmacy of these patients. So that's how in a geriatric patient, it is always better to go for a regional anesthesia. That is another advantage for regional anesthesia itself. Plus, you can add a morphine intrathecally as an adjuvant. So it can produce prolonged post-op analgesia because many times I've seen these urologists, they'll put a traction. So to prevent bleeding from the prostatic area. So the traction can produce severe, pain for the patient. And, if you have used just 0.1 milligram morphine, so the patient will be quite comfortable.
Thank you for doing a fantastic job as a teacher.
Thank you, Malay. I'm also hearing so much about you.
Thank you, Gurudat sir. Thank you, Paul. And thank you, Safia and Jinu, for that wonderful session. I think we shall move on to the next session. And it's already 10:30, so we'll move on to the next session. So over
Thank you, Juno, and thank you, Sophia.
Thank you, sir.
Thank you, sir.
We move on to the next case. That's a short case, cataract presentation. So the case will be presented by Dr. Manika Goel from the School of Medical Sciences and Research, Sharda University. And the examiners are Dr. Manjunath, Professor and HOD, Government Medical College, Mysore, and Dr. A.V. Mallikarjun, Professor, KVJ Medical College, Sulia, who formerly worked as Professor in KMC Manipal and Yenapoya Medical College. So over to you, sir.
Good morning to the organizers at the outset. And I'm always happy to get connected with Kerala because for the last 30 years, I have been having friends from Kerala who have been postgraduates here, and now they are professors there and doing very well. And when Paul said hi, I was very happy because I've been going regularly as examiner to many of the colleges in Kerala because of Mubarak and others. And I always love Kerala and I'll always be liking to come there. And I was surprised when a postgraduate from UP called me and said she's going to present. I thought this was Kerala refresher course, and how did you get a chance to do it? That's a great show again, involving everybody all over, though it is a Kerala refresher course. Thank you very much, and good morning to Dr. Manjunath.
Good morning, sir. Good morning, Dr. Mallikarjun, sir. Thank you very much. Definitely, it is a pleasure to be along with you as a senior colleague. And even I am also worked in Kerala, and I am happy to be part of the Kerala ISA refresher course. I was working in Kerala for some time, for nearly from 95 to 2000, I was working there. And many of them, especially Dr. Mubarak and everybody I know, they are our examination professional colleagues. And as you said, they are doing a fantastic job. And it is definitely good to know all the more postgraduates. There are many postgraduates watching this video, and definitely we're going to have a very good discussion follows. Thank you, Dr. Mallikarjun, and I'll go ahead with the presentation. I think Dr. Mallikarjun, sir.
Yeah, welcome, Manika. You can start your presentation.
Good morning, all. I am Dr. Manika Goel from School of Medical Sciences and Research, and I am going to present a short case of cataract. My patient Raman Kumar, a 67-year-old male, Hindu by religion and farmer by occupation from Dankor, UP, came with chief complaints of diminution of vision in both eyes since 8 months, with right more than left. Patient was apparently all right 8 months ago when he began to develop diminution of vision in both the eyes, which was more in right eye. It was insidious in onset and gradually progressed to current state. Diminution of vision was same for both near and distant vision, and it was not associated with pain, redness, watering, discharge, headache, double vision, colored halos, or frequent changes of glasses. The patient has been using glasses for 20 years for myopia until 40 years of age, and then he changed to glasses for presbyopia type. No history of ocular surgery, trauma, or use of steroid eye drops was present. My patient is a known case of hypertension since 8 years on tablet telmisartan for 40 mg. There is no history of diabetes mellitus, asthma, ischemic heart disease, or tuberculosis. Family history was insignificant, as well as surgical history was insignificant. The patient takes a mixed diet, predominantly vegetarian, with normal appetite and regular bowel and bladder movement. Patient is a tobacco chewer for 20 years and doesn't consume alcohol.
Okay, so you have given the history of this patient who is complaining of diminution of vision.
Yes, sir.
How are you associated with the ophthalmology OT? How often you go to the ophthalmo OT?
Sir, mostly they perform the surgeries under their arena only. It is only for specific conditions when we need to give GA in pediatric or psychiatric patients, or patients who are apprehensive, or in cases when patients present with hypertension or bradycardia during intraoperative periods. That is when we are called for.
Most of the time it is the ophthalmologists are managing their own cases unless they require a general anesthesia for this pediatric or elderly patient, apprehensive, psychiatric patients, and some trauma where you are called upon to give anesthesia. So it is not an environment where you regularly give anesthesia. Plus, why is it that ophthalmic surgeries are done under local anesthesia most of the time than under general anesthesia? What are the advantages? What are the disadvantages of this?
So most of the patients, most of the patients are geriatric patients with many comorbidities. So they want to, so the effects of the general anesthesia can be allayed by using regional.
Is that the reason why they do under local?
So they can, provide well akinesia and well analgesia and akinesia can be well done with the blocks which they.
Yeah, the blocks are enough. It is not because the patients are elderly, not because the patients have comorbidity that these patients land up with the local anesthesia. Because local anesthesia with 1-2 injections can provide good analgesia, akinesia, what is required for them. Even a very sick patient with multiple comorbidities can be taken up under local anesthesia. That is the reason why most of you said the patient has come with the loss of vision. What are the common causes for this diminution or loss of vision? You have to know about.
So they can be either congenital or acquired. So in congenital causes, we can have, it can be because of syndromes like Down syndrome or congenital rubella syndrome and phenylketonuria. And in acquired causes, it can be due to cataract, due to diabetes mellitus, then galactosemia, then it can be due to raised ICP. There it will be because of sudden, they will present with sudden loss of vision. Then due to trauma or infections.
Okay, what about
sir, 1 minute.
Yeah.
Sir, Monica, because
Yes,
your
yes.
patient is a 67-year-old patient with hypertension. So regarding this, so patient is having a diminution of vision. Any other history relating to your hypertension? So because could the hypertension can cause the diminution of vision?
So
Could it be a cause for your diminution of vision? Hypertension.
Stroke can cause.
Long-standing hypertension. So you have to think of changes in the long-standing hypertension in the retina, in the retinal vessels.
Yes, sir. Hypertension can have end organ damage, including retinopathy.
Okay, that's the one thing you have to rule out. And what are the other things you will rule out in the history as well as history is concerned? Because it's a hypertension patient and a old age patient. Any other causes regarding the just for the this is a region, this is an old age patient, is a natural history of the patient, so that you will going to have that diminution of vision. Any other causes pertaining to the diminution of vision as far as the old age is concerned? You have to look for the history wise. Patient is a myopic for nearly 20 years, right?
Yes.
Yeah. Any other myopic changes you can think of? No, because of their long-standing myopia, patient might have gone for changes. A lot of changes are there in the retina. That was one of the causes.
There will be increase in the axial length, so there will be thinning of the retina. So the tears in the retina can be because of myopia.
Okay. So history of myopia, is it relevant in this patient as far as your anesthetic management is concerned?
Yes, so for many blocks, we need to have the axial length. The axial length should be known, and it should be at least within 25 millimeters. If it is more than 25 millimeters, then chances of globe injury are high.
Okay, okay. That's one thing is, so as far as the myopia is concerned, you should be very careful. And during a performance of your block, you should be very careful about the globe perforation and the axial length. Okay, one thing. And second thing is, because of this patient is a hypertensive patient, and whether it is well controlled or not, so the past history of the hospitalization you should inquire. So past history of hospitalization, past history of any CVA relating to the hypertension episodes, hypertensive crisis, that should be included. I think you're going to, I think you're not inquired about the past history of hospitalization.
Sir, surgical history, and there was no any ocular trauma or any such hospitalization history, sir.
Okay, okay. Patient is a diabetic?
No, sir.
Okay, okay. Any other history suggestive of vascular malformations, headache, persistent headache, vascular malformations?
So
okay. Could it be a cause for this diminution of vision? Any other vascular malformations?
Yes, sir. There are vascular malformations in the retina which can cause diminution of vision. There can be so black spots can be seen, as the patient will complain of.
Because the patient is old age, you should ask about the history of atherosclerosis, ischemic heart disease. So you should inquire about the ischemic heart disease. Is it important? Yes. Yeah. Is it important as far as your diminution of vision is concerned? Ischemic heart disease?
So they are more prone to hypotension, so that can cause sudden loss of vision by decrease in the perfusion.
Okay. So history-wise, you have come from general history-wise. What is your diagnosis as far as the history is concerned? You have taken history, and what is your opinion regarding the history?
So that the patient is a 67-year-old elderly patient and a known case of hypertension presenting with diminution of vision, and the cause has to be found out. That is most likely due to old age.
Okay.
Cataract.
Sir, Mallikarjun sir, Karen.
Yeah, you said old age. Can you classify the geriatric patient?
Yes, sir. Sir, elderly patients are individuals with age more than 65 years. They from 65 to 75 years, they are young old. From 75 to 85 year old, they are medium old, and more than 85 years, they are oldest old.
Why are you worried about a geriatric patient? What are the common medical conditions which you come across in your day-to-day practice?
So there are several comorbidities, like in respiratory, they usually have COPD. Then in CVS, there are known cases of ischemic heart disease, hypertension, or they might have pacemakers or this thing. Then in CVS, in cerebrovascular, they might be candidates of stroke. They might have a history of stroke or cerebrovascular disease. Then in endocrine, they might have diabetes mellitus, thyroid disorders, which and in renal they can have CKD. So these all have to be taken into consideration when we take up such a patient.
So whenever you come across a geriatric patient aged more than 65 years, you look for all these conditions. And when you said history of hypertension, as Dr. Manjunath sir said, you have to look for end organ damage in these patients. In your history, you never mentioned about, you just said the patient is a known hypertensive. Am I right?
Yes,
sir.
You should always look for any end organ damage, that is either the respiratory effort, the effort tolerance should be mentioned. Of course, this is a short case. I don't know, exams you'll have just about half an hour. We'll not allow you to present the whole case. We will just ask you what are the positive findings so that we can discuss more about the anesthetic. Okay, what are the common surgeries you come across in this geriatric patient other than cataract? One is cataract, of course. Very often you come with geriatric patients.
It's long bone fractures, then like hip fracture, then TURP, hernia. So these are the common.
Okay, what are the anesthetic implications of a geriatric patient? We'll just enumerate. We'll not go into the discussion.
Yes, sir. Yes, Mallikarjun sir, you said this is a short case, and usually we never ask the posterior to present this case. Straight away, as you said, we will ask for the diagnosis and positive points and straight away. But because we are given a long case, we given a 35 to 45 minutes, you can go for that. That's why, just sir. Yeah, sir. Okay, yes, sir said. So what are the complications of geriatric? Yeah, go ahead with Monica.
So there are many physiological changes, like in CVS, the arteries stiffen.
What are the changes? What are the implications you go on telling? What happens to the respiratory system, cardiovascular system, their skeletal system, and their anesthetic implications?
Sir, in CVS, there is impaired baroreceptor activity, due to which they are more prone to hypotension during intraoperative and in the perioperative period. Then they have ventricular hypertrophy, so they are at an increased risk of diastolic dysfunction or fluid overload at any time in the perioperative period. Sir, in the respiratory system, sir, the arteries are stiffened, so therefore there are chances of hypertension. And sir, in the respiratory system, they have reduced ventilatory response to hypoxia and hypercarbia. Then they have reduced airway reflexes. Therefore, there are increased chances of aspiration. The parenchymal changes are there, so the ventilation perfusion mismatch is also there.
What happens to the residual volume?
Sir?
What happens to the residual volume?
The residual volume increases, and the closing.
decrease FRC.
Yeah. A functional residual capacity.
Sir, FRC decreases.
Yeah, that is very, very important. Yes. FRC is very important as far as the respiratory system is concerned. So what is meant by FRC? What is the relationship of FRC with the closing capacity?
Sir, FRC is the volume of air which remains in the lung after normal expiration. Okay. And sir, closing capacity is expiratory reserve volume. It is a capacity, that means it is a combination of two volumes, that is residual volume and expiratory reserve volume. Sir, it is the and the closing volume. Sir, it is the capacity. It is the volume of volume at which
what is one minute. Our question is, what is the FRC and closing capacity? What is the relationship between the FRC and closing capacity? Sir, and FRC, why we are worried about that in old age?
Sir, because closing capacity increases and FRC decreases, therefore the ratio which should be more than 1, it reverses, and there are chances of small airway closure at normal tidal volumes also in old age.
What's your worried? Why are you worried about that?
They are at increased risk of desaturation and atelectasis.
Yes, yes.
So pre-oxygenation in these patients is very important, and shorter duration of laryngoscopy and intubation will always prevent hypoxia, especially if they are compromised patients. Okay, go ahead. What happens to their spinal and epidural?
So the epidural space is reduced. The spinal and epidural space is reduced because of the calcification of the ligaments, and therefore there are chances of higher levels of the neuraxial blockade.
Epidural dosage of your local anesthetics, it keeps on reducing with age.
Decreasing with age.
Okay.
Then, so the number of neurons.
Central nervous system, Manika. Yes. How will they react when you go to see them? Okay, you're gone for this patient only. This patient was requesting general anesthesia for some reason. So when you go see him, how do you go about talking to him? What problems you get when you are talking to these patients?
So they are hard of hearing. They usually have difficulty in understanding language. Issues are there. There can be sluggishness while speaking. Then they might be so depressed, or they might be they might be anxious, and they might not be able to understand the procedure they are about to undergo.
What about the hard of hearing? Patient might have a hard of hearing. Patient might have a decreased cognitive functions, may be decreased.
Yes.
In these patients. Okay.
Cognitive function is very important in these patients. So you should look for all those things. Yes. What happens to the renal function and the liver?
So the renal function, the creatinine clearance decreases, and therefore there can be decreased clearance of the GFR and renal blood flow. It decreases. Therefore, there can be decreased renal clearance of various drugs. And similarly for hepatic, sir, the hepatic blood flow decreases, and the function of P450 enzymes also decreases. So hepatic clearance of drugs is reduced. So the total body water, it decreases, and the body fat increases. So the volume of distribution for lipophilic drugs, it increases, while for hydrophilic drugs, it decreases.
So what will you do when the volume of distribution is increased? What does it matter to you?
So,
how will you use this during your anesthetic management?
So, sir, drugs like benzodiazepines, they are more sensitive to benzodiazepines, and there can be prolonged actions of such drugs.
Yeah.
No, what is the dosage of the drugs? Dosages.
So the doses are usually reduced.
So you have to be given titrated dosage. Okay. So sleeping dosage or induction agents and all the drugs should be decreased. So you should not go for a regular dosage.
Regular.
Okay.
What about muscle relaxant in these patients with large volume of distribution?
So the plasma cholinesterase activity decreases. So therefore, the depolarizing agents, they can have a prolonged action. And the non-depolarizing agents, they have.
Yeah, what about the neuromuscular receptors, neuromuscular junction, changes in the neuromuscular junction? Also, you have to tell about that. Changes in the neuromuscular junction, receptor level, okay, volume distribution, everything will be counted here. So that decreased dosage of the drugs, the maintenance dose should be decreased. Okay.
Okay, go ahead with your
general physical examination, sir.
The patient was examined under adequate light. My patient was well oriented to time, place, and person with height 153 centimeter, weight 65 kgs, and a BMI calculated to be 27.7 kgs per meter square. The vitals were grossly normal with temperature 98°F, pulse rate 82 beats per minute, regular rhythm with normal tension, volume, and character of vessel. All the peripheral pulses were palpable. Blood pressure was 140 by 80 millimeters of mercury measured in right arm in sitting position. Respiratory rate was 16 per minute and no pallor, icterus, cyanosis, clubbing, lymphedema, lymphadenopathy or edema was noted. Airway examination was normal with mouth opening 3.5 centimeter, thyromental distance 7 centimeter, upper lip bite test grade 1. Oral cavity had absent anterior upper incisors and loose right lower premolar. No dentures were present and Mallam putty grade was 2. Neck movement was adequate with more than 90 degrees.
Okay, when you check the blood pressure, the BP was 200 by 110 on the preoperative day. You said the patient is on telmisartan 40 mg.
Yes, sir.
What you are going to do now?
Sir, the acceptable level of BP, sir, the BP should be less than 180 by 110 millimeters of mercury. So 200 by 110 millimeters of mercury. Here we will have to find out the cause that the patient might be anxious or.
When you go see the patient, the BP is so much. When you check back the records, the blood pressure is 150 by 80, 150 by 90. What do you think it could be because of?
So it might be because of anxiety.
Yeah, white coat hypertension. We are not discussing hypertension because somebody else is also presenting. But since this is a patient with hypertension, you should always think of anxiety and white coat hypertension. What is pulse pressure?
So pulse pressure is the difference. Between systolic and the diastolic blood pressure.
What happens in this patient? What happens in these patients? Who are the old age patients?
So the pulse pressure increases because of the stiffening of the vessel.
Okay. So
the systolic pressure increases and diastolic decreases.
200 by 90. You want to treat this hypertension further?
So first I would like to counsel the patient. And if still not, then I can give sir small doses of benzodiazepine.
Okay, my question is, if you want to add any antihypertensive to this higher BP, don't try to reduce the systolic pressure. Why is it that diastolic pressure is more important for you?
Sir, that is because diastole is the time when the coronaries get the blood supply. So, sir, the myocardial perfusion can.
Monica, one more thing. Just yes, sir has said the blood pressure is about 200 by 120. So, because white coating effect and you are given a small dose of midazolam, it has decreased. And this physician says that I will going to manage this case. Go ahead with the surgery. What you will going to do it? What is the implications of this increased blood pressure? Why are you worried about this increase in blood pressure as far as your cataract surgery is concerned?
Sir, increase in blood pressure is also associated with increase in intraocular pressure. Yes, and so, sir, there will be, so there can be a hemorrhage, or there can be,
one more thing. What is meant by ocular perfusion pressure? What do you mean by ocular perfusion pressure?
Sir, ocular perfusion pressure is MAP minus intraocular pressure. That is mean arterial pressure minus intraocular pressure, which is the pressure at which the retina and the optic nerve are they receive their blood supply. So sir, if there is any
worried about that? Are you worried about that?
Yes, sir. If there is any increase in the intraocular pressure, then perfusion pressure will decrease and can cause
what is normal intraocular pressure? What is the normal intraocular pressure?
So 16 plus minus 5 millimeters of mercury. And if it is more than 25 millimeters of mercury, we can label it as intraocular.
Are you worried about that?
Increased.
When sir, this situation, sir has said, so you are worried about the ocular perfusion pressure also, you have to be worried, and you have to postpone the surgery till the optimization of the blood pressure is done. I think so, sir. Okay, sir. Mallikarjun, sir.
Very good, very good. She was right. Can
sir.
you tell something more about IOP? You said the normal pressure is 16 plus minus 5. So the normal pressure is about 10 to 20. What are the other effects of increased ICP? What happens if you are doing a surgery in a raised intraocular pressure?
So there can be a protrusion of the orbital contents if there is an open eye injury, or whenever there is a corneal transplant, full thickness corneal transplant, then the intraocular pressure is in direct contact with the atmospheric pressure. So there can be eventuation of the orbital contents.
Okay, then once you said about intraocular pressure, you have to know what the anesthetic induction agents, your narcotics, your inhalational agents, which have an effect on the IOP. Which would you like to use, which you would like to avoid to have any great changes? You don't mind reducing the IOP, but you don't want the IOP to go up. So what are these drugs which can affect the IOP?
Sir, all the inhalational agents, they decrease intraocular pressure.
No, sir, sir, as to which are the drugs which you can avoid?
Which can avoid.
Yeah.
Sir, amongst the inhalational agents, we must avoid halothane.
What happens with inhalation anesthetic agent, especially as far as the IOP is concerned? Is it safe to use inhalation anesthetic agents or not? Inhalation anesthetic agents, generally what they do, whether it decreases the IOP or increases the IOP?
It decreases IOP.
Oh yeah, what are the drugs which you can avoid? Any other drugs?
Sir, we should avoid succinylcholine and...
Yes, succinylcholine will be avoided. Any other drugs?
Ketamine, sir, although some new studies say that it doesn't.
Yes.
Okay, but for exams, you can always say avoid ketamine.
Yes.
What about the muscle relaxants? Anything other than suxamethonium, non-depolarizers?
The pancuronium should be avoided because it is long-acting and histamine releasing.
Okay. So you should always know that IOP is an important factor during eye surgeries, especially when what are the anesthesia techniques which can result in raised IOP other than the drugs?
So
your procedure, you are doing your induction, you are doing everything though. What are the precautions you will take to decrease the IOP, starting from the mask ventilation?
Yes. So the external pressure, which can be because of the mask, which is covering the eye, it can increase the IOP. Then during laryngoscopy, if the duration is
pressure, you should say pressure on the eyeball should be avoided. So you have to unnecessary undue pressure. The hold in the mask should be perfect. Otherwise, you will going to have undue pressure on the eyeballs. Eyeballs should be protected during the induction, during your mask ventilation. You should be very careful as far as the eye is concerned. Okay, one thing. Okay.
Then, sir, during laryngoscopy, the duration should be smooth and short duration, less than 15 seconds. Sir, preferably video laryngoscopy can be used. Then, sir, at the time of extubation.
What you said? What you said? Video laryngoscopy
should be preferred.
Video laryngoscopy.
Sir, if we have a choice between direct and video laryngoscopy, then we must.
So you want to avoid the laryngoscopy?
Yes, sir.
By the laryngoscope. Okay. But most of the time, it is not an easier technique compared to your laryngoscopy. Shorten the duration of your laryngoscopy. Do a quick, smooth intubation. Use some drugs which can prevent.
Intubation response. Attenuation of the intubation response is very, very important. Yes. Okay. So you attenuate the... Yeah, you have to attenuate because this is a hypertension patient. You should take care that the hypertension crisis should not happen, and you have to attenuate this with some drugs. What are the drugs you can attenuate the hypertension intubation reaction in these patients?
So we can use IV preservative-free lignocaine in the doses of 1 to 1.5 mg per kg 45 seconds before the laryngoscopy. Then we can also use adrenergic inhibitors like labetalol, or we can use sodium nitroprusside or nitroglycerin. But mostly lignocaine does a good job.
3 ml of 2% lignocaine, 90 seconds before your laryngoscopy has to be given IV. These days, we also use fentanyl 1 to 2 micrograms, about 30 seconds to 45 seconds before. Yes, we have dexmedetomidine. So many drugs are there, and you should make sure that when you are doing a procedure like this in a hypertensive patient, you don't want the IOP to go up. You see to it that you do these things very carefully. Okay.
Bottom line is gentle laryngoscopy. That is very, very important.
Yeah. Gentle laryngoscopy, short duration, well lubricated tube.
Yes, sir.
Yeah, okay. Go ahead.
Ocular examination. The head posture was straight and erect. Both the sides of the face were symmetrical. Ocular symmetry was symmetrical. On bedside visual acuity, projection of.
Skip this.
Yeah. Are you routinely examining these eye examinations? So usually this anesthesia part, especially our postage, they will be given so the diagnosis will be given. Only thing is, for the sake of the completion, you have to examine, especially for the short procedure, you may not require. And as far as you are not an ophthalmologist, you are an anesthetist. So you examining the patient as an anesthetic point of view, and ophthalmic anesthetic implications of ophthalmology you have to know. Okay, Manika? Sir, yes, yeah, that's why sir has said skip this slide.
Any positive findings in the CNS?
No, sir.
CVS?
No, sir. So
okay.
No systemic positive.
Sir, one more question, sir. One more. As far as the CNS is concerned, any relevant history which is relevant to the cataract surgeries? CNS examinations.
Sir, in the meningeal irritation sign,
what are the signs of vertebrobasilar insufficiency? Is it important, vertebrobasilar insufficiency in these patients? No, vertebrobasilar insufficiency. If the patient is having suddenly dimness of vision, sudden loss of vision after getting up from a sleep, is it important?
Not right.
No, because these patients may go in for sudden loss of vision in these patients also. So because of the atherosclerosis and because of the luminal narrowing of the vertebral artery, these patients, so you can expect some amount of problem in the vertebral, say a problem in the eye also. Okay, that you should inquire. Okay.
So
okay, summarize. Sorry, sir. Sorry.
No. Go ahead, sir.
Okay, sir. Mallikarjun, sir, go ahead.
Yeah. So you have a patient who's posted for cataract. What are the choice of anesthesia you have in this patient?
Sir, before that, sir, Mallikarjun, sir.
Yeah.
Sir, would you like to go for any investigations? Because before that, sir, yeah.
When I ask you what anesthesia, you are supposed to tell the
yes, okay,
investigation.
Sir, okay.
What investigations you want? Routine.
Sir, routinely for ASA 1 and 2 patients, special investigations might not be required, but for
Monica, one more thing before going on to the one investigation parts. This is a patient with a 67-year-old male, hypertension for 8 years with antihypertensive medications, presented you for a cataract surgery, right? This is the case scenario you are going to give in it. So for what is the next, how will you going to prepare this? How will you going to do it? So when you are going to call, whether you are going to have an array of investigations, okay? So blood routine investigation and special investigation like that, or is there any caveat? What are the pre-anesthetic evaluation during the pre-anesthetic evaluation? What is the recent guidelines saying that regarding the pre-operative investigations in these patients?
So recent guidelines say that for ASA 1 and 2, no investigations, no routine investigations are required. But
okay.
If the patient has any medical illness, then investigations appropriate to the medical illness may be taken up. Like for
one thing is, this is a very low risk surgery. The cataract surgeries are considered as a low risk surgery, but the patient is a high risk patient. Two things contrast. It's a low risk surgery and the patient is a high risk patient. So there are two schools of thought regarding the pre-anesthetic evaluation. One says that there may not be any requirement of investigation and they can go ahead with the regional blocks. The second school of thought say that you have to go for a full investigations. So starting from everything, and patient should be in a optimal medical conditions during the surgery. Okay, there are two schools of thoughts, but as far as our guidelines is concerned, as far as recent, because of patient safety and medical legal purpose. So just take it this medical legal purpose, as far as patient safety is concerned, you have to go ahead for a normal investigation. You have to go out for routine investigations, right? You have to go for routine investigation, and patient should be prepared as an optimal condition at the time of surgery. Okay, sir, Mallikarjun sir.
Yeah, go ahead with your investigations now. You always in the exams when they ask what investigations you want to do, you can always say that I would like to do HBTC, DCSR, urine albumin sugar micro, blood urea creatine, blood sugar, chest X-ray, ECG. These are the routine things what we do. And for every case, you can just go on repeating this. No examiner will say no for it. Then what are the special investigations you want to do? Of course, you have a thyroid patient, you have a cardiac patients, then you can add on. These are the routine investigations which we do in almost every patient has. Manjunath sir said that because of our constraints, medical legal problems, we would like to have these basic investigations done in all the patients. Okay, when you did all these investigations, they are within normal limits. Now, how about you go about preparing this patient for an anesthesia? I am not still saying whether it's general or regional, but what will you do on the previous day? All investigations are within normal limit. The BP is under control. So what you're going to do on the previous night?
Sir, I would like to prescribe an anxiolytic for the patient, and first I will take an informed written consent. I will give the NPO orders, the 8 hours for solid and 6 hours for semi-solid and 2 hours for clear liquids. Then I would like to ask the patient to omit the morning dose of ARB. Sir, it is an angiotensin receptor blocker, so I would like to skip the morning dose of.
There are two things. What is actually said about antihypertensive drugs, and which are the drugs you want to skip and why? In general, what you do with your antihypertensive drugs in a hypertensive patient before surgery?
Sir, in general, ACE inhibitors and ARBs are the ones which we skip before the surgery, on the day of the surgery, on the morning of surgery, and sir, rest all are continued.
Okay, why you want to, is it always that you want to skip your AC inhibitors? Are there two schools of thought?
Yes, there are two schools of thought, because one school says that it might cause it might cause hypertension intraoperatively, and the other might say that it causes catecholamine resistant hypotension.
So what is your school? In your hospital, what your consultants follow, what your teachers tell you?
Sir, for small doses we continue, and for minor surgeries we generally continue.
One more thing, surgeon says that this is a small surgery, I don't require any investigation, I don't require any. So only thing is you just come and stay behind me and say near the patient, I will going to go ahead. What your opinion on this? Usually this is a thing happening, especially cataract surgeries. The surgeons, they will going to give the block and they will going to do the surgeries. They said, ask the patient to take full breakfast and come for the surgery. Okay, they will going to say that you have your food and come for the surgery because you are going to have a fainting attack. So you have to have a full stomach. So take full breakfast and you take all the medications, and there is no, they will go to advise the patient. This is the commonest things happening in our institutions, because we as anesthetists will go as a standby anesthesia. That is called standby. So what your take on this? Would you like to go for a, would you like to go for a
surgeon to keep the patient's NPO, no matter, so because the patients are high risk, no matter the surgery is low risk, but then the patients are high risk and might require airway handling or sedation also at any time. So sir, the entire pre-operative assessment should be thorough with sir, the adequate NPO should be maintained.
Okay, you are called upon suddenly in the theater. Our patient is not cooperating, the block has failed. Please come and give sedation or anesthesia. What will you do?
Yeah, this is a typical situation, sir has said. This is a typical situation where we are calling for, we are called, especially as a ophthalmologist will going to call you like this.
Sir, I will check for the vitals and for the history. I will also ask for the history of the patient, if the patient has any comorbidities, and sir, accordingly, if allowable, then I will give a benzodiazepine.
Make sure that the patient is fasting make sure that the patient's vitals are normal. Get a quick history about the patient. If you have any doubt, you say that I am not very confident going ahead with this case because the patient has not followed strict NP orders. As I said, they usually come with their breakfast and then are posted. So always see, most of the situations we are never called in, unlike this. Suddenly, okay, this is one situation where you are asked to come and give general anesthesia. There is another situation they call you. Patient is having bradycardia. What are the causes? We are running short. We have just another 4 minutes. Sir, we'll try to finish it in
Yes,
time.
sir. Yes, sir. So,
what do you think the bradycardia could be and how do you prevent it?
So bradycardia may be because of the oculocardiac reflex intraoperatively, or maybe because the patient was already on a beta blocker and it got exaggerated.
Okay, this is an oculocardiac reflex. What is it and how do you prevent it? How do you manage it?
So oculocardiac reflex is trigeminovagal reflex, which was introduced by Ashnell and Dagnini. And sir, it is usually due to traction of the extraocular muscles, or even the extraocular of the intraorbital contents like the globe or the periosteum. Also, it occurs most commonly in pediatric patients during strabismus surgery, mostly with the traction of the medial rectus.
What about in old age? Old age, does it not occur in old age patients?
Sir, it occurs because mostly now cases are, sir, it can occur whenever there is a traction on.
Whenever there is any pressure on the eyeball, or even during giving a local anesthetic agent, sir.
Yes,
the local anesthetic agent also they will going to cause oculocardiac reflex. You should be very careful of.
Yes.
Yeah. So what are the symptoms of oculocardiac reflex?
Sir?
What are the symptoms?
Sir, it presents with bradycardia, arrhythmias, or junctional rhythms, or asystole.
I said
along with
the findings. How do the patient present? How will the patient react to a bradycardia? Nausea, vomiting?
Nausea, vomiting, simple.
Right? That is the symptoms. These are the findings. How do you treat it?
So first we will ask for to stop the manipulation of the globe. Then we can we will check for appropriate ventilation and oxygenation, and deepen the plane if required.
No, you are given. Say this patient has given a regional block. Usually under regional block, the patient will be undergoing surgery. So manipulation is stopped. You give atropine.
Atropine.
What is the dose? Yeah.
Atropine in 7 mics per kg increments.
Okay.
Okay. Will repeated oculocardiac reflex happen?
So it generally doesn't happen because of the fatigue of the reflex arc of the cardio inhibitors.
Remember that the first attack is the worst, then subsequently the brady is much less. Yes. But this is one situation where you are called upon to tackle the patient. Other situations where you are called upon in a ophthalmic OTs, the patient is restless, patient is having hypertension, patient is having hypotension, please come and do something. And one last few question is, when you give general anesthesia, you want to keep the patient spontaneous or you want to ventilate the patient?
Sir, I would like to ventilate the patient.
Endotracheal tube, or you want to use a LMA? Why? 2 questions you have to answer.
Sir, I would like to use an LMA because it will prevent the effects of laryngoscopy and endotracheal intubation and extubation. So the increase in IOP will be avoided. Yeah. Then, sir, so the other question was.
So LMA, would you like to use LMA in this patient?
LMA, sir. I would like to use LMA because sir, the increase in IOP will be avoided.
The other question is, you want to keep the patient spontaneous or ventilate?
Sir, I would like to ventilate the patient because if I keep the patient spontaneous, then the chances of increase in IOP are higher, sir. Because of
carbon dioxide retention and oxygen. If you keep the patient spontaneous, if the patient hypoventilates, there will be accumulation of carbon dioxide. There will be increase in your pressures. Okay. Thank you, sir. Your last question for her.
Yeah. Monica, what is the regional, just enumerate the regional blocks which you have, we can give for these patients. What are the enumerate the blocks?
So retrobulbar block, peribulbar block, subtenon block, So these are the 3 regional blocks which we can give.
Have you given any blocks?
No, sir.
What are the recent advances? Recently, can you give? Recently?
Yes, so we can give ultrasound guided. We can give these blocks ultrasound guided, so they are more safer and the needle trajectory can be seen. It is just that special probes are required.
Why special probes are required?
So because so there are two index. Yeah. So there are two index, that is thermal index and some mechanical index. So the thermal index is the level the amount.
The tissue temperature will be raised because of normal. If you use a normal transducer, the tissue temperature will be raised. Yeah, that is the one thing.
Short duration of less than 90 seconds.
Yes, very good. So less than 90 seconds. So you have to use a different. Probe for S1. Okay, one thing. What are the complications as far as your normal these things are concerned? Regional blocks. Complications of regional blocks. That's a pet question for the examiners.
So for retrobulbar block, most commonly there is retroorbital hemorrhage. There can be ocular perforation. Then, so because of this, then there can be central retinal artery occlusion. So for the peribulbar block,
one more question I'm going to ask. The patient has given a retrobulbar block. Okay, they use a local anesthetic agent. They given a retrobulbar block. Patient has stopped breathing. Okay, it is not responding. What is your take on this? How will you going to manage? What is your diagnosis? Patient has stopped respiration. He has stopped respiration, and he is not responding to your commands. The moment you are given the local anesthetic agent, he has stopped breathing and he is not. He has lost his consciousness. What is your problem? What is the problem? What might have caused this?
So, due to brainstem.
The injected local anesthetic can enter into the subarachnoid block. So it can enter through the optic nerve sheath. That is the one commonest dreaded complications. Okay, so patient can go for respiratory arrest immediately. So you have to be very careful. One thing. Second thing, suddenly patient may have going for systemic toxicity because of the intra-arterial injection. Conversions may also be happen. So you should be very careful as far as the dreaded complication is concerned. Okay. Sir, Mallikarjun sir.
Thank you, Manika. You have done a good job. I think you are well prepared for your exams. All the best. Thanks to the ISA Kerala. Thanks to Venkatgiri et al. And thank you very much, Manjunath sir.
Thank you, sir. Thank you, Thank you, Monica. Tanika, you have done well. Good luck for your examinations. Okay. God bless you. So, Mallikarjun sir, thank you, sir. Thank you very much. It is so nice to sit with you, sir. Mallikarjun sir. It's a senior faculty. Now I remembered you, sir.
Finally. Okay. Happy about that. And all the best to all the postgraduates of Kerala also.
Okay. Thank you, Dr. Rajesh and Benil and Venkatgiri sir, for giving us this opportunity to.
Mallikarjun. Mallikarjun was my senior, my teacher, and I was doing. Did very well. Namaskara.
Namaskara, sir. Venkatgiri sir, namaskara, sir. Thank you for giving me the opportunity, sir, for this. Okay, sir.
Last year also, you invited you did well. Thank you.
Yes, sir. Thank you, Rajesh, and thank you, Benil. Okay, sir.
Thank you, Mallikarjuna sir. Thank you, Manjunath sir. Thank you, Manika, for that wonderful discussion. Over to Jitin for the next session.
Our next session is a short case presentation on adenotonsillectomy. This session will be chaired by Dr. A.L. Meenakshi Sundaram, Honorable Dean of Government Medical College, Peramballur, and Dr. Gurudat sir, Professor and Head of the Department, JSS Medical College, Mysore. We welcome you to chair this session, sirs. And the case will be presented by Dr. Kirti P., PG student from Lakeshore Hospital, Ernakulam. We have 45 minutes for discussing this case. Over to the examiners.
Thank you, Jitin. Thank you very much. Again, good morning to everybody. So after a healthy, fruitful discussion by Dr. Mallikarjun and Dr. Manjunath, so now we will be going in for tonsillectomy discussion. Okay, Dr. Kirti is there.
Yes, sir. Good morning, sir.
You're there? Yeah.
Yes, sir. Yes, sir. I'm there. Good morning, sir.
I don't know about Dr. Meenakshi Sundaram. He was telling me that his net has got some problems. Sir, are you there?
Yeah, I'm here. I'm here.
Good morning, sir.
I'm not able to see you.
Sir, I'm here. I am seeing you. Usually you see only handsome people, so I am not seeing.
So, good morning, sir. Minash sir, Sudhar, good morning, sir.
Good morning. Manjunath, I was listening to your entire questions and answer session. So I was here for the past 45 minutes, but here it is fluctuating. Power is fluctuating. So safety first. So I have informed previously Binil and Dr. Gurudat.
Yeah, so Minash Sundaram, sir, because of your smartness, people power is also fluctuating, sir.
My power is stable only. My power is stable. The players.
No, because power is fluctuating because of you are sitting, smart people sitting there, sir.
Anyway, first of all, I thank Kerala ISA not only for this opportunity, they have made it as a Zoom examination. Because if Dr. Gurudat and myself, if we are doing the examination physically, I will be having a problem because usually I am having the habit of not sitting with handsome people. So now it is an opportunity that I can operate through Zoom. And Dr. Kirti, go ahead.
Yes, sir. Good morning, everyone. Today I'll be presenting a short case on adenotonsil enlargement. 8-year-old male child born of non-consanguineous marriage with full-term normal vaginal delivery coming from Chertala. Informant being mother, which is reliable, came with chief complaints of recurrent episodes of sore throat lasting for 8 to 10 days for the past 2 years. The child was having 5 to 6 episodes per year, and all the episodes were associated with decreased food intake, and it was relieved on conservative management. History of snoring for the past 2 years, history of mouth breathing for the past 6 months, and presently the child came with complaints of sore throat for the past 1 week, and the child is on oral antibiotics for the past 4 days. No history of fever, no history of bad breath, no history of epistaxis, no history of bleeding gums, and no history of ear pain or reduced hearing. Antenatal, natal, and postnatal history uneven full. Developmental milestones attained for age. On general examination, the child is alert and active. Weight is 25 kgs. Height is 122 centimeters. Vital signs, heart rate is 96 per minute. Blood pressure 98/62 millimeters of mercury recorded on the right upper limb. Temperature is 97.6 degree Fahrenheit. Head to foot examination. The child was having adenoid faces, bilaterally enlarged grade 2 tonsils, and bilaterally enlarged jugulo-digastric lymph nodes. On airway examination, mouth opening more than 2 finger breadth, Malamati classification grade 2, temporomandibular joint mobility normal, no loose teeth, neck movements normal. On systemic examination of all systems within normal limits. Summary: 8-year-old male child with acute and chronic adenotonsillitis with no features of toxemia, posted for adenotonsillectomy. Thank you.
Thanks, Dr. Kirti. Now you have mentioned that the child is posted for adenotonsillectomy. So, what anesthesia you prefer for this patient?
I prefer general anesthesia for this child, sir. General anesthesia.
So, what investigations you will do before proceeding with general anesthesia for this patient? For this patient.
Yes, sir. I'll do a complete blood count. I look for hemoglobin, BT-CT, total count, and a platelet count, and ESR, and PT-INR for the child, blood grouping. And in the present scenario, I'd like to do a COVID antigen testing for the child.
Right. Then what pre-medication you will give?
For this child, pedicloral 75 milligram per kg. So it is 10 ml of pedicloral can be given for this child.
Then you don't want to give any other pre-medication.
Yes, sir. Oral midazolam can be given.
See, Dr. Kirti, 1 second. See, now clinical examination is entirely different. See, we are asking you how you will do. We are not asking a theory part. Midazolam can be given, diazepam can be given, lorazepam can be given. We want how you will proceed. We want to analyze whether you will anesthetize the case safely or not. You tell me what you will do.
Okay, sir. I will give an IV midazolam 2 milligram for the child. 30 minutes before shifting to the operation theatre.
Pedicloral when you will give?
Pedicloral, 45 minutes before. Sir, if I am giving pedicloral, I'll give 45 minutes prior to shifting the child to the operation theatre.
See what you are going to do. You will give pedicloral 45 minutes before and midazolam 30 minutes before.
No, sir. I'll give either one of these. I'll give
pedicloral, telling you what you will do. What you will do, I am asking. Okay, because sir, when you are doing a case, we will not be by the side to guide you. Whatever you like to do, you can do. Now you tell me what you will do.
I'll give oral pedicloral syrup. 10.
So only oral pedicloral. So yes, then sir, you are not bothered about any anti-sialagag.
Anti-sialagog will give, sir, when the child is in the recovery, I'll give injection glycopyrrolate 0.2 milligram IV.
What is the meaning? What is the, see, I want you to tell me as a pre-medicant whether you will use any anti-sialagag or not.
Yes, sir. I will use an anti-sialagog.
See, for my sake, you don't answer. I am asking in your institution whether you are giving or not.
Yes, sir. We are giving glycopyrrolate.
Then why you are not telling that? If you are giving glycopyrrolate, then you are not. Then it means how many cases of adenotonsillectomy you have anesthetized?
Sir, along with the
see, simple question I am asking. As a trainee, how many adenotonsillectomy cases you have anesthetized?
Sir, I have been with the consultant and we have done around 8 to 10 cases.
For 3 years?
No, sir, I am just entered final years.
So for 2 years you have done 8 cases. That is so good. For that 8 cases you have given pre-medication or not?
Yes, sir, given pre-medication. Oral pedicloral syrup and glycopyrrolate as an.
What is the dose of glycopyrrolate? What is the dose of glycopyrrolate?
0.01 milligram per kg.
Why you are not preferring atropine? Why you are not preferring atropine?
Atropine is not because glycopyrrolate is having minimal cardiac effects and glycopyrrolate does not cross the blood-brain barrier. So it is having more anti-sialagog effect than atropine.
Good. So which is a tertiary ammonium compound? Which is a quaternary ammonium compound?
Glycopyrrolate is a quaternary ammonium compound.
Good. Whether you want to give any narcotic as pre-medication?
Since this child is having an adenoid hypertrophy also, I would like to avoid a narcotic pre-medication.
So then how will you anesthetize? You are given pre-medication glycopyrrolate. Then what you will do? Connect all the machines, check anesthesia machine, everything is done. How yes, you will proceed? How you will proceed?
I'll set the operation theatre with all the emergency drugs kept ready. Atropine loaded according to the child's weight. Like I will.
Why atropine is loaded? Why atropine is loaded?
Atropine is loaded for the anticipated any bradycardia.
See, you said you will avoid atropine because it is having problem. Why you are anticipating a bradycardia? You are given glycopyrrolate.
Yes, sir.
Then why you are anticipating bradycardia?
So usual emergency drugs to be kept ready.
See, emergency drug means you can say I will load atropine, I will load adrenaline, I will load amiodarone. So many things you can say, but you are very specific about atropine. That is the reason I am asking why you are doing that.
Okay.
How will you proceed?
Anesthetics drugs to be loaded and labeled, and all the airway equipments to be checked, and correct size ETT for this child.
That and all done for you. I have done that. Everything is ready. Now you start injecting drugs because we are having as it's a short case, we are having short time duration.
Okay, sir. Okay, sir. After IV cannula, after ensuring that IV cannula is having a good flow, I'll give after pre-oxygenating the child, I'll give fentanyl 50 microgram for this child and propofol 50 milligram.
What is the dose of fentanyl? What is the dose of fentanyl?
Fentanyl 2 microgram per kg.
So you said 15 or 50?
50, 50, sir.
Right.
50.
Then why you are giving narcotic? This child is having adenoid. Why you
Yes,
are
sir.
giving narcotic now?
Sir, as a pre-medication, I will avoid narcotics, sir, to decrease the chances of airway obstruction prior to entering the operation theater. On the table, to decrease the hemodynamic responses during intubation, I would like to give fentanyl 50 microgram. Then propofol 50 milligram is given, and after when we were able to confirm ventilation, vecuronium 2.5 milligram.
Repeat. You will give fentanyl 50 microgram. Then
yes, fentanyl 50, propofol 50 milligram.
Propofol 50 milligram.
Yes, sir.
Then
if I'm able to ventilate the child, I will proceed on.
What is the meaning if I am able to ventilate the child? What is the meaning?
Sir, if there is any, since the child is having adenoid hypertrophy, if there is any difficulty in mask holding, or if I am not able to ventilate the child, so risk after giving relaxation, chances of desaturation is high. So after confirming,
ventilation means you want to try face mask ventilation, is it?
Yes, sir. Face mask.
Then you have to be very specific about that.
Okay, sir. Okay. With face mask ventilation, if I am able to ventilate the child, I will proceed on with vecuronium. 2.5 milligram can be given to this child, and I'll ventilate for 2 to 3 minutes, and after that, oral endotracheal tube.
Why you are not preferring succinylcholine?
Succinylcholine, because of the succinylcholine is avoided unless it is a anticipated difficult airway.
But Kirti, I think you are getting confused. Confused with the language or with the subject, I don't know. You anticipate respiratory obstruction for this boy, is it?
Yes, sir. Yes.
You expect a respiratory obstruction.
Yes, sir.
By giving a relaxant.
Yes,
By
sir.
giving then vecuronium is a relaxant or not?
Yes, sir. Vecuronium is an intermediate acting muscle relaxant.
So succinylcholine, intermediate acting or long acting?
Succinylcholine is a short acting depolarizing muscle relaxant.
And you are worried about the short acting, but you are confident about intermediate acting relaxant, is it? I don't know. I think for this examination purpose, you are answering differently. You are doing in your institution like this. For all tonsillectomy cases, you are using vecuronium in the first onset itself after propofol.
Yes, sir. Vecuronium.
No, I am asking in your institution whether it is a routine practice that you are using only vecuronium for intubating the patient.
Sir, since it is an adenotonsillectomy case.
Dr. Kirti, my question is very simple. It is only yes or no. In your institution, for all tonsillectomy cases, you are using propofol and vecuronium, is it?
Propofol. For some cases, we use choline also, sir.
That's what I'm asking. Then why you are not using succinylcholine for this patient? I don't know. Right, it is your choice. You are using vecuronium. Then what you will do? You are ventilating 3 minutes. Then what you will do?
Then I'll insert an oral endotracheal 6 millimeter internal diameter oral endotracheal tube is inserted, and I'll confirm the position by first 5-point auscultation and end-tidal carbon dioxide.
What endotracheal tube you will use? 6 size means whether it is cuffed or non-cuffed.
Oral cuffed endotracheal tube, 6 millimeter internal diameter.
Regular PVC.
Yes, sir. Regular PVC.
Regular PVC. Then how will they do tonsillectomy with that oral endotracheal tube?
Sir, after placing the Boyle Davis mouth gag. We usually position it in the corners of the normal positioning, and we usually change the tube to the other, when they are doing the opposite side, we usually change the tube position. Since we are using a normal endotracheal tube, conventional endotracheal tube. Since
if you say conventional endotracheal tube, whether you are having any non-conventional endotracheal tubes?
No, sir. This meaning
whether you have ever heard of a reinforced endotracheal tubes?
Yes, sir. Reinforced is South Pole, North Pole tubes, like oral ring adder L1 tube, which it is used for adenotonsillectomy, so that it can be fixed in the midline with the gag in between in the gag.
Have you ever used RAE tubes or Oxford tubes?
RAE tubes we haven't used, sir.
Regular endotracheal tube you are using, and you are pushing the tube to one side.
One side.
Right. First they will do tonsillectomy or adenoidectomy in your institution.
First adenoidectomy, sir.
It will be done. Right. Whether you use a pharyngeal pack?
Yes, sir. After doing an adenoidectomy, we'll use a pharyngeal pack.
You use a pharyngeal pack, or surgeon will use after adenoidectomy?
Surgeons will use a pack.
So before that, you will be using only cuffed endotracheal tube. Not in addition, you will not pack the surrounding areas.
Throat pack we used to keep, sir.
Regularly you are doing that?
Yes, sir. Throat pack.
Then once surgery is over, what you are going to do? What are all the monitoring parameters you will measure?
Yes, I'll measure on ECG, non-invasive BP, temperature monitoring, pulse oximetry.
What temperature monitoring? What temperature monitoring you will do? Why temperature monitoring?
Temperature monitoring to avoid hypothermia to the child. And
I think 8-year is not a child, is a boy.
Boy.
Third year student. Third standard. Third standard.
Okay.
But you will use temperature monitoring, is it?
Yes, sir.
You can. So what probe you will use for the temperature monitoring?
Temperature, skin probes is kept. Skin for the we have a probe, and then
that means you have never monitored a temperature in your institution. Just for me, you are telling that. It's okay. You will monitor the ECG, then you will monitor the temperature, then
ECG, pulse oximetry, BP, and end-tidal carbon dioxide.
Oh, that also you will measure, is it? ETCO also you will measure in your institution.
Yes, sir.
Yes, right. Then once surgery is over, what you will do?
At the end of surgery, make sure that there is no active bleeding from the tonsillar site. And if there is any active bleeding, we can give a suction under vision, and to before planning for extubation, I will confirm that there is no active bleeding. That is, then I will plan for an awake extubation. So after ensuring the child is making spontaneous attempts to breathing, I'll give a reversal with a neostigmin, 50 mics per kg. For this child, 1.25 milligram I will give neostigmin, and glycopyrrolate 0.2 milligram I will give.
Then what will do?
Then after reversal, if the child is taking adequate breaths, I will try to extubate the child in lateral, in head down lateral position, and yes, sir.
See,
making sure.
Use 1 minute, Dr. Kirti. You said you will be using propofol as an induction agent.
Yes, Yes, sir.
Why not thiopentone?
Sir, propofol has propofol is short acting, and with it is a long half-life of propofol is less when compared with the thiopentone. And thiopentone has the risk of laryngospasm, since the level of anesthesia is not deeper when comparing with propofol. So risk of laryngospasm is more with thiopentone, and recovery will be delayed with the thiopentone when compared with the propofol.
But before injecting propofol, you have to inject one drug, because what are all the complications of this injection of propofol? Commonest side effect?
Commonest propofol pain on injection. It causes hypotension, myocardial depression.
No, commonest side effect is pain.
Yes, pain.
That too for an 8-year-old boy. Whether you will take any precaution to alleviate that pain?
Lignocaine 1.5 milligram per kg. For this child, 3 ml of Xylocard can be given, or in the propofol syringe, we can load 1 ml of Xylocard and then load propofol. So it will be 1 ml per 1 milligram per ml.
Which is preferable, lignocaine first followed by propofol, or lignocaine propofol cocktail?
As a cocktail, sir. As a cocktail.
Is it? Which is preferable?
Sir,
you have never used lignocaine, is it?
Yes, sir, we have used it.
Well, but if you have used it, you would have mentioned it. But now we are on the stage of extubation.
Yes.
See, the advantage is you initially give lignocaine, because if you are giving a mixture of lignocaine propofol, both are going to act at the same time. Pain will be there. You first give a shot of lignocaine. What is the added advantage of using lignocaine in addition to this alleviation of propofol pain? What is the added advantage?
Added advantage.
You said you will be using fentanyl for that. But lignocaine also does the same.
Lignocaine it decreases the hemodynamic responses because intubation associated hemodynamic response.
So when such a wonderful drug is there, you have to compulsorily use it, right? At the time of extubation, if the child is coughing, what you will do?
If the child is coughing, to deepen the plane.
See, you have extubated. Now I am saying you have extubated, child is coughing.
Yes, sir. Dexmedetomidine. I will give a dexmedetomidine up to 10 mics. I will give.
Yeah, I will give you a clue. I will give you a clue. If you are saying so many drugs like this, then the examiner will drag you to that level. Then I will be asking you, what is the dose of dexmedetomidine? Why not midazolam? Why not this? Why not that? See, already you have used fentanyl, pedicloryl. You are saying dexmedetomidine. You are not saying, first of all, you will find out why the patient is coughing.
Yes.
That you have never said. When I am asking, just when the patient is coughing, you are going to use dexmedetomidine. What is this? Then now I will ask you a practical question. See, you have extubated. The surgeon says there is a ooze in the tonsillar.
Can I take over? Or?
1 second, there is a ooze here. Now I am going to hand over. Yeah. Now you are going to hand over. The surgeon says there is a ooze on the tonsillar area. He wants to check whether there is a significant bleeding or not. What you will do? Just you want to check. I am not saying post-tonsillectomy bleeding. You are extubated. The surgeon says, I want to recheck. Now, what is your plan?
After extubation, sir?
Yes, you have extubated. The surgeon says, you have also checked. You said, I will check for bleeding, everything. You have extubated. Yes. The surgeon says, I want to check. This is just like a check curettage obstetricians are doing. He wants to check. Post-tonsillectomy bleeding will occur even at the end of 6 hours or 4 hours. So that is different altogether. I'm asking, he is having a doubt. He wants to recheck. You have given neostigmine, glycopyrrolate, reversed. Now, what is your plan of anesthesia?
Now, if it is just checking, I'll give a propofol 20 milligram propofol I will give for this child, sir. If they just want to check.
Then he will apply a bile to his mouth gag. Then only he can check. Will it be possible with propofol rigidity?
No, sir.
So even in this, if you are getting stuck, then if the patient is going to bleed, that itself is going to be a problem. Routinely, the surgeon says, I want to check, because once extubated the patient, they will be having a doubt, right? Now you have to think an answer at the end. Now I want to ask you, if the patient is having cough and a fever in the preoperative examination, whether you will take up the case or not, this patient.
This patient, if there is a cough, I will ask whether it is productive cough or not. So if there is a productive cough and associated auscultatory findings like wheeze and audible sounds are there, I will not take this child as an elective case.
My question is no added sounds, no rolls wrong. The patient is having fever, cough, whether you will proceed with the case or not.
Fever, cough, we can proceed with the case.
Sorry.
Unless it is not a productive cough.
The fever, no. If there is a fever, please wait. If there is a fever, you please wait, because you may not be knowing whether there is a bronchial irritability or not. When there is an active focus of infection, with substantiated by your total count, then you please wait. That is the only indication for postponement of the surgery. If the child is febrile, you wait, because the surgeon will give preoperative antibiotic for 3 to 5 days. Then they will take up the case. As it is an elective procedure, it is always better to wait if it is a febrile child with the productive cough, as you said. Now my time is now, the alarm has come for me. Now I request Dr. Gurudat to take over the patient, as well as Dr. Kirti.
Thank you, sir. Another, I think we have how many minutes?
20 minutes more, 20 more. 20 minutes for you.
Yeah. 22 minutes. I think it is 48, sir. Another 12 minutes are there.
Sir, 12 minutes, sir.
Another 12 minutes. Okay, no problem. Okay, Kirti, you have just now extubated the patient, and suddenly the patient is going in for a stridor. So how are you going to manage? And what you expect the patient to have, and how do you manage this particular situation?
Sir, I'll suspect laryngospasm in this child.
Very good, very good.
After confirming that, I'll just give 100% oxygenation by giving.
Now what was the position of the patient? You had extubated the patient in left lateral or right lateral, or whatever may be the lateral position, isn't it?
Yes, sir.
Okay, you want to bring the patient to supine posture, or you want to keep the patient in that posture only?
I'll bring the child to supine and I'll give a jaw thrust.
No, better to keep the child in that position only, isn't it? Because it is a secretion draining position, and any secretions would be the first thing that would have produced this extra stimulus to produce this laryngospasm. And usually laryngospasm occurs when? As soon as you extubate, why laryngospasm can occur?
Due to the stimulus, due to the secretions.
But if there is a secretions, every patient will not develop laryngospasm, isn't it?
If the child is having any reactive airway before.
No, that will be bronchospasm.
Yes, sir. Bronchospasm.
Now, one thing you should always understand in the exam when you are answering, you should always answer when you extubate the patient, when the patient is not completely awake. Okay. Especially in stage 2 anesthesia, wherein it is a stage of delirium, where all the reflexes are exaggerated. At that moment, if you extubate the patient, there is always a chance of any slightest of trigger, the patient can develop laryngospasm. That is why it is very important, not just the lateral position. It is always see that the child is completely awake before you take out the tube. So that is very important. Okay, now unfortunately you have extubated the patient when the child was not completely awake. So, and the child has developed laryngospasm. One thing you said that you would like to give 100% oxygen. Okay, then with just 100% oxygen, you are holding the mask, or you are going to, forcibly push oxygen, because laryngospasm means it can be partial or complete. Almost nearly 90% of the laryngospasms are partial. That means there is a chink of opening is in between.
Yes,
unless you force oxygen, oxygen cannot enter there.
Yes,
what you are going to do?
I'll give a jaw thrust and pressure over the Larson's point. And
No, you are giving oxygen. I was asking you, would you ventilate the patient with oxygen, or you just hold the mask with 100% oxygen?
I'll give CPAP, sir. I will give 100% oxygenation through CPAP with the face mask.
It is better to ventilate the patient.
Ventilate the
patient.
patient.
To push the oxygen with a narrow chink of opening that is there in between, isn't it? Many times, yes, even just holding the mask with jaw thrust and then applying pressure and then pushing oxygen itself can relieve laryngospasm. That is one thing you should always realize. Okay, well, you said something about the Larson's maneuver.
Yes, sir.
What is this Larson's maneuver?
Larson's point is through we can give a pressure over the mastoid, between the points of mastoid process, base of the skull and the ramus of the mandible, so that the laryngospasm may get relieved.
Okay, what is the mechanism? Pressure. What is the theory of the relief of the laryngospasm with this? Why, how laryngospasm can get relieved? There are many theories, isn't it? One is that the pain itself. Second thing is, there only the glossopharyngeal nerve is there. Glossopharyngeal nerve is also involved in the laryngospasm along with superior laryngeal nerve. So, because you are compressing the glossopharyngeal nerve, there is always a chance of laryngospasm getting relieved. Okay, now laryngospasm has not been relieved.
Okay, sir.
Still, the patient is having severe distress and is becoming cyanosed.
Yes. I'll deepen the level of anesthesia with the propofol.
Very good.
According
how much
to this,
propofol you will be giving?
To this child, 20 milligram propofol I will give.
Okay, 25 kg child.
Yes, sir. 20 milligram propofol I will give.
Is enough to relieve laryngospasm, right? That means, the child was very light, isn't it? So slightly, yes, if you deepen the plane of anesthesia, so again the laryngospasm may disappear. So that is one thing. So, but still laryngospasm is there. Anything else you'd like to do?
If still the laryngospasm is there, I will try giving a succinyl colon.
Yes. What is the dose?
0.1 to 0.5 milligram per kg is given. So
but
for
is it
this
enough?
child,
is it enough? 0.1 milligram?
0.5, 0.1 to 0.5 milligram.
No, because you would have given neostigmine for reversal, isn't it? Once you have given neostigmine, has it got anything to do with the effect of succinyl choline? What is neostigmine? What does it do? Neostigmine. What does it do?
It acts on the acetylcholine.
It's an inhibitor of acetylcholinesterase, isn't it? Okay. Has it got any effect on pseudocholinesterase also? So it inhibits pseudocholinesterase also. That means when you give regularly succinylcholine of 1 milligram or 1.5 milligram per kg body weight, only 10% of the drug will reach the neuromuscular junction. Almost 90% of the drug gets metabolized by pseudocholinesterase. Now, if you are given neostigmine, even a smaller dose of succinylcholine is enough, because there won't be any functional pseudocholinesterase to antagonize the effect of succinylcholine. That's why even 0.1 to 0.5 milligram per kg body weight may be sufficient to relieve the laryngospasm. Okay. Now, everything is fine. Now the child has been, you could manage the laryngospasm. Okay, the child is fully awake now. And what position you want to keep the child in the postoperative period?
I'd like to keep in the left lateral, head low position, tonsillar position.
Post-tonsillectomy position. What is this post-tonsillectomy position? What should be the upper limbs? How the upper limb should be, the lower limb position?
Left lateral with no pillows under the head, and
so non-dependent upper limb.
Non-dependent upper limb should non-dependent upper limb should be kept below the child's head, and dependent upper limb should be kept flexed, and
no, it should be behind the back of the child.
Behind the back of the child.
The idea here is the child should not, turn to the supine posture. Once the dependent upper limb is kept behind the back, so the child will not be able to turn to the supine posture. The child will remain in this position only. So the non-dependent upper limb, why you keep underneath the head is, or under the face is, so that the child should not completely put its head, to the prone posture and then get suffocated. So these are the two things which you have to talk about. Okay, after about 2 hours, the attendants complain of the blood coming out of the mouth also, and child is also restless. So what do you think now? What has happened? And the surgeon says that he has to take the child immediately to explore. So what do you think the child might have had?
It should be a primary post-tonsillectomy bleed.
Very good. So now the surgeon says, no, there is no time. I have to take the child as early as possible. What are your concerns?
Concerns is since active bleeding is there coming from the mouth, the child, I'll make sure I'll get ready another IV line for the child. I'll assess the child whether the child is responding.
Will the child will allow you to put on another line? Very difficult for children, isn't it? In the first, before only, you should have told about Emla cream in the beginning.
Emla cream, yes.
So that is very important. Okay, now, that already IV line was there. So yes, you would like to assess the amount of bleeding?
Sir, amount of bleeding is difficult to assess in this child since because of swallowing, we cannot assess the amount of exact blood loss. So,
but you can definitely assess based on the signs, isn't it?
Signs, yes, depending upon the tachycardia, tachypnea, amount of urine output, capillary refill time, BP.
So all those things, definitely. Would you, suppose if you think that the child has bled a lot, would you like to ask for even any packed cells to be brought?
Yes, sir. I will arrange for packed cells and start resuscitating the child immediately with crystalloids and colloids. And
fine, very good. Yes, so now, would you like to put a Riles tube? Because you always think it may be a full stomach because the child would have swallowed so much of blood. So would you like to put a Riles tube?
A Riles tube. Initially, I will not put a Riles tube because if there is any clot behind the nasopharynx, it will trigger the bleeding further. So
it's very good because this is one common question most of the examiners will be asking the students for post-tonsillectomy bleeding. You should never put a Riles tube because you'll be putting the Riles tube blindly, and that can dislodge the clot and then can produce profuse bleeding. Okay, now the child has been brought to the OT. Now, how are you going to induce and manage this child?
Yes, I will.
Another 2-3 minutes. Jitin, just 2-3 minutes.
Sir, 2 minutes.
Okay.
Yeah, 2-3 minutes. Yes.
Yeah. Sir, I'll before that I look back the previous anesthetic chart and the size of
you have given the anesthesia.
Since I have given anesthesia, so I will keep ready the tube size 1.5 millimeter lesser than the previous tube used. So I will keep ready 5.5 millimeter oral endotracheal tube.
Right.
And I will start a fluid resuscitation, and I will induce with ketamine.
No, what sort of an induction you will be doing?
I will do an intravenous induction.
Before also you had done intravenous induction.
Yes, sir. Now also I will
full stomach.
Full stomach rapid sequence induction.
That is what is very important. So you should always talk about rapid sequence induction here. And as early as possible, you have to get into the airway, isn't it? That is what is called rapid sequence induction. They may ask you about the rapid sequence means what are the steps of rapid sequence induction. They'll be asking you. That is another very important thing you should always talk about. So induction agent can be depending on the amount of
hemodynamic status,
blood loss.
Blood loss.
Ketamine may be an ideal choice. And what about the muscle relaxant you will be using now?
Muscle relaxant I use scolin, sir. Scolin.
Never say scolin in the exam.
Succinylcholine.
Yeah, succinylcholine or succinylcholine.
Or succinylcholine.
Okay. Now how much succinylcholine now?
Now 50 milligrams.
You have given neostigmine.
Yes, sir. Half the dose, 25 milligram, I will use succinylcholine.
Now, I'll have to ask you, what is the duration of action of neostigmine?
Duration of action, 1 hour, sir. 60 minutes.
90 minutes, isn't it?
60 to
90 minutes. So, but I told you 2 hours. Now you want to reduce the dose of succinylcholine for rapid sequence induction is always a higher dose because you have to get excellent intubating conditions within 60 seconds. That is the idea. So if you give even less than 1 milligram per kg body weight, you may not be able to get the excellent intubating conditions within that 1 minute. So that is the reason why always go for 1.5 milligram per kg body weight. Listen to the examiner's question. Then only you can realize. That's why I was stressing 2 hours, isn't it? So that is the most important thing. And after, once you intubate, what you are going to do?
After the tube is in position,
again, the surgeon will be using Boyle-Davis gag.
Boyle-Davis, again,
so where do you fix the tube now?
Fix the, sir? I didn't get.
Where do you fix the tube?
Since I'm using oral endotracheal tube, I'll fix it to the sides according to the.
No, usually Boyle-Davis gag will have a slot in the middle for the tube position.
To hold. Yes, sir.
I don't know, in your hospital you have the Boyle-Davis gag with a slot for endotracheal tube, or you don't have?
No, sir, we don't have a split in the Boyle-Davis
That's
gag.
the reason why you said that we'll be shifting the tube to one side and
to
the other
side, opposite side.
So here there is no problem, isn't it? Because they are not going to operate in any other one side, this side or that side. You can just fix it to the sides also. But proper fixation of the tube is very, very important. Okay, once the surgery, again the hemostasis the surgeon has secured, what you are going to do now? Again, you will have to reverse because you have to give non-depolarizers. You have to reverse and you have to be extremely careful because once the child has already gone for laryngospasm, so you don't want the laryngospasm to be repeated, and the surgeon also to see that he does the maximum amount of hemostasis without any problem. So you have to keep the child in the lateral position and
lateral position and awake extubation.
Monitor the child in the postoperative period. Okay. Thank you, Kirti. Sir, anything else?
Thank you, sir.
No,
I think we have exceeded the time by 4 minutes.
It's okay. Yeah. But I think I have set the alarm. I think Dr. Kirti has taken that 4 minutes initially while presentation.
Anyway, well done, Kirti. You have done very nicely.
Yeah, Dr. Kirti has done very well.
Because she's not exam going, sir. The main thing is she's not exam going. Even then, she answered quite well.
Yeah. He said she's final year, but now she said she just entered final year. But she's good. She's good.
But Kirti, my advice for you is keenly observe everything for every surgery.
Okay, sir.
Because probably you have not observed properly about this particular tonsillectomies, though you have been exposed for about 8 tonsillectomies. So observe keenly so you learn better.
I request Dr. Kirti to tell what she is practicing in the examination. Don't say I will use remifentanil, I will use alfentanil. What you are doing, you are saying so many things. What you are practicing, you please tell. That will bail you out. Your internal examiner will also take care of you and he will say we are doing only like this. Fine.
And one more advice, Kirti, for you, because you are still doing your PG. So you always read about the next day's cases on the previous day. And whatever theory knowledge you gain, you try to apply that for practice next day. So you will learn a lot. If you just read about the cases, whether it is hypertensive, diabetic, or whatever it may be, or the type of surgery, You read about that and then go, you will be a better anesthesiologist. Definitely. So at least if you have not done this, you do it.
For the second year, she is too good. Right. Yes. So okay, you are certified by 2 examiners.
So right. You can take, sir, she can take exam in August.
Thanks, sir.
Yeah, provided she gets only one short case of tonsillectomy.
All the best.
Thank you, sir. Thank you.
Right, sir. Thank you, sir.
Thank you. Thank you,
Thank you. Thank you, sir.
Thank you, Gurudat sir. Thank you, Meenakshi sir. Thank you, Kirti, for that wonderful discussion on tonsillectomy. And over to Ginny for the next session.
So next we come to the long case, that is the hypertensive disorders of pregnancy. So this case will be, the examiners would be Dr. Mubarak, HOD, Calicut Medical College, and Dr. Harsoor, Professor and HOD, Ambedkar Medical College, former Karnataka Director of Medical Education. The case will be presented by Dr. Priya and Dr. Bhuvaneshwari, both from Calicut Medical College.
Yeah, good afternoon, everyone. Good afternoon, Dr. Mubarak. Hope our postgraduates are ready for the presentation. Dr. Priya.
Good afternoon, sir. Good afternoon, Harsoor, sir. Good afternoon. And thanks, ISA, Jeannie, and all. So, shall we present?
Dr. Harsoor, sir, Dr. Mubarak, sir. Good afternoon.
Yeah, good evening, sir. We were with you for the nice discussion on tonsillectomy.
Thanks, sir. We will be seeing now hypertensive disorders of pregnancy.
Okay, sir. Okay, sir. And you have promoted Dr. Kirti for the exams in coming August.
If we were the examiners, the result is out already. Yes. But you are saying Dr. Priya will be presenting, but there are a Priya Square.
Yeah, Priya and Bhuvaneshwari both are.
Whether Priya Square are going to present or it is only Dr. Priya?
I think that they have.
Yeah, another is Dr. Bhuvaneshwari. Priya and Dr. Bhuvaneshwari it is.
Oh.
Right. Anyway, it was a very good talk by the presentation by the previous set of people and excellent discussion, Dr. Meenakshi, Dr. Gurudat. Nice discussion going on right from morning. I think it was a real feast for the postgraduates.
Sir, Dr. Gurudat is a station director, sir. For Kerala, he is stationed permanently.
No, he's an asset. He's an asset not only for Kerala, also for Karnataka.
He is stationed. No, in this session, he is stationed. Yesterday, he was throughout the session.
True, very, very.
Dr. Gurudat was there.
Yeah,
and
today also he is there.
Sir, that is the faith ISA Kerala has on me, sir.
Everyone, sir, everyone.
Good teachers are always recognized.
Thank you, sir. Thank you, sir.
See, he loves teaching.
Yes.
Teaching is a passion. Dr. Priya Square, we are consuming your time so that you will be prepared. Are you ready?
Yes, sir.
Yes.
Yeah, please start. Please start.
Good afternoon, one and all. We are going to present a case on hypertensive disorder of pregnancy. Coming to the case presentation. 22-year-old primary gravida at 36 weeks of gestation, whose LMP lies on 8/11/2020 and EDC on 15th of August 2021, who is a BCom graduate by education and presented with complaints of edema of legs for the past 1 week and headache and blurring of vision for the past 1 day. History of present illness. High blood pressure was detected at 32 weeks of gestation on routine antenatal checkup, and patient was started on oral nifedipine 10 mg twice daily, and patient was on regular follow-up since then. The headache was present in the forehead and occipital region. It was not associated with vomiting and not relieved by taking rest. There is a blurring of vision, and her blood pressure was found to be 160 or 110 millimeters of mercury. So patient was admitted, tablet levetolol 100 mg twice daily was added, and magnesium sulfate regimen was initiated. There is no history of altered sensorium, seizures, dyspnea, snoring or hoarseness of voice, epigastric pain or vomiting, oliguria, and bleeding manifestations. Past history. There is no history of hypertension, heart disease, diabetes mellitus, kidney disease, epilepsy, and thyroid dysfunction. Family history. Her mother is hypertensive, and there is no history of gestational hypertension or preeclampsia in family members. Personal history. She follows a mixed diet. Her bowel and bladder habits are normal. There are no addiction history. Menstrual history. She attained menarche at 13 years of age. She had regular cycles and normal flow. No dysmenorrhea was present. And last menstrual periods was on 8th of November 2020. Marital history. She was married for past 1 year, non-consanguineous marriage. Obstetric history. Her pregnancy was detected by urine pregnancy test and confirmed by obstetric ultrasonography from a nearby hospital. She was on regular antenatal checkup and her pregnancy was uneventful until 32 weeks. So her second trimester were uneventful. And at 32 weeks, she was detected to have high blood pressure. And then she was started on oral nifedipine, 10 milligram twice daily and was on regular follow-up. Sir?
I think Bhuvaneshwari will go with the general examination.
Okay, sir. Okay.
Summary, 22-year-old primary gravida, gestational hypertension detected at 32 weeks of gestation, started on tablet nifedipine, 10 mg twice daily, and now she admitted with edema of legs for past 1 week and headache, blurring of vision and high BP. Then added on tablet levetiracetam and Mexel regimen was started. And her mother is hypertensive. Then on general examination, patient is conscious, oriented, afebrile, no pallor, no tick, no cyanosis, no clubbing, no pedal edema, no lymphadenopathy. Generalized edema present, including facial puffiness, bilateral pedal edema, sacral edema present. Height is 160 centimeter, weight is 80 kilogram, BMI is 31. Peripheral venous access is difficult. Arterial collateral is adequate. Spinous process difficult to palpate because of edema. Vitals: pulse is 66 per minute. Regular rhythm. Good volume. Vessel wall not thickened. Blood pressure 162/96 millimeter mercury measured in the right upper limb in a sitting position. 150/in the left lateral position. JVP is not elevated, respiratory rate is 16 per minute, and saturation is 97% in room air. Airway examination, mouth opening 3 finger, Malamati class 2, temporomandibular joint can insinuate 1 finger, thyromental distance is 6.5 centimeter, bilateral nasal pattern is normal, no deviated nasal septum, neck movements normal, breast enlarged, thyroid normal. And cardiovascular examination, precardium is normal, apex width palpable in the left fourth intercostal space in the mid-clavicular line. There is no palpable thread. S1, S2 is normal in mitral, tricuspid, pulmonary and aortic areas. There is no murmur. Respiratory system examination, upper airway normal, trachea is central, chest movements and expansion equal on both sides, bilateral air entry equal, no normal vesicular breath sound, no added sounds. Central nervous system examination, mental functions normal, cranial nerves normal, sensory and motor system examinations within normal limits, no cerebellar dysfunction or meningeal irritation, no hyperreflexia. Obstetric examination, fundal height correspond to 36 weeks of gestation, longitudinal line, cephalic presentation, fetal heart rate 160 per minute. Summary, 22-year-old primary gravida, gestational hypertension detected at 32 weeks of gestation, started on oral nifedipine 10 mg twice daily. At 36 weeks of gestation, she admitted with pedal edema for one week and headache and blurring of vision for 1 day. At that time, high BP was recorded 160/110 and added on tablet levetiracetam and Mexel regimen was initiated. Then mother is hypertensive. Diagnosis, 22-year-old primary gravida, 36 weeks of gestation, severe preeclampsia with impending symptom, on tablet nifedipine, tablet levetiracetam and magnesium sulfate, single life fetus in cephalic presentation.
So that's your history taking and the examination. Anything else you would like to add upon? That's you've completely covered all the examinations. Am I audible?
Yes, sir. Yes, sir.
Okay. So why do you say you have made the diagnosis of a severe preeclampsia? Am I right?
Yes, sir.
Yeah, what are the points in favor of severe preeclampsia?
Yes, sir. So the patient was admitted with a blood pressure of 160/110 millimeters of mercury, despite being on treatment on oral nifedipine 10 milligram twice daily. And also patient had new onset of cerebral visual disturbances in the form of headache and blurring of vision. So because of these three features, I categorize it as severe preeclampsia, sir.
What are the other possible differential diagnoses?
So for severe preeclampsia?
Yeah. See, it is basically a raised blood pressure with other symptoms. So how do you classify the hypertension in the pregnancy?
Classification, according to American College of Obstetrician and Gynecology, hypertensive of disorder of pregnancy is classified into gestational hypertension, preeclampsia, chronic hypertension superimposed on preeclampsia.
So why don't you think that the other possibilities are there? It's a chronic hypertension or a gestational hypertension or a combination?
So as her blood pressure was detected after 20 weeks of gestation, initially she was diagnosed to have gestational hypertension at 32 weeks of pregnancy. And now at 36 weeks, patient presented with blood pressure 160/110 millimeters of mercury, despite being on treatment with nifedipine. And also patient had headache and visual disturbances, blurring of vision. So these three findings more correlate with severe preeclampsia, sir. And patient was not hypertensive before 20 weeks, so we ruled out chronic hypertension.
So you have taken the history of.
Yes, sir.
Previously, she was not hypertensive.
Yes, there is no history of hypertension.
Okay. So so that means it is a possibility is more in favor of a preeclampsia and impending symptoms. Okay, fine. Right. So what we are going to discuss in the next, say about 1 hour or so is the pathophysiology of this preeclamptic toxemia, what it was called earlier, or the hypertensive disorders and their management. And for the benefit of all the other postgraduates also, what I would like to say is the majority of the examiners expect an answer for how to manage this particular case, the history that you have taken in the examination. This is number one. And the focus is on what you practice in your institution, because the practice pattern varies from institution to institution, say from a different kind of across the country. So therefore, a question that is often asked in your institution, how do you manage such cases? So I want both Dr. Priya and Bhuvaneshwari to take note of this, and also for the benefit of all the other postgraduates. Okay, there will be some kind of a controversies, and yes, you can answer that. These are controversial issues that if the examiner does not agree, better to keep quiet at that particular point of time. So this is a general introduction what I would like to give. And the next point is, see, any case management, it is absolutely necessary that you have a sound theoretical knowledge of that particular disorder so that your management becomes more easier. It is, yeah, it is a general anesthesia. You just put an endotracheal tube, you relaxant and manage. It's not that. Okay. So therefore, we will be discussing a little more issues about theoretical aspects also in this. You agree, Dr. Mubarak?
Yeah, we'll go along with that in that line, sir.
In that direction only. Okay. All right. So how do you define preeclampsia, Dr. Priya?
The preeclampsia is defined as new onset of hypertension and along new onset of hypertension more than 140/90 millimeters of mercury, which is measured at at least two intervals more than 4 hours apart, at least 4 hours apart. And along with proteinuria more than 300 milligram per 24 hours, protein creatinine ratio more than 0.3, and urine dipstick or urine dipstick 1+.
Okay. So is there anything like a mild, moderate, severe or something like that you classify?
So preeclampsia can be classified into without preeclampsia without severe features and severe preeclampsia. In preeclampsia without severe features, that's just a BP more than or equal to 140/90, and along with proteinuria of more than 300 milligram per 24 hours, and protein creatinine ratio more than 0.3, and 1+ urine dipstick. In preeclampsia with severe features, there is blood pressure more than or equal to 160/110 millimeters of mercury, thrombocytopenia with platelet count less than 1 lakh per microliters, and pulmonary edema, impaired liver function with elevated liver enzymes of more than AST more than 70 international units per liter, or with severe persistent right upper quadrant or epigastric pain, pulmonary edema, and cervical and visual disturbances.
Preeclampsia is classified either as a mild or a severe. There is nothing like a moderate preeclampsia. So it is either mild or a severe one. Severe form, yes, you have to manage quite aggressively. Preeclampsia mild case also can be there. Okay. So with regard to the pathophysiology, I think if I can add a little, there is a lot of controversy. Probably we may not spend much time on that. It is what is the basic pathophysiology involved in this, in hypertensive disorders of the pregnancy?
First one is abdominal presentation, failure of cytotrophoblast to invade the uterine vessels. Then second one is excess release of anti-angiogenic factors like soluble FMS like tyrosine kinase and soluble endoglin, which scaven the vascular endothelial growth factor and placental growth factor, it leading to widespread endothelial dysfunction. Then there is thromboxane and prostacyclin imbalance. Then immunological intolerance between the fetal-placental and maternal tissues. Then genetic predisposition in monozygotic twins with HLA-DR4.
Okay, so there are, the pathophysiology of this preeclampsia is a evolving subject. A lot of investigations are going on in that. But the thing remains is there is abnormal invasion of the, or inadequate invasion of the trophoblast into the spiral arteries. That remains, but how and why it happens is a matter of investigation. So let's not go right now into that particular thing. All right. Okay. What are the common risk factors that are involved in the development of this that we know, the development of preeclampsia?
The demographic risk factors include advanced maternal age, more than 35 years, Black race, and Hispanic ethnicity. Genetic factors include family history of preeclampsia, history of placental abruption or fetal demise in previous pregnancies, or limited partner who has fathered preeclamptic pregnancy in another woman. And behavioral factors include cigarette smoking has a decreased risk reduction in preeclampsia. And maternal factors include, or obstetric factors include multiple gestation and hydrus vitalis. Maternal factors include systemic disease, include diabetes, hypertension, or chronic kidney disease, antiphospholipid antibody syndromes, or systemic lupus erythematosus.
Yeah, in many instances, it may not be possible to pinpoint or identify what the risk factors are there. Okay, it is only the pregnancy that may be only factor. And among the pregnancy, what is important? It is the placenta or the fetus that is the cause for this?
Placenta is the cause.
Why do you say so?
Abnormal placentation is the basic pathology of preeclampsia.
Correct. So that is the reason. And another reason is even in the absence of a fetus, like in a molar pregnancy, still the preeclampsia can be seen where there is no fetus. There is only placenta, you know. So therefore, it is often said that it is the placenta is the culprit here in this particular development of this preeclampsia. Okay, so you know the pregnancy is a normal physiological process and it involves several physiological changes that happen during the pregnancy in the first, second, third trimester of pregnancy. I'm sure you are fully aware of those things. Okay, let's not go into that. But what is important is, what are all the systems this preeclampsia or eclampsia it affects? What the systems are affected and how it is different from a normal pregnancy? Can you enumerate the system-wise one by one so that each of them that is relevant to the anesthesia practice?
Cardiovascular system, there is increased vascular tone, increased sensitivity to vasopressors, so leading to hypertension, end-organ ischemia, then hemodynamic changes in a severe untreated preeclamptic patient will have widespread vasoconstriction, and there is low cardiac output, low CVP, low pulmonary capillary wedge pressure. In treated preeclamptic patient will have systemic vascular resistance will be high. Increased pulmonary capillary wedge pressure, it is disproportionate with the increase in central venous pressure.
So
Then
that is the most important problem that we see in hypertensive disorders and the preeclampsia. The one is colloid oncotic pressure and leaky capillaries and increased systemic vascular resistance. Okay, and in addition to that,
what about the intravascular volume?
what happens to the blood volume in this? It is
intravascular volume will be depleted.
It is a what is typically described as a contracted blood volume. Okay, so what about the other systems? Hemodynamic is there. Then what are the changes you see in the respiratory system?
Sir, in airway and respiratory system.
Airway,
there is increased mucosal capillary engorgement and increased chance of tissue friability and increased risk of bleeding. And also there will be, because of pharyngolaryngeal and subglottic edemas, there will be tracheal diameters and laryngeal diameters would be decreased. And all these factors are seen in normal pregnancy. These factors are exaggerated in preeclamptic pregnancies and increasing the risk of airway obstruction, difficult intubation or failed intubation, and increased risk of hypoxemia in these patients.
Okay, so the respiratory system is also severely affected because of the edema that is seen normally in the pregnancy, and that gets worsened in this particular case. And in addition to the common things that happen in the routine pregnancy also, like decreased FRC and the early
oxygen consumption.
Okay, Bhuvneshwari, what are the central nervous system changes you see?
Central nervous system, patient will have severe headache, hyperreflexia, hyperirritability, and eclamptic convulsions. It is and visual disturbance, hemorrhosis, scotoma, and blurring of vision. It is because of failure of auto-regulation. It leads to hyperperfusion and vasogenic edema. It is more prominent in posterior circulation, that is posterior reversible encephalopathy syndrome. These patients will have headache, vomiting, and visual disturbances. It is not always associated with hypertension. Diagnosis made by MRI.
So in the preeclampsia, milder form, the central nervous system may not manifest, although they are present. But in a severe form, all these central nervous system primarily predominates, and that will be prominently visible in these cases. Any coagulation abnormalities you see in these patients?
Yes, sir. The most common hematological abnormality seen is thrombocytopenia in these patients, sir. Apart from which, there is widespread platelet activation, agglutination, and deposition, leading to microthrombin formation, which can result in end organ damage. And also, there is increased risk of disseminated intravascular coagulation, particularly in the setting of severe liver disease, fetal demise, or abruptio placenta, sir. And that can result in either a hypocoagulable state or resulting in thrombosis, or a hypocoagulable state result because of platelet consumption and clotting factors consumption, resulting in hemorrhagic complications.
Right. So basically, it is a case of a prothrombotic state. Pregnancy is a basically prothrombotic state. And over that, some of the other problems also you do see in these patients. Okay, so what are the other changes? Any other systems are involved in
hepatic system? There is periportal hemorrhages, and fibrin deposit in the hepatic sinusoid. Patient will have right upper quadrant pain or epigastric pain, and subcapsular hematoma of the liver. Then patient can develop HELP syndrome, hemolysis, elevated liver enzymes, and low platelet count.
Right. So the hepatic system also, once again, is it seen in a milder form, or it is mostly seen in the severe
preeclampsia?
Yeah. Okay. So that is what about the other systems?
In renal system, sir, because of the renal vasospasm, there is decreased blood flow to kidneys and resulting in decreased glomerular filtration rate and oliguria. And also proteinuria is also a manifestation, mainly because of increasing pore size and chart sensitivity will be different in preeclampsia. Apart from it, there will be increased serum creatinine because of the decreased creatinine clearance.
So the renal blood flow is affected, the glomerular filtration rate is affected as well. What is the reason for the proteinuria? Why is it occurs?
Increase in pore size of the capillary and chart selectivity is alteration of chart selectivity, sir.
Okay, so these are some of the common systems that are involved in the preeclamptic toxemia.
What about the fetal-placental unit?
Uteroplacental circulation, it is impaired. it lead to fetal intrauterine growth retardation, and there is increased sensitivity to oxytocin also.
Okay, so the system of central nervous, the cardiovascular system, hemodynamic circulation is affected, the airway and the respiratory system is affected, central nervous system is affected, and the hepatic and the renal system. So practically you can say all the systems of the body are affected by this particular thing, the preeclampsia. So therefore it is very, very essential that you keep all these factors in mind when you are anesthetizing such patients, right? Okay, so next is how do you optimize? Okay, this is the patient. The patient is in this particular case, already they have optimized this patient, and to a great extent, the blood pressure is brought under control. So if you are given an opportunity to optimize the patient before she comes for either the labor analgesia or for the section for the delivery, how do you optimize this? What is the definitive treatment for the eclampsia or preeclampsia?
Termination of pregnancy, sir. See,
it is a termination of the pregnancy itself. So straight away, do you want to take up for termination or you want to optimize this patient?
No, sir. I have to optimize the patient initially, sir. Sir, we'll focus initially on the maternal and fetal surveillance, and we'll rule out features such as end organ damage like acute renal failure, pulmonary edema, risk of eclampsia, and then also at the same time we'll focus on the fetal heart rate, and fetal monitoring also is simultaneously done. And then we'll manage the acute hypertensive crisis with intravenous antihypertensive agents. Injection labetalol 10 to 20 milligram IV bolus is given, followed by 20 to 80 milligram every 20 to 40 minutes to a maximum dose of 300 milligram. Or it can be given as 0.51 milligram per minute infusion can be given. And or hydrolysine 5 milligram IV or IM bolus, followed by 5 to 10 milligram IV every 20 to 30 minutes. In addition, sodium nitrochloride and nitroglycerin infusion can also be.
One second. Let me interrupt you. So let me come back to my original statement. How do you manage such case in your institution? That will be the question. So what common practice you do?
So we initially start with
obstetricians do, and you will be a party for it. So what do you do? How do you administer orally the labetalol you use commonly, or you use other drugs? What are the common drugs used to control the blood pressure in this, or minimize or bring down the blood pressure?
Oral medications like
oral medications. How do you use? What drugs do you use?
Labetalol, a tablet labetalol. It is a non-selective alpha beta blocker and selective alpha blocker. It is initiated to 200 to 2400 mg per day in a 2 to 3 divided doses. Then nifedipine. Nifedipine, nifedipine, it is a calcium channel blocker, a selective renal arteriolar vasodilator. 30 to 120 mg per day orally in a 2 to 3 divided doses. It is commonly, these drugs are commonly used in our institution.
Okay. So labetalol and the nifedipine are the two commonly used oral drugs that are used in your institution by the obstetricians or yours. In case if this patient lands up in a obstetric ICU, if you are asked to manage, now the option is what are the other drugs that you use? See, once in the obstetric ICU, the patient is having a severe hypertension.
Yes, sir. We manage with intravenous.
What you described. Then what are the drugs? You have managed any type of such cases?
Sir, actually, these patients are in obstetric. People manage these patients, sir. So we are usually called for seizure control and
right, seizure
for hypertension.
Okay. What are your theoretical knowledge about this? How do you manage this?
Sir, intravenous antihypertensive agents are used for management of acute hypertensive crisis.
Okay, what are those drugs, intravenous drugs you use? I see.
Sir, IV intravenous labetalol or intravenous hydrolysine, sodium nitrochloride infusion or nitroglycerin infusions are commonly used, sir.
All of them?
Yes, sir.
Used.
Sodium
Can you just tell me the dosage with them? How do you administer?
Sir, intravenous labetalol 10 to 20 milligram IV bolus followed by 20 to 80 milligram every 20 to 40 minutes, up to a maximum dose of 300 milligram. High or 1 to 2 milligram per minute infusion. Hydrolysine 5 milligram IV or IM bolus, followed by 5 to 10 milligram IV every 20 to 30 minutes. Or
how the action is different from labetalol and hydrolysine? Are they the mechanism of action same or different?
Labetalol is a non-selective beta blocker and a selective alpha blocker, sir. Hydrolysine is a arterial dilator, sir.
Yeah,
Vasodilator.
direct vasodilator. Okay. What are the other drugs that you use?
Sodium nitroprusside infusion can be used, sir, 0.3 at a dose of 0.3 to 0.5 microgram per kilogram per minute, and can be used in incremental doses of 0.5 microgram per kilogram per minute up to a maximum dose of 5 microgram per kilogram per minute. But we don't use this preferably because as the first choice, sir, because of risk of fetal and maternal cyanide toxicity with higher dose infusions and with prolonged durations.
Kept in mind the fetal effect, fetal cyanide toxicity should be kept in mind when you are using the sodium.
What is your target control of BP?
Sir, target control is systolic blood pressure of 120 to 160 millimeters of mercury and diastolic blood pressure of 80 to 105 millimeters of mercury. Mean arterial pressure should be reduced in 15 to 20.
Does it apply in all the patients, or does it depends upon the hypertension, the previous hypertension of the patient?
Sir, blood pressure is reduced in a controlled manner, sir, like 15 to 25% of mean arterial pressure, of initial mean arterial pressure, and abrupt decrease in blood pressure is avoided, sir.
Why? What's the reason for that?
Sir, it can result in, because of these patients, autoregulation would be set at a higher range, and sudden decrease can result in ischemia of the vital organs, sir.
Okay.
So whatever the blood pressure you want to bring it down, it should be a gradual, even in the ICU, it should not be a very rapid change in the, because the autoregulation will be already altered, right? So have you ever used dexmedetomidine in these cases?
For control of BP, we have not used dexmedetomidine, sir.
There are some reports published, but there is no definitive information about the use of dexmedetomidine. But there are reports that are published in the journals. Okay, that may not be there one. Okay, any other drugs you would like to use other than this as an anesthesiologist?
Nitroglycerin.
Yeah.
Nitroglycerin.
Yes.
It is
and remifentanil can be used.
Remifentanil is another new drug that is available in the anesthesiologist armamentarium that also has been tried with the variable success.
Have beta blocker available in the theater, no? Rapidly acting.
Esmolol
is another drug that can be used. So these are some of the drugs.
You can use.
What is your target? Where do you want to stop it?
Target systolic blood pressure is 120 to 160 millimeter mercury, and diastolic is 80 to 105 millimeter mercury. To decrease the initial MAP to 15 to 25% from the baseline.
Okay, set a target for
around 140/90.
Say around 140 plus or minus. Yeah, it's a better target. Okay, so that's how you manage the blood pressure in this hypertensive management. What other systems you would like to manage in this optimization?
So seizure prophylaxis with magnesium sulfate is initiated, sir.
So seizure prophylaxis is a very, very important if the patient is having any imminent signs. So how do you manage that?
Various regimens are available. Pictured regimen. It is first 4 gram IV bolus, 4 gram IV bolus, followed by 5 gram IM each buttocks, followed by 5 gram IM alternate buttocks every 4th hourly. Then Sussman's regimen, 4 gram IV bolus, followed by 1 gram per hour infusion. In our institution, we are following KFOG regimen. It is 4 gram IV bolus over 10 to 20 over 20 minutes, followed by 5 gram IM in each buttocks, followed by 1 gram per hour infusion.
Okay. Both the regimen.
Mechanism of action: magnesium. It is NMDA antagonist. It will increase the seizure threshold. It will improve the cerebral blood flow. Other effects, it is an anti-hypertensive, central CNS depressant, anti-hypertensive effect, topholytic and bronchodilator. During MEC-self infusion, we have to monitor patient mental status, urine output, respiratory rate, and patellar reflex, because magnesium has a narrow therapeutic index.
Also, placental transfer is possible, and it can result in fetal heart rate variability, and fetal muscle tone will be decreased, and fetal respiratory depression is also possible.
Okay, so that's right. So both the another common regimen is a Pritchard regimen that is also followed in various institutions in addition to what you are doing it, but definitely both of them have got a similar result. And how do you monitor the toxicity? Clinically, how do you monitor, and the biochemically, how do you monitor?
So, clinical signs like patellar reflexes, respiratory rate, urine output, and mental status is monitored, sir.
Okay, and what is the biochemical investigations? How do you monitor this? What is the
Sir, serum magnesium level is monitored.
Yeah, what is the normally therapeutic range, and what is the toxic ranges?
The normal level of serum magnesium is 1.7 to 2.2 milligram per deciliter. The therapeutic level is 5 to 7 milligram per deciliter. And toxicity begins when the level exceeds 10 milligram per deciliter. Sir. Initially, it begins with patellar reflexes are lost when the levels are more than 10 milligram per deciliter. Respiratory paralysis occurs more than 15 milligram per deciliter. And cardiopulmonary arrest with more than 20 milligram per deciliter.
Okay, remember that.
What are the anesthetic problems of in patients on magnesium?
It will prolong the neuromuscular, non-depolarizing neuromuscular block action, and it will cross the placenta, and it will produce decreased heart rate and beat-to-beat variability and fetal respiratory depression. Then it is a topholytic chance of PPSD.
Postpartum hemorrhage is also present. So uterine relaxation.
Any effect on the central nervous system? Depressant effect?
Yes, central nervous system. It's a depressant.
Any drug interactions are known?
Sir, magnesium sulfate and nifedipine can produce. They can produce synergistic effects. And also with because of non-depolarizing agents, it should be used cautiously because of the neuromuscular blockade, prolonged blockade action of magnesium sulfate. And also it should be used cautiously in patients with hyperkalemia and with those with renal dysfunction and digitalized patients.
What are the common drugs that are affected by this? Which neuromuscular blocking drugs are most affected?
So mostly non-depolarizing neuromuscular blocking drugs are affected, sir.
Like vecuronium, mivacurium, and atracurium.
Okay, so therefore you need to be a little careful. The most important thing is nifedipine and the Maxel both are used together in most of the cases, and they will be potentiating the action of each other. So nifedipine potentiates Maxel and Maxel potentiates the nifedipine action. So therefore you need to be careful in choosing the dose of this particular drug. Okay, so that is the okay. So that you have to be a little careful about as far as the. So this is how these are common things, right? Any other things, drug optimization you are using? Like steroids, do they become part of our treatment? Any role for us to manage?
So those patients presenting in less than 34 weeks of gestation period, we administer corticosteroids to promote fetal lung maturity. Betamethasone is preferred over dexamethasone, and it's given in dose of 12 milligram, 2 doses over 24 hours, 12 hours apart.
What is the drug that is commonly used in these patients?
Betamethasone.
Betamethasone. So some people even try dexamethasone, but it is found that betamethasone is more effective and useful. So 12 milligrams used 2 doses. Okay, so once you optimize these patients, anything else is there, Dr. Mubarak, to optimize the patients?
Suppose the patient even with on magnesium throws a convulsion and you are called for, what will you do?
Sir, once a patient has strong convulsions, we have to initially manage the airway, breathing, and circulation status. Sir. So first airway is managed. Patient is put on the left lateral position, and jaw thrust is given, and also a soft lubricated nasopharyngeal airway can be inserted. If the patient has stopped breathing or apneic, we can support the ventilation with assisted ventilation with back mask ventilation, and we have to apply we have to apply monitors, saturation probe, and watch for the oxygen saturation. And for circulation, we have to secure an IV access, and we have to frequently monitor the electrocardiogram and blood pressure. And in case if the BP blood pressure is high, we have to manage with antihypertensive agents. And for seizures, we have to start magnesium sulfate, 4 to 6 gram IV bolus, followed by 1 gram per hour IV infusion. And if it is persisting seizures, another 2 gram IV bolus can be given. And if it's still retractable seizures, we can choose other additional agents like phenytoin 50 milligram per kilogram, or benzodiazepines like benzodiazepines, diazepam 10 milligram IV, or sodium thiopentone 50 milligram IV can be used.
Can the patient throw convulsions after delivery?
Yes, sir. Postpartum period also.
How long you will continue the magnesium sulfate regime?
Magnesium sulfate is continued until 24 hours after the delivery, or after the last eclamptic seizure, whichever is later.
Okay. So these patients, if they are in the obstetric ICU and likely to come to the OT for termination of a pregnancy, what are all the monitors that you use? Routine monitors and the special monitors?
So routine monitors including electrocardiogram, non-invasive blood pressure, pulse oximetry. These are used, sir. In case a patient has additional complications, we'll look for invasive monitoring.
Okay, well, what are the indications?
Indication.
Do you use invasive monitors routinely or any specific indication?
No, sir, we don't use routinely.
Only in indicate acute hypertensive crisis, then pulmonary edema, patient is having oliguria, and planned use of rapidly acting vasodilator, and then
Then what about urinary catheter? Is it an invasive monitor or not? Do you monitor the urine output?
Yes, sir. Yes.
So urine output, hourly urine output monitoring is an excellent monitoring tool, which is very simple and minimally invasive. Okay, so that should be done in all the cases. It will be done. It will be catheterized routinely, but then you have to monitor hourly urine output. That gives a very good clinical status of the patient. Okay, and then the other ones, it's a common this thing. I have seen some of the postgraduates telling, yes, the moment there is a hypertensive disorder or the preeclampsia, they say radial artery cannulation and the CVP monitoring. These are not indicated in the mild cases, and even in the moderate cases, only when you are aggressively trying to control them. Okay, and the neuromuscular monitoring, if it is available, that will be excellent tool. If it is available, yeah, that will also.
Capnography, when there, especially if you are using general anesthesia. Capnography.
That has to be kept in mind. Okay, right. So any other problems that you are likely to see in these patients in addition to the cardiovascular and the hypertension and the other one is
coagulation status of the patient.
How do you monitor? How do you measure? What are the investigations you do for that?
The baseline platelet count should be done, and a platelet trend of platelet count is more important. So in those patients diagnosed with severe preeclampsia, we have to do at least daily platelet count is done. And coagulation, if platelet count is less than 1 lakh, we have to look for other coagulation monitors also, like prothrombin time, activated partial thromboplastin time, and fibrinogen level. For coagulopathy.
When do you get this platelet dysfunction and all? Commonly, in which conditions? These are likely to go for coagulopathy more. Which conditions?
If the patient
associated with liver dysfunction What do you call them?
Those with HELLP syndrome.
If the patient had HELLP syndrome, patient will have impaired liver function.
Or HELLP syndrome? What do you mean by HELLP syndrome?
It is characterized by hemolysis, elevated liver enzymes, and low platelet count in patient with preeclampsia. Hemolysis, it is characterized by abnormal blood smear. It is showing cystocyte, bursates, and echinocyte, and elevated increased bilirubin more than 1.2 milligram per deciliter, and LDH more than 600 international unit per liter. Elevated liver enzymes, AST more than 70 international unit per liter, LDH more than 600 international unit per liter, and low platelet count. Platelet count is less than 1 lakh per millimeter.
Yeah, have you heard of classifying this thing, Mississippi classification?
Mississippi classification, it is based on
platelet count, sir.
Platelet count.
Basically on platelet count, it's classified into class 1, 2, and 3. In class 1, platelet count is less than 50,000 per millimeter cube. Class 2, 50,000 to 1 lakh. And in class 3, 1 to 1.5 lakh. And in class 1 and 2, AST would be more than 70 and LDH would be more than 600 per international units per liter. And in class 3, AST would be more than 40 international units per liter and LDH would be more than 600 international units per liter.
So basically, it takes into consideration three platelets, the liver enzymes ALT and AST, and the third one is LDH. What does it indicate? LDH, what does it indicate?
Hemolysis.
So it is an indicator of the hemolytic status of this thing. Okay. All right. So what are any other differential diagnoses you can make for the HELLP syndrome?
Yes, sir.
Acute fatty liver of pregnancy, acute cholecystitis, then appendicitis, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and nephrolithias.
So those things also should be kept in mind. It is not that always you should think only in terms of a HELLP syndrome. The other possibilities also will be there. That's especially the acute fatty liver, the pregnancy. So that is okay. So that's how you have to analyze these patients, the patients you diagnose, and then you try to optimize before they come to the operation theater. What are all the role of anesthesiologist, in which circumstances you are involved in the management of these cases?
Sir, in providing labor analgesia or in management of acute hypertensive crisis or other maternal obstetric complications, in management of for providing anesthesia for emergency and elective cesarean sections, and for ICU management for the management of complications, and for maternal and neonatal resuscitation.
Okay, if you are called in to conduct or provide a labor analgesia for this particular mother of what you are describing, what is your approach? How do you proceed with this?
First, I'll evaluate the patient and I'll ensure the coagulation status of the patient. If the coagulation profile is normal, I'll go for a lumbar epidural. What are
the options that are there in your mind? One second, what are the options? Labor analgesia, what are the options that are there in your mind?
Non-pharmacological methods and non-pharmacological methods are there, sir. Among non-pharmacological methods, we don't prefer, and among pharmacological methods, there is intravenous opioids or inhalation agents like Entinox or Heliox can be used. And for intravenous opioids, we can use remifentanil infusions as a patient control analgesia, or
which is got a better, more advantageous in these particular patients. Which method is more advantageous?
Sir, lumbar epidural analgesia is more advantageous in these patients. Sir.
It is, but what are the advantages? What are the supposed advantages of lumbar epidural analgesia in this?
It decreases the basal metabolic rate. It increases the maternal catecholamine release, and improves the uteroplacental circulation and increased intervillous blood flow, sir.
So what are the precautions that you take? What are the concerns that you have before you institute a epidural or a neuraxial block?
The patient's coagulation parameters should be normal. Only then we'll approach with the epidural.
What do you mean by coagulation parameters? What are the things you see?
The platelet count should be more than 80,000 international units per liter. And if it is between 50,000 to 80,000, we'll evaluate the patient with the platelet trend of platelet count as well as other coagulation parameters like prothrombin, APTT, and fibrinogen. And if it is less than 50,000, we won't approach with the, we won't go for a neuroaxial block technique.
Neuroaxial block. What is the
Is it only the platelet count that is important?
No, sir. The trend in platelet count and the last 1 to 3 hours, platelet count the last 1 to 3 hours is more important.
And platelet functioning also may be affected. So you have to monitor any other clinical bleeding manifestations also. Suppose you have the oozing from the intravenous site or something like that, you should not.
Okay, sir.
Despite your platelet values.
Is there any role of aspirin in these patients?
Aspirin, low dose aspirin, it is commonly recommended because it will inhibit the thromboxane A2. It will in the platelets, it will inhibit the platelet aggregation.
Okay, so some of the patients may be on aspirin, but do you want to go in for a neuroaxial block in these patients or no?
Yes, sir. Low dose aspirin is not a contraindication for neuroaxial blockage.
Provided the platelet quality and the count both are good, if you are satisfied with that, then you can go for it. What are the other options in addition to lumbar epidural analgesia? What are the other options?
Sir, intravenous opioids.
No, can you, no, neuroaxial block. Can you give a spinal block for these?
Sir, for analgesia, epidural.
Yes.
Yes, sir. We can give a spinal block also, sir, but the motor function is not preserved, sir. So
what is walking epidural? I have heard walking epidural.
Yes, sir. Walking epidural is low dose spinal dose is given so that motor function is relatively impaired, relatively preserved compared to.
What is the commonly used drug that is preferred in these cases for providing the labor analgesia?
Sir, here we use injection bupivacaine at 0.1255% in our institution, sir.
0.125. What is the other recommended dose? What is the any disadvantages of using higher concentrations?
Bupivacaine has got a lower higher cardiovascular CNS toxicity ratio, sir. So there is more cardiotoxic compared to propivacaine.
No, I am asking about the concentration.
If you are using more higher concentration, it will cause motor block also, and patient will have hypotension.
Okay, you are more worried about the motor blockade. What is the importance of motor blockade? Why you should avoid in any labor analgesia? Motor blockade should be avoided.
Because if the patient has to participate in the labor process, her motor should be preserved, sir. Only sensory block is required.
It is preferred so that the mother's participation in the delivery will be affected if you use higher concentration. So commonly preferred dose, initially you use 0.125 followed by 0.0625 will provide sufficient analgesia. And any additives you would prefer in these cases?
Fentanyl, 2 microgram.
Additives to the neuroaxial blockade?
Fentanyl.
Like fentanyl or
2 microgram per ml.
I think we have lost touch with them.
Hello, sir.
Sir, in our institution,
any additives you think of?
Fentanyl can be used as an additive.
What is the dosage you prefer fentanyl?
So 1 to 2 microgram per ml of 1 to 2 microgram per ml is used, sir, of the local anesthetic agent. Okay,
so that also it will help you in lowering the concentration of the local anesthetic agent that is used. You can comfortably use 0.0625 if you are adding some additives like fentanyl. So that is beneficial. Some of the, even recently, some reports are published wherein they have used dexmedetomidine also, but it is yet to be stabilized. So definitive reports are not available in that. Okay. All right. So if this patient, that is for the labor analgesia, we've got another 15 minutes of our time, 15 or 20 minutes, right? Okay, these patients, if they are coming for cesarean section, say elective cesarean section, what is the plan of anesthesia you have in your mind?
Plan of anesthesia?
So the options of anesthesia include single shot spinal technique or graded epidural. or combined spinal epidural or general anesthesia. But in this patient, we prefer.
You concentrate on your patient and what is your preferred. You cannot give 3 or 4 techniques for a single patient. No, you consider this patient and what is your choice.
Okay. Single shot spinal anesthesia would be subarachnoid block would be considered technique of choice.
So you prefer spinal anesthesia?
Provided there is no coagulopathy and her intravascular volume status is good. And there is no other contraindications for regional anesthesia.
Why did you?
No, what are the other contraindications? What contraindications you mean? You said coagulopathy. Yeah,
coagulopathy, acute hypertensive crisis, intractable seizures, hypovolemia or hemodynamic instability, or patient refusal.
No, see, I said elective cesareans. Yeah, Mubarak, please go ahead.
Tell me advantages of choosing your technique of spinal anesthesia, some single shot subarachnoid block. Why did you choose advantages?
Advantages. It will maintain the uteroplacental circulation. It will improve the avoid stress response to intubation, and airway problems are avoided. Then we can provide.
Can be counter provided if the hemodynamics are stable only. If the hemodynamics are unstable, all these things are be countered. What about the technical easiness? Which is easier, an epidural or subarachnoid?
Subarachnoid block is technically easier.
Technically easier. It has got definite endpoint. You are used with the technique, but though it has got disadvantages. Okay.
So what are the concerns you have if you are using a general anesthesia compared to spinal anesthesia? What are the advantages of general anesthesia and what are the concerns?
Anesthesia concerns patient factors, that is full stomach. Even patient had 8 hours of fasting, we should consider as a full stomach patient. Then difficult airway and aortocaval compression. Then difficult.
No, aortocaval compression can occur in both the categories of anesthesia, whether neuraxial block or general anesthesia. You have to take precautions. What are the concerns for general anesthesia?
Intubation, accelerated hypertensive response during intubation and extubation.
And
because
what about
the
the airway?
Difficult airway management, which can result in failed intubation or difficult intubation.
Pregnant airway itself is difficult, and when it comes to these conditions, it becomes more difficult. You have got generalized edema, contracted blood volume, your intubate responses. So added pregnancy itself is a high risk, and the airway becomes more difficult and intubation. But still, what are there are definitely indicators for general anesthesia. What can be, even with these conditions, sometimes you may have to opt for general anesthesia. What are those conditions?
So coagulopathy, hypovolemic status, intractable seizures, ongoing hemorrhage. Patient.
Okay. So when there is a definite or a suspected hemorrhage, you have to be way more cautious in avoiding the neuraxial blockade. Okay. Right. So what are this thing, if you are using general anesthesia, what are the precautions that you take in these patients?
Precautions.
How do you manage this? See, like a contracted blood volume, even the airway is always considered as a difficult airway. Even if clinically it is not apparent, it must be considered as a difficult airway, especially all pregnancy, especially the pre-eclamptic patients. So what are the special precautions you do take in this?
Okay, sir. Before starting the procedure itself, I'll set the table with difficult airway cart ready. All the necessary equipments required for it, and as well as for maternal and neonatal resuscitation equipments and drugs would be kept ready, sir. And in addition to which, I expected an exaggerated hypertensive response. So for that, I'll give an intravenous labetalol prior to induction to decrease the hypertensive response during intubation.
Yeah. What about the other
And
things?
a rapid sequence induction is preferred in this. It will be done in this case because of the full stomach status.
Yeah. Well, see, all mothers, like what you said earlier, should be considered as the full stomach patients. Like I think RSI already it was discussed in the last talk, so let's not go much into the depth of it. Okay. See, what are in case if you are using the the general anesthesia, the possibility of general anesthesia, how do you pre-medicate these patients?
Sir, as I suspect a difficult airway in these patients, and pre-medication would be with the short-acting. The pre-medication would be for aspiration prophylaxis would be given, sir. And apart from that, glycopyrrolate 0.2 milligram IV is given, sir, to decrease the secretions. And
What prophylaxis do you use?
Aspiration, sir, injection ranitidine 50 milligram IV and injection metoclopramide 10 milligram IV is given, sir.
You do routinely in your institution?
Yes, sir. These are routine use.
Okay.
We don't give 0.2 molar. Sodium citrate is not commonly used. We don't give sodium citrate here, sir. 0.2 millimolar sodium citrate. We don't use.
You don't use. Why do you don't use? Why do you are not preferring that? Have you seen how many of anybody has seen the sodium 0.3 molar sodium citrate?
We haven't seen.
It was available in the market about 15 to 20 years back for a very, very, very short duration, and it was never used. What are the reason why it is not popular? What are the disadvantages of using? Theoretical question I'm asking. Yes, it is good you are not using it.
The particulate agent, sir. Is that particulate agent?
How much volume you have to consume for that?
30 ml.
30 ml should be consumed.
Yeah,
sir. So
it is a large volume. That is one. 30 ml you have to give it. And what is another one? Single important. In addition to the volume, it tastes very, very bitter taste. So it is not at all an acceptable one. That is the reason why it appeared for a very short time and just disappeared. It never picked up in the market. It is only for a theoretical considerations. Okay, it is not
another scenario. See, you have a functioning epidural, and the obstetrician decides to go for an emergency cesarean section with the diagnosis of fetal distress. Which are the conditions where you can continue with the epidural, and which are the conditions where you cannot continue with the epidural for emergency cesarean section in that condition?
So when the fetal, if there is fetal distress which requires an emergency cesarean section, it depends on the urgency of the procedure, sir. If it is a fetal distress and fetal heart rate is less than 100 per minute, then we have to, we cannot wait for the epidural to act, sir. Epidural to attain the block, sir, level of block. So in those scenarios, we'll prefer a general anesthesia technique.
Dire fetal distress. When you have some time to establish the blockade in functioning, you can continue with the epidural. Then what about the volume status of the patient?
Yes, sir. Intravascular volume status should be adequate, but the clinical evaluation of that is difficult, sir. In case of an emergency.
But you can see the response of the patient to the epidural, how the patient responded, and your monitoring systems and your urine output will give a rough guide whether what is the volume status. And if the hypertension is not controlled, uncontrolled hypertension, or if there are any signs of, and another problem is you cannot preload or you cannot give faster fluid, and if there are any signs of pulmonary edema or any signs of lung involvement in the pulmonary edema, better not to go for a
regional technique.
Okay.
Okay. See, what about the combined spinal and epidural? What are the advantages or disadvantages? It's good. Do you practice that?
So we practice a single shot subarachnoid block here, sir.
Okay.
But combined spinal epidural is technically more difficult because in case of this patient with sacral edema, the placement of an epidural and functioning of the epidural, we won't be definite about that, sir. And depends on the urgency of the procedure also. If we have given a low dose spinal technique and we are opting for an epidural to give additional doses, if the patient is in a dire fetal distress, we won't have time for the epidural to attain the level of block. Otherwise, if it is an elective procedure, combined spinal epidural can be given with a low dose spinal drug, and amount of spinal drug dose can be reduced, and additional drug can be given by epidural to attain the level of block if it is an elective procedure.
One major disadvantage is when you are combining a epidural with a spinal, you don't normally give a test dose for epidural catheters. Placement. Okay, if you give spinal, then if you are not sure whether your epidural works or not, that is the major disadvantage of a combined spinal epidural in these cases. Okay, what is the test dose, the drug you use? That's quite a controversial one. What drug, epidural, proper placement of the epidural catheter?
In our institute, we are using lignocaine 2% without adrenaline, but current studies are showing we can use lignocaine with the adrenaline as a test dose.
You can use, if this fetal heart rate status is good, you can still use, because it is more safer to use adrenaline than not using it. Yes, definitely plain lignocaine also is beneficial, but there are controversies. Some people agree, some people do not agree. There are recently the reports appear that you can go for the, okay, all right. How do you manage this spinal anesthesia for cesarean section, elective cesarean section?
The hypotension.
Yeah, how do you conduct a spinal anesthesia for a cesarean section?
Sir, I'll evaluate the patient. I'll explain the procedure. I'll evaluate the patient and look at the investigations, current investigations.
Concentrate on the differences or the special precautions in this situation in a preeclamptic patient. For example, the preloading. What about the different anything regarding preloading, regarding the fall in blood pressure management, those things? Yeah.
The restrictive co-loading is done in these patients, sir. 1 to 2 ml per kg per hour is given, sir. So that we have to aggressive co-loading can result in, because of capillary leak and decreased plasma oncotic pressure, higher risk of pulmonary edema is there. So we prefer we use a restrictive co-loading.
Yeah.
And hypotension is managed with.
What about the chance of hypertension? Is it more or less?
So recent study says with single shot spinal, it's negligible, sir. Hypotension, risk of hypotension is negligible.
When compared to the other non-hypertensive mothers or non-preeclamptic mothers, is it the same or different? The incidence of hypotension, is it same or different?
The same,
same.
Yeah, it's why you have got so much of a doubt. You are doing day in and day out, you are doing a preeclampsia patients in your hospital, no? So there is no difference as far as the incidence of hypotension is concerned. And what are the preferred drugs that you use for treating the hypotension? Vasopressors?
Phenylephrine and ephedrine can be used. Ephedrine are used, sir, but both are used in a lower dosage, sir. Phenylephrine 25 to 50 microgram as starting dose, or ephedrine 5 to 10 milligram as a starting dose.
What is the reason why you want to use in a smaller doses?
Because of the exaggerated response to the catecholamines in preeclamptic patients.
There will be exaggeration. So therefore, this patient may not require a larger dose, and they are quite sensitive. With the regular doses or even the lesser doses, they do. The blood pressure.
What are the precautions while using oxytocic drugs in this condition?
Oxytocin can be used, but methagen should be avoided in severe preeclamptic patient. Then we can use corboprust also. Oxytocin 3-unit IV bolus. Wait for 3 minutes. And assess the response. If the uterus is not contracted, we can give another 3 units IV and watch for uterine contraction. If the uterine contraction is inadequate, give another dose of 3 units IV bolus.
So totally how many doses you use? Maximum how many doses?
Maximum 3 doses, sir.
3 doses maximum.
Maximum 3 doses of 3 international units bolus injections. Okay.
Is methadone absolutely contraindicated? Suppose the patient is not responding to oxytocin, prostaglandin, and uterus is still flabby and planning for obstetric hysterectomy.
Intramyometrial prostaglandin F2 alpha can be given.
Okay. Suppose the patient can go for a complication like obstetric hysterectomy. What are the added risks in this situation?
Sir, as a patient,
uterus is not contracting despite of oxytocin, and
as a patient is a volume contracted state, there is higher risk of bleed and risk of coagulopathy is also there. There is higher risk of bleeding in these patients, and sudden hemodynamic collapse should be anticipated, sir.
And suppose this happened in a patient having an epidural in situ, you have given combined spinal epidural or epidural. Will you proceed with the epidural in that condition for obstetric hysterectomy?
No, sir. We'll proceed with the general anesthesia, sir, because of hemodynamic instability anticipated.
What are the problems in inducing general anesthesia in such a patient who is having a functioning epidural for an obstetric hysterectomy? So these sort of questions comes when you have cleared, you have passed, and you have reached a high level. Only these sort of questions come. So be confident and try to answer. Okay.
So the hypotension has already set in. No, sir. The sympathetic blockade results in hypotension, sir. Depending on the level of blockade. So with an additional induction with the additional use of induction agents, which are myocardial depressants, there is increased risk of hypotension and collapse, hemodynamic collapse.
Effect of anesthetic drugs and positive pressure ventilation can
also attribute to hypotension
in an already compromised patient who is hypovolemic, had a cesarean section. So while induction, you have to take all the precautions of using minimal intravenous agents, and you can choose. Sometimes you may have to use even ketamine-like agents despite of pregnancy, because when the hypotension is there, or you can mix with ketamine small dose with propofol, or you can use etomidate, and you should have IV access adequate. You should start IV extra lines. You may, if you don't have an invasive monitoring, you may have to start to put on invasive lines once the patient is stabilized. So these are certain things which you have to consider while inducing a general anesthesia on the top of a failed spinal or a failed epidural, or on the top of a functioning epidural for complications like an obstetric hysterectomy. What about postoperative care?
Yeah, few more minutes left. A little information about what is eclampsia. How do you define eclampsia?
Eclampsia, it is defined as new onset of seizure or persistent coma in a pregnancy, or unexplained coma in a pregnant woman, or in a postpartum period in a woman with signs and symptoms of preeclampsia without any pre-existing neurological disorder.
Okay, so it is necessary that both should be there? Both the components, seizure and the coma?
No, sir. Seizure or unexplained coma.
Seizure or unexplained coma, or both. Any of the two components can manifest as a thing. So how do you manage these cases? I think already we have discussed that. That's it's the termination of the pregnancy only.
Yes, sir.
Okay, so that is the only definitive treatment. But till such time, you have already discussed about the thing. Any other things, Dr. Mubarak, we need to discuss in this?
What about the postoperative care of this patient? How do you monitor this patient after a cesarean section?
So these patients are monitored in high dependency units, sir, with strict monitoring of the blood pressure and urine output and intravascular volume status, sir. And also
what are the strategies for postoperative analgesia? Principles?
Sir, intravenous opioids can be used, sir, or transverse abdominis plane block, ultrasound guided transverse abdominis plane block in case of general anesthesia.
What about use of NSAIDs?
NSAIDs are not preferred, sir, because it can result in a platelet inhibition, sir,
and it will aggravate the hypertension also.
Yeah. Okay. So it's a what are the other problems? Have you heard of a postpartum eclampsia?
Yes, sir.
Yes, sir.
Yes.
What is postpartum eclampsia?
So in those patients who presents with eclampsia for the first time in the postpartum period, usually within the first 7 days after delivery.
Normally, how long this the preeclampsia or eclampsia persists in the postpartum period?
So 12 weeks.
12 weeks of postpartum.
So it can be there up to 12 weeks. So therefore, what is the importance of this managing the postoperative analgesia?
Hypertensive
the symptoms do persist. Yeah, that is it. Symptoms do persist in the postpartum period also. Therefore, it is very essential that you maintain a proper analgesia so that the hypertensive response will not be exaggerated in these mothers. Okay, that should be the strategy of this. Okay. Any other things, Mubarak, or should we invite any comments from our colleagues? The other
think one chat box, is it, what about the time organizers, Jitin? I think we have almost one question I have seen in the chat box, press and pet differences. I think that, have you seen?
Press and pet, okay.
Yeah, that's one question when this thing has come here.
Press.
I think the term, I assume that PET to be pre-eclamptic toxemia. That terminology has been taken out actually. It is not used nowadays. I think it is not the PET scan. So I don't know whether what they meant, whether it is pre-eclamptic toxemia or PET scan.
Pre-eclamptic toxemia or toxemia of pregnancy is no more used. It is the pre-eclampsia is the common term that is used.
Oral drug of choice in postpartum eclampsia. One question has come. Oral. I think when there is postpartum eclampsia, oral drugs are not going to be effective. You will have to continue with magnesium for further time, and you may have to reassess the neurological status to find out any fresh events have occurred for the occurrence of eclampsia like that. You will have to do a detailed neurological evaluation. Or you can give other and control of hypertension like with labetalol. Those angles also has to be considered.
Yeah, there is another question, that is management of a patient going for DIC. CDIC management, yeah, the only answer here is a termination of the pregnancy. That is the first one. And then is one of the case of consumption coagulopathy, no? That's the DIC. What's a double catheter technique of epidural analgesia? There's another question. You would like to answer, Dr. Priya, double catheter technique?
Sir, spinal microcatheters can be used, and in addition to the epidural catheters, we don't use these things here.
No, probably what they mean is double catheter is the one of the things that was described earlier. The placing catheter, one catheter for the first stage of labor and the other one for the second stage of labor. One in the thoracic level and one in the sacral level. So that's what was there. But it is no more valid because you never predict where the catheter moves. It is assumed that it moves caudally, cephalad, but there is no guarantee that it will go in that direction. And it is not used anymore, that double catheter technique. It's the only thing is single catheter. We do make the patient sit or semi-recumbent position for the second stage. Okay. Right. Any other expert comments on these discussions that we had?
Seniors, they can unmute and make their comments.
Pardon me, Binil?
They can unmute. Participants can unmute and directly discuss with you.
Yeah, anybody can join. Fast track spinal can we use in pre-eclamptic patient with fetal distress? Yes, fast track, what exactly we mean?
Rapid sequence spinal anesthesia.
Rapid sequence spinal anesthesia. The conditions remain the same. If there are no contraindications for a spinal anesthesia, yes, the answer is the same. Then dural puncture, epidural. Yeah, dural puncture is a possibility is much higher, especially when the mother is having especially during the contractions, there is a possibility of the dural puncture is more. So therefore, it is commonly recommended. The common question that is another common question that is asked for a examination is, when do you place the epidural catheter? We do place the epidural catheter when the mother is expected to go into the labor or when she is not in active contraction. During that time, you place the catheter, but only thing is you activate when she is depending on your institutional protocol, either 5 centimeters or 7 centimeters in a multi and 3 centimeters in a primary. That's whatever is followed. But the thing is, if you want to avoid the dural puncture or the intravascular placement, it is better you use it when the mother is quiet and still yet to get the labor pains. So that's the thing. Okay, any other things are there?
The question on epidural sieve. What is an epidural sieve?
Epidural sieve. That's probably the epidural block will not be acting. Any particular patches that will not be acting, and the exact reason is not known. But possibilities are that when we try to use some air for testing purposes, in such a situation, it may be there. I think that may be the answer. But
No,
not.
can I come in, Mubarak sir?
Yeah. Mallikarjun sir. Yeah.
Yeah, epidural sieve, usually he has said that when a patient has undergone previous cesarean section and for the next delivery, she is undergoing an epidural analgesia. So if she ruptures with the epidural analgesia, will the patient complain of pain? So this epidural sieve is the term used that when a patient has a rupture of uterus with an epidural analgesia, still the pain is appreciated by the patient when the patient has a rupture, and this is called as epidural sieve.
Okay, that's a rupture of the uterus.
Yeah, when the
Despite
previous suture gives way, generally when you give epidural analgesia, you are supposed not to appreciate any pain. But it is said that when you have given epidural analgesia for a patient who has undergone previous section, and if there is a give way in the uterus, the patient will still complain of pain, and this is called as epidural sieve. It is just like the patient comes out of this one to appreciate the pain.
That's one of the, that is a possibility, yes. I do remember having read this particular thing. Okay. Thank you, Mallikarjun, for enlightening that and refreshing your memory once again.
Namaskara.
Yeah, namaskara. It's nice that your presentation was good. I did follow it.
Thank you, sir. And nice seeing you also.
Yeah.
Nice seeing you, sir.
Yes, definitely. Virtually, at least we are seeing, if not physically. Okay, can we time our epidural to the cervical dilatation? That is another question. What exactly it means? Yes, we have to, but it has no role in the cervical dilatation as such. Cervical dilatation is a hormonal process, but we can time it at that particular time. Or what we say, it's in the primaries, I said, it is for a 3 centimeter dilatation. And
sir, one thing regarding cervical dilatation, when the epidural works, the pain-induced inhibition of cervical dilatation is cut, and there may be an enhancement of cervical dilatation. That we have experienced and we have seen. There is, though it is mainly hormonal, so pain-induced inhibition is not there, and patient and labor can fastly progress, and your epidural should not be overdosed to produce the motor blockade. So properly, when the patient is having severe pain, that factor is there.
Okay, dural puncture, epidural technique. I did not understand the question. Okay, in fetal distress, how can we enhance the onset of action of epidural? Yes, one of the methods, already you have the epidural is in place. Yes, there is the addition of any of the analgesics. That may be controversial one in these cases. The only thing is the concentration can be increased. Anand Bangar has asked this question, it looks like. Vinil, that's
I think when there is a severe fetal distress, we don't actually advise or advocate epidural.
No, enhance the onset of action. That is the rapid onset of action.
Another thing is,
the answer can be because,
sir, in personal experience, I find that I have found that and our teachers used to say, when you add freshly mixed adrenaline to lignocaine, it acts faster than the ready-made lignocaine with adrenaline. So our professor Unikrishnan always used to advise to add freshly mixed adrenaline. So that is one reason of fast, and we never had any problem of onset when you use such solutions.
Okay, so Edward Johnson has clarified that what Mallikarjun has told, that is the answer, that's right. The pathological pain is perceived by the mother when she is under the epidural block. A good epidural block, still she is feeling, that is placental abruption or the uterine rupture. Yes, that's right.
That is one of the reasons that your analgesic dose should not be too much. When your motor block, your analgesic dose should be minimal, and patient can perceive some amount of pain. Because if you give a higher dosage, this type of pain may not be perceived and you may miss it. So that's also there.
And DP.
Sir,
yeah.
Dural puncture that is done intentionally in epidural analgesia.
Okay.
And is recently they are mentioning that intentionally with the smallest puncture needle, maybe 29 size or something, you make a dose. The onset of analgesia is very good, immediate onset of analgesia, and it is recommended when you are putting epidural, intentionally you make a small puncture in the dura, so you get immediate analgesia, because one of the action of epidural is through the subarachnoid.
Yes.
There are 4 mechanisms of action. One is through the subarachnoid, one is directly the nerves passing over, one is, of course, the drug gets absorbed and action, and the other one is paravertebral, like that. And here, intentionally, a small puncture is made, and you get a very good immediate onset of analgesia to be supplemented by the epidural, what you are doing afterwards. So that is recommended presently.
Yeah, it is nothing but an extension of a combined one. The earlier,
yes, extension of a combined, yes.
Yeah.
Here, a small dose they give with the, actually what you are, not small dose, what you are giving in the epidural, that itself dissipated into the subarachnoid space. But here you are creating a hole in the dura.
Okay.
That is Dr. Ambarish.
Thank you, Ambarish, for that.
Well done, Harshra. I was following it. You have almost covered everything.
Yeah, thank you very much.
Refreshing, actually. Well
There
done.
was some of the latest things. Dr. Sanish has also clarified about that. Thank you, Sanish. Any other things? Time to place epidural in obstetric patient can be latent phase of labor. Yes, that's what I told already. In the latent phase, we place the catheter, but activate it only when it is required, when it is indicated, as per your institutional practice. Right. Yeah, that's a latent phase. Okay. Okay, thank you very much. I think we have covered as much as possible, and very good job done by both our postgraduates, Dr. Priya and Dr. Bhuvneshwari. I think your preparation was excellent. Full marks to your professor, Dr. Mubarak. Thank you, Dr. Mubarak, for chairing the session with me. And hopefully all the audience are benefited by that. And at the same time, I think I should also thank the organizers of this particular program, Dr. Vinil, Dr. Nazar, and Dr. Jitin, who coordinated, Dr. Rajesh. All of you, the entire Kerala is very active, and I wish all the best, the ISA Kerala and the participants, so that most of the students will be benefited in your examinations. Wish you all the best in your future endeavors and your examination.
Thank you, Harso sir. I am very glad to be a co-chairperson with such a senior faculty from our fraternity.
It's my pleasure, sir.
I really enjoyed the session, sir.
Yeah, it is an opportunity given to me by the ISA Kerala, so that I could see for a long time Mallikarjun. Also, I was not seeing Ambarish. Yes, I was speaking over phone. I could see him. It's a nice occasion. Thanks a lot.
I am not able to see Ambarish. Not showing Ambarish, sir.
Venkatagiri is the pillar of that.
Yeah, no, not pillar. Ambarish, where is Ambarish, sir? I am not seeing his face.
Yeah, he disappeared. Ambarish, yeah, he is back here. Ambarish is once again back on the screen. Ambarish.
Venkatagiri, well done.
We are only speaking over phone, not seeing physically.
So yeah, Venkatagiri, we have been following ISA Kerala very closely, and I must really appreciate with the leadership of Venkatagiri, who is going to take over as the president. We are really very proud, and ISA Kerala is doing fantastic.
Ambarish sir, nice to
great job.
Mubarak,
Mubarak, seeing after 10 years.
Yeah, not 10 years, sir. Not 10 years. So many years, sir.
We are co-examiners, no?
Yeah, we are co-examiners. Yeah.
Yeah, I am back in Bangalore now. I am in Bangalore.
Yeah,
I joined the medical college, Raja Rajeshwari Medical College, because my family is here, so I am back in Bangalore.
Okay. Sir was my guide actually. Then the guide was changed since sir went to Saudi at that time when I did my PG. Yeah. And we had nice time as my professor being co-examiner with me for so many times, and now seeing for after a long time.
Thank you. I am hearing your this one in the ISA, this and webinars and all. It's really very nice to see you, very active.
Okay,
and
sir,
you are continuing it, and please keep it up.
Okay, thank you very much, sir.
All the best. All the best. Bye.
Yeah.
Bye.
Thank you, sir. Thank you, Mubarak, sir. Thank you, Priya and Bhuvaneshwari. It was a wonderful discussion.
And thanks,
we will have a short lunch break. I will have a short lunch break, and we'll join back at 2 o'clock for a short case discussion on Burns contracture of neck. So we'll join sharp at 2 o'clock.
Okay.
unmute, sir.
How are you?
Oh, fine, sir. You had your lunch?
A lot of noise.
Nice. No, they are playing music.
The music is a lot, really.
Yeah, they are playing music.
Tell them to stop the music.
No, it will be there till we start.
Oh, stopped.
How are you, Supradeep?
Sir, we got another 5 minutes to start.
Yeah, no problem, no problem.
Supradeep? Unmute, Supradeep.
Good afternoon, sir.
Yeah, hello. How
Are you starting? Are we starting?
No.
No, sir, in another 5 minutes.
Another 5 minutes. So he is
Okay.
just sharing his screen.
Okay.
Supradeep. So ready, Supradeep?
Yes, sir.
Okay, I'm not ready, but okay, whenever you want to start, you can start. No problem, beta.
Yes, sir.
We'll wait for another 5. Exactly
Sure.
2 o'clock. Jitin?
2 o'clock, sir.
4 more minutes, sir.
Sure,
Yeah.
sure.
Start
No
at
problem.
exactly 2.
Supradeep, when is your exam?
Sir, I have given my theory exam, sir. Result is yet to come. And practical date has come, sir. It's on 18th of August.
Okay.
He is DNB student, sir.
Oh.
Yes.
Oh, I didn't know. I don't know what is DNB.
No, he's not from Kerala, I was telling.
He's not. I think he's not. You are not from Kerala.
No, because
Are you?
this is a Kerala PG refresher course. So he has, voluntarily he has come to present.
Good. I'm happy.
Very good thing, Supradeep.
Thank you, sir.
Very nice of you. Otherwise, you are from which place, Supradeep?
Sir, I am basically from Odisha, sir.
Odisha.
From
Okay.
Yes, sir.
You told me you are from Cuttack.
Yes, sir. I am from Cuttack, Odisha. I'm doing my DNP in Bangalore, Satyasai Medical Institute.
Edu sir, namaste.
Namaste.
Namaste, Venkatagiri hai idhar.
I can't see you. I can't see you. Unless I see you, I cannot talk to you.
Then we will take selfie when you are together.
Why you are not seeing?
Now you can see me.
Yeah, now I can see you. How are you?
Fine, doing well.
Good. Every Saturday I see you going to some temple.
Yeah.
You are too much over-religious.
Oh, not too much religious. All Saturday.
I know, all Saturday he goes.
Earlier, all Saturday, I used to be in flight or traveling all over India. Now all we stopped Corona, so I have to go to temple.
So now COVID has made you much more religious and much more temple man.
Yes.
Sir, shall we start, sir?
Whatever, I'm ready already.
Jitin.
So welcome back, everyone. Our next session is a short case presentation on Burns contracture of neck. This session will be chaired by Dr. R.P. Geddu, Professor D.Y. Patil Medical College, Mumbai, and by Dr. Gurudat, Professor and HOD, JSS Medical College, Mysore. We welcome you to chair this session, sirs. The case will be presented by Dr. Supradeep Biswal, PG student from Sri Satyasai Institute, Bangalore. We have 45 minutes for discussing this case. Over to the examiners.
Yeah, you can start.
Sairam and good afternoon all. I would like to thank ISA Kerala for giving me this opportunity, sir. Sir, my case today is a 25-year-old male patient, chemical factory worker by occupation at Bangalore. And he came with a chief complaint of excessive post-burn scarring at lower part of the chin, anterior and lateral aspect of the neck, upper chest and right upper arm for 18 months. He has grossly restricted neck movement with inability to look upward, and mouth opening is also limited. Into history of presenting illness, patient was apparently all right. Prior to the fire explosion accident at workplace 18 months ago, following which he developed burn, which involves lower part of the chin, neck, chest, and right upper arm, which approximately accounts for 30% of the total body surface area. Initially, he was managed for a week in high dependency unit and later in the burns unit, and finally discharged after 25 days of treatment. There is a history of ICU administration and acute management of burn, history of repeated burn dressing under multiple GAs. Gradually he developed scar tissue formation over the lower chin, neck, and upper chest and right arm with restricted neck movement and limited mouth opening. There is a history of weight loss up to 10 kg over 3 months post that event. There are no history of stridor, shoot in the sputum, respiratory distress at the time of sustained burn injury, no history of voice change, dysphagia, aspiration at the time of sustained burn injury, and no history of airway intervention at the time of sustained injury or tracheostomy in the later part of his treatment. In past history, there is no history of diabetes, hypertension, bronchial asthma, TB, epilepsy, or psychiatric illness. Personal history, he's on mixed diet. Addiction history, he was a smoker 5 years prior to that incident, consuming 1 packet per day. Apart from that, he has no addiction, no allergic history, appetite was normal bowel and bladder habit. He sleeps in left lateral position with a pillow under his neck. Family history is nothing contributive, and treatment history, no other relevant medical or surgical treatment history. Coming to general and physical examination, patient is conscious, oriented to time, place, person, comfortably sitting with no signs of respiratory distress, thin built and averagely nourished. Weight is 50 kg, height 155 centimeter, with a BMI of 18.4. There is no signs of pallor, icterus, clubbing, lymphadenopathy, or edema. Veins are accessible. Vitals, pulse is 72 beats per minute on right radial, regular in rhythm, moderate in volume. Arterial walls are well palpable, no radioradial, radiofemoral delay, and all peripheral pulses are felt normal. BP 120 by 70 in left arm in sitting position, respiratory rate of 14 per minute, and room air saturation is 96%. To airway examination, mouth opening is 2 fingers or 3 centimeter. Modified Mallampati grade 4, no loose or missing teeth. Thyromental distance could not be measured. Sternomental distance is 8 centimeter. Upper lip bite is grade 3. Patient is unable to protrude mandible. Temporomandibular joint cannot insinuate 1 finger in front of tragus. Effective mandibular length 8 centimeter. Neck movement extension of neck less than 65 degree, and lateral rotation limited to 20 degree, and flexion of 50%. Nostrils, both nostrils are normal size and patent, and the Lemon score of 6 by 9, which is difficult there. Local examination on inspection, burn scar present over the lower part of the chin area, front of the neck, laterally up to the medial border of the sternocleidomastoid, upper chest, and right arm. Circumferential scar involves approximately 50% of the anterior chest above the nipple line. Left side clavicle is visible, and 1/3 of the right clavicle is covered with scar tissue. There are 3 strong bands are visible of visible scar tissue starting from the mentum to the mammary region. There are no active ulcers, sinuses, or fistulas. thyroid, cricothyroid membrane and trachea are not visible. On palpation, scars are non-tender, firm, raised above the skin surface, and sternal notch can be palpable. Thyroid, cricothyroid membrane or trachea could not be palpated. Carotid pulsions are well felt. To systemic examination, respiratory system on inspection, shape of the chest is
any abnormality? Systemic examination?
No, sir. Only on inspection, scars are there on the upper part of the chest.
That's okay. That already I have told. If there are no, positive findings, you can skip this.
No positive finding in respiratory as well as in cardiac, abdomen, and neuro-wise also normal.
Because it's a short case, you can skip all those for today. Okay. So final, your summary.
Summarize, sir.
Yeah.
A 25-year-old male patient with post-bone contracture over the lower chin, neck, upper chest, right upper arm of 18 months duration with a difficult airway of grade 4, scheduled for elective contracture release and skin grafting under GA, general anesthesia.
Sir, Gedu sir, you can ask questions.
You can ask. I'll start. Guru, you can start. I just wanted to ask.
Yeah,
I'm starting.
Yeah.
I'm asking you that what will be the problems associated with this if I want to give a GA?
Sir, as it is a difficult airway, so maintaining the airway will be difficult under GA, sir. If the patient is unconscious, then it will be a difficult airway to manage, sir.
So how you are going to plan for a release of the contracture? Firstly, basically what investigation, important, relevant investigation you can tell me.
Sir, if I'm planning for contracture release, then starting from investigation, I will do a CBC, hemoglobin, and coagulation profile, and LFT, RFT, and PFT, and blood grouping, cross matching, electrolytes, and one X-ray of the chest and neck, and ECG.
Why you want to go for a why you want to go for a PFT? Is PFT going to be very easy for this patient?
Sir, to check for any restrictive disease because of this injury happened in the past, sir. Any fibrosis.
Don't agree, but anyway.
For that, bedside lung function tests are sufficient, isn't it? You can always go for a bedside lung function.
Yes, sir.
Unnecessarily going in for PFT. Of course, PFT you can definitely go for flow volume dupes, isn't it?
Yes,
especially because this patient has been tracheostomized before. So you want to know whether there is any narrowing at that particular level of the trachea. You can also get X-ray of the neck also, lateral and AP view, because post-tracheostomy, definitely there can be scarring and we don't know, isn't it? To choose for a smaller tube, definitely that is there. So these are the investigations. Okay. Okay, sir. Carry on, sir.
Thanks. What is the relevance of your electrolyte investigation?
Sir, usually post-burn patient will be having, because of hemolysis and tissue injury, there will be increase in potassium and loss of magnesium, calcium. So I'll do an electrolyte for that.
What is the relation, I mean, the relevance of the increase in the potassium, up to what level you cannot give? If I want to give a succinylcholine.
Yes, sir. So succinylcholine will cause increase in potassium level up to 13 milliequivalents per liter. It can go, sir. So we'll avoid.
I agree that, but then what is the range? For example, now this patient, your patient has got a burns 18 months back, you said.
Yes, sir.
So is it okay for him to give scoline?
No, sir. Ideally, I will avoid scoline in this patient because of scoline will post-burn because of the proliferation, upregulation of the post-junctional or extra-junctional SES receptor, acetylcholine receptor, there will be prolonged depolarization and hyperkalemia. So I will avoid scoline in this patient. Up to 2 years, it is not advisable to.
No, as per what are the latest guidelines? It's not for 2 years. That's why I'm asking, what is the latest guidelines? Now, as per this patient is 18-month-old months, can I give, let's say his potassium serum level has come to 4.8.
Yes, sir.
Can I give scoline?
I'm not sure, sir, regarding the latest guideline. For burn patient, ideally avoid, sir.
You cannot say that it's for 2 years. As per the latest guidelines, I can give scoline even after 180 days. Earlier, they used to say for 210 days, but now it has come down to 180. In fact, there are something papers reports also which has come that even after 120 days, if your potassium level is less or within normal range, I can give. But in any case, up to 180 days is more acceptable figure for me. I will not give till 6 months. After 6 months, I can give, unless the amount of the burn you had is more than 50%, then I may think of 210 days. But in this patient, it says something like 30% burns.
Yes.
So in such a patient, I think at the most 180 days is enough for me. I can give scoline. It all depends. Like if you got if your body is burned 70%, then I may have to go for 240 days. If your body has got a 50-60%, then I will have to go 210 days. But if it is less than 40%, 180 days is enough. For example, if you have met with an accident, you had a burn only for your both upper limbs, which amounts to, let's say, 18%. Can I not give you scoline? I'm not bothered about your airway. For example, your airway is absolutely normal. You had a burn on your chest wall and your hands because you were drinking tea and that hot tea fell on your dress and you had a burn.
Yes, sir.
And I counted your burns is 22%. And your airway is normal. I can give in after 180 days.
Okay.
These are some of the latest guidelines that have come. What do you say, Gurdat?
Yeah, what is very important is how the burns has healed. The ulcers are still persistent. The burns has completely healed. Suppose if the burns has completely healed, then 6 months, maximum is 6 months. And that too, if the burn percentage is high. So the burns percentage is less than 15%, absolutely no. And it is superficial burns, there is no contraindication. And the potassium level, higher potassium level will be only in the acute burns phase. Now, after say 1 or 2 weeks, the potassium level will be back to normal, isn't it? So as such, for potassium levels, as such, we know that the maximum potassium levels should not be more than 5.5 for anybody to be given succinylcholine, because it is the therapeutic dose of succinylcholine is going to increase by 1.5 to 1 milliequivalent. I'm not talking in burns. In general, I'm talking about. So that's why anything above 6.5, sudden increase, you cannot give succinylcholine. That's why Dr. Gedu sir is asking, what is the maximum potassium level at which you can still give succinylcholine? That is 5.5.
See, you are a normal person. If I give you 100 scoline, how much potassium will increase in your body?
So 0.5 to 1 MEQ.
Max to max 0.2 to 0.4 milliequivalent will increase. But if you got a burns and if you are less than 180 days, then it can increase from 0.8 to 1.4 milliequivalents, which again becomes, see, you have got normal, now you have got a burns and you have got a 5 milliequivalent potassium now. That doesn't mean if I give you scoline, it will go to 10, but it will go to something like 6.8 or 7. So you can land up into some problems. You understand? It doesn't multiply twice, but still it will be significant highs, provided how much is the area of your burn. As I told you, you were drinking tea, you had burn only of your chest wall and hands. You can still, I can give you very easily. And how many days before I can give you, for example, some person has met with the burns right now, and he's been brought into the casualty, and he's posted for debridement, suturing, or something like that. Can I give him schooling?
Yes, sir. Up to 24 to 48 hours, we can give Solian, sir.
Good. So now in this patient, I'm not talking about scoring at all. In this patient, what is your plan for release of the contracture?
Sir, first, my plan A will be awake fiber optic intubation followed by release of contracture, and or I can go for asleep fiber optic intubation. And my plan B will be inhalation or ketamine induction with contracture release followed by video laryngoscopic or intubation or intubation while intubating LMA. And my plan C will be tumescent anesthesia with contracture release, and plan D will be blind nasal intubation.
Blind nasal intubation, whenever there is a distortion of the airway anatomical structure, it will not work. Okay?
Yes,
blind nasal is not an option for you. And I go one step further. I'll say that whichever institute you are working, you don't have fiber optics.
Okay, sir.
And this patient has come to you. I cannot send the patient outside where there is a fiber optic available. So there is no fiber optic for you. Now you tell me how you are going to go ahead.
Then I'll go with my plan B, sir. Either I'll under inhalational or ketamine induction after the contracture release. Then I'll plan for video laryngoscopic intubation or intubating LMA.
Can you explain me with the inhalational or ketamine induction and contracture release how you are going to proceed for it? Tell me. Explain in detail. Like you want to give, let's say, oxygen nitrous and CO. How you are going to go ahead? Tell me.
Okay, sir. First, I'll confirm the NPO status, consent and informed consent. Then pre-medicate the patient.
What? What pre-medication?
In pre-medication, anxiolysis, anti-anxiolysis, like midas 0.05 mg per kg or 1 mg I'll give. Antiemetic ondansetron 4 mg and any proton pump inhibitor like pantoprazole 40 mg. And with that, I'll induce after monitoring. I'll attach all the ASA standard ASA grade monitors and yes, and then I'll induce. I'll secure IV line. I'll start fluid and I'll start inducing patients.
In what way? Tell me.
With SIVO.
SIVO.
With sevoflurane. Yes, sir.
And
with sevoflurane.
when you continued SIVO and patient has gone under anesthesia and now he started obstructing the airway. You are seeing that he has got a obstruction. There is a tongue fall and he is not being able to breathe properly. The chest movements are sinking. I mean, sternum is going inside. So there is a signs of obstruction. So now what will you do?
I'll start bag mask ventilation, positive pressure ventilation. I'll give, sir.
You can't. You will not be able to do that also. Because as you said, airways, I mean, oropharyngeal airway is too small. You cannot put oro.
Yes, sir. Nasal patency is adequate, sir. I can put a nasopharyngeal airway and I'll start giving positive pressure ventilation. And I'll ask the one senior anesthetist and surgeon should be on standby, sir, for any help. And I'll ask the surgeon to release the contracture under once the patient is under.
Which part of the contracture he will release? You tell me. How you know which part of the contracture you have to release? Because your contracture is right from your mentum to up to your sternum. So which one I'll go to release?
Sir, in my case, there are 3 strips of bands that starting from mentum to the upper part of the chest. So I'll ask the surgeon to release those 3 bands so that the neck movement I can achieve a minimum neck movement for and mouth opening for.
No, that's
further,
not the correct way. You can't release 3 contractures as you are saying. I will not accept that. You have to tell me exactly part you are going to release and how you are going to know that which one to release and how much, like if a surgeon and I am going to cut the neck of the patient with that release, whatever you want to say. You tell me how much I will release, where I will stop. That doesn't mean I can release right up to your larynx or the cords. That's exactly what I'm asking you. This is a practical question.
Not sure, sir.
Yes, Gurudat, you want to say something?
No, whatever you are asking, you can always answer. You are correct in asking this particular question.
See, I tell you one thing. We were students. I am from Solapur. We never had a fiber optic scope, but we never refused such patients. Only thing what we used to do is, listen, Shubhradev, are you listening?
Yes, sir. Yes, sir. I'm listening, sir.
In such a condition, in exams also, this is a favorite question. What is this noise coming? Who's talking this? Who's disturbing this?
Gedu sir, now you can unmute yourself and tell. I have muted everyone.
Thank you. Now the thing is what we used to do those days because we never had fiber optic. Can you hear me now?
Yes, sir.
Yes, sir. Yes, sir.
Yeah. So what we used to do, once the things are being done, either oxygen nitrous and nowadays halothane was there, or even for that matter, ketamine, I don't mind. The minute you start ketamine or oxygen nitrous halothane, that time we used to tell the anesthetist, and that way senior anesthetist, of course, as you rightly said, surgeon should be ready. So that surgeon is ready to cut on the neck, where to cut the neck. What I will do, I will put my laryngoscope in the patient's mouth. Okay?
Yes,
and
sir.
thereafter, I will extend the neck, and wherever there is an obstruction, I'll tell him to start slowly releasing the tightest part till I can see the epiglottis. So he's not going to cut till your trachea reaches or till your larynx reaches. The minute I start seeing, because I'm observing inside, seeing by either epiglottis or maybe 1%, and I'll continue my anesthesia so that the surgery and the scar will be better. This is what was our plan.
Sir, but now everywhere fiber optic scopes are available, and majority of the medical colleges, hospitals, fiber optic scopes are there. But only thing is, the student should know how
But
to use
exam
it.
purpose,
Because
we should, as you rightly said, for exam purpose, they should know the other things. Because if I ask you, Shubhradev, how many
Yes,
times you yourself have induced the patient with a fiber optic?
Sir, I have observed many times. I have used once, sir.
that is the problem with majority of the students. When we ask them, they would not have done even a single time. Or they'll say that they have just, in a workshop, they have done on a mannequin. So that is the reason it's very important to know the other options also. Because every examiner will be asking you this same question: how many times you have done? If you say that you have not done, then what are your other options? Because you don't know how to do a fiber optic scope.
That's exactly what I'm asking you.
Correct.
And in exam, you are supposed to know the other options also, because fiber optic is not a final solution.
Yes, sir.
But Subradip, can you place bilateral nasopharyngeal airways and then provide insufflation anesthesia till the contractures are released? Can it be also an option? Nasopharyngeal airway and insufflation anesthesia. No, in this
no,
you have not written that in your options plans. Can you use it?
I'm not sure about that, sir. I have not used, I have not read anything like that.
No, because with that, when you are keeping nasopharyngeal airways, so at least, the tongue fall will not be there. And a continuous insufflation of sevoflurane will be there. Patient will be under anesthesia. That also you can keep it as an option, provided the nostrils are patent. That you would have examined, isn't it?
Yes, yes, sir.
Yeah.
Well, you also mentioned about tumescent anesthesia. Can you talk to me something about tumescent?
Sir, tumescent anesthesia, initially it was discovered by Jeffrey Klein, who's a dermatologist, and he started with a solution of 1% lignocaine, and with 1% lignocaine and sodium bicarbonate 8.4%, 12.5 ml, and normal saline of 1000 ml, and adrenaline 1:1000, 1 ml. He started with that. Then currently,
along with that, you have to also put hyaluronidase.
Hyaluronidase 1500 international unit. So currently, most in our hospital we use 30 ml of 2% lignocaine and hyaluronidase 1500 international unit, and 10 ml of bicarbonate and adrenaline with Ringer's lactate, 1 liter Ringer.
Okay, you have mentioned it's okay, but is it easy to put a tumescent anesthesia in the contractures where you got a different bands at different levels? So you cannot reach, like the way tumescent had been practiced for the obesity, for the what we call bariatric surgery and etc. It was planned originally. So there it is easier for me to raise the skin and to put. Here it's a contractures are there, and normally they say in the contractures the what you call nerves and all are already been as good as dead. They are not been approachable. And plus, you cannot come in a layer where I can inject subcutaneously at the or whatever layer I want to go in the bun contracture. So how it is going to work? And what are the complications of tumescent?
So complications, first thing is local anesthetic systemic toxicity, because it contains lignocaine. Apart from that, overhydration, because we are giving large amount of fluid, overhydration. And
anything more?
Adrenaline we are giving, sir. It can cause an cardiovascular instability.
Air embolism. You are injecting a lot of places here, pushing the syringes and all. Plus volume is also a big one.
Yes.
Have you given tumescent any time?
No, sir. No,
so this is just a theoretical you are telling me.
Yes, sir.
That's what we always say. It is always better to go for a practical. Same thing you have written above also, that I'll go for a intubating LMA. To put an intubating LMA in a bun contraction, is it that easy?
That is after release, I think. What, Supradeep?
Yes, sir. After contracture release, I will. After contracture release, I will go through either video laryngoscopy or intubating LMS. Sir, in video laryngoscopy. video laryngoscopy, as my patient is mouth opening is 2 finger width. So in this patient, I can also go for video laryngoscopy because I can insert a video laryngoscope with 2 finger widths.
Now, which video laryngoscopes are ideal for restricted mouth opening? Can you just name some video laryngoscopes where the restricted mouth openings are there? You can still go for video laryngoscopy and manage.
We use our King Vision, sir. Apart from that, McGrath is there. McGrath and
they are all requires slightly at least 2.5 centimeter mouth opening, isn't it? So you can't have, because 2 finger, I don't know what is your centimeters in centimeters. You should always measure airway.
It's in 3 centimeters. Yes, sir. It's 3 centimeters. I've written 3 centimeter, 2 finger breadth or 3 centimeters.
3 centimeters, definitely you can use video laryngoscopes.
Even on that background only, I was asking you, since you got a 2 centimeter or 3 centimeter mouth opening, can you put an adequate size of intubating LMA also, even if I release your contraction? Because intubating LMA is also not going to be that easy to put. Approach is easier, but putting is not easy. And even after you put, it's not easy that you are going to put it properly, location is proper. What about CMAC?
CMAC, we can prefer a CMAC or
But again, is it awake or under anesthesia you want to go for?
Sir, it is under anesthesia, sir.
Okay, under inhalation anesthesia, you mean?
Yes, sir. Under inhalation anesthesia, yes, sir, under inhalation.
Now, Supradeep, one question I just want to ask you. Suppose you have induced the patient with sevoflurane and you are trying for video laryngoscopy using CMAC. Okay, then what problems you can expect? So what is the, how long your sevoflurane will be effective when you are doing the laryngoscopy?
Sir, after sevoflurane induction, I'll try to put my video laryngoscopy, and as early as possible, I'll try to intubate this patient.
No, because this is a difficult airway, isn't it? This is a difficult airway. You know that you may not be able to get into the airway rapidly. You will take your own time, even with the video laryngoscope, because there is so much of contracture of the neck. There is a lot of distortion of the anatomy there. So even with the video laryngoscope, you may not be able to visualize the larynx properly. So then if you have used sevoflurane, so what is the problem? Does the patient come out rapidly?
Patient will come out rapidly, sir.
Why the patient will come out rapidly with sevoflurane?
Because it has a duration, because of its blood gas coefficient. It will very rapidly come out. Fastest induction, fastest recovery, sir.
Yeah, blood gas solubility coefficient of sevoflurane is how much?
Sir, it's 1.4, sir.
Sorry, it is
0.4. 0.4.
0.4 is desflurane. 0.63. 0.63. So this is one thing, again, you will have to keep it in your mind. It will not occur with halothane, because halothane blood gas solubility coefficient is 2.4. Induction is delayed, and recovery also is delayed. It will not be so fast. Yes. But with sevoflurane, one problem is the laryngospasm. Because when you're trying to manipulate, the patient is coming out, the patient goes for laryngospasm. In a difficult airway, you will have a lot of problems. So how you can change your method of induction and video laryngoscopy in this patient? You have everything ready. Can you use IV induction agent?
Yes, sir. I can use ketamine for this patient also, sir.
No, ketamine, again, the problem is, the vocal cords will be hypersensitive. You just touch them, the patient will go for laryngospasm. And second thing is, there won't be any relaxation. And you can't give any relaxant also here, because, you know that it may be a very difficult airway even for ventilation also, mask ventilation,
Yes,
because you can't hold
yes,
a mask properly because distorted anatomy.
Then I can sedate the patient with dexmedetomidine also. I can go ahead.
No, you can go for many things, but have you heard about Thrive?
Yes, sir.
Now, if you have Thrive, can you use IV propofol?
Yes, sir. We can use ibuprofen with Thrive, sir.
Yeah, with Thrive, IV propofol, because Thrive also, what is the advantage of Thrive in such patients?
It can give PEEP. Also, it can give PEEP of 5 to 7, sir. With
You don't say PEEP, it is always CPAP, isn't it?
CPAP.
Okay, you are not paralyzing the patient.
More than that advantage is you have got a prolonged apneic time.
Apneic time.
Thrive, you can give even something like 7 to 10 minutes time you can get for us to intubate. Like normally with a scoline, whenever we give and we ventilate, mask ventilate, you don't get more than 3 to 4 minutes. But here you can get even up to 10 minutes, 8 to 10 minutes with Thrive. And in Thrive, there is a continuous low flow oxygen, nasal oxygen still going. So it will give us a more breathing time for us to take a time to intubate. Even if I take a little longer time, it doesn't matter. So this is one of the techniques to improve the apneic oxygenation.
Plus, the carbon dioxide accumulation is also not much. Of course, with prolonged Thrive, there can be increase in the carbon dioxide, but for a short period of till you intubate the patient, absolutely Thrive with the propofol is one of the things you can always use for getting into the airway, because I didn't know that this patient's mouth opening is 3 centimeters. 3 centimeters is quite wide. So definitely you can use many of the video laryngoscopes. Suppose if it is even less than that, can use some of the video laryngoscopes which are even used at 1 centimeter mouth opening.
With CMAC,
the 1 centimeter I'm talking about.
No.
You have Bullards, isn't it? The
Bullards,
one,
yes.
of course. Hardly we see that. Bullards, Upshur, Oos. They don't have flange. They have only the blade. So as long as you can put a 6 millimeter endotracheal tube, because you have to put an endotracheal tube also along the stillet, along with the these kind of laryngoscopes. So once that can be introduced, even up to, they say that 0.7 millimeter, 0.7 centimeters of mouth opening you can use. So the other one, the latest one is Bonfil retromolar video laryngoscope. Have you heard about Bonfil retromolar video laryngoscope?
No.
Yeah, because on the sides, intramolar space is larger or wider when compared to the interincisor space. That's how the Bonfil retromolar video laryngoscope. It is a rigid, like a light band only. It's rigid. It is easy to introduce because it is not a flexible one like fiber optic. So definitely you can use that also as one of the options you can always have, because nowadays there are multiple options for difficult airways. Of course, probably the best would be the gold standard in this patient is fiber optic nasotracheal intubation. Okay, if you think that fiber optic nasotracheal intubation is the gold standard, many times you may be asked, okay, how are you going to plan and manage the fiber optic nasotracheal intubation in this patient? Tell me from the beginning how you are going ahead and then plan for. Sir, can I ask this question?
Yes, absolutely relevant.
Okay.
Sir, first I will inform the patient. I will explain the patient regarding the procedure, and I'll take a consent.
Okay.
And then I'll keep a senior anesthetist and a surgeon ready as a standby. I'll keep my difficult airway cart ready. Then in the pre-op area, I will I'll nebulize the patient airway with lignocaine, 2% lignocaine.
Okay.
And I'll give a anti 4% lignocaine, and I'll give the antiemetic and anti-Cialogox glycopyrrolate, antiemetic ondansetron 4 mg, glycopyrrolate 0.2 mg, and I'll give a nasal decongestant of xylometazoline 0.1% 2 puff, and after nebulization, I'll shift the patient in the OT, and before any procedure, monitors, I'll attach all the monitors. Before any procedure, I'll give a topical lignocaine of 4% topical atomizer. Via atomizer, I'll anesthetize the patient's nasopharynx, and I'll check the patency of the nose. The better the nose which is better patent will go for that.
Any particular IV infusion you can start? And any particular drug will help in better cooperation from the patient?
I can use dexmedetomidine for sedation.
Yes, very good.
Patient will be patient will cooperate better.
More cooperative. People have done fiber optic nasopharyngeal intubation with only dexmedetomidine.
But don't you think in this patient, even if you give dexmed, a little higher dose goes, patient will get obstructed. So it is not wiser. But still, there is one thing that has been missing by you. So far, you have given a good look, anesthesia technique and all for fiber optic. But there is one more thing that must be told in men. You can't give anything that is local anesthesia in the transtracheal or all those things, particularly in this patient where you don't have any landmark to give anything. So here, I am telling you, you should always say one word in fiber optic that has been universally used. We call it as a spray as you go.
As you go. Sago techniques.
Sago.
So you have to tell this very importantly. Even if topical anesthesia, even if you're given a what you call nebulization, still you should always say that I'll go for spray as you go.
Yes.
So I'll keep that thing ready.
Yes.
Okay.
But,
so
and you also mentioned blind nasal. If I ask you how exactly will go in this patient for a blind nasal?
Sir, first, all the pre-medication what I have mentioned.
Actually, everything is done. Monitor, everything is done.
Everything,
come to the direct point.
Yes,
I have given local also. Okay, I have given local also. I have given nebulization also. Done. Next.
Airway is the same airway, or you are asking in general blind nasal? Sir, in general blind nasal or for this patient?
See, he has mentioned plan D, blind nasal in this patient only.
Okay.
So I'm asking in this patient only.
Okay.
It's not my question, it is his answer. I want his answer now.
Right.
Yes, tell.
Sir, I'll choose one size lesser. That means for this patient, I'll take a 7 size cuffed tube, and I'll keep it in the lukewarm water to make it a little softened so that it will go easily, sir. And I'll keep the beveled edge of the endotracheal tube towards the medial aspect or towards the nasal septum. As I go advance the tube, I'll hear for the breath sound. Once it is tubular in nature, and it is, I'll advance it, and I'll check for the EtCO2 and the breath sound as well. And once it is confirmed, the airway is confirmed, then I'll induce the patient with inhalational agents.
But Supradeep, one very important thing for blind nasal intubation is keeping the patient in intubating position.
Yes,
or
sir.
the nasal, the morning of sniffing air position or intubating position, whatever we call it as. So in this patient, it may not be possible at all.
It cannot.
No,
Yes,
because he cannot have a extension of the head. Invariably,
Yes,
your
sir.
tube will be going into the esophagus.
Yes,
so
sir.
that is why blind nasal may not be an option for you in this particular patient. So
Yes,
anyway, we have only 1 minute now, sir. We have only 1 minute. Dr. Gedu, sir. Okay, you are talking about the fiber optic. Can you just continue and finish it off?
Yes, sir. Then I will also use Sago technique for this fiber optic for better airway anesthesia, and I'll keep the fiber optic. First, I'll check the nasal patency. The better nose I'll choose, and I'll fit the adequate size, the selected size of tube into the fibroscope, and I'll proceed through the nose. And
why do you want to decongest the nostril?
Sir, in case it bleeds, it will be difficult to see through the fiber optics.
Yeah, because one of the contraindications for fiber optic bronchoscopy or endoscopy is blood in the throat.
Blood, yes, sir.
So you'll not be able to see anything. Of course,
yes, sir.
With the modern fiber optic scopes, very good suction will be there. You can still do good suctioning and then can manage. But
yes,
glycopyrrolate is a must. Light sedation is a must if
yes, sir.
Not too much of a difficult airway, or patient doesn't have OSA. Definitely you can go for. And always keep the scope straight. So never bend the scope, because if you are bending the scope, you don't know where exactly the tip is going. And always keep looking at some opening when you are going. And once you see the epiglottis, then you know how to manipulate it, because you can manipulate only in two directions, isn't it? The tip.
Yes, sir.
So then you can manipulate and then you can enter. What is your final position of the fiber optic scope before you introduce the endotracheal?
Sir, just above the carina, I have to see the carinal angle. Just above
you have
the
to identify the carina. You have
the
to
carina
identify the carina. So once you identify the carina, so definitely
I'll advance
can
the
I
tube.
can I give now induce the patient and then push the tube?
No, sir. It's better to I'll secure the airway first. I'll push the tube first, then I'll start inductions.
Yeah, because many times what happens is the patient will not be cooperative for pushing the tube.
Yes.
So he will be cooperative for putting the fiber optic scope. So at that, when you are 100% sure that your fiber optic tip is visualizing the carina, so you can definitely give propofol. Now patient will be very comfortable. You can just put the tube and then inflate the cuff and take out the the fiber optic scope. So anyway, Supradeep, well done. I don't know, we have lost Dr. Gedo. So I think there must be some
Gedo
problem.
sir, can you unmute yourselves? Gedo sir is muted.
Not able to hear him.
I think you people unmute me basically. So okay, Guru is more important than Chela. Guru's talk is more important. Anyway, doesn't matter. I just wanted to highlight one last point. Since you said blind nasal, can I just add a little bit? What because this is the latest one where the endotracheal tube tips have come, which can be manipulated from outside. The tip can die. This is the tube tip. This is the tube tip. I got a control which I can pull and it can go up and down also. So in such a tube, I will put such a tube, and at the other end of the tube, that is the machine end of the tube, I will put a ETCO2 monitor, and thereafter I will slowly guide the tube towards the trachea. So even if it is going beyond the trachea or here and above down, I'll manipulate my tube with the tip which can be connected, which can be diverted from the distal proximal end. I can push it like that, and thereafter wherever I get a fairly good amount of ETCO2 waveform, I'll push the tube. Naturally, if I'm entering the trachea or cords, patient will start coughing, and thereafter, since I'm getting a good wave of ETCO2, that means I'm very much in the trachea, and then I can induce. This is the latest one that has come up.
Flexible tip endotracheal tube, sir.
Yes, that's what I'm telling you. This is, of course, Shubhradeep, I didn't expect from you, but I'll just to add to your knowledge. Okay?
Yes, sir.
So thank you very much, Jitin.
Thank you, sir. Thank you.
I hope it was okay.
Yes, sir.
Shubhradeep, fairly well done. You are done.
Well done, Shubhradeep.
Good. Congrats.
Thank you, sir.
And thanks, Jitin, Venkatgiri, and Nazar, and everybody. Thank you, Guru.
Sir, thank you, sir. Thank you. Thank you.
Reduji is telling something about Venkatagiri. Scolding me? You are telling something about my scolding me, I think.
Who Who's spoiling me?
We will meet in Mumbai and take selfie soon.
You are my selfie friend. I know that.
We will meet in Ahmedabad on 29th of November.
I will try to come physically there. Definitely, I am registered already.
You will be there.
Yes, I will be there. Don't worry.
Hey Giri, ಆದಿತ್ಯರ ಮಧ್ಯಾಹ್ನ ಎಂತ ಕೇಸ್ ಮಾಡ್ತಾ ಇದೀಯಾ?
Emergency, yes.
Okay, enjoy.
Okay, Supradeep. Okay, Jitin.
I am here in my
Thank you.
class also. I am going home. Finish my case. I sit at home and see you. Okay.
You can start the next case, Jitin.
Okay, Venkatgiri, thank you so much. Thanks, Nazar,
Thank you.
Vinil, and Jitin. Thank you so much. Supradeep, good show. Thank you.
Thank you, sir.
Okay,
Thank you, Guruji. Thank you.
Thank you.
We now come to the next long case. That would be COPD patient coming for cholecystectomy. The students are Dr. Parvati and Dr. Anjali coming from Pushpagiri Hospital, and the examiners are Dr. Madhusudan Upadhyay, Professor KMC Mangalore, and Dr. Sumesh Rao, Professor KMC Mangalore. So over to Parvati and Anjali.
Are you there?
Good afternoon, sir.
Good evening.
Are you there, Parvati and Anjali?
Yes, Anjali is definitely. Oh, okay. Yeah, your voice is getting distorted. I think it might be your bandwidth.
It's not clear, sir.
Dragging a bit. Let's see. That also gets energized as we go by.
Okay, sir.
First of all, thanks to ISA Kerala for organizing such a wonderful event for the sake of the postgraduates, and happy to be a part of this. Sumesh?
Yes, sir.
Yeah.
So shall we begin the session, Dr. Parvati and Dr. Anjali?
We should.
Yes, sir.
You can start with presenting your patient.
Thing is, it's extremely bright behind you. That is why I think. Yeah, that's okay. You can't switch off the OT lights. It's okay. We'll start off. Sharing the screen. Who is sharing the screen for the case discussion?
I'm sharing the screen, sir.
Yeah. Yeah, all the students, please remember that COPD is always a long case for you people in the exams. And theory too, you can get questions on the COPD, which will be a part of multitude of comorbidities, and as a long question, or you can also have short questions from COPD, the ICU management, the emergency management, and then the comorbidities, the surgical management. Therefore, COPD is, anyways, we do see a lot of patients with COPD. Therefore, for your clinical acumen to improve too, you have to know about the COPD and how to manage. And to tell you frankly, I don't mind a patient with low ejection fraction with the real cardia coming for anesthesia. I can somehow prop up the cardia, but I hate it when the patient has wheeze and intraoperative bronchospasm, whether it is because of asthma or COPD exacerbation. I find it extremely difficult to manage them on table. I dread intraoperative spasm rather than intraoperative hypotension. Therefore, COPD is very important. And if you are ready with the PPT, can we start?
Can you see my slides, sir?
Nope. I can see only myself. Should I? Or maybe Sumesh can share the screen. It's only about the case, right? You can present it. Let's not waste time. Already we are 9 minutes behind.
Good evening, everyone. We are presenting a case. We are presenting a case of a 58-year-old male patient, a mason by occupation, hailing from Tiruvalla, He came with presently complaints of abdominal pain and vomiting since 1 day and 1 episode of fever. History of present illness. Patient complained of abdominal pain, which was sudden in onset, intermittent, colicky pain. Each episode lasted for about 20 to 25 minutes. Initially, it was localized around the periumbilical region and now reaching to the upper right quadrant and exacerbated on taking oily food. The patient also had vomiting. He had 3 episodes of vomiting, which was yellowish in color, non-projectile, containing ingested food particles. The patient had 1 episode of fever, which was low grade and not associated with any chills or rigors. Patient also complained of breathlessness since 8 years and is on inhaled daily medication, exacerbated on exposure to cold and dust, and when hurrying uphill, the patient has to stop for his breath. The breathlessness aggravated for the past 2 months and relieved on taking inhaled medications. The patient has about 8 episodes a year. Last exacerbation was 2 months back, and the patient was admitted in the hospital thrice in the last 1 year. The patient has cough for the past 2 months, which was productive, scanty, white, mucoid, not foul smelling, and not blood stained. The patient has no history of any chest tightness. Coming to the past history, the patient is a known case of dyslipidemia. History of recurrent respiratory tract infections is present.
Can I break in? Yeah. Does cough, the history of cough, does it give you a clue to what you are handling, how the patient is?
The patient is having cough for the past 2 months, which is productive and whitish in color.
Yeah, that is this patient. Depending on the cough with the expectoration, does it give you any clue to what the patient has?
If it is scanty sputum, we go with the chronic bronchitis. If it is a copious, you can go for bronchiectasis diagnosis. With the color of the sputum, if it is yellowish in color, we prefer pneumonia or any infection. Then if it is rusty in color, it is rusty in color, it is pneumococcal infection.
Okay.
Then pink frothy in color, pulmonary edema.
And nowadays, because of the COVIDs,
black in color,
aspergillus, right? Okay. And does the cough qualify as one of the tests which you should do pre-operative?
Yes, sir. It belongs to the bedside PFT test called as cough test.
One of the
bedside PFT test.
Yeah, one of the bedside PFTs. You carry on. We'll discuss that later.
Coming to the past history, the patient is a known case of dyslipidemia. He has history of recurrent respiratory infections. There is no history of invasive mechanical ventilation, no history of any unconsciousness, any previous surgery or anesthetic exposure, or childhood asthma, tuberculosis, or any seizure disorder. There is no history of diabetes mellitus, hypertension, coronary artery disease, cerebrovascular accidents, thyroid dysfunction, or any food allergy. Treatment history, the patient is on Foracort inhaler.
Was there any history of hospitalization for his COPD?
Yes, sir. Yes, 3 times last year.
Last year. Was he in the ICU or was he in the ward?
He was in the ward, sir. He was given oxygen therapy in the ward.
He was given oxygen therapy with
oxygen therapy. Okay, we'll discuss that later. Okay, carry on.
Coming to the treatment history, the patient is on Foracort.
Can you, sorry to interrupt again. Can you people please slow down a little bit? Why did you ask for this history of food allergy here?
For induction of anesthesia, we are using drugs which can cause propofol and all, which causes allergy. Egg allergy is there.
Okay,
and
so
for
that means,
medications that we use can cause.
Okay, so you are meaning it in general, just for your anesthetic drugs. Is there any relation between respiratory disease and allergies?
Yes, sir. Who have bronchial asthma history, they can have allergy to many food particles, like this. Food allergy history will be there for bronchial asthma.
Okay, so what is the Eagles triad for that?
Urticaria.
Okay, it's basically on examination sinusitis or nasal sinuses, polyps. Okay, then allergy and asthma.
Asthma.
Okay, right.
Yes.
Go on.
You said the guy has breathlessness.
Yes, sir.
What grade was that?
This MMRC 2, sir.
MRC? How do you grade dyspnea? How do you grade dyspnea?
Classified according to the Modified Medical Research Council grading.
Okay, that is
so
one.
Then we have the Rosian's classification and American
Roizen's.
Thoracic Society.
Yeah, right.
Roizen's and
Then
American Thoracic Society classification.
what do you use? Basically, what do you use? Which one of these do you use?
MMRC, sir.
Okay, yeah. When we grew up, we used Roizen's, and I always felt Roizen's was the easiest. And then now you have the MRC. How do you grade breathlessness according to the Medical Research Council classification?
In grade 0, the patient gets breathless only during strenuous exercise. In grade 1, the patient has breathlessness when hurrying on a level ground or when he's walking slight up a hill. In grade 2, the patient walks slower than peers of his same age group or has to stop for breath when he's walking at his own pace. In grade 3, the patient gets breathless when he's walking around 100 meters. The patient has to stop for breath. And in grade 4, the patient cannot leave the house. He is breathless at rest.
Okay. Anyways, you have mixed up various classifications. But grade 3 is he has to stop because of the breathlessness when walking on a level ground at his own pace, basically. Okay. Yeah. Fine. Carry on. Where does this guy belong to?
Grade 1, sir.
Okay. Chal.
Grade 1, sir. Grade.
Oh, I heard that. Carry on.
Okay, coming to the treatment history, he's on Foracort inhaler, which is formoterol plus budesonide, 2 puffs, 101. He's on salbutamol inhaler, 2 puff SOS, and tab atorvastatin for dyslipidemia, 10 mg HS. Coming to the family history, he is married.
Wait. Slow down. Okay. So what is pertinent here? So he has been on what drugs?
He's on formoterol plus budesonide combination, 2 puff BD, sir, and then salbutamol inhaler, 2 puff. He's taking SOS.
Okay, so he's only on inhaled drugs, right? How long has he been on these drugs?
For the past 5 years, sir.
And there has been no.
Every day?
Madhusudan sir was asking, is it every day? Yeah.
Yes, sir. Daily medication he is taking.
Okay. Now continue with the significance.
He's taking a short-acting bronchodilator, beta-2 agonist, and an inhaled corticosteroid therapy.
Okay, no, wait. My question was, you said that he has been taking these drugs for the past 5 years, right?
Yes, sir.
But meanwhile, he has also been having frequent episodes during the last 2 years, couple of years. And during the last year, he said he has been coming into hospital 3 times.
Yes, sir.
Right? So do you think either the history of treatment is wrong, or he's not taking the drugs properly, right? Or he has not been followed up by a pulmonologist?
Yes, it is not being optimized properly.
You have to either optimize or escalate his treatment or shift to other drugs, right?
Yes, sir.
So that is when you have to ask the question if he is taking the drugs properly or no. So these are inhaled agents. Have you actually checked him taking the drug? Is he doing it in the right manner? Does he use a spacer?
No, not using a spacer, sir, but we haven't checked.
Yeah, he's also a manual laborer. Could he actually afford the drug, and was he taking it? Was he compliant to the treatment? So all of these are questions that you wanted to ask at that time.
Okay. So.
Yeah, ultimately, it may not be your primary responsibility to see how he has been taking, whether he has been compliant, but still it is worthwhile knowing because you are going to treat the patient holistically, right? When he comes for anesthesia, obviously you are going to manage him and you want the bestest of the outcomes for this patient. Therefore, I think it's worthwhile looking into each smallest details, okay? Carry on, please. Yeah, then again, I was asking you about the significance in anesthetic importance of these agents.
Okay.
He's on steroids.
Long-term use.
Yeah.
So long-term use of steroids can cause cortical suppression.
And beta-2 agonist long-term can cause hypokalemia and hypokalemia to the patient.
That's what? Only hypokalemia?
They can precipitate arrhythmias.
They can precipitate arrhythmias.
Hypokalemia.
And what are the other side effects of salbutamol?
Tachycardia.
Okay. Do they get tremors? Do they get tremors? Yeah, obviously, right? Yeah. And the steroids, so how would you supplement these patients? You said that can have the suppression, adrenocortical suppression. How will you supplement?
So the patient is for cholecystectomy, sir. So we consider it as a major surgery. So we will give a 100 mg IV stat prior to the surgery and give it 100 mg QATH for the next 48 hours.
Okay. No, the answer has to be complete, not only for this patient. Otherwise, the question was, how do you supplement steroids when the patient has been on steroids?
So if in case of patient on long-term steroid therapy, especially if the patient is taking IV oral steroids 10 mg, more than 10 mg for more than 10 weeks, within the 10 more than 10 days within 10 weeks of surgery, we will have to supplement with IV corticosteroids. Otherwise, it is not advised now for substituting with IV steroids. If we are in substituting steroids in minor surgeries, we have to give 100 mg stat and follow IV infusion for 24 hours.
IV infusions?
100 mg for 24 hours.
The
minor
patient
surgeries?
Is, for minor surgery, the patient is
only for the major surgeries, you give 100 milligrams on induction and then continue for at least 24 hours, minimum of 24 hours. That is 8 hourly. That should be about 4 doses. Okay. If it is minor surgery or it's a moderate surgery, what do you do? 25 milligrams. You give 25 milligrams, right? Yeah. That should be more than enough. There was a time when we used to give 100 milligrams 3 times a day for every damn surgery. It is not so enough. Minor surgeries, you will give only 25 milligrams, and major surgeries like this surgery, you give 100 milligrams and continue for 24 hours every 8 hours. Okay. Yeah.
So, and yeah, what are the perioperative considerations if the patient was on long-term steroids?
If the patient was on long-term steroids, the dose has to be continued perioperatively. Like for major surgery, we have to.
No, I mean, we already discussed that. No, what are your anesthetic considerations or problems? So basically, you have to keep in mind the the hypothalamo-pituitary axis suppression, hyperglycemia induced by the prolonged steroid, right? And delayed wound healing. Okay. Does it affect the airways?
Infections?
Yes. Does it affect the? Okay, infections might be more common then.
Then in COPD patients, bronchodilation is not provided by steroids. So ideally, we have to give a bronchodilator first and then give steroid.
Okay.
It is not effective in COPD patient.
Yes. So as people are also answering in the chat box, so there are also other considerations like airway problems, oral candidiasis, okay, especially since he has been on inhaled steroid for a long while. And there can also be muscle weakness. Okay. Yes. Right. Go on. Osteoporosis. Yes. Good. Go on. Continue.
Coming to the personal history, the patient has a mixed diet. Appetite is normal. No sleep disturbance, normal bowel and bladder habits. He was a chronic smoker since the age of 23 years. He uses around 20 to 25 BDs per day. He has a PAC-year of 43.75 and smoking index of 875. He's an occasional alcoholic.
Okay, stop. So what is a PAC-year?
It is a number of cigarettes that the patient is using per day into number of years that the patient has been using, has been smoking divided by 20.
Okay, so how did you get this number of, that was my next question. How did you get this number of 43.75?
The patient has been smoking for the past 35 years and the patient is using around 25 BDs per day divided by 20.
Yeah, one problem. So this was for cigarettes, right?
Yes, sir.
So a pack of cigarettes is 20, right?
20.
Into 365.4 days by 20, as you said, right? 20 or 25 years,
yes,
right? So that gives you your number. What about the concentration of tobacco between BD and cigarette? It'll actually be much more, right?
Yes, sir. Okay, sir.
Yeah, because
it is more, right?
It is more with BD, so yes, sir, unfiltered and concentrated, yes.
Oh, okay, yeah.
Okay, so that pushes up your smoking index yet further. Okay, so what is the smoking index?
Smoking index is the number of cigarettes that the patient has been smoking per day into the number of years that the patient has been smoking.
Okay, right. So what is the importance or significance of the smoking index? What's the importance of that number?
If it is less than 100, then we expect only mild complications. Between 100 to 300, there might be mild postoperative pulmonary complications. And if it is more than 300, we should be expecting major complications post-surgery, post-pulmonary complications.
So how did that indexing begin? I mean, what was the major consideration for them when they started the index or in the publication?
Whether he is a mild smoker, a moderate smoker, or a heavy smoker.
Good. The thing was, see, the numbers were, as you said, 100, 200, and 300. Okay.
Yeah.
So if it is more than 300, what the original author said was, you have to keep in mind the very high possibility of a
heavy smoker and heaviness index.
Of a lung adenocarcinoma. Okay.
Yes.
Yeah, so you have to keep malignancy in mind if the number is more than 300. All right.
Yes,
so shall we ask you now about the relationship between smoking and COPD, which is an essay question for which you should be able to write 5 pages?
Yes, sir. The effects of smoking in the respiratory system. It increases the secretion of mucus. It is there will be hypersecretion and more proliferation of the mucus glands, and then it will cause decreased ciliary activity and thus decreased ciliary clearance. Then there will be action on the primary airway, causing airway irritation. It will make the airway hyperreactive. And then there will be, due to the smoke irritation, the epithelial lining will become more, permeability will increase for the epithelial lining, and that can cause more penetration of the toxin.
That's basically damage, right? It's endothelial damage. Okay, right. Then.
And permeability increase, and this reactivity, hyperreactivity will increase. Then there will be the lung will be bronchitic lung, so there will be flattening of the diaphragm with the increased barrel-shaped chest. So there will be decreased lung compliance, and then there will be increased synthesis and production of elastolytic enzymes, and these enzymes can decrease the compliance of the smaller airways, and there will be decreased ventilation, VQ mismatch will be there.
Okay, good.
Then the carbon monoxide in the cigarette smoke can combine with the hemoglobin and form carboxyhemoglobin. This carboxyhemoglobin is have more affinity towards oxygen, towards hemoglobin. So there will be left shift of the oxygen dissociation curve, and thus the tissue release of the oxygen will be reduced due to decreasing T50. So the tissue will go in for tissue hypoxia. This tissue hypoxia can cause erythropoietin stimulation and cause polycythemia also.
So this is the major action of the gaseous
All right, good.
phase.
So
that is
you
carbon
said
monoxide.
polycythemia, right? What
Yes, sir.
what side effect do you have to keep in mind perioperatively?
DVT, more chances of DVT.
Yes, DVT and
Because-
thrombosis. Okay, so you have to hydrate the patient adequately. You have to make sure of the circulation. You might think of early anticoagulation. Okay. Now, after
Yes,
all
sir.
this, yeah, that was a good answer. After all the Ramayana, let me ask one question. What is the commonest cause of COPD?
Cigarette smoking.
Yeah, so start with that. Okay. Yeah, continue.
What are the other risk factors? Anyway, you are done with the history. What are the other risk factors for COPD?
Occupational exposure, like in gold mining or cotton textile industries, indoor air pollution mainly by biomass fuel or wood burning, outdoor air pollution, genetic factors like alpha-1 antitrypsin deficiency.
Yeah. What is the significance of that? It runs in the families, right? You should, when you take the family history, you should ask about antitrypsin deficiency. Yeah. Yep.
Then developmental anomalies of lung.
Yeah.
Yeah.
I think that's done. Yeah. Carry on.
Coming to the examination, general examination, the patient was conscious, oriented, alert, and cooperative, moderately built and nourished. His height was 167 centimeter and weight was 58 kg. The BMI was 20.86 kilogram per meter square. He had grade 2 clubbing. He had grade 2 clubbing. There was no pallor, icterus, cyanosis, lymphadenopathy, or pedal edema. Skin and hair was normal. Nails staining was present. Skin turgor was normal. Capillary refill time was less than 2 seconds.
Good.
Coming to the vitals, he was
Okay, let's say, yeah, you said grade 2 clubbing, right? So let's say this patient had a higher grade of clubbing. What would be your, what would be your thoughts?
The causes of clubbing are basically categorized into respiratory, cardiovascular, and other
Right.
causes.
Good.
And respiratory causes, there is lung pneumonia, lung abscess, empyema, malignancy.
Yeah. So to cause clubbing, which is peripheral tissue.
Yes, sir. There should be severe hypoxia.
Yeah.
Yep.
So that causes the peripheral capillary dilatation and growth, right? So
yes, sir.
The causes have to be chronic, right? In this patient, it could be respiratory and cardiac, as you said. What could it be cardiac in this patient?
Pulmonary can.
Yes, I mean you would have. I mean that's a pretty late stage, isn't it?
Yes, sir.
Right. What about respiratory causes? So chronic, yeah. So the chronic bronchitis or chronic infection, as you said, right? It could also be malignancy again.
Yes, sir. Malignancy
Okay.
would be.
Yeah. All right. Continue. Thank you.
The patient was afebrile. The temperature was 37.8 degrees Celsius. Pulse rate was 92 per minute. It was regular, normal in volume and character. There was no vessel wall thickening. There was no radioradial or radiofemoral delay, and all peripheral pulses were felt. BP was 130/96 millimeters of mercury, recorded in the supine position in the right upper limb. Respiratory rate was 25 per minute. It was abdominothoracic. Saturation was 96% in room air. The JVP was not raised. Coming to examination of the airway, there was no facial asymmetry or dysmorphic features. There was no loose tooth or dentures. Mouth opening was 5 centimeter. It was Mallampati grade was 2. Temporomandibular joint admits 1 finger. The thyrometric distance was within normal limits. Neck movements were adequate. The spine was normal with no kyphoscoliosis. Coming to the systemic examination, abdomen, inspection was normal. Palpation, tenderness was present in the right hypochondrium. Murphy's sign was positive. Percussion was normal. On auscultation, bowel sounds were heard. There was no other added sounds. Coming to the inspection, upper respiratory tract was normal. Respiratory system, the upper respiratory tract was normal. Lower respiratory tract, trachea appears central. Chest was barrel-shaped. Bilateral supraclavicular hollowing was present. There was no infraclavicular flattening or drooping of the shoulder. Chest movement appeared to be decreased bilaterally, and respiratory rate was 25 per minute. On palpation, the inspection
Okay, wait a minute.
confirmed.
Slow down. Okay, so what is your impression from the respiratory system findings?
possibility of an emphysema, sir.
How are you saying that?
Because his chest is barrel shaped, there is increase in the respiratory rate. There is bilateral supraclavicular hollowing, and chest movements appears to be decreased bilaterally.
Okay, his respiratory rate is nearly doubled, right?
Yes, sir.
Would you say he had dyspnea at this stage when you examined him?
Dyspnea not at rest, sir.
Okay. Right.
With exertion.
You said he was comfortable at rest and then respiratory rate is so high. Did you look for central cyanosis?
There was no central cyanosis, sir.
Okay.
Right. So I'll take you back to Madhu sir's original question. Okay. So this person, you have not sent investigations yet, right?
Yes,
So from your examination findings, how can you say whether it is chronic bronchitis, COPD, or emphysema?
There is no central cyanosis. So that's a point against chronic bronchitis. And the patient has barrel-shaped chest. Again, that is towards emphysema.
And there is no feature suggesting of core pulmonary or pulmonary arterial hypertension.
Okay.
And in the patient on the history wise, there is exacerbation with sputum production, but scanty sputum production only. In chronic bronchitis, the sputum production will be more compared to emphysema.
Really?
And
really? What is the difference in sputum between chronic bronchitis and emphysema?
Sputum production is nil or not there in emphysema. Chronic bronchitis is characterized.
Okay, let me put it this way very simply for you. What is emphysema?
Emphysema is a pathological dilatation of spaces beyond the terminal bronchioles without any obvious
and then in the later stages, what happens?
It is irreversible damage.
Okay, irreversible damage of the alveoli, right?
Yes, sir.
Along with hypoproteinemia, etc., because of the damage, right?
Yes, sir. Yes,
and
sir.
Basically, the patient unfortunately starts coughing his lungs out.
Yes, sir. Yes, sir.
Right? One of the definitions of emphysema is what is the normal quantity of sputum production daily?
100
less
ml.
than 100 ml.
Less than 100, right? So what happens in chronic bronchitis with this sputum production? What kind of sputum are we looking at?
Scanty mucoid.
Yeah, it will be more solid. It might be scanty, or it might, at the most, it might be CAS. Okay, he will be coughing out CAS. What about emphysema? Yeah, there is a whole lot of liquid sputum. Okay, he will be producing sputum throughout the day, right? You have seen patients sitting with a cup and coughing out into that, right?
Yes.
It will definitely be more than 125 ml. And it usually is also infected and foul smelling because of his, the systemic complications of the respiratory disease.
Yes.
Okay. So how else do you differentiate between the chronic bronchitis and emphysema on examination?
On examination.
Relax. Just think and answer. The patient is in front of you. You are examining him. Okay. What are the things that you will look at? What are the questions that you will ask to differentiate between these two important conditions?
The duration of the symptoms. For chronic bronchitis, it might be present for at least cough with sputum production for at least 3 months for the past 2 years.
Right. Go on. You can go on talking.
Then we ask for, on examination, we look for mainly for central cyanosis. They are because chronic bronchitis, they are blue blood. Then features of heart failure, which is seen more with chronic bronchitis, a raised JVP, a parasternal heat, shift of the apex beat,
hepatomegaly,
a tender hepatomegaly in case of right heart failure, bilateral pedal edema.
Okay, right.
Features of polycythemia, which would be more with
so why is all this happening? Yeah, why is all this happening?
Because
which means the question is the pathophysiology. Okay.
In chronic bronchitis, there is inflammation of the airway, And in emphysema, it is permanent, irreversible dilatation of bronchioles.
Okay, you said blue blotter, right? What is blue blotters and pink puffers?
Emphysema patients are usually, they don't have cyanosis. So they're called pink puffers, and in chronic bronchitis, there is presence of central cyanosis.
So why are they puffing?
Emphysema,
Yeah, why are the emphysematous patients puffing?
Because there is dilatation of the
Okay, basically this is like whistling or pursed lip breathing, right?
Yes, sir.
So as we said, their lung tissue and the lung musculature, airway musculature is destroyed. Okay, so
Yes,
they cannot generate enough positive pressure to exhale.
Yes, sir.
Right? Okay. Yeah. So last question on examination. What is the tripod position?
The patient is leaning forward with his hands on the mattress with a purse.
Why? Why?
Yes. Because he's in supine position, the FRC will be reduced.
Okay, that's one. Yeah, he can't lie down. All right. His breathlessness increases because of various factors. Might be both the respiratory as well as cardiac. But why is he sitting up, fixing his arms and struggling to breathe? Basically, again, yeah. So somebody has answered in the chat box. Okay, yeah, the respiratory muscles are affected, right? So he has to make use of the accessory muscles of breathing or the extrathoracic muscles. Okay, yeah. So he's using the arms to fix and to have a fulcrum for the muscles, extrathoracic muscles to contract. All right, thank you. You're doing very well. Thank you.
We'll go a little faster because
yes, sir.
We've got another 34 minutes left. Yep.
Coming to the palpation, the inspectory findings were confirmed. Chest expansion was 2 centimeters, AP diameter was 23.5 centimeter, transverse diameter was 22.5 centimeter. The chest movements were decreased bilaterally, and the vocal stenitus was decreased bilaterally. Coming to the percussion, hyperresonant note was heard in all areas, and on auscultation, vesicular breath sounds were heard.
There were no wheeze.
There was a bilateral occasional rhonchi was present.
Okay.
And vocal resonance was decreased bilaterally. Bedside PFT, room air saturation was 96%. Single breath counting was 25. Subrasi's breath holding test was 20 seconds. Cough test and wheeze test were positive. Coming to the cardiovascular.
Okay, so from the bedside pulmonary function test, I mean, that's all you did?
That's all? What is Snyder's match flowing test?
In Snyder's match flowing test, the lighted candle is kept at various distances from patient's mouth, and the patient has to blow out the candle with his mouth wide open without pursed lips. And the distance from which the patient can blow out the candle, we'll get to know about the maximum breathing capacity of the patient. If it is at a distance of 3 inch, we have 3 inches, 6 inches, and 9 inches.
Okay.
At 3, if the patient is able to blow out the candle at a distance of 3 inches, then the maximum breathing capacity is 40 liters per minute. Okay. Then if it is at a distance of 6 inches, it is 60, and at a distance of 9 inches, it is 150.
Okay. What should be? How do you do the Subrasi's single breath count?
The patient is asked to take a deep breath and count from 1 onwards, and we have to see till which number the patient can count without exhaling, and normally he should be able to count above 40.
Okay.
It helps us to know about the patient's vital capacity.
And the trend is useful because when the patient becomes a little bad, you should repeat this, and if he can count only a little less, it means that the disease is deteriorating. Also helps you in the post-operative time when you do the single breath count. Then what is the breath holding test? Subrasi's.
The patient is asked to take a deep breath, and we keep the stethoscope in the patient's trachea and to look for early exhalation, and we see how long the patient can hold his breath. Normally, the patient should be able to hold his breath for about 40 seconds. If it is less than 25, then it suggests poor cardiorespiratory reserve.
Okay.
And if it is less than 15, it is very poor cardiopulmonary reserve.
Okay. What else do you do?
Then we have de Bono's whistle, sir.
Yep.
So basically for measuring the peak expiratory flow rate.
Yeah. What does it tell you?
So yeah, what are the tests of, I mean, what are the better quantitative tests that you could do that give you some numbers that you can act on?
Bedside.
We can do a right peak flow meter.
Peak flowmetry, very good. Okay.
Right respirometer.
What's his full name? What is Wright's name?
Thanks.
Martin Wright. Okay, sure. Carry on. Yeah, what is, yeah, answer Sumesh. When did he come out with this respirometer or the peak flow meter? 1959. Okay, go on. Go on. What are the numbers you get? What is normal?
Normally for females it is 300 to 500 per liter per minute, and for males it is 450 to 700.
700 liters per minute. Okay. Yeah. Any other bedside test you?
For post expiratory time.
Yeah.
The patient is asked to take a deep breath and then exhale out as fast as possible. And if the post expiratory time is more than 6 seconds, that suggests an obstructive airway disease. Then we have maximum laryngeal height, wherein at the height of expiration, the distance from the thyroid cartilage to the suprasternal notch is measured. If it is less than 4 centimeters, that suggests an obstructive airway disease.
Okay, good. Yeah, that should be good enough. But make sure that you do all these tests when you have a case of respiratory disease and you present them. The examiners will be mightily pleased. All right. Yeah. Go on. I think we're okay. CVS,
yes,
there
sir.
is nothing. There's nothing on CVS.
So I think we can go on to the discussion. So all the organ systems seem normal.
Yeah, exactly. CVS, you have to know when the patient has cor pulmonale, obviously there will be findings. You have to examine the CVS, and then the CNS too you have to examine because
hypercarbia can cause cause sedation and anesthesia.
Yeah, when they retain carbon dioxide, obviously, depending on the carbon dioxide levels, the mentation changes. Okay, you should examine the CNS too, and the drug side effects. I told you about that. The CNS examination has to be done for that too, right? Shall we? Yeah, there is a question in the chat box. Any role for incentive spirometry? Yeah, you have to do it because one thing is it helps the patient to know how the incentive spirometry is done so that the PPCs, the incidence comes down. You train them to do it, incidence comes down. And post-operatively, you continue with that, then obviously it helps. Okay, yeah, carry on. Where are we? Yeah, just summarize the diagnosis and then the patient is posted for cholecystectomy. Yeah.
So we have a 58-year-old male patient, Mason by profession, who is a chronic smoker since the past 35 years, presented with complaints of intermittent abdominal pain aggravated with food intake associated with fever and vomiting, and have features suggestive of COPD, optimized with regular medications, and is now posted for cholecystectomy.
Yeah. But anyways, let us not get into the medical management. As Sumesh said, if that guy had 8 episodes of exacerbations, I think he needs better control.
Yes.
How will you investigate this patient? You have this patient who has had the exacerbations throughout the year, irrespective of the seasons.
Yes, sir.
Yeah, how will you
first I will do a blood investigation. In blood investigation, I will do hemoglobin to check for anemia or polycythemia. Then I will do a total count to see if there is any active infection. In that, differential count is also needed to check for the eosinophil count. If eosinophil is high, we'll have to do an absolute eosinophilic count to see an underlying asthma component. If it is more than 300, we can say that there is underlying asthma for the patient. Then I'll do a platelet. So usually in a COPD patient, the platelet is either normal or increased because of chronic smoking. Then I'll do a renal function test to assess the baseline and due to baseline values. Then serum electrolytes, sodium and potassium.
No, what did you say? Baseline what?
Urea and creatinine value.
Okay, renal function.
Renal function test.
Okay. Okay.
So baseline urea and creatinine value. Then I'll do a serum electrolyte, sodium and potassium for you because the patient is on long-term bronchodilators. There's chance for hypokalemia.
Okay.
Then I'll do a coagulation profile. I am planning for any regional block to check for the coagulation. Then I'll do a LFT liver function test.
No, one sec. What is your argument for the coagulation profile? When the patient does not seem to have anything indicative in the history and the physical examination, it's very clear that whether you look at Miller, or whether you look at any preoperative testing protocols, there is no need to test the things which the history and the physical examination does not indicate, right? Therefore, please don't over-investigate the patients, and there is no need. Unless you believe that the patient is in sepsis, then obviously that kind of sepsis, you will not do a lap chole or open chole. Yeah.
Yes. Then I'll do a liver function test because the patient is for cholecystectomy.
Because the patient has cholecystitis.
In that, we look for the serum albumin value, which is less than 3.5. It indicates poor nutritional status, which can lead for postoperative pulmonary complication. Then I'll do a ECG. I'll use blood grouping, typing, and serology. Then I'll do a chest X-ray to see for the features of COPD. There is hyperinflation of lung field, then flattening of diaphragm, or if there is peripheral vascular pruning of vessels. Then if the tubular heart is there, then I'll do a ECG, 12-lead ECG. In 12-lead ECG, signs of right ventricular hypertrophy. If there is R/S ratio.
That's routinely done, or is there any significance for an ECG here?
ECG, the patient has gone into core pulmonary, then we'll have P pulmonary in the ECG and features of RVH.
Okay.
So it will determine our anesthetic management, whether the lab.
It's only of academic interest. The ECG here is only of academic interest. Okay. You want to see whether the patient has P pulmonary or not, is it?
Yes, sir.
Yeah, it's not, basically it is not indicated. It's okay. No harm in doing that. Yeah. Yeah, carry on.
Then I'll do a pulmonary function test, spirometry.
Mm-hmm.
Then in spirometry, I'll check for the assessment of mechanical function. Then for next, I'll check for the test for blood gas exchange. Then I'll check for the ventilatory drive of the patient. And I'll check for then in the spirometry, for the mechanical function, they'll check for the static lung function test and dynamic lung function test.
Yeah.
Static lung function test consists of 4 volumes and 4 capacities. The 4 volumes are tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Then 4 capacities. Inspiratory capacity, total lung capacity, vital capacity, and functional residual capacity.
Okay, hold on here. Right. So what are you mainly looking for? It's a COPD patient. You're doing a spirometry. What are you looking for?
FEV1 by FVC.
Yeah, you want to know the degree. You want to know the degree of damage. You want to know the reversibility. You want to know if the patient will withstand your planned anesthetic procedure.
Yes,
you want to classify the postoperative complications, right?
Yes, sir.
Yeah.
And you also want to grade the COPD the patient.
COPD, yes.
Right? Yeah. Now, anyway, we have repeatedly talked about the PPCs, post-operative pulmonary complications. What could be the risk factors for PPCs?
The main risk factors for PPC can be patient factors or surgery-related factors. Patient factors include patients who have not stopped smoking since past 8 weeks, patients who are more than 60 years, ASA more than 2, GOLD classification 2 or 4, and patients who's having hypoalbuminemia less than 3 or blood urea value more than 30. The surgery related factors include long procedures which are more than 3 hours, surgical procedures which mainly involve the upper abdomen or intrathoracic cavity.
Okay.
Emergency surgeries and surgeries which are under general anesthesia.
Okay. Yep. Anything else?
So we are on the. Yeah, you're going to say something?
So basically, the major post-operative pulmonary complication is pneumonia and acute respiratory failure or failure to extubate within the 8 hours of surgery, or if you have to re-intubate the patient after extubation in the ICU or in the recovery. Or the minor complications of post-pulmonary complications are atelectasis, bronchospasm, laryngospasm, and unexpected need for oxygen therapy. So there are different criteria for predicting the post-operative pulmonary complication. One of it is based on the surgery and the patient factor. Another is based on null and midget criteria, in which the FEV1 is checked. If the FEV1 is less than 1 liter, that is the patient is considered as a respiratory cripple, then we check for the PaO2 and PaCO2 of the patient. If the PaO2 and PaCO2 is normal, that is if PaO2 is more than 60 and PaCO2 is less than 50, the post-operative pulmonary complication will be less. Then if FEV1 less than 1 liter and if the PaO2 is less than low and PaCO2 is normal, then the need for oxygen therapy in the post-op will be more and the complication will be mildly increased. And if the FEV1 is less than 1 liter and if the PaO2 is less than 60 and PaCO2 is increased, then the chance for the need for post-operative mechanical ventilation will be high. And another classification is based on the spirometry values, FEV1 less than 50% of the predicted, or FVC less than 50% of predicted. If DLCO is less than 50% predicted, then MVV is less than 50% predicted, there is a chance for post-operative pulmonary complication.
Yes, good. Now, one basic question and then we move on. How do you classify COPD based on the, don't shut yourself off, based on the FEV1?
We have the GOLD classification of COPD. Basically, we look at the post-bronchodilator FEV1 by FVC. If the post-bronchodilator FEV1 by FVC is less than 0.7, then we classify the patient as a COPD patient. And then the grades of classification is stage 1, 2, 3, and 4, which is mild, moderate, severe, and very severe. So the first is when the FEV1 is more than 80%, it is stage 1. FEV1 between 50 and 80% is stage 2. Stage 3 is when the FEV1 is between 30 and 40%, and stage 4 or very severe is when the FEV1 is less than 30%.
Okay, good. Good. Okay, then we have, Sumesh, you were asking something? Or?
No, sir. There is just, I think there is 20 minutes leaving for questions, so we can progress into the anesthesia.
Yeah, this particular patient with all this, there is only moderate disease. Then the rest of the investigations we believe are almost normal, but for hemoglobin, which is 14, and total count is just on the borderline 11,000, and there is no active infections right now, and is for surgery. The gallbladder has to come off. What would you do? The surgeon says, we would like to do laparoscopic cholecystectomy. What's your take?
The choice of anesthesia would be general anesthesia with controlled ventilation with an epidural analgesia.
For a laparoscopic cholecystectomy, epidural analgesia. No, first we are still stuck with the first option, lap chole versus open chole. The surgeon says lap chole. I'm a very conservative, fearful anesthesiologist. I have just opened my eyes. I'm scared to manipulate the airway. What are the two techniques you use when you anesthetize your patients? It could be regional versus general. It is regional versus general. And in general anesthesia?
In general anesthesia, we can either intubate the patient and go for a controlled ventilation.
Yeah.
We can either do spontaneous ventilation or we can use supraglottic airway devices.
Yeah, exactly. One is less intervention. The other one is maximal support. Okay. What would you like to do?
I would like to intubate my patient and do a controlled ventilation since this is an upper abdominal surgery.
Anyways, this patient given scenario, where do you place him risk-wise?
Intermediate risk.
ASA?
ASA 2.
Okay. You believe everything is absolutely controlled, optimized. Okay. I think ASA 2 is perfectly all right. What are the chances that the patient will have PPCs? Post-operative pulmonary complications.
Considering the surgery as an upper abdominal surgery, the post-operative complication will be more, and the patient is current smoker. He is continuing, so that also add on to the increased chance for post-operative pulmonary complication. And then the exacerbation history is there, so there is increased chance for pulmonary complication.
Okay, yeah, go ahead. This is lap chole versus open chole. Do you have any arguments?
It's a lap, preferably a lap chole is preferred because it is a minimally invasive surgery, which has a shorter duration compared to the open chole, and the patient can be the early ambulation is possible with a lap chole, and the post-op pulmonary complications is also much less with lap chole compared to open chole, and the incision is also smaller when we are in lap chole, so the reduction of FRC will also be reduced post-operatively. So preferred would be lap chole.
I'm a fellow who has just trained myself in laparoscopic procedures in GEM Hospital, and I have come back. Okay. I take 4 hours for a laparoscopic cholecystectomy.
Oh, okay, sir.
You are my anesthetist. Would you still give anesthesia for a laparoscopic cholecystectomy in this guy?
With such prolonged duration and open chole would be
quickness is important. Somebody who is just at the beginning of the learning curve, it's a little too tough. But I think laparoscopic cholecystectomy is one of the basic laparoscopic surgeries. Therefore, I think it's all right. You can go ahead with laparoscopic cholecystectomy. How do you anesthetize? What the precautions do you take? You already examined your patient is already optimized. There is no wheeze, but he has emphysematous changes, tubular heart, and flattened ribs and flattened diaphragm on the chest X-ray.
Okay.
How will you?
On the pre-op day,
yeah,
we give a pre-medication of low-dose benzodiazepine, tab diazepam 10 mg. Then we give a proton pump inhibitor, tab pantoprazole 40 mg. Then we'll give a prokinetic tab metoclopramide 10 mg. Then we'll give a bronchodilator short-acting beta-2 agonic salbutamol nebulization. Then we ask to continue all the meter-dose inhaler the patient is taking. If the patient is on steroid, we'll give IV steroid on the day of the surgery. Then we have to advise the patient to continue with the incentive spirometry and the breathing exercises that we have to advise the patient to take. Right. Then after pre-medication on the previous day, on the day of surgery.
Is there any benefit for your long-acting benzodiazepine from the previous night?
It is an anxiolytic dose that we are giving, so that can reduce
this anxiety is caused by you, right? This anxiety is caused by you. You could mitigate it by just a rapport with the patient and explaining things to him, right? It's just a moderate surgery, which will be over in an hour or so.
And the next day, the patient has to, same evening or next morning, the patient has to go home. And benzodiazepines, even if you talk about the benzodiazepines, go for better ones rather than the diazepam.
Yes.
Diazepam, the metabolite is also active, right?
Yes, sir. Doxepin.
Yeah.
Yes.
Therefore, you can't be using diazepam anymore. Use lorazepam if you wish to.
Yes,
Why
sir.
not? Yeah.
Lorazepam can.
Yeah, lorazepam. The rest, I don't have any objection to.
Yes.
Yeah.
So like Sir said, remember that you might need to monitor, you might need to oxygenate if you're giving any kind of sedative to these patients. Okay?
Yes, sir.
Yeah, right.
Then on the day of the surgery, I'll advise the patient to take a short-acting beta-2 agonist inhaler, salbutamol inhaler, 2 puffs, and a short-acting anticholinergic inhaler, salmeterol inhaler, 2 puffs. Ipratropium inhaler, 2 puffs, and inhaled corticosteroids, 2 puffs, prior to shifting to the OT.
It said that the patient, even intraoperatively, if he has to develop the bronchospasm, he responds best to the inhalers the patient has been on always. Therefore, you have to bring them to the OR too, the same inhalers. But I think it's the overkill. The way you have been nebulizing, you have been giving MDIs, it's a little bit of overkill.
Yes, sir.
I don't think you have to keep on repeating them. If you are doing nebulization, so be it. Don't go in with the MDIs again and again.
Yes.
One shot is enough. The patient doesn't have any V's, doesn't think you don't need to do all this. Steroids, when you say steroids, you be specific, whether it is small dose steroid or 100 milligrams of hydrocort, because its perioperative cover is always with hydrocort. Never give a chance for the examiner to ask another question. Okay.
Yes, sir.
Right now you have been up to the distinction levels, but then if you want to score more, don't give the chance to the examiner to repeat questions, ask repeated questions. Yeah.
Yes.
Hydrocort, say how much hydrocort. Okay, we have discussed that. You carry on.
Yes, sir. Then pre-medication I'll give on the operation theater after connecting the pre-induction monitors like heart rate, continuous ECG, NIBP, and saturation. I'll give a low dose benzodiazepine, midazolam 0.01 to 0.05 mg per kg for as anxiolytic. Then I'll give an antiemetic ondansetron 0.1 mg per kg. Then I'll give an analgesic, preferably a short-acting opioid, that is fentanyl is chosen. 1 to 2 microgram per kg will be given.
That is too little. That is too little. What makes you so scary? You can always go to 2 to 3 months. You want the patient analgized, right? Lighter planes of anesthesia. Lighter planes of anesthesia can still precipitate bronchospasm. Therefore, give good analgesia. Yeah.
Yes, sir.
3 months.
I'll use a higher dose of induction agent than go with a low dose of opioid.
Reason? Reason?
So respiratory depression can be more.
Then why? Then if you are so worried about the respiratory depression because of opiate, which you give on table when everything is controlled, then why give diazepam to the same gullible guy to knock out his respiratory center the previous day, right? Isn't he more sensitive to any CNS depressant drugs? Obviously, right. Our respiratory center will be more sensitive, right? But this is in the war.
Sir, can you hold on 1 second? Sir, 1 second, sir.
What happened? Where is scaring me?
No, I think there is something going on behind them.
That's okay. That's okay. It's part of life.
Yeah.
I hear you, sir.
Yeah, we.
Okay.
Sir, can you hear us now?
Yeah, we can.
We have always heard you.
Yes.
We did only a little bit of dragging because I'm sure your bandwidth is quite low. Yeah. I thought somebody was flushing behind you continuously.
It's raining here, sir.
Yeah, it's raining here too. No issues. That's okay. The thing is, the patient is on the table and it is a controlled environment. And 1 to 2 micrograms of fentanyl versus 2 to 3 micrograms of fentanyl is not going to make a huge difference for you to be a little more conservative to reduce the narcotic doses. Okay, you will stick to a little higher because you don't want the patient to have any pain, any
Lighter plane.
yeah, and then induction agent, you said you will use more of if you use more of propofol, then obviously the patient will have more of
hypotension, bradycardia.
Yeah, you want to treat that rather than I'm okay with the little more fentanyl. Yeah, propofol. Yep. The generally asked question is, we are running short on time again. The generally asked questions are, which are the anesthetic agents which are bronchodilators?
Yes.
Obviously, ketamine is a bronchodilator, very good bronchodilator, but propofol is also a bronchodilator. Ketamine cannot be used because it's not that favored an agent, it's an induction agent.
Yes.
All right.
Propofol can also suppress airway reflexes and it can reduce the stress response.
Yeah.
So propofol.
Yep. And then, what is the relaxant of that? Would you do an RSI or would you do an RSI or would you go ahead with a conventional induction?
I'll go ahead with an rapid sequence induction with rocuronium or vecuronium.
You fall into the trap. Why do you need an RSI here? You don't need RSI. Okay. It's a routine case, right?
Yes.
Yep.
Preferred muscle relaxant will be vecuronium or rocuronium. Then maintain anesthesia.
Why not cisatracurium?
Cisatracurium is also vecuronium, rocuronium, or cisatracurium.
Okay.
And vecuronium is not available.
Yeah, it's not available. Whatever is not available, you need not talk in the exams. It's only for the theory.
Okay.
Yeah.
Why not pancuronium? It's only 20 rupees. It will last 1.5 hours.
Yeah. It is a long-acting drug and it can cause
exactly. It'll last 1.5 hours. The surgery will be all comfortably.
So it's a long-acting drug, so we don't want residual neuromuscular blockade and we want an early extubation.
But you are giving rocuronium without a reversal agent.
So pancuronium can also have airway
like Madhusa said, when we might dig traps, but do not jump into them wholesale.
Okay, sir. Vecuronium or rocuronium is preferred.
Why not cisatracurium? You are putting down cisatracurium now. Rocuronium, no, actually, both vecuronium and rocuronium, you need Sugammadex to use, right? That is what is famously believed. Without the Sugammadex, you are not supposed to use. I am not votary of that because we have used rocuronium and vecuronium in tons before. We don't even have Sugammadex even today. Yeah, fine. Any of these agents are okay. The agent to avoid is atracurium. Obviously, the histamine release is an issue there, and you don't want to have bronchospasm. And further is what is the best inhalational agent you can use?
Halothane is the best, but sevoflurane is more preferred now.
Why halothane should not be used?
It's not used nowadays. It's not
yeah, it is not to be used because it's an agent as historical as ether is. If you are trying to say that, not exactly. The reason what you should give is
it can cause arrhythmias.
Yeah, exactly. It can precipitate arrhythmias, and if the patient is on already bronchodilator, which makes the myocardium more susceptible for arrhythmia, you will surely have arrhythmia on table. So you can avoid that. Which is the better bronchodilating inhalational agent other than halothane?
Sevoflurane.
Okay. Can you use desflurane?
desflurane and isoflurane is avoided since it irritates the airway. Airway irritant.
Exactly. They are the airway irritants. Therefore, don't even comment on that. Okay. You should not use them.
So I think we are on the last 5 minutes.
No, it is last minute.
Yeah, right.
Yeah, obviously the things you should remember is, I think Sumesh, you can sum it up.
Yes.
Post-op analgesia is something which you have to keep in mind. I will just finish that and then you can sum it up.
Right. Okay.
Post-op analgesia is, you talked about epidural analgesia, but epidural analgesia for laparoscopic cholecystectomy is a little too much of a overkill. You say
Yes.
it is a Brahma
For
on a
laparoscopy.
sparrow.
For laparoscopy, we can give local infiltration and IV agents and IV agents like paracetamol can be used.
Okay.
Then we can use regional blocks and if needed, low dose
Regional
opioids.
blocks in the sense?
Like regional blocks like transverse abdominal plane block.
Again, it's a little
TAP,
bit of
erector spinae
overkill.
block.
Yeah, it's a little overkill. Yeah.
Okay.
It will
Erector
be,
spinae block.
your punctures will hurt more than the laparoscopy incisions.
Okay, sir.
Yeah, paracetamol should be good enough.
Good
But
enough.
if it is a prolonged surgery, you please remember that the stretching of the peritoneum can hurt for a little. No, peritoneum can hurt for a little longer time. And maybe you have to supplement with narcotics then. Otherwise, paracetamol should be more than enough. And then you can also look at preemptive analgesia, like you can ask the surgeon to infiltrate before he puts in the incisions, makes the incisions, puts in the ports. And I think that should be more than enough. But make sure that the patient is well analgized because you have to avoid the PPCs. Pulmonary complications.
Complications.
Yes. Rectus sheath block, somebody asked. Yes, it is possible. You can give. But it's again a little bit of a overkill. Yeah, Sumesh, I think you can sum up. And
Yes, sir. Thank you. Thank you very much, Dr. Madhu, sir. So, Dr. Parvati and Anjali, you have done a very good job of explaining the anesthetic considerations of chronic obstructive pulmonary disease and a patient coming for a laparotomy or, a patient coming for abdominal surgery with a COPD. So I congratulate both of you, both for the efforts you have put in, as well as your presentation today. And we also congratulate your teachers for having prepared you from the Pushpagiri Medical College. And Dr. Madhu sir and I also thank Dr. Binil, Dr. Giri, and the office bearers of ISA Kerala for having given us this opportunity. So thank you all. I think there have been a lot of questions in the chat box, which we have attempted to discuss. And thanks for the excellent participation from everyone. Thank you.
Thank you, sir.
Thank you so much, Sumesh. How do you rate yourself?
Me, sir?
No, not you. Not you, the kids. Distinction? Okay, do well in the exams, do well in life. It was a distinction material. Okay.
Thank you, sir. Thank you, sir.
Okay, sure. Thank you so
Best
much.
wishes, people.
Thank you, sir.
Thank you, sir.
We wind up. Over to you, Jeannie.
Thanks, sir. For the next.
So our next session is a long case presentation on an elderly patient with hypertension and IHD posted for bilateral hernia mesh repair. This session will be chaired by Dr. Lynette J. Morris, Professor and HOD, Government Medical College, Trivandrum, and by Dr. Baljit Singh, Professor and HOD, the Faculty of Medicine and Health Sciences Hospital, SGT University. We welcome you to chair this session. The case will be presented by Dr. Anju Teresa Joseph and Dr. Leenu Krishnan, postgraduate students from Government Medical College, Trivandrum. We have 1 hour and 15 minutes for discussing this case. Over to the examiners.
Good afternoon, everyone. Thanks, Dr. Jitin, for this kind words, one. And secondly, the privilege to be part of this scientific program. Particular thanks to Dr. Venkat Giri and to Dr. Binil and all the team workers who are associated with this program. I can't see Dr. Lynette Morris. Is she there? Good afternoon, ma'am.
Good afternoon, sir.
Very good.
Audible?
Oh, very well. Yes, I can see you also now, and you're very, very clearly audible. I think we can ask the students to go ahead with the case presentation, and then we can.
Okay, sir.
Yeah.
Fine.
Dr. Anju and Dr. Linu, can you go ahead with the case presentation, please?
Yes. Good evening, everyone. Case history. So our patient is Mr. Gangadharan, an 80-year-old male hailing from Trivandrum. He is a diagnosed case of heart disease and hypertension. And now he is presenting with complaints of swelling in both the groins. Informant is the patient himself and Mr. Raju, the patient's son, who is residing with the patient, and the information they give is reliable. Coming to the history of present illness. Our patient noticed a swelling in bilateral groin area, which was initially the size of a lemon and gradually increased in size over the period of 2 years to assume the current status. The swelling, he noticed, used to increase in size on straining, lifting heavy loads, and is reduced on lying down. He gives history of associated occasional dragging pain over the swelling. There is no history of discoloration of skin over the swelling, no sudden severe pain over swelling, no discharge from the swelling or swelling elsewhere in the body. He has no history of chronic cough with expectoration or evening rise of temperature or chills or significant loss of weight or appetite. And there is no history of swelling of legs. Coming to his past medical history, he gives a history 12 years back. He gives a history of left-sided chest pain with radiation to left shoulder while at work. He initially took rest and had some antacids for 1 day. However, his symptoms persisted and therefore he went to the hospital where he was found to have some block of cardiac blood vessels on evaluation. He was also diagnosed to have high blood pressure since then. He was started on some blood thinning medications and antihypertensives then. Since then, he has had occasional episodes of left-sided chest pain with even mild exertion. 10 years back, he underwent some cardiac surgery along with stent placement, following which his symptoms have subsided. He now has only slight limitation of physical activity, and he can manage to climb 2 flights of stairs by himself. His symptoms have not increased in frequency or severity or duration over the past 10 years. Following this stent placement, history suggestive of his effort tolerance is more than 4 meds. He gives no history of swelling of legs, no distension of abdomen or palpitations or dyspnea on lying down. There is no bluish discoloration of skin or cough with pink frothy sputum or syncopal attacks. He has no history of diabetes mellitus, bronchial asthma, or renal or liver disease or tuberculosis in the past. Coming to his drug history, as stated by his son, he is currently on tab icosapent 75 mg once daily, tab metoprolol 50 mg twice daily, tab enalapril 2.5 mg twice daily, and tab atorvastatin 10 mg at night. Coming to his personal history, he is a reformed smoker. He used to smoke about 10 BDs per day, starting from an age of 25 years, and he stopped 12 years back following his first episode of chest pain. So that comes to around a pack years of 21.5. He has history of occasional alcohol consumption, but he stopped 10 years back following diagnosis of his heart disease. He also had history of betel leaf chewing, which he stopped 10 years back. His bowel and bladder habits remain unaltered. Coming to the family history, he is the eldest among 4 children. He is married and has 2 sons. There is history of hypertension in both parents and 2 of his siblings. And history of heart disease is in 1 sibling at 50 years of age. There is no history of any malignancies in the family. So his socioeconomic status, my patient was a manual laborer, a load bearer by occupation. He stopped working 12 years back following diagnosis of the heart disease. He hails from a low socioeconomic status. Sir, impression. Our patient is an 80-year-old male, a reformed smoker, who's a known case of heart disease, possibly ischemic heart disease and systemic hypertension, post cardiac stent placement, now presenting with bilateral inguinal hernia, and there is no history suggestive of congestive heart failure. Coming to the general examination, he is moderately built and nourished. His height is 175 centimeters, weight is 66 kilogram, and his BMI comes to around 21.5 kilogram per meter square. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. His skin shows ichthyosis. Hair and nail is normal. His temperature is 98.2 degree Fahrenheit, measured in the left axilla. His pulse rate is 64 per minute, regular in rhythm, normal in volume and character, and there is no radiofemoral delay. He has vessel wall thickening. All peripheral pulses could be equally felt on both sides. His blood pressure is 140/96 millimeters of mercury, measured in the left upper limb in the sitting position, and his respiratory rate is 20 per minute, regular and abdominothoracic in pattern. Coming to the airway examination, nose, he has no deviated nasal septum or nasal discharge or crusting. Bilateral fogging is present on cold spatula test. His mouth opening is more than 2 finger breadths. He is edentulous and has no artificial dentures. He has poor oral hygiene. His myelopathy class comes to class 3. The temporomandibular joint admits 1 finger. Thyromental distance is measured as 7 centimeter. His sternomental distance is 13 centimeters. His neck movements are full in all directions, and his spine is non-tender. No obvious abnormalities were noted. Coming to local examination of the swellings, on inspection, there is a globular swelling in the right inguinal region, about 6 into 5 centimeter size, not extending into the scrotum, and there is impulse on cough present over the swelling. Skin over the swelling appears normal. In the left inguinal region, also there is a globular swelling, 4 into 4 centimeter, not extending to the scrotum with cough impulse. There are no visible pulsations or scars or sinuses over the swelling on both sides. On palpation, inspection findings were confirmed, and in the right inguinal region, a globular swelling 5 into 5 centimeter size, not extending to the scrotum, was found. It was non-tender to palpation, and there was no local rise in temperature. The swelling is reducible and cough impulse is present. On 3-finger test, impulse is felt at the superficial inguinal ring on both sides, suggestive of direct inguinal hernia. And deep ring occlusion test revealed swelling appearing medial to the deep ring, again suggestive of direct inguinal hernia on both sides. On the left, globular swelling is of size 4 into 4 centimeters, not extending into the scrotum. There is no local rise in temperature and it is non-tender to touch. Skin over the swelling is normal and cough impulse was present, and swelling appears reducible. Coming to his systemic examination, examination of the cardiovascular system, his pulse rate is 64 per minute, regular in rhythm, normal in volume and character. His vessel wall appears thickened. There is no radiofemoral delay, and all pulses could be felt equally on both sides. His blood pressure is 140/96 millimeters of mercury in the right upper limb in sitting position, and his jugular venous pulsation is not elevated. On inspection of the precordium, shape appears normal. Apex beat could not be localized. There were no other visible pulsations or dilated veins or scars or sinuses over the precordium. On palpation, apex beat was localized to the 5th left intercostal space in the midclavicular line. There were no other pulsations felt or no left parasternal heave or thrill. On percussion, the right heart border corresponds to the right sternal border and the left heart border corresponds to the apex. On auscultation, first and second heart sounds were heard normally in all areas. There were no S3 or S4 and no murmurs. Coming to his respiratory system, the upper respiratory tract, nose appears normal. There is no deviated nasal septum or nasal discharge, no paranasal sinus tenderness, and throat appears normal. On inspection of the chest, the trachea appears central. Apex beat was not visible. There is no supraclavicular or suprasternal hollowing. His respiratory rate is 20 per minute, regular, and is abdominothoracic in pattern. His chest movements are bilaterally equal in all auscultatory areas, and no dilated veins or pulsations or scars over the chest wall. On palpation, there is no local rise of temperature. The trachea is central. Apex beat localized at the 5th left intercostal space in the midclavicular line. Chest expansion is measured as 2 centimeters at the level of nipple. His chest movements are bilaterally equal. On percussion, resonant note is heard over bilateral, supraclavicular, infraclavicular, mammary, axillary, infraaxillary, suprascapular, interscapular, and infrascapular areas on both sides. Auscultation, on auscultation, normal vesicular breath sounds were heard in all areas on both sides. His chest was clear and no added sounds were present. Coming to examination of the gastrointestinal tract, mouth and throat, he is edentulous. His gums show nicotine staining and he has poor oral hygiene. Abdomen inspection. His abdomen was scaphoid, umbilicus is central and inverted. All quadrants move equally with respiration. There were no dilated veins or scars or sinuses over the abdomen. Hernial orifices, swelling both inguinal areas, as described earlier, was found in local examination. Palpation, abdomen is soft and non-tender to touch. His liver is palpable 1.5 centimeters below the right costal margin. There was no splenomegaly. On percussion, upper border of liver was percussed at the 5th intercostal space in the midclavicular line. The lower border of liver was percussed 1.5 centimeter below right costal margin, and the liver span comes to around 12 centimeters. On auscultation, normal bowel sounds were heard. There were no bruit. Coming to the central nervous system examination, his higher mental functions were found to be normal. He has no focal neurological deficit. The sensory system, reflexes, and gait appear normal. So summary, our patient is an 80-year-old male, a known case of systemic hypertension and ischemic heart disease, post-cardiac stent placement, an ex-smoker, now presenting with bilateral inguinal swelling, possibly direct inguinal hernia, which is uncomplicated, and he is posted for elective hernia repair surgery.
Thank you so much for the case presentation. So it's a bilateral inguinal hernia in a patient who is hypertensive, who has coronary artery disease, and he has had some stent also placed a few years back. Yes. Okay. All right. You said it's a bilateral hernia. Generally, there is a cause to the development of hernia in a patient who is this old. And you have ruled out all those causes.
Yes, sir.
One, let me give you a bit of hint. See, the patient is either going to have chronic cough, he's a chronic smoker, and you have said that he doesn't have cough and no chronic cough with expectoration, point taken. The second point that you said was that patient doesn't have any urinary complaints as well. Sometimes these patients, 80-year-old man is likely to have some sort of prostatic enlargement. And, that is going to make urination difficult for him. So that may be another reason why the patient is straining. Either he is coughing badly or he is straining because of which the hernia appears. Or, anything that makes the person increase the intra-abdominal pressure. It may be a chronic constipation as well. So all these factors you have ruled out. I do not deny the fact that in spite of, even in the absence of all these factors, patient can still have hernia. It's not that a patient cannot have hernia, but I think one of the factors, if it had been positive, would have correlated very well with the history that we have. You presented the history very well. I fully appreciate that. But this was something which appeared to me that cross with the eventual diagnosis that we have. All right. So, this is an old man, he's about 80 years. So, what are your main problems here? Why a person who is at 80 years of age is specific to you rather than a person who is, say, 20 years or 30 years? All right. If you want me to rephrase that word, why is a geriatric patient of more important or more serious a concern to you as an anesthetist than a person who is 20 or 30 years old? I hope I made it clear.
Okay, sir. Mainly my patient being 80 years of age, the main problems associated with this age group is geriatric age. They've got increased incidence of comorbidities like diabetes mellitus, hypertension, which is present in my patient. He's a hypertensive. And second thing, they've got a decreased physiological reserve of all organ systems, starting from the cardiovascular, respiratory, and CNS, GIT, liver. So coming to the cardiovascular system, especially in my patient, him being advanced age, there is age-related vascular vessel stiffening. And so this vessel stiffening, it increases the afterload, and that itself increases the myocardial oxygen demand, which is detrimental in my patient in a perioperative setting, because it itself makes my patient prone to myocardial further ischemic heart disease, fresh MI. Then there is also accelerated atherosclerosis at this age, which is also a concern because the vessels being stiff, they'll be less they will have less beta-2 mediated vasodilatory response. Then also at this age group, the vessels, there is a low cardiac output, so low blood flow. Then he is also an ex-smoker, which also increases the risk of coagulopathy.
Then all these vessel
just hold on.
Yes,
How
sir.
much decrease in the cardiac output occurs, say, every year, approximately? It's nearly 1% every year after, say, about 30 years or so. For someone who is at 80 years of age, the cardiac output is going to be nearly half of what a 20-year-old would have. That is approximate. So you can make out as to what you are looking at. What about the blood pressure? You said vessels, they get they narrow down, and the blood pressure increases. How much is the increase in blood pressure? Age-wise.
Age-wise, both systolic and
It's about 1 millimeter of mercury every year after 50 years of age. So you can add up approximately, you will get that value. Okay. Any other change that happens to a patient who is, say, 80 years old? Anything happens to the ECG?
Yeah, in the coming to the heart condition, with age, there is myocardial fibrosis can occur. So that itself decreases the effective, the contractility of the heart. And that also causes a low cardiac output. And also the valvular condition changes. There is thickening, age-related thickening and stenosis of the valves. Especially aortic stream, if the aortic valve is calcified, it hampers the hampers the cardiac output. Then cardiac also, the alteration in the hypertrophy and the fibrosis of the myocardium itself can damage the conduction system, and my patient would be at increased risk of arrhythmias at this age. So,
afterload?
Sorry, sir.
What about the afterload?
The afterload increases because there is increase in the systemic vascular resistance at this age. So vessels are stiff. And also there
is myocyte thickening and hypertrophy leading to stiffening and hypertrophy of the ventricle. That makes the ventricle less compliant. So he'll have diastolic dysfunction is common in elderly.
Okay. This is diastolic dysfunction, you said. There is systolic dysfunction, which is more common at this age group.
Diastolic dysfunction.
Why so? You're right, but why so?
Because the heart age-related, the occurrence of this myocardial interstitial fibrosis is more common here. Unless there is a coexisting other disease, diastolic dysfunction remains more common because structural changes in the heart are more severe than the vascular changes at this age.
All right. So anything else that you have in the cardiovascular system?
And also my patient, the compensatory responses to any physiological stress would be reduced. So the maximal heart rate of my patient would be reduced. So even if my patient develops hypotension due to any cause, the compensatory tachycardia would be reduced. And also the response to any of the sympathomimetic drugs would also be reduced. So my patient...
Now what happens to the conduction?
The hypertrophy as well as the myocardial, the myocyte death due to the age, both of them, they cause disarray of the conduction fibers. So my patient would be more prone to arrhythmias at this age.
As well as there will be slight delay in conduction. Conduction will be relatively slower as compared to someone who is, at a younger age group, because the cells there in the SN node also decrease in number. So that's why the conduction also is affected.
Okay. And also then my patient, since he's in a low cardiac output state, then my patient would be more dependent on preload for forward ejection, because in case he requires both a normal sinus rhythm without any tachycardia, and also he needs an adequate fluid volume. In the absence of these two, he's very prone for hypotension.
Okay, hold on there. So now let's go to the respiratory, since the time is such. So let's move on to the respiratory system. Ma'am, please feel free to come in anytime. But Leonard, please, yes, sir, come in anytime.
Yes, sir. You can continue. Let them continue, sir.
I've just you may not feel so. Okay. Yes, ladies, please carry on.
Respiratory system, sir.
Yes.
Okay. Coming to the respiratory system, with age, there is a weakening of all the muscles, including the diaphragm and the intercostal muscles. So the strength of the respiratory effort, that would be reduced in my patient, especially. Then also there's age-related calcification of the costochondral joints. The arthritic changes are there. So the chest wall as such is very stiff. So the compliance of the chest wall would be very much reduced. And age-related degradation of the protein in the of the lung. So there would be emphysematous changes age-wise. And also my patient being an ex-smoker, he would have already had those emphysematous changes. So the emphysematous changes are there. And also by the age of 66 itself, the FRC, the closing capacity becomes equal to the FRC even in the standing position. So my patient being 80 years of age, he would have increased the basal, there would be increased basal epileptasis. So that itself increases the chance of hypoxemia due to shunting and the closure of this basal small alveoli. Then also my patient would be more prone to perioperative pneumonia, because age-related there is decrease in the pharyngeal muscle tone. Then there is also decreased effectiveness of the cough. Then the mucociliary clearance would be reduced. Then there is esophageal hypomotility, and all these it would make my patient more prone to aspiration. So post-op pneumonia is also a possibility in my patient.
What happens to the ciliary activity?
Ciliary activity is reduced, and especially since he was a smoker, there would have also been that damage.
So this is one factor which is very important in the post-operative period, because if the ciliary activity is less and he is not able to cough effectively, so that's quite often the reason for retention of secretions, which further get infected, and patient ends up with pneumonia. Also, in case there is prolonged lying down or immobilization of the patient, patient is lying in the bed, so there is likely to be some sort of hypostatic congestion also in these patients, which will add to the development of pneumonia. Further on, you see, these patients at this age, they often have some degree of kyphosis as well. The spine, due to the osteoarthritic changes, osteoporosis rather, the spine sometimes gets some degree of kyphosis, so that becomes addition to the respiratory impairment because of adding the restrictive factor to it. So apart from not only the constrictive, there is some sort of restrictive disorder. I don't mean that every patient would have it, but this is something that is quite often seen in this age group. All right. The cough reflex, you already said, is quite often blunted, and these patients are more likely to get post-operative chest infection, right? What can you do to ensure that the chest infection in the post-operative period is reduced as much as possible?
First thing, if I'm one thing is I would avoid over sedation, especially any drug that I give, especially in the case of opioids. I would give them in a titrated doses so that he does not have any respiratory depression, okay, and he's not overly sedated. And second thing, in case I'm going for a general anesthesia mode, then I would always I would avoid intermediate and long-acting neuromuscular blockades, and I would reverse my patient after the procedure only after adequate. I would extubate my patient only after adequate reversal has been ensured. Then prior to the procedure, I would possibly give an antacid to neutralize the acidity of whatever gastric contents are available, so that in case he does aspirate, the acidity of those contents would be reduced and the chemical pneumonitis associated would be reduced.
Right. These patients are more likely to have some sort of airway obstruction in the post-operative period, particularly, not frank airway obstruction, but snoring, and the possibility of sleep apnea is also more common. Why is it so?
Because the pharyngeal muscle tone will be lost with advanced age.
Right.
Then esophageal motility is decreased, so gastric contents can't be forwarded to the stomach. So there is increased risk of aspiration in elderly patients. Then
not only that, I mean, when you said
genioglossus muscle tone is also lost, so there is chance for the tongue obstructing while the patient is supine.
The tongue coming back on the posterior pharyngeal wall, so that will happen. And the possibility of aspiration, as you were saying, in the post-operative period is also high. The reason being, you said decreased peristalsis, you were saying something?
And also they've got a basically reduced respiratory, the response to hypoxia would be reduced. So that is also
no, with regard to aspiration, post-operative, in the post-operative period, aspiration. the tone in the lower esophageal sphincter is decreased. Okay, so there's more possibility of the gastric contents coming into the oropharynx, and the patient can have aspiration. So that may be one of the reasons that in the postoperative period, these patients can have a problem. Okay, carry on. What else in respiratory is done? So let's come to some of the system. Which one would you like to carry on? Let's say start with GI system. You have already said about the pharyngeal muscles. You have already said about the peristalsis. What happens to the peristalsis or esophagus? Does it normal?
Hypomotility is there.
It?
There is the peristalsis would be reduced. Hypomotility.
That's right. Yes, there is hypomotility. Patient might feel some sort of dysphagia also. May complain like that, but it's not dysphagia. Frankly, it's basically because of the reduced peristaltic activity of the esophagus. Okay. Anything else you would like to say about the GI system?
Hepatic blood flow is also reduced with age. So drugs, so any drug that I give, drugs that are dependent on the they have got a high hepatic extraction, those drugs, the elimination would be reduced and they would have a prolonged duration of action. And the liver, the hepatic reserve is also reduced. The liver can easily develop ischemic changes with any change in any physiological stress. Then also coming to the drug metabolism, the phase 1 metabolism, drug is also reduced.
These patients are also likely to have some degree of gastritis, also chronic gastritis. You don't forget that these patients are having some joint pains, so they are having some sort of analgesics for a long period of time. So these patients are likely to have gastritis, and in the postoperative period, there may be some possibility of stress ulceration as well, or the gastric distension these patients might complain of. So that's again not something that cannot be overlooked. Yes, go on. Ma'am, please feel free to come anytime.
Okay, sir.
Please.
And then the drug metabolism, the phase 1 metabolism of the drugs, that would be reduced. The phase 1 activity is reduced, but the phase 2 is relatively unaltered. Then the increased risk of aspiration is already mentioned. And then
what about the kidneys? Anything happens to the kidneys?
Yes, sir. With age, there is cortical atrophy. The normal kidney in normal adult, which weighs around 250 grams, with every year the cortical atrophy occurs, and in elderly it comes to around only 180 grams with relative loss of the cortical nephrons, and then also due to glomulosclerosis. Then
GFR falls by around 1 milliliter per kilogram per meter square every year after the age of 50 years.
Number of glomeruli decrease.
Sir?
Number of glomeruli also decrease.
Number of glomeruli decrease. And since the lean body mass is very less in elderly patients, the creatinine levels will be lower than normal. So lower creatinine levels can even obscure an underlying chronic kidney disease. Then they are more prone to urinary tract infections and urological infections. In females, postmenopausal females, because of the atrophy of vagina and breakdown of skin, ascending infections are very common, and this predisposes to UTI in females. In males, male elderly patients can have enlarged prostates, which leads to stasis of urine inside the bladder, again predisposing them to urinary tract infections.
What about the capacity to conserve sodium? Is it maintained, decreased?
Sir, dysnatremias are very common in the elderly age. They are more prone for developing hyponatremia.
Yeah.
Then
it's not very uncommon. Very commonly seen in the postoperative period, or even before also. Okay.
Okay, sir.
What about thermoregulation and old age?
Ma'am, even if there is total body fat increases in the elderly, but subcutaneous fat loss is very much pronounced. Subcutaneous fat is what insulates the body against hypothermia. And also due to the changes in cutaneous microcirculation, elderly people are very prone to developing hypothermia.
And in this patient?
And in this patient, hypothermia is detrimental because it can increase the postoperative shivering can all increase the myocardial oxygen demand. which is detrimental in a patient with ischemic heart disease.
Okay. Okay, sir.
What about the bladder? Anything happens to the bladder in these patients? Okay. Anything?
The muscle weakness is there. Weakness can detrusor muscle weakness can occur. There can be, and also due to the enlargement of the prostate, the bladder weakness of the bladder and retention of the urine can occur.
The bladder capacity decreases. Okay, that may be one of the reasons that patients have to go to the washroom very frequently. Okay, there may be other reasons, of course. There can be other reasons. There's no denying that. But this is one reason that can happen. Okay, carry on.
Then coming to the musculoskeletal system.
Go ahead with
musculoskeletal system, sir.
Any other system that you are that you would like to go to?
Musculoskeletal system.
Yes, please go ahead.
There is decrease in both the muscle mass as well as the muscle strength with age. Muscle mass decreases by around 1% per year after the age of 30, but the muscle strength decreases by 3%, which is higher. And also there are arthritic changes and the loss of the subcutaneous fat. Also, all these make the arthritic changes would make the difficulty in positioning, and they would be more prone to injury. So they would have to be carefully padded all pressure points, and the loss of the subcutaneous fat itself makes the nerves more prone to pressure injuries. So careful padding is required. Then musculoskeletal system.
But
osteoporosis is also there at this age, so that makes that would make my patient more prone to fractures.
Okay.
Okay.
What about the integumentary system?
Sorry, sir.
Integumentary, skin and other things.
Skin, there is a high incidence of ichthyosis, skin drying, and skin is easily fragile. It would collagen is reduced, so easy bruisability. Then the subcutaneous fat is less.
Yes.
Cutaneous circulation is also impaired, so making them more prone to hypothermia, sir.
Cutaneous and also wound healing would be impaired.
Okay. Anything else? See, these patients are more prone to bed sores as well.
Yes, sir.
There is loss of subcutaneous fat and everything. They have no cushioning effect. The weight bearing is directly from the bone onto the bed. So there's ischemia of the skin, which is more easily that occurs, and these patients are more likely to get the bed sores as well. So what's important? How will you prevent that? Of course, it's very simple. I mean, you would say that yes, turn around the patient every 2 hours, put a water mattress, put air mattress, whatever, so that the pressure is equally distributed, to all parts of the body.
What about IV access?
Yeah, important question.
Intravenous access would also be difficult in, they would have fragile blood vessels. So,
not only fragile, the skin, because of absence of subcutaneous fat, you find it difficult to cannulate any existing veins. Okay. So the skin will slip as you try to cannulate. Okay. Fine. Continue.
Yes, go on. But anything else that can bother you with regard to induction of anesthesia in these patients because of the loss of subcutaneous tissue, as well as thin skin?
Fat content is reduced, so the lipophilic drugs.
No, IV cannulation may be difficult sometimes.
Yes.
Okay, the veins are not supported by the fat around, so the moment you try to touch the needle, it moves around, and eventually you end up making multiple punctures to the side. So IV access may sometimes be difficult because the veins, it's difficult to stabilize a vein. If you're an experienced person, certainly you can do that, but it may be a little difficult sometimes in the hands of particularly the newer ones. Yes, go on.
Then coming to the hematological system, the patient would be with age. There is the bone marrow tissue, the bone marrow, there would be atrophy, so there would be reduced erythropoiesis. My patient would be more prone to anemia. Also, on top of it, the intake might be reduced. So nutritional anemia can also occur. Then there is also, due to the loss of bone marrow tissue, my patient would be more prone to leukopenia, so making him more prone to infections in the post-operative period as well, which is also detrimental. Then
I think in GI system missed out on something. The motility of the intestines also goes down. So that may be one of the factors that these patients are likely to have constipation, particularly in the post-operative period, because there may be fecal infection in case patient is not given some sort of laxative or some drugs to evacuate the bowel. So they can end up with fecal infection if he's on bed for a long period of time in the post-operative, although not for hernia, but yes, that is something that needs to be looked into. Okay, anything else that you would like to say?
This patient is edentulous. What is the implication to you as anesthetist?
Very true.
Madam,
Hello?
Madam, an edentulous patient is considered to, we would be, it would be able to, difficult to establish bag and mask ventilation for an edentulous patient because of the hollowing of cheeks and soft tissue.
And loss of buccal fat.
Buccal fat.
What are you going to do with it? The madam is going to ask the next question. You have to deal with it. You have to.
How do you overcome that? That's what sir wants to know.
We apply cushioning material to make the seal, to ensure a proper seal. We would keep some cushioning material like a pad in between the mask and the patient's face.
Okay. Anything else? See, just think, why is intubation difficult in these patients? In a normal patient who has dentition, so you can open the mouth with the laryngoscope, and that's good enough because there are teeth, and then there is a large oral cavity. Whereas in these patients, since there are no teeth, so the oral cavity is not as large as you have in a normal person who has dentition. Okay, there is one Indian gentleman, a very respected anesthesiologist, who has devised or who has made some change in the laryngoscope blade. Do you know of that? No. There is one man, Dr. Doshi. What he has done is he has increased the the flange part of it. That becomes it wider. So that helps to open the alveoli. Not the alveoli, the gums far apart, so that you have more space available there, and that does it all. That helps you to intubate that patient more easily. What else makes difficult intubation in these patients?
So the falling back of tongue due to hypotonia of hypopharyngeal muscles and the genioglossus. It can obstruct the upper airway.
Anything else? That is obstructing the airway. I'm saying obstructing the airway. Yes, position.
Position. Due to the arthritic changes of the joints, it would be difficult for them to place my position in
what changes
morning air position.
What changes in the jaw?
Arthritic changes, so it would be difficult to extend his neck. And
are the arthritic changes in the jaw more serious a concern at the time of intubation of such patients, or some other changes?
Both. Arthritic changes of the jaw is also significant because the mouth opening would be restricted. Then
the spine.
Spine also, it would be difficult to position.
That's more difficult. You see, that's more likely to happen. Okay, because of the arthritic changes. Sometimes these patients there is slight increase in the curvature at the thoracic junction. So you may need to keep a high pillow because sometimes they have a hunched back. So the positioning may be somewhat difficult. Then extension may not be as good as you can have in a person who is, say, 20 years old. Okay, so all these things make, tongue falling back makes your bag mask ventilation difficult. Arthritic changes, or because of the spine changes, it is a positioning may be difficult. So there are a combination of factors which, as Madam was asking, can make your intubation difficult in these patients. All right? Okay.
Yes.
Anything else that you would like to say about these patients?
Then on the whole, my anesthetic concern, one was, as we have dealt so far, about the geriatric age. The second one is my patient being having a history of ischemic heart disease. Managing the perioperative period, it would be my goal would be to maintain the myocardial oxygen supply demand balance, because anything which increases the myocardial oxygen demand or reduces the myocardial oxygen supply, both of these could cause a further ischemic heart, further fresh myocardial infarction. So that would also be my main concern, one of my main goals. Then also my patient is a hypertensive. So he would have exaggerated response to any of the drugs. So that is also another concern. And also, since ischemic heart disease, along with he's a post-stent placement patient, so there is a risk of stent thrombosis and bleeding due to the antiplatelets. But since he has already covered a period of around 10 years after the stent placement, the risk of thrombosis would be reduced. But since he's continuing antiplatelets, ecosprin, he's at increased risk of bleeding during the procedure.
Okay.
So these are my main concerns.
You said that these are your concerns. I appreciate your concerns, very valid and very genuine. Now, how are you going to meet your concerns?
Yes, sir. So first, since my planned mode of anesthesia is central neuraxial block with...
Okay. So you want to come to that. All right. So your choice of anesthesia is central neuraxial block. All right.
Okay.
What technique?
Epidural.
So central neuraxial blockade with graded epidural anesthesia, with epidural insertion at L1, L2 intervertebral space to achieve a dermatomal block up to T10 level.
So you can achieve that level only at L1, L2 level.
No, sir.
Sir, my being an elderly patient, his spine can have arthritic changes, and it would be difficult. A thoracic epidural can be technically difficult.
You don't give thoracic epidural for a patient who is trying to go hernia surgery, will you?
No, sir.
Don't mention thoracic epidural. They're not going to catch you there. So please don't do that. You have been doing very well. I am sincerely, I sincerely appreciate that. But don't go into thoracic epidural. Don't ever mention it. Now I pose a slight difficulty for you. Tolerate me for some time. This is a patient you examined the back, and you feel that the spine is almost fused. It can happen. Now what are you going? What comes to your mind? Is it going to be an easy epidural? Is it going to be a difficult epidural? If it's going to be a difficult epidural, what are you going to do about that?
So it would be a difficult epidural, especially through the midline approach. So we can go for a paramedian approach for approaching the epidural space.
Why is it difficult in the midline approach?
So the calcification of ligaments, interspinous and supraspinous ligaments can occur at this stage. So it might be difficult to, sir?
What about ligamentum flavum?
Ligamentum flavum will also be calcified. So it might be difficult to...
Hold on, lady. Ligamentum flavum is the only ligament that does not calcify. Don't make this mistake of saying it to the examiner that this will calcify. And can you tell me the reason? I'll give you 1 mark extra.
The yellow elastic ligament with no...
Absolutely. It's because of yellow elastic fibers. And there are a few other joint ligaments also, which I'm not going to bring in at this time because of the shortage of time. So this is the only ligament that doesn't calcify. The supraspinous and interspinous calcify. That's very right. It's a good answer. Now let's say that you found the spine which is almost fused. You hardly feel the interspinous space. What are you going to do now?
First, I would try a paramedian approach for epidural needle insertion.
All right.
If not possible, I could go for I would use ultrasound guided epidural needle placement.
Okay, hold on there. I think it's a very simple question, but this is asked every time there is a mention of regional anesthesia or for epidural or for spinal anesthesia. What are the structures that you pierce as you go from skin to the, say, subarachnoid space or the epidural? I know you're laughing that it's so simple a question. We know it by heart, right? Go ahead.
So skin, first I would pierce the skin, then the subcutaneous tissue, then supraspinous ligament, then the interspinous ligament,
Yes.
then the ligamentum flavum.
Yeah, good. You don't need to think. You have done 100 times, more than many 100 times. Okay, then once you pierce the ligamentum flavum, what comes next?
We enter the epidural space, sir.
Right. In case you have to go to the subarachnoid space, then what?
I have to pierce the dura.
Yes.
And the arachnoid matter of the.
Yes. Then you go there. All
and
right.
then we'll enter the intrathecal space.
This is with regard to the midline approach. Is
Yes.
that right?
Yes, sir.
Now, as I told you that these ligaments are calcified, supraspinous and interspinous are calcified. What are you going to do now?
So paramedian approach, I would go for a paramedian approach where I can.
What are the structures that you pierce now?
So skin, subcutaneous tissue. I can actually bypass the supraspinous and the interspinous ligament.
You will bypass anyway. You can't. It's not the question of you can or you may, you perhaps, you probably. No, you will bypass. That's the whole purpose of paramedian approach. Okay, then what next?
Paraspinal muscles.
Good. This is something that most of the students miss out because they say that skin, sir, subcutaneous tissue, sir, ligament flavum. You know, there's a lot of gap between the ligament flavum. So I asked you specifically. Okay, forget about this. Now you know that. All right. Anything else that you would say about, what about the drug? Will the dose of drug be same or it is going to be less or it is going to be more?
Yes.
And the dose of the drug required to achieve even the similar block would be less as compared to a younger individual because one, the elderly, their nerve roots are more prone, they're more sensitive to local anesthetics. Second, the epidural space would be narrow. There is loss of adipose tissue in the epidural space with age, and also there is a stenosis of the intervertebral the neural foramen. So the exit of the drugs laterally through the foramen would be reduced, and with the same dose of drug, a higher cephalad spread would be achieved.
And since you are putting in a catheter, I believe you are putting in a catheter. Is it right?
Yes, sir.
Right.
Yes, sir.
So how much catheter would you keep inside the space, epidural space?
5 centimeters, sir.
Okay. Why 5? Your answer is right. I appreciate
5 centimeters because one is if it is less than 5 centimeters with repositioning, making the patient supine, there is a risk of catheter dislodgement. And any further threading, there is the risk of unilateral block or patchy block. So that is why I would like to
block.
Sorry, sir.
Why patchy block?
Like there is a chance of catheter migration,
out of the neural canal. It might go through one of the intervertebral spaces and it might go out. So you may not have a block which is bilaterally equal. All right?
Yes.
Okay. All right. Anything else with regard to the regional anesthesia?
Regional anesthesia, one, even advantages it, sir.
Okay. All right.
Sir, an epidural anesthesia will blunt the sympathetic response of increased heart rate and hypertension in this patient, because those things tachycardia and hypertension can increase the myocardial oxygen supply, increase the oxygen demand of the myocardium, and therefore be detrimental to this patient with ischemic heart disease. Another one is analgesia is superior with epidural anesthesia, and it can also be extended to the postoperative period, where again all these effects can worsen his cardiac status, pain, tachycardia and all. So we would like to extend analgesia to the postoperative period to reduce the morbidity and mortality of the patient.
All right.
Postop ADS would be reduced, sir.
Early ambulation is possible if we provide superior analgesia. Elderly patients are at more risk for developing DVT and thromboembolism and all. So such events can be reduced if we put a epidural analgesia.
Get these patients out of the bed as early as possible, because sooner they are out of bed and they are mobile, their possibility of DVT goes down. Okay. All right. What other precautions or that you will have? Madam, please feel free to come. Please come in. Madam, please join me.
Yes,
please carry on.
This patient is on antiplatelet, no?
Yeah.
Yes,
supposing the patient was on dual antiplatelet, can you comment on that and with regards to your anticoagulant effects, with regards to your epidural or central neuraxial blockage.
So if my patient would have been on dual antiplatelet, that increases the risk of bleeding, especially if I'm proceeding with a central neuraxial blockage, there would be the risk of spinal hematoma. So I would always consider the risk of whether the risk of bleeding or the risk due to stopping the antiplatelet, the risk of thrombosis would be higher. And in my patient,
what's the risk of stopping a dual antiplatelet therapy? What's the risk?
Stopping a dual there is a risk of one is stent thrombosis.
Okay, so that's the most important thing. So when you stop your clopidogrel, especially, that is one important factor which predisposes to the development, especially if it is stopped prematurely when you have a drug-eluting stent. So you'll have to weigh the risk of stent thrombosis along with the risk of bleeding. So if the bleeding is manageable, then we can take up the patient with your antiplatelet. But in certain surgeries, there is a definite risk of bleeding, which is over and above the risk of stent thrombosis, which are those cases in which you'll have to definitely stop your antiplatelet therapy before you take them up for surgery.
Madam, in high-risk surgeries like neurosurgeries, spinal cord decompression, then in intraocular surgeries, abdominal aortic aneurysm repair surgeries, we'll definitely have to stop antiplatelet therapy. And also in prostatectomy.
Prostatectomy. Okay. So in those kind of surgeries, you'll definitely have to stop your antiplatelet because the risk of bleeding into closed spaces or the risk of bleeding is higher when compared to your stent thrombosis. Okay. So when the patient comes with a PCI, percutaneous coronary intervention, what are the things you should see in your preoperative assessment?
And for a patient with a PCI or a stent in situ, first thing is we have to ensure whether a stent is there or he only underwent a balloon angioplasty. Second thing is the interval between the PCI procedure and the timing of the surgery, current surgery. Then whether he has been receiving a dual antiplatelet therapy for enough duration, that depends on the type of stent which is inside.
What are the types of stents? Coronary stents?
Intracoronary stents could be either bare metal stents or drug-eluting stents. Balloon angioplasty had a risk of early arterial vessel closure leading to repeat MIs. So bare metal stents were introduced. Bare metal stents, they had larger struts, so they could cause endothelial injury and again lead to the risk of thrombosis. And also there was a chance of there was increased risk of neointimal hyperplasia leading to stent restenosis. So in order to combat this, drug-eluting stents came into place. Drugs like stents used to be coated with durable polymer coating with drugs like sirolimus, everolimus, or sotarolimous came into place. The problem with these drug-eluting stents is that they take longer time for re-endothelialization. So for a prolonged period, the patient will be prone to stent thrombosis. That is, with drug-eluting stent, we have to continue dual antiplatelet therapy for at least 1 year after the stent insertion.
Okay. Okay, sir. Over to you, sir.
This patient is on certain drugs. I think one is the antihypertensive. Can you name the drugs that this patient is on?
Metoprolol 50 milligram OD, ecosprin 75 milligram OD, antihypertensive, sir. Okay, and enalapril 2.5 milligram twice daily, sir.
Okay. What are the drugs that you would like to discontinue before surgery and what you can continue for surgery? Say hernia, and then we'll think of surgery which is more than hernia.
So this is a hernia surgery, which is a superficial surgery. So it's a low risk surgery. We do not expect much of a bleeding. So since our patient has already completed the period of dual antiplatelet therapy and he's like 10 years after the PCI and he's only on ecosprin, aspirin monotherapy. So aspirin monotherapy, it is okay to continue during the perioperative period because we do not expect much bleeding in our patient. Then beta blockers should be continued perioperatively because they have good antihypertensive, anti-ischemic, and they also decrease the myocardial contractility, decrease the heart rate, thereby increasing the coronary perfusion. And they also have a myocardial cell membrane stabilizing effect, and also platelet aggregation also is inhibited by beta blockers. So beta blockers, it is always good to continue in the perioperative period. Then enalapril is an ACE inhibitor, angiotensin converting enzyme inhibitor. It is better we stop enalapril 24 hours prior to surgery, because the patient can go into refractory hypotension following induction of anesthesia if he is not discontinued enalapril.
There are certain drugs which antiplatelets and anticoagulants. There are certain guidelines with regard to institution of regional anesthesia, say epidural, putting in an epidural line. So can you enumerate those guidelines with regard to placement of epidural? Not necessarily in this patient.
Regarding antiplatelets, if my patient was on clopidogrel, I would ask the patient before the needle insertion. Before the needle insertion to be stopped 7 days prior to needle insertion, and the removal of the epidural catheter can be done soon after. If the drug can be restarted soon after epidural catheter removal. In case of ticlopidi, the drug would have to be stopped 10 days prior to the epidural needle insertion or the catheter placement, and restarting can be done soon after the epidural catheter removal. In case of prasugrel, the drug would have to be stopped. Prasugrel would have to be stopped 7 to 10 days prior to epidural needle insertion, and the restarting would have restarting after the catheter removal should be there should be a gap of around 6 hours, and then tirofiban. In that case, we have to stop for at least 5 days and a 6 hours gap before restarting after the epidural catheter removal. And coming to anticoagulants, sir?
Yes.
Okay. Now, coming to unfractionated heparin, we can 6 hours after the stopping of a 6 hours after the stopping of the therapeutic dose, it is safe to insert a central neuraxial catheter, and 1 hour after the insertion of the catheter, we can restart. Then coming to low molecular weight heparin, depends on whether the patient would be on a therapeutic dose or prophylactic dose. If my patient is on a therapeutic dose, I would give a 24 hours gap between the last dose and the needle insertion, and 4 hours gap after the catheter removal till restarting, for restarting the low molecular weight postoperatively. And if my patient would have been on a prophylactic dose, I would give a 12 hours gap between the last dose and the epidural catheter insertion, and 4 hours gap after the catheter removal, I can restart the low molecular weight at the prophylactic dose.
Okay. This patient, let's say, I'm making things difficult for you further. Let's say this patient has had a bed sore in that region, right? And you are not very comfortable going ahead with regional anesthesia, or patient just doesn't give you consent for regional anesthesia. Either option you take it, I don't mind. My point is that you have to give general anesthesia to this patient. What are you going to do now? Start right from your preoperative visit to the postoperative admission to the recovery. Please go ahead.
Okay, so in that case, I would plan for general anesthesia with controlled ventilation with a cuffed oral endotracheal tube for this patient. On the preoperative day, I would visit the patient and I would introduce myself and tell the patient what is the procedure I'm planning to do. I would give him a note on the fasting guidelines he has to follow before surgery. Before that, I would take an informed consent from the patient and a reliable bystander. Then I would tell him the fasting guidelines, which is 6 hours for solid, and he can take clear fluids till 2 hours before the planned procedure. This is important because any decrease in intravascular volume can be detrimental in this patient following induction if he goes into hypotension. That can cause...
Sorry,
sir?
Unlimited amount of fluid?
No, sir. While fasting, he can continue to take clear fluids until 2 hours before surgery.
Okay. I was just asking the volume. Can you allow him unlimited fluid? He has a jug full of water 2 hours before.
No, sir. As
100 ml.
Yeah.
As per thirst.
Okay.
100 per hour max.
Yeah. Go ahead. All right. So he hasn't taken water. He follows your advice. Go
Sir,
on.
then I would add give him anxiolytics to alleviate his anxiety. I would also counsel him. Plus, I can give a short-acting sir.
Yeah, what kind of anxiolytic? Because
Sir, I can give a short-acting benzodiazepine like alprazolam 0.25 milligram on the night before surgery, which could alleviate his anxiety. Then I would also give a prokinetic and a proton pump inhibitor to him, preferably pantoprazole 40 milligram at night as well as on the morning of surgery. So then I would ask him to discontinue.
Apart from what you do with regard to the drugs that you use on this patient, what's important is very patient listening, reassuring to the patient, and giving some sort of counseling. That will work better than your anxiolytic or something. Because if he understands that, if he understands that you are a competent person, that will happen only in case you listen to his story. These patients quite often are hard of hearing. They have poor vision. So you have to be patient while you are dealing with these people. One plus, these patients sometimes are psychologically low. One, they know that on the wrong side of age. Secondly, I'm not saying every patient, but most of these patients are kind of not well cared, and the family support is not as much as you may see in a young patient. So there may be some psychological disorders also in these patients. They may be somewhat depressed. They may be, they may not be able to communicate properly. They would be quite low. So it's important that you talk to those patients, patiently listen to them, and reassure that everything will be okay. All right. So drugs are important, all right, but more than the drugs, I think it's the time that you spend with these patients. All right, carry on. So patient has now come to the recovery, not to the recovery, to the OT. Consent checked, machine checked, drugs checked, prepared, and everything is there. Go ahead now.
Drugs, OT, I would keep the OT warm.
OT, warm, good, very nice, fine. How much warm? Surgeon will jump from you. So, beta, you will keep OT warm, all right, as long as the surgeon is comfortable. Otherwise, he will make, he'll be throwing tantrums. Either you keep the OT warm or you keep the patient warm. I mean, the patient should be warm. As madam earlier asked you, these patients are likely to be hypothermic, okay, after surgery. So they are more prone to hypothermia. So you will, in case the surgeon wants, the temperature to be cool, or it's extreme of summer season, you would like to have the temperature low. So be sure that you warm up the patient very well. It's not that the patient also gets cold. That's going to be difficult. All right. So it's a good point. I note that. That's nice. You are taking care of the patient's temperature. What else?
Then also I would, after checking, keep the drugs ready. I would keep
drugs ready, consent is ready, table is ready, machine checked, everything done. Move on.
Okay. On the day of the surgery, I would, in the preoperative room, I would visit my patient. I would again reintroduce myself. I would reassure him. I would again counsel him to allay any anxiety if he has. Then I would ensure that he has taken his morning dose of metoprolol, and I would also ensure that he has had a 24 hours gap since his last envelopable dose. Then I would, the antiplatelet, I would also ensure his, whether he has fasted for there's at least a 2 hours of gap since his last fluid intake, clear fluid intake, and that he's been fasting from solid foods for at least 6 hours. Then I would ensure that he's had his morning dose of pantoprazole as well. Then then I would recheck the consent, whether it has been signed, the informed consent both by the patient and the bystander. Then I would recheck whether the blood and platelet concentrate have been arranged in the blood bank. Then under local anesthesia, I would say
patient for hernia repair.
Yes, sir. since it was, sorry, sir.
Do you need really blood for these patients?
No, sir, not
you don't need that.
Okay.
Right? For a hernia surgery, which is simple, maybe an hour surgery, a good surgeon might finish in 45 minutes even. Or of course, sometimes people can take 1.5 hours. That's a different story. But I don't think you need blood for this patient, right? So since you are saying everything, I'll check this, I'll check that, I'll check consent, everything. There's one thing else that you would do. Need a hint?
IV cannula.
What? Anemia? Anemia? No, not anemia. With regard to the documents.
Document. Consent.
Consent is that you said it already.
Patient identification.
Surgical safety checklist also. You have to take all those columns before you proceed to induction of anesthesia. The first sign in that has to be checked. In that also, in that comes blood required or not required. The imaging displayed or not displayed. Patient has some allergy or not. Things like that. So not only that you check consent, you also check or tick on the surgical safety checklist also. This just came to my mind because you were saying, sir, I'll check consent. I said everything done. Please move on. You still got stuck to the documents. Okay, go on. All done.
Then, under local anesthesia, I would secure an 18-gauge IV cannula in his non-dominant hand, left hand in my patient. Then in the preoperative room, I would start an IV fluid. I would start normal saline at 100 ml per hour by the IV cannula. Then I would also administer midazolam 0.5 milligram intravenously, along with ondansetron 4 milligram intravenously. And since I'm planning for general anesthesia, also glycopyrrolate 0.2 milligram intravenously. Then again, then I would shift my patient to the I would wheel my patient into the operating room, and after ensuring adequate assistance, I would gently shift my patient to the operating table. I would again reassure him, then allay any anxiety if he has. Then I would pre-oxygenate.
Go on quickly.
Then I would pre-oxygenate my patient. Then after shifting my patient to the operation table, I would attach some monitors. I would attach non-invasive blood pressure, a pulse oximeter, and a 3-lead ECG in my patient, especially since he's a case of ischemic heart disease post-stent placement. Then I would obtain the baseline values. Then after recording the baseline values, I would proceed with my procedure with my general anesthesia. I would give fentanyl 50 microgram IV. My patient weighs 66.
How much is the weight of the patient?
66 kgs, sir. In titrated doses, I plan to give in titrated doses.
Okay, titrated. So do you think 50 microgram will be good enough for a patient at the time of induction of anesthesia?
No, sir. 60.
Normally, how much do you give?
65 would be required, sir.
Now, how much do you normally give per kg body weight to say to a 40-year-old or 50-year-old?
2 microgram per kilogram, sir.
Yeah. So 50 is grossly less for someone who is 60 kilos or something. Is that right?
Yes,
okay.
Sir.
What can be the problem if you give less of fentanyl at the time of induction?
There would be an increased stress response, sir.
Do you want in this patient?
No, sir.
You certainly don't want.
No, sir.
So, what are you going to, what I'm coming to, sorry, ultimately is, as to what are you going to do to ensure that there is no pressure response or there is minimal, because this one patient, you can't afford to have any pressure response. That's why I brought you to general anesthesia. Otherwise, you are doing very well with the regional, you had escaped and done well.
Okay. One is, first, I would keep the patient warm even till the procedure started, and also in the process.
The patient is warm, all right. I'm just asking as to what are you going to do to eliminate that pressure response or eliminate pressure response?
One is intubation. First is prior to intubation, I would give an opioid, fentanyl. I would give at least 60 microgram per kilogram.
Oh, so you have increased the dose. You have bargained with 10 microgram more from 50 come to 60.
100.
Be a little more generous.
Okay. 2 microgram per kilogram, 120 microgram, but
okay. 2 micrograms is not going to cause much problem.
Okay. Then also to reduce the stress.
So we have to we have to finish it fast, please, quickly.
Then also to reduce the stress response, I would give I would induce my patient with propofol, followed by the initial bolus of 60 milligram. I would give into 20 milligram aliquots prior to intubation, prior to the direct laryngoscopy, and also I would keep ready esmolol 30 milligram. In case my patient develops a tachycardia, I would administer esmolol 30 milligram IV. And also the duration of the laryngoscopy, I would do smooth, swift laryngoscopy, limiting it in duration as much as possible to reduce the associated stress response. Then prior to...
I differ a bit here. Yes. Rather than the reactive approach, seeing that the patient's pulse rate has gone up or something has happened, then you give all this thing. These drugs should be given preemptively. You can't afford to have any pressure response, any shooting up of blood pressure or pulse rate in this patient. Okay. So all the drugs that you mentioned that I will, keep it ready just in case it happens. Don't wait for happening. Prevent it. That's better than treating it. Okay.
Then also
your intubation should be as smooth as possible. Point taken. Then what?
Then prior to before intubation procedure, I would give lignocaine also to reduce the stress response.
Yes.
I would give
how much and when?
90 milligram of lignocaine. I would give it 90 seconds prior to the intubation. Prior to the
So 1.5 milligram per kilogram, 90 seconds before laryngoscopy is given.
Okay, all right, done. What next?
Then for the maintenance for the maintenance of anesthesia, I would administer oxygen and nitrous oxide at 3 and 3 liters per minute each. Along with, I would place a volatile agent. I would keep isoflurane at 0.2 to 1% so as to maintain a MAC of 1.
The time is almost up, so we'll have to hurry up. This patient is going to the recovery now. Quickly, just tell me what are you going to monitor? And then you are shifting the patient to recovery, and what are the things that you will do, and we'll end it up. Ma'am, is that okay? I think
yes, sir.
Sure. Want to harass the organizers.
Okay, sir. Fine.
Whole day program. Yes, but quickly.
So in the post anesthesia care unit, we should again keep monitoring his heart rate.
Intra-op monitoring quick.
Intra-op, we should.
One is I would ensure adequate fluid status. That I would look at the heart rate, the BP. They should be maintained within 20% of the patient's baseline awake normal value. Then I would patient has to be normothermic. Then I would monitor his blood glucose level. It has to be maintained less than 180 milligram per cent.
Pain should be, so any amount of pain can again increase the sympathetic stress. So that should be addressed.
You have told 2 more important parameters as yet. ECG, yes or no?
Yes, sir. Yes.
You didn't say that. End-tidal, yes or no?
Yes,
sir.
You didn't say that. Okay, post-op, patient is out in the recovery. What are you going to do there?
So a patient should be ultimately pain-free. There should be no sympathetic response. So we should keep him pain-free.
How much pain score you will accept on VAS scale?
Sir, less than 1.
Less than 1. That is
no pain at all. Should be absolutely pain-free with an epidural insert.
Well, all right. If you have done a great job, see, we are talking about the epidural now. We are talking about general anesthesia. We came to general anesthesia only because epidural could not be given because of whatever reasons. Okay. There's one thing apart from all that. You see, I will like to end it up already. We have crossed 2-3 minutes. There is one thing that you might experience in this patient. Leave aside hypothermia, you have discussed well. You've arrhythmias, yes, blood pressure shooting up and down. Anything else that comes to your mind?
Carbon dioxide, I should avoid hypocarbia.
Hypocarbia
can cause both hypocarbia, hypercarbia.
No carbia, no oxygen, anything else beyond that?
The patient should be extubated only after adequate.
It is extubated. Patient is shifted to the recovery without tube.
Okay.
these patients are likely to have urinary obstruction. He's an 80-year-old man. He's likely to have prostate enlargement. Always look for the bladder. If the bladder is full, patient will be very restless. That also will shoot up his parameters. Blood pressure will go up, pulse rate will go up, and he will be very uncomfortable. Ma'am, kindly do the closing remarks, please.
Okay, sir. Thank you, sir, for being with us for the past 1 hour. And we, on behalf of the Trivandrum Medical College and on behalf of our team, I thank the ISA members for having given our students an opportunity to present here. Thank you.
Thank you so much for giving me the privilege to be here, part of this great program. And it's good to see you, ma'am, Lynette.
Okay, fine, sir.
God bless youngsters, young two ladies. All the very best. You did very well. Although I had a bit, but then it was just to see, if there are any gaps in the information. God bless you. All the very best.
Thank you, sir.
Thank you, sir.
Bye-bye.
Thank you, Baljit sir and Lynette madam. And thank you, students. We'll move on to the next session. Over to Ginny madam.
Okay. So we now reach today's penultimate case presentation, that is the repair of cleft palate. We are very fortunate and very happy that all the students and the faculty have been very particular in adhering to the time. So we are strictly running at time only. So the case presentation will be done by Dr. Linbi Chako, who is a student of Malankara Orthodox Syrian Church Medical College. And the faculty includes Dr. Ramkumar Venkat, who is associated with the Mission Smile. He was a former professor and HOD KMC Manipal. And the next examiner is Gurudat sir, who is already doing his fourth case presentation as a faculty. We hope, sir, you are not already tired. So over to you, sir.
Well, thank you. Can you hear me, please?
Yeah. Good evening, sir. Dr. Ramkumar, sir.
Good evening. Hello, brother. Yeah. Am I heard also?
I did not see you on the. Yeah.
Limbi, can you hear both
Yes,
Dr.
sir.
Gurudat and me?
Yes, sir.
Okay.
Good evening, sir.
Good evening. Right. So let's get started. Okay.
Okay, sir.
So we are to, along with Dr. Gurudat and me, Limbi will take us through the anesthetic concerns and anesthetic management of a patient with a cleft palate.
Yes, sir.
Okay, go ahead. You can present your case,
Yes,
Limbi.
sir.
Okay.
Okay. Good afternoon, all. Today I'm presenting a case on cleft palate. So the informant was mother, and the history was reliable. It was a 10-month-old male child with history of nasal regurgitation while feeding and recurrent ear infection. Child had frequent episodes of upper respiratory tract infection and was given antibiotics and nebulization for the same and was never hospitalized in the past. There was no relevant family history. Birth history, the mother had no history of any drug intake or infection during the pregnancy. The baby was full term, born by lower segment cesarean section with birth weight of 2.8 kg, passed urine and meconium within 24 hours, and there was no other congenital anomalies detected at birth. Feeding history, child was given breast milk since birth and weaning started at the age of 6 months. He has difficulty in sucking and nasal regurgitation of milk and weaning food. Child is fed with pallida. Immunization history, child was immunized for the age and the developmental milestones. Child can stand with support. Immature pincher gas was there, waves bye-bye and utters mama. General physical examination, child was playful and afebrile at the time of examination. His length was 75 centimeter, weight 8 kg and head circumference was 42 centimeter. There was no pallor, no cyanosis and no edema. Vital signs, heart rate was 110 per minute. Saturation was 100% in the room air. BP was 80 by 50 millimeter of mercury and the respiratory rate is 28 per minute. On the airway examination, there was a left unilateral cleft in the soft palate, approximately 2 centimeter, which is seen in the roof of the oral cavity. And all of the systemic examination was within normal limits. These are the investigations of the child, and the echocardiogram study was normal and the coagulation profile was also normal. So summary of the case. A 10-month-old term baby born by lower segment cesarean section with a birth weight of 2.8 kg. There is no history of ICU admission or other congenital anomaly. Presented with a unilateral cleft palate with history of nasal regurgitation and recurrent ear infection. No history of developmental delay or no history of lower respiratory tract infection requiring hospital admission. Immunized for age with a weight of 8 kg now. On examination, there was a left unilateral cleft in the soft palate, approximately 2 centimeters, seen in the roof of oral cavity, and the child was admitted to the hospital for palatoplasty surgery. Diagnosis: it is a left unilateral cleft palate with normal milestones with no other congenital anomaly seen.
Okay, that's a very good summary, Limbi.
Yes, sir.
Essentially, when you're presenting a short case, the examiners expect you to present the whole thing within 2 to 3 minutes. Okay, so that then we can continue with the discussion. Can you go back to your first slide, and then we'll go step by step as we discuss this case. Okay. Yes. So you mentioned here that it's a 10-month-old child. Okay, and there are frequent episodes of upper respiratory tract infection. Now, very often children come with a runny nose, right?
Yes, yes,
so
sir.
how do you differentiate an infective runny nose from a non-infective runny nose? Because you labeled it as upper respiratory tract infection.
Yes, sir.
What if I say it was only just a watery discharge, not an infection? It's quite common in pediatric age groups. So how do you dissociate these two? Because the implications are quite different, right, Limbi?
Okay, yes, sir. From the history, if the the nasal discharge is foul smelling, or if it is associated with any fever or productive cough, like associated lower respiratory tract infection also, and from the investigation, if the total count value is high, more than 10,000 per ml, then it is suggested, or if on examination, like in the chest, there will be crepitations, then it can be, the surgery can be postponed for 2 to 3 weeks. Because the child is having an active infection that can result in post-operative respiratory complication.
Suppose a mother says that, a week ago I came to the MOS hospital. Child was treated for an upper respiratory infection 1 week ago. Now the child is asymptomatic. Okay. When can you take up? What is the earliest you can take up this case?
3 weeks. After 3 weeks, 2 more. We need to wait for 2 more weeks, so that the airway become less reactive.
After the treatment is over, the child is asymptomatic.
Yes, sir.
So you will wait for another 3 weeks, is it?
2 weeks, sir.
2 weeks. So what are the recommendations?
2 to 3 weeks after an active infection.
What happens if you take up before that?
Like the respiratory tract is overreactive, so there will be more chance for post-operative bronchospasm.
Fine, that's good. Okay. So very often, we are faced with this problem of differentiating an infective from a non-infective, a nasal discharge. And I think you've described it quite well, right? Now, you also talked about, okay, go on to the next slide. And then.
Sir, in the meantime, sir, usually
yes, sir,
some of the examiners do ask why after a respiratory infection, the child becomes, the airway becomes hyperreactive. What is the reason? Because you said that 3 weeks you have to postpone. Why 3 weeks? Why not 2 weeks? Why not 6 weeks?
So that secretion and all
Now what happens is, whenever there is a infection, especially a bacterial or viral infection, the vagal nerve endings, they become hypersensitive. So any stimulation of the upper airway, so more release of acetylcholine and acting on the M3 receptors, bronchospasm. So this is common thing, and this hypersensitivity of the respiratory tract will take almost about 3 weeks, the nerve endings to disappear. So that is the reason. Usually they say 6 weeks, but even 3 weeks is enough because the sensitivity would have come down drastically. Sorry to interrupt, sir, in this.
No, you're absolutely right. I'm glad you pointed out that 4 to 6 weeks is the ideal duration. But then when a child is having frequent infections like this, then we have to find the right window period to operate. Otherwise, it will just carry on like that. Okay. So now on this slide, is there anything specific you would like to point out?
There was in the feeding history, the child had difficulty in sucking and nasal regurgitation of milk and the weaning fluid from the since birth. So that resulted in recurrent infections.
Okay, Limbi, what is the ideal age at which cleft palate is repaired, and why?
Cleft palate is usually repaired when the child is at 10 months of age. This is because before the development of the speech. Ideally, the cleft palate should be corrected before the development of the speech.
Okay.
And also
how about the lip? I know we're not don't have a lip deformity in this child, but suppose this child had come with an isolated cleft lip.
It should be corrected early by 10.
You can operate?
Yes, sir. It should be corrected before 10 weeks. This is because if the child is only having cleft lip, then that will also help in the like sucking, feeding of the baby, because cleft lip will result in difficulty in feeding, and that will result in failure to thrive.
Okay,
so early correction is better.
Okay, Limbi, wait. Will it result in difficulty in breastfeeding or difficulty in bottle feeding? This 10 weeks is linked to that particular period. Okay, so very often what happens is when the child starts getting weaned off the mother's breastfeed, that's when they will start putting on bottle feeds.
Yes,
the child will not be able to get suck properly from a bottle. Whereas with the breast, the child is able to get an adequate, seal, and it won't be much of a problem to breastfeed. Very often, the mothers and the babies learn the trick for the right method of breastfeeding. So lip alone, is not a major problem for breastfeeding. But when it switches to bottle feed, that's the problem. That's the time you will probably need to correct it. Okay. Have you heard of a rule called the rule of 10? Very often we talk about that. What is that?
Yeah, in cleft lip, the cleft lip should be corrected with the baby of 10 weeks age, 10 pounds weight, and when the hemoglobin is 10 gram per deciliter, and when the total count value is less than 10,000 per ml. For the cleft palate, it should be corrected when the baby's weight is 10 kg, with 10-month age baby with a hemoglobin of 10 gram per deciliter, and when the total count is less than 10,000 per ml.
So, Limbi, what is the name of this rule of 10? Any name is there? Somebody's name? It's called as Killer's rule of 10. Killer. And Limbi, one more question here, because you said that 10 weeks and 10 months. Why can't both the surgeries to be done by 10 weeks? Why do you want to wait for? Because anyway, before speech, the child starts speaking, you'll have to do the palate surgery, you said. But why not together by 10 weeks or before 10 weeks? Why should you wait for a child to grow till 10 months to do the palate surgery?
After the correction of the cleft lip, the width of the cleft, the palate defect will reduce. So
no. You want the tissues also to mature, right, Limbi? You want the tissues to mature. Tissues, see, it's very difficult to operate in the depths of the mouth when the tissues are still very fragile and young. So the surgeon also prefers to put it off a while till the tissues become a bit more, they grow a bit more, and then they'll be able to mobilize and approximate. Sorry, Gurudat, I answered your question. I'm so sorry.
No, and one more
what
thing,
you had in mind?
Lip surgery is a minor surgery.
Correct.
So even first week, second week, even as a neonate also it can be done. You need not have to wait even for 10 weeks. But palate surgery is a major surgery wherein quite a bit of blood loss also occurs. That is why it is better for the child to grow a little bit more so that it can tolerate this major surgery for that infant. So that is the reason. And as such, sir was telling about the tissue growth also. So these are the two reasons why you have to wait. You don't do together both the surgeries. Right.
Limbi, you've written on this slide, no history of drug intake or infection during pregnancy. Do you want to narrow down to one particular part of pregnancy? Is it throughout? Let's say that mother had fever
first trimester.
First trimester. Please narrow it down some more. There's a period of organogenesis. What's
till 8 weeks.
Organogenesis?
4 to 8 weeks time.
4 to 8 weeks. 4 to 8 weeks. Okay. Right. Even you can extend it a bit more, 4 to 10 weeks or so. Okay. So it's basically 30 to 70 days, the organogenesis. And cleft lip and cleft palate occur as a result of maldevelopment or disordered development of which part during embryology?
The maxillary process, fusion of the maxillary process with the medial nasal process and the.
Okay, right. So it's also the branchial arches, and we will come to. You written here no other congenital anomalies. What are the common congenital anomalies associated?
Usually, the child with cleft palate will have Pierre-Robin syndrome and Treacher-Collins syndrome and all. So they will have micronathia, glossotosis, cardiac anomalies. And in Treacher-Collins syndrome, there will be choanal atresia or ear or eye malformations.
Okay.
So we need to rule out all these congenital anomalies.
Well, in any syndrome, what are you going to look for? No other. Are you just going to label it as Teacher Collins or Superior Robin? Or are you going to look for any
Cardiac anomalies.
Yes,
Correct.
precisely. We need to look for cardiac anomalies, right? Because again, part of the heart develops from the branchial arches, right? So that's why you need to know a bit of embryology. So along with the deformity of the face, you also get associated problems with the cardiovascular system, and that's the reason CVS must be very carefully evaluated. Okay, of course, syndromic children have other issues as well, and thank you for enumerating Teacher Collins and Vera Robin syndrome. Okay, Guru, you have any questions on this slide, or you want to proceed a bit further?
Yeah, one more thing is many of the syndromes are associated, isn't it? Not just Peter Robin or Treacher Collins. Even Klippel-Feil is there, and especially Catch-22 is one of the congenital syndrome that can be associated. So all these syndromes, many even Down syndrome may be associated with cleft lip palate. So you may be asked about all these syndromes, individual syndromes, and their anesthesia problems associated with. So you just have to know about all the syndromes associated with cleft lip palate. Right, sir?
Okay, so let's go on to the next slide, and then that's okay. Immunization's fine. Okay, milestones are good. Right. So let's say this child is now being scheduled at 10 months of age for cleft palate repair. Okay, and the child doesn't have an infective etiology for the nasal discharge. Put up the last slide where we had the investigations. Essentially, they were all looking normal, right?
Yes, sir.
All investigations are normal. So with this kind of an investigation profile, and you've seen the child, how would you prepare this child for cleft palate surgery? Any preparation?
So during the pre-anesthetic checkup, we need to take a detailed history like I took, and also look into the investigations, whether they are normal, and do a blood grouping and RH typing, especially for the cleft palate baby, and arrange blood for the same. And then we need to do an echocardiogram if on examination, if there is any murmur. And we need to talk about the NPO status to the mother, explain about the nil.
Maybe if you want to impress your examiner, because we're now preparing you for the exams, right?
Yes,
so you should talk about your patient, right? It's an 8 kg patient. So don't just say, I will reserve blood. You say, how much blood are you going to reserve? Are you going to reserve a whole adult unit for this patient?
No, sir. 80 ml.
Yeah. So you must, for an 8 kg patient. Okay. So you will say that I will either type and hold or cross match. Is there any difference between the two? For a palate, would you like to have the blood in the theater, or if you type the blood, would it be enough and it's available in the blood bank?
Blood bank is enough.
Blood bank is enough, no? Yes. So very often the surgeons are very adept. Very rarely do we land up giving blood unless it's a very huge defect. And this child has only a soft palate defect, mainly, right? So very unlikely that we will need the blood. So let's just type the blood and the group and RH typing, and hold the blood in the blood bank. Okay, right. Then what else?
Since my child does not have any syndromes or facial anomalies like cleft lip or any other syndromes, so I'm giving pre-medication. I would like to give pre-medication like syrup midazolam 0.5 mg per kg.
Tell me how much for this child, okay?
4
That's more impressive. See, yes, don't give general answers. We're talking about this child weighing 8 kilos coming for cleft palate repair. It would be more appropriate if you say, okay, I'll give
4 mg.
4 milligrams you want to give, okay?
Yes, sir.
0.5 milligram per kilo, okay? So you can say I'll give 0.5 milligram per kilo.
5 milligram of midazolam 45 minutes before induction of anesthesia.
Do you think it's mandatory? Do you think this child is going to have separation anxiety?
Yes, sir. Children more than 6 months need, because of the stranger anxiety will develop in 6 months of age. So any child more than 6 months require.
Are you a little concerned about giving sedative pre-medication in children with clefts?
If you are anticipating a difficult airway, better not to give sedative pre-medication.
Okay. So it depends. In your evaluation, this child is not likely to have a difficult airway. Is that what you're saying?
Yes, sir.
Okay. What in the history will tell you that there's likely to be a difficulty? What would the mother tell you?
if the child has cyanosis during feeding, there is cyanosis or increased sweating or like any congenital anomalies. And also during sleep, the patient has sleep apneas, histories of apnea.
Okay.
And change in posture will relieve the symptom.
Okay, right. Okay, go ahead. Unless Dr. Gurudat wants to ask something about the pre-op preparation, go ahead.
No, one more, just wanted to tell her that, all pediatric patients in the examination, you should always note also that the IV line, whether, you have a good IV line, you will have to mark it, and then you have to tell the examiner that I have found a very good IV line, and that will be there, or a vein for cannulating the child. Because it is very important, you have to mark it, and then you have to tell the concerned ward sister also not to manipulate it. Because many times you would have marked and she would have taken that line for some blood, drawing the blood or anything. So it's very important. This is, you have to, in adult patients you don't do this, but in pediatric patients you always look for a vein for your cannulation during your anesthesia. So that's why it's very important. During examination you should always do. Okay, in preparation you said that midazolam is fine. Okay. Any other better pre-medicants you can give other than midazolam alone?
Trichlorophos can be given 600 mg to this child.
Now, what is the common pre-medicant you are using in your hospital?
Here we are giving trichlorophos.
Trichlorophos. Okay.
Yes.
Any promethazine is better? What are the advantages of promethazine as a pre-medicant in a child?
That will relieve nausea.
Yeah, there are multiple advantages, isn't it? Sometimes you may be asked, like it also has, it is sedative, it is anxiolytic, it is antiemetic, it is anticholinergic. That is very, very important in this, and also has got antihistaminic property. So multiple advantages are there with the phenargan syrup. So you can definitely, you can also use 0.5 to 1 milligram per kg body weight of phenargan, that is promethazine hydrochloride. But whatever that is being used in our hospital, you should always tell. Not for the sake of examination, you want to change it. So if you're using trichlorophos, fine, that is also good. Right.
Yes, sir.
Okay, go ahead. So this child is now asleep with your pre-medication outside the operating room. Okay, and you got your operating room ready. Would you tell us what you'd like to keep ready in the operating room before you shift the child in?
Okay, I would like to first check the machine section and keep ready the section apparatus, and the fluid warmer and the forced air warmer should be ready, and the operation room should be warm. Then LMS, pediatric difficult airway card should be available in the operation theater, including the different size oropharyngeal airways, different 1.5 and 2 size LMA, classic LMA, bougie, jet ventilator and all. In my child case, there is it is not a very anticipated difficult airway, but even then we need to get ready the pediatric difficult airway kit in the OT. Then the Jackson Rees, I will be using the Jackson Rees modified ISTP circuit, and also the closed circuit should be available. Then the monitors should all be ready. And I will prepare the fluid, like since my child is 8 kg, I will calculate the fluid, like the maintenance fluid of 32 ml, and with the deficit correction, the IV fluid will be, ringer lactate will be preset with the burette, like when the child is getting the OT, after the IV cannulation, I should directly connect the IV fluid. Then
when will you allow the last feed? When can I feed the child?
Yes,
it's
sir.
an 8 o'clock surgery, 8 a.m. surgery. When will you allow the last feed?
Like clear fluids can be given till 6 a.m.
No, don't talk about clear fluids, solids and all that. This child, 10-month-old mother is breastfeeding, wants to know, when can I feed the child last?
4 a.m. Till 4 a.m. she can breastfeed the child.
Okay.
After that, surgeries.
After that, if the child is still hungry and crying, then you can probably give
clear fluids till 6 a.m.
After 6 a.m. So 2 hours before is what you're saying.
2 hours before the
2 hours before you can give clear fluids. And breast milk, you're saying up to 4 hours before.
4 hours before the surgery.
Is that the current recommendation?
Clear fluids can be given up to 1 hour before the surgery.
And is breast milk equal to cow's milk?
No, sir. Cow's milk should be faster. The child should be given cow's milk only till 2 a.m. like 6 hours before the surgery. It should be halted for
longer
6
fasting
hours.
would be given. That's what you're saying with cow's milk as compared to breast milk. Is that what you're saying?
Yes, sir. Breast milk for 4 hours and cow's milk for 6 hours.
Okay, NPO part is over unless Dr. Guru wants to add anything. Otherwise, go on. Now, the theatre is also ready. And
yes,
you're placing the child inside on a patient trolley. The child is sleeping on the trolley. Okay. With
Yes,
your
sir.
pre-medication, child is nicely sleeping. Enter the operating room. What next? You're the senior PG in charge and you've got a consultant with you. And the consultant told you to induce the case. Right?
Sir.
Go ahead.
I would like to induce it.
With my eyes closed, I should be able to imagine what Dr. Limbi will be doing in the operating room. Okay, to see.
Yes, sir.
That's how I'll understand that you are practically good. Okay.
Yes, sir. Yes, sir. Since the child is sleeping, I will like to put the monitors like non-invasive BP, ECG, pulse oximetry.
And you make
and
sure that the child wakes up. This is the worst answer I expected.
yes, sir.
Okay, you've taken all the trouble of giving pre-medication and then you trouble the child that is sleeping on the trolley. What is
Okay.
steel induction?
I will use the Jackson-Lee circuit and pre-oxygenate the child with the face mask a little away from the face. After that, I will incrementally give the sevoflurane and induce the child with inhalational induction. Once the child is asleep, I will.
Would you buy this idea or would you go still with connecting non-invasive blood pressure, pulse oximeter, ECG leads and waking up the child? Would that be a better idea or would inhalation induction, and then applying the monitors would be a better idea? Whatever you do in your hospital, okay?
At least we need to keep a pulse oximeter and, if possible, keep the ECG lead before giving sevoflurane. This is because there is more chance for bradycardia, and so we need to monitor the child.
If you're at the head end, you can induce the child. Okay, and if I were your consultant, I will just say go ahead, and I have my stethoscope ready.
Yes,
in
sir.
my ears, I can place it on the chest if I have a problem. Okay,
Yes, sir.
child with 2 or 3 breaths is not going to have a cardiac or a respiratory arrest.
Yes, sir.
As long as the child is breathing smoothly and regularly, there won't be a problem. And as soon as the child gets quiet, put on the pulse oximeter. Till then, use only your stethoscope. Your consultant can just help you by auscultating the heart if there is any doubt at any time. Okay, so
Yes,
don't
sir.
immediately
Sir, it
apply
all-
all monitors. So your monitoring will consist of.
Sir, it all depends on what induction agent she'll be using, sir.
She wants you sevoflurane, she says.
Yeah, if she's using sevoflurane, absolutely there won't be any bradycardia or any problems, isn't it? But if you're using halothane, definitely you can have all the problems. So that's how sir was telling that if you're using sevoflurane, you can always induce the child, gravity induction or steel induction, and then once the child is sleeping, quietly, then you can always apply all the monitors. It is always there, right?
See, the place where I worked, Limbi, we had a
Yes, sir.
pediatric anesthetist who, the child cries, a sleeping child is woken up during her induction, you'd be sent out of the theater that day. Okay, so that's how strict pediatric anesthetists are. So don't lose the advantage of a good pre-medication, right? The whole beauty of pediatric anesthesia is smooth induction and smooth recovery. Okay, remember that. Go ahead. Okay, so now you induce a child is breathing 4% sevoflurane or 5% sevoflurane with oxygen smoothly. Airway is fine.
Yes, sir.
Okay. And you applied all the monitors. Then next.
Now I will secure an IV cannula
Okay.
and connect the fluid, and will give glycopyrrolate 0.08 milligram.
I'm very poor at maths. Again, for an 8 kg child, why don't you calculate everything for the 8 kg child? When you get a case like this, you must keep everything ready for an 8 kg child. Okay. Okay. Once again, please tell me for an 8 kg child, how much of glycopyrrolate?
0.08 mg, sir.
Okay. 0.1 milligram, milligram per kg.
0.01 mg per kg.
Linby, 0.08 will be too much. Is it 0.008 or 0.08?
0.01 mg per kg, sir.
0.1 mg. So she's rounding off 0.08 to 0.1.
Yeah. So it should have been 0.008, isn't it? Or 0.01. If you say 0.08, it will be too much.
Too much. Okay.
Even more than atropine.
Yes,
okay. Right.
So glycopyrrolate given. Okay. Child is only breathing oxygen and sevoflurane now. Okay, next.
Next, I will induce with propofol. 15 mg propofol will be given, and I will check for whether bag mask ventilation is possible.
Okay.
And then since the airway is not much if I'm able
to ventilate, bag mask ventilation is okay, right? Then what do you do?
I will.
You had already induced the child with sevoflurane. Why again propofol?
Okay, I was just going to come to that, but Gurudat asked the question. Okay, I was going to ask that next after remaining drugs. Yes, the Guru. So what Guru wants to know is 2 milligram per kilo is what you've given, 16 milligrams of propofol over and above a child breathing smoothly with 5% sevoflurane. Would that be an overkill? Is it really necessary? Okay, you don't need to give a full inhalational induction and a full intravenous induction. That's when you'll have problems. So tight it is. Maybe you can reduce it to 1 milligram per kilo now.
Okay. No, but so why propofol again? Was sevoflurane not enough?
I will reduce the sevoflurane. And
now, why do you want to reduce sevoflurane when you are inducing the child only with sevoflurane and getting an IV line also? So why propofol again? Is it does it help? Sevoflurane, what is the problem with sevoflurane when you handle the airway? Many times with sevoflurane, what has been found is these children may go for sometimes laryngospasm and also the bronchospasm. These are very common with breath holding or very common with sevoflurane. So addition of a small dose of propofol will definitely suppress the airway reflexes and it will definitely prevent these complications. So yes, you are right in giving a small dose of propofol, but don't give full dose of propofol.
Yes, sir.
Yes. Okay.
All right. Okay. Then next.
Then if I can bag mask ventilate the patient, then I will give atracurium like muscle relaxant, 4 mg IV, and then I will ventilate for 3 minutes. And after 3 minutes, I will do scopy with a 1 number blade, Macintosh laryngoscope blade. I will do the scopy and intubate the child with a 4 mm ray tube, south pole. And I will auscultate for the air entry. If the air entry is bilaterally equal, then I will secure the tube and it should be fixed to the chin in the midline without affecting the symmetry of the lips. And afterwards, I will pack the throat with throat pack so that the aspiration of the blood going into the larynx can be prevented during the surgery.
Okay, Limbi, are you using a cuff tube or a non-cuff tube?
Cuff tube, sir.
Cuff tube, okay. And what is the full form of RAE?
Ring adder Elvin tube.
Okay. If that's not available, can any other tube be used?
We can use Oxford tube or microcuff tube can be used.
Okay. You've seen an Oxford tube?
No, sir.
No. Okay. So theoretically, yes. Okay. Because in fact, historically, Oxford tube was used first for cleft lip and palate repair. And only after that, these RAE tubes came into use. Okay, for a short while, they also used armored reinforced tubes for a while. Conventional tubes were used, right? So all of this has been used till eventually we have now settled on the ring adder Edwin tube. Okay, fine, 4 millimeter tube. Okay, next, surgeon's ready to position. Do you position and you put a pack? You said, right?
Yes, sir.
You put a pack. Okay, good. Next, how do you position the child? Okay.
So one thing, sir, here, majority of the times the surgeons will pack the throat because they don't want us to pack the throat because, this is a soft palate surgery. So if you are packing the throat, the pack may come in their way of doing the surgery. So many times the surgeons say that, no, leave it to me, I am going to pack the throat. So I think that is what routinely done for palate surgery many times.
But just make sure that only one pack is put. Communication with surgeon is important. You don't put a pack and then surgeon also puts a pack, then you'll have 2 packs. Right. Okay. So be very announce when you place a pack on the throat. Whoever is placing it. Okay.
Okay.
But enough instances of throat packs being retained. Okay. So right. So what's the position for surgery?
I will keep the body of the child extended, like I will keep a folded format to extend the body, and the neck will be hyperextended and kept in a head ring, so that hyperextension of the neck.
Neck will be kept, or the head?
Head will be, sorry,
Okay,
head will be hyperextended.
Mhm.
So that the exposure, surgical site exposure will be better, and the bleeding can like the blood can be collected in the nasopharynx, that can be suctioned out, like the blood won't go into the larynx.
Is there any other monitor that would be used at this point of time?
End-tidal capnography is already there. End-tidal capnography,
I didn't
temperature
know the
probe,
computer. Yeah, I was looking for that.
skin temperature probe should be kept, and
Temperature probe also can be placed. Okay, right. Okay.
yes, sir.
So now the surgeon is ready to put in the gag.
Yes, sir.
Okay, what is the name of this gag that they use?
Dingman mouth gag.
Dingman mouth gag. Okay. So what are the problems that or what should we watch for as anesthetists when the gag is being placed, and what are the problems that can happen?
During placing the gag, it can compress the tube, and or it can dislodge the tube. So while the surgeon is
What
putting
second
and
part I didn't hear. Second one I didn't hear. It can dislodge.
Dislodge or compress the tube. Kinking of the tube can occur. So we should always
right. Kinking will occur at which point?
While putting the gag as well as during opening the gag.
No. At which anatomical point will the kinking occur? Does this child have any teeth at 10 months?
No, sir. This child was no.
No teeth. Okay. But you can have a problem where the gag is the tube is compressed between the gag and the alveolar margin.
Right.
That's one point. The second thing is deep down, the innermost part, the blade, the tongue blade, which lies in the pharynx. Okay, that's the other part where it can kink. But luckily, we have used a RAE tube, and that problem should be fixed. Okay. Any other problem? The surgeon is happy. He's put the gag and he's pulled it out 3-4 catches. Tuck, 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 tuck. He opens it out. What should you be watching at that time?
You should be watching for the kinking of the tube, so the airway pressure will rise as well. Also,
so put the patient on a ventilator. That means I understand you put the patient on a ventilator, or you're hand ventilating.
Hand ventilate, sir.
Better to hand ventilate at this time.
Hand ventilate, so that we can assess whether we can able to ventilate. If there is any rise in airway pressure or tightening of the bag is there, then we need to ask the surgeon to remove the mouth gag.
What else would you do, Limbi, at this point? Okay, the end-tidal carbon dioxide, the waveform is good. Okay, and
yes,
the air pressure does not go up. As you're ventilating, you don't feel any major rise in the pressure. The bag is not becoming tighter. What else can happen when you apply the gag? You need to auscultate both sides of the lung again.
Yes, sir. Yes, sir.
Why?
Displacement of the tube can occur. No, it can go into because it is hyperextended. It can go into one side, bronchial, endobronchial, or
okay, extension will pull out the tube or push in the tube.
Pull out the tube, so the position of the tube can change, or the.
However, with the gag in place, okay, it can push the tube further in. So application of the gag, whichever gag they're using, can potentially make the tube endobronchial.
Yes,
you need to auscultate both lungs after the final position is done. Okay, and also look at your capnograph and airway pressures. Right. Okay. No, Dr. Kuru was asking about laryngospasm.
Yes, sir.
Right. At what point of surgery do you think laryngospasm occurs most commonly? Have you seen a case of laryngospasm?
Yes, sir. During the extubation time.
Extubation time. What was the surgery then? Was it also cleft palate or?
No, sir. Tonsil.
Can we talk a bit about now that now the rest of the surgery will go on? Okay, what are we going to do for pain management? Till now, I heard you gave propofol, sevoflurane, and glycopyrrolate.
Yeah.
Anything else you want to give?
After the induction, we can insert paracetamol suppository 30 mg per kg. So 240. So 170 plus 170 milligram and 80 milligram suppository can be inserted. At least 240 milligram suppository can be inserted after the induction.
Okay.
And fentanyl can be used. That is 16 mcg IV, like 2 mcg per kg. 15 mcg. I will give 15 mcg of fentanyl after the induction.
Can the surgeon do anything that will reduce?
He will give infiltration at the incision site in order to reduce the bleeding.
Okay, that is the best. If you block nociceptive receptors at the site of surgery, that will be the best way to block pain or to give pain management without over sedating the child. Any other things, I mean, the fentanyl can sedate the child. Okay, paracetamol, I agree, will give good analgesia, but without any sedation. So I agree with whatever you say, but it will also help. Okay, so the surgeon must infiltrate. And what do they normally use for infiltration?
They use lignocaine with adrenaline 1 in 2 lakh dilution, 1 ml per kg.
Okay,
and
1 ml per kg. All right, that's about 2%. You said no. That's 20 milligrams.
Yes, sir.
20 milligrams per kg. So you are giving 1 ml per kg.
1 ml per kg.
You're okay with that? Head and neck surgery, no?
Yes, sir.
Would that be, what is the maximum dose you can use of lignocaine?
5 mg per kg.
So you are allowing them to use 20 mg per kg. Some mistake there, or you want to correct yourself? See, you said 2% lignocaine with adrenaline, that's 20 milligram per ml, 1 ml per kg you said. Is it all at one shot, or you're going to allow them that over a period of time?
Over a period of time.
Even then,
1 in 2 lakh dilution.
Even then, you need to keep the total dose in mind. Okay.
Yes, sir.
So it seems a rather large dose. So be careful about local anesthetic overdose.
Limby, you can go up to 10 milligram per kg body weight for lidocaine with adrenaline for infants.
7. Okay.
Yeah. Plain lidocaine, 5 milligram per kg body weight. With adrenaline, up to 10 milligrams you can go for. Any role for dexamethasone, Limby?
And
for cleft palate?
Like anti-emetic effect is there for dexamethasone, and
what else? Here, what do you expect in the post-operative period?
Edema will be there because of the mouth gag and manipulation of the tissue.
So surgery is there only near the, very close to the airway, actually inside the airway itself. So post-operative edema can also produce problems, respiratory distress for this patient.
Yes.
So there is no harm in giving 0.1 milligram per kg body weight of dexamethasone also as a routine thing. So at least just as a pre-medicant only, you can give once you get the IV line.
Yes, sir.
Right, antiemetic effect also is there, no, for dexamethasone, antiemetic effect also.
Yes,
right. So you mentioned that you have come across a case of laryngospasm. How did you manage that? Because you could get it in this surgery also. So
yes, sir.
What are the precipitating causes for laryngospasm in this kind of head and neck surgery?
Like secretion or bleeding or clot in the airway.
That is similar to the adenoid or tonsillectomy, right? So blood
yes, sir.
Right? Okay.
Yes, sir.
Okay,
then edema, like because of laryngeal edema, can be because of the endotracheal tube that is placed for a long.
Laryngospasm. We're talking two different things now.
Yes, sir.
Okay. Laryngospasm, is it different to laryngeal edema?
Yes, sir.
Yeah. We're talking about laryngospasm.
Yes, sir.
Which is a transient closure of the glottis, partial or complete closure of the glottis due to maybe irritation caused by the blood or secretion.
Blood or secretion.
Right. How do you detect it? Let's say it happened now. Everything went smooth in surgery, and at the time of extubation, let's say this child developed a laryngospasm. Unfortunate. Okay, everything went smooth until then. What would you do?
First of all, I will give 100% oxygen.
Okay.
Then I will give intermittent positive pressure ventilation with like if after extubation, if it is happening, then I will give positive pressure ventilation with 100% oxygen with a tight mask. If it endotracheal tube, I will try positive pressure ventilation.
Don't fall into the trap, Limby. This is not the right way to treat laryngospasm. Positive pressure ventilation against a closed glottis. Where will all the air go?
Subcutaneous.
Subcutaneous. What do you say? You are giving positive pressure ventilation against a partially or a completely closed glottis. Okay, and you are ventilating 100% oxygen. Where is it likely to go? It won't go into the trachea. So which other tube will it enter? Go into the esophagus, right?
Yes.
So have you heard of CPAP?
Yes, sir. Yeah. Continuous
positive airway pressure. So that's what you would do. You'd use a tight fitting mask. You will give adequate flow into your Jackson-Rees circuit so that the bag becomes tight.
Yes, sir.
Okay.
Yes,
the bag becomes tight. If you have a manometer, you can check it. But if you don't have a manometer, a tight bag should be available. Give adequate flow to keep the bag tight. That will imply that the positive pressure is created within the throat. And that generally will break the laryngospasm. Okay, so don't give positive pressure ventilation. Okay, IPPV is not a good idea when there's laryngospasm. Just give a CPAP of 3 to 5 centimeters of water, 100% oxygen. Right, it doesn't break. After some time, bradycardia develops. The child starts getting a desaturation, 80. Saturation is 80%. And bradycardia of 45 beats per minute. What do you do next? The laryngospasm obviously is not breaking. What do you do?
Yes, sir. I will give propofol 8 mg per kg. 8 mg, sorry, 8 mg, like 1 mg per kg. 8 mg propofol I will give to deepen the plane of anesthesia, and I will try whether I can ventilate or not. Even then, if I am unable to ventilate, then I will try to give succinylcholine 0.25 mg, like 2 mg of succinylcholine.
Okay. So,
and then ventilate the baby.
Okay, right. Have you heard of Larson's maneuver? Larson's, Larson's maneuver. Something for you to look up, or maybe somebody's been answering all the questions on the chat. So let's see whether this answer comes up as well. Larson's, Larson's maneuver to break laryngospasm. Okay, if you don't know it, look it up. Okay. Somebody is giving the answer on the chat, but you don't look at it now. That person's the right direction. Okay, go ahead.
Sir, time
up, no? Yeah, another 2 minutes. One minute more. Yeah, 1 minute more. Okay, last question. What is a tongue stitch, and when do you apply it?
Postoperatively, the surgeon will apply it in order to prevent the fallback, and it will be removed. It will be kept throughout the post-operative period, like in the recovery room. And while the patient is shifted out the recovery room, we will remove the stitch, and it will be stabbed to the chin to avoid the.
Most surgeons prefer to put a tongue stitch. Okay, it's a very safe method to go by. Okay, because anybody in the recovery area can just apply a slight tug on that tongue stitch and can relieve airway obstruction, particularly when they have done, pharyngoplasties, or this is a soft palate repair. You don't know. So if there is airway obstruction at that point with airway edema coming in, it will help. Okay, so the tongue stitch is also very useful. And of course, we must always remember about the throat pack. Okay, once the pack is in, pack must come out. So it's always a good idea to post it somewhere on the wall of the operating room. Throat pack in, throat pack out, or put it on your anesthesia record. Throat pack in at this time, out at this time, so that there is a record that somebody has watched the pack go in and watched the pack come out. I think it's very, very critical to note that. Okay, we are done. Yeah, my alarm is going for 45 minutes. Okay, so we can stop here, and maybe we've got one more case discussions there after this. And Guru must be very tired today.
No, sir, no problem.
He's going on like batting with many other partners. Yesterday he's been at the mic. Okay, Limbi, did you have any question for us? You are allowed to ask us one question. No questions. Time on.
Sir,
okay, thank you so much. Yeah.
Sir, it was a real honor to be as examiner along with you, sir.
Oh, no, not at all.
It was almost a dream coming true.
Thank
you so much, sir, for accepting this particular, invitation. I'm very thankful to you, sir.
I must thank Dr. Gurudat as well, because he's always very good company to be an examiner with, and also Venkatagiri, Nazar, Vinil, and Rajesh for giving us this opportunity. And Limbi, I understand you have another year to go for your exams, okay? So it's too early to wish you for the exams. But anyway, when you appear for the exams, all the best.
But she answered very well, sir.
Very well. You've done very well.
Very well, sir. Fantastic. Really, Limbi, congratulations.
Very good.
You almost answered almost all the questions, except barring one or two. Really, very good.
The take home here is you must remember that you always give answer for your patient, okay?
Yes, sir.
Your patient's body weight, okay? What monitors you would put. And, it should come in a sequence such that Dr. Gurudat and I will imagine that we are in the theater with you and doing the case. Thank you. Good day. Okay, bye.
Thank you, sir.
Thank you, Guru. Indrani is ready, I think, for the next presentation. Hi, Indrani. Okay, I'll mute myself and stop the video. Thank you.
Hi,
so we have come to the...
It was fantastic to listen to all of you.
Okay, so we have come to the last session for today. It will be a long case presentation on a patient with mitral stenosis posted for lap appendectomy. This session will be chaired by Dr. Indrani Hemant Kumar, Professor and HOD, KEM Hospital, Mumbai. She is also the President of Research Society of Anesthesia and Clinical Pharmacology, and by Dr. Mariam Koshi, Professor and HOD, Jubilee Mission Medical College. The students are Dr. Biona R. and Dr. Finija Francis, both PG students from Jubilee Mission Medical College. Over to the examiners.
Welcome, Finija and Biona. As you all know that mitral stenosis is a long case and invariably will be kept. So there is no two ways. One case of mitral stenosis is always there. So please start your case. Start your case presentation, please.
Today I am going to present a case on mitral stenosis for lap appendectomy. 32-year-old male patient came with complaints of pain abdomen.
I think your audio is not very good.
Audio is feeble.
32-year-old male patient came with complaints of pain abdomen, nausea 2 days, fever.
Finija, yes, are you wearing anything, what do you call your earbuds or anything like that?
No, madam.
You're not wearing any earbuds, right?
No, ma'am.
Okay, then I don't know why your audio is still not very good. Anyhow, be loud then.
Okay. History: a 32-year-old patient came with complaints of pain abdomen 2 days, nausea 2 days, fever for 1 day.
Binil, 1 minute, please wait. Who's the other student? Biona. Does Buna have this?
No, they're
Can
together.
Biona present this?
Otherwise, you can log in from some other devices.
Can Biona present the same thing?
Madam, let Finija continue. Meanwhile, Biona can come log in through other device, and she can take over. That will be better.
Okay, fine. Okay, continue.
History of present
illness. He is a non-case of valvular.
Now it is better. Yeah.
It is better.
Okay. All right. Yeah. Good. Better now. Yeah.
Valvular heart disease, and the patient was apparently normal 2 days back when he developed pain abdomen, which was acute in onset, continuous in nature. It was dull aching pain over the lower right side of the abdomen, radiating to the umbilicus, and it was associated with nausea. He also complains of fever for 1 day, which was continuous, high grade, associated with the chills and rigors, and it was relieved on taking paracetamol. No history of vomiting, constipation, bleeding via dysuria, hematuria. No history of abdominal distension, dyspepsia, mass per abdomen. No history of yellowish discoloration of eyes or urine. No history of rashes over the body and joint pain. Past history. The patient gives history of fever, joint pain, and swelling at 12 years of age, mainly in the elbow and the knee. Lasted for 2 weeks. It was medically managed. At the age of 25 years, he developed progressive dyspnea. First, the breathlessness was present on doing severe exertion, gradually progressed. Now he complains of breathlessness on doing ordinary activities. Evaluated and diagnosed to have some valvular heart disease, took medical
Can't hear anything now. Just can't hear anything.
She got disconnected. Let me check, madam. She got disconnected.
That's why I think the other girl should take over, Duna. Duna should take over, and her audio is like, she's getting a good audio, getting out of the good audio. The audio is also, there's some, problem with her equipment, whatever, laptop or whatever.
We are both presenting from the same place.
Oh, okay.
The same device.
All right. If they have two devices, let them go to two different rooms.
Sir, I think you can call her.
What happened, Bruna? What happened?
Yeah. Tanisha, you can unmute your. Tanisha, unmute. Tanisha, unmute and talk. Unmute and talk. We can see you. Please unmute.
Finija, go to the left-hand corner to the mute button and unmute that. Yeah.
Yeah.
Now talk loudly. See that whatever is there,
Yes, ma'am.
Yeah. Share the screen and you can start.
If you are not able to share the screen, it's okay. You can present without presentation.
Is it possible, sir?
Start. Please start. Start talking.
Yes, sir. Yes. No history of hoarseness of voice, no history of dysphagia, no history of bluish discoloration of fingers, toes, no history of weakness of limbs, deviation of angle of mouth. Treatment history. He is on tab penicillin 400 mg BD, tab metoprolol 50 mg OD. Family history, no history of similar illness in the family, no history of diabetes, hypertension, other significant illness in the family. Personal history, he is a non-alcoholic, non-smoker, takes a mixed diet, bowel and bladder habits normal, no history of drug allergies. Coming to examination, general examination, is conscious oriented, moderately built and nourished. Height is 168 centimeter, weight is 60 kg, BMI is 22.9, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. Vitals, pulse rate 62 per minute, regular in rhythm, normal volume and character, condition of vessel wall normal, no radial, no radiofemoral delay, all peripheral pulses palpable, normal. BP is 110 by 70 mm Hg, right upper arm, sitting position. Respiratory rate 20 per minute, regular, abdominothoracic, JVP not elevated, and he is afebrile. Airway examination, facial deformity, mouth opening more than 3 fingers, Mallampati class 2, thyromental distance 8 cm, neck extension normal, examination of ears, inspection, shape of precordium normal, apex deep visible, no other visible pulsation, no dilated veins or scars. Palpation, apex beat palpable at left fifth intercostal space, half-inch medial to mid-clavicular line, tapping in character, no thrill, no palpable P2, no left parasternal heave. Percussion, right heart border corresponds to right sternal margin, left heart border corresponds to apex beat. Auscultation, mitral area, S1 was loud, S2 heard normal, opening snap was present, a low pitched rough rumbling, mid diastolic murmur, grade 3/6 with pre-systolic accentuation, best heard in the left lateral position in full expiration with the bell of the stethoscope. Other areas S1, S2 heard normal. Examination of GIT, oral cavity normal, examination of abdomen, inspection, shape of the abdomen normal, umbilicus central and inverted, all regions move with respiration, no visible pulsation, peristalsis, dilated veins, scars, hernial orifices and genitalia normal. On palpation, no local rise of temperature, tenderness was present in the right iliac fossa, guarding was present in the right iliac fossa, and rebound tenderness was present. No other mass palpable, no hepatosplenomegaly. Percussion, liver dullness, upper border at right fifth intercostal space, no shifting dullness. Auscultation, normal bowel sound heard. Examination of the respiratory system, upper respiratory tract normal, examination of chest normal, examination of CNS, higher mental functions normal, cranial nerves normal, motor system examination normal, sensory system and reflexes are normal. Summary, 32-year-old male patient presented with complaints of pain, abdomen, nausea and fever for 2 days. He is a non-case of valvular heart disease, NYHA class 2, on treatment with beta blocker. Regular on examination, regular pulse, tapping apex beat, loud S1, opening snap, and mid-diastolic murmur with a pre-systolic accentuation at the apex. And on abdominal examination, tenderness, guarding, and rebound tenderness in the right iliac fossa. Now admitted for laparoscopic appendicectomy. Diagnosis, 32-year-old male patient, non-case of mitral stenosis, rheumatic in etiology, NYHA class 2 with acute abdomen, came for laparoscopic appendicectomy.
Okay, I went through all, so I've heard everything. But your case has absolutely no cardiac symptoms at all, right?
NYHA class 2, madam. He was having, he developed.
So do you want me to discuss lap appendicectomy or you want me to discuss mitral stenosis? Anyway, your case is, see, your patient didn't come out with any symptom. Okay, now what are the salient cardiac symptoms which this patient generally come for?
Patient,
supposing your case is NYHA grade 3, say. Okay.
Yes, ma'am.
So what will be the usual symptoms you will find in these cases?
NYHA classification consists of 4 elements: dyspnea, palpitation, angina, and syncope. So it is classified into 4 classes. NYHA class 1 is in a cardiac patient, there will be no symptoms. There is no limitation of physical activity and there will be no symptoms on doing ordinary activities. In NYHA class 2, in a cardiac patient, there will be mild limitation of physical activity and the patient will have symptoms on doing ordinary work. Then in NYHA 3, the patient will be having symptoms on doing less than ordinary activity, and there will be a moderate limitation of physical activity. And NYHA class 4, the patient complains of symptoms on at rest.
So what are the symptoms basically? Supposing the patient is NYHA grade 3. So yours, so what are the symptoms the patient can present to the hospital?
NYHA class 3 maybe in mitral stenosis, the patient may be having a PND with the pulmonary edema, PND or orthopnea with the pulmonary edema symptoms.
Just that? Only
Then,
only PND?
So
So patient will complain of dyspnea. Okay, dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Anything can happen. What else? What other symptoms patient can have?
Chest pain.
Why chest pain? Okay, now the patient is having dyspnea. Why dyspnea? Why orthopnea? Why PND?
It is breathlessness maybe due to PND or PND or orthopnea.
Why? See, supposing I run.
Yes, ma'am.
200 meters, 300 meters, and I start getting breathless, right? I get breathless, right?
Yes.
I don't have any heart disease, but I get breathless. Whereas a patient of mitral stenosis is getting breathless. Is there a difference between the two of us?
Yes, ma'am. In mitral stenosis, there is decreased left ventricular filling that can lead to decreased cardiac output, and also due to obstruction to the left ventricular filling flow, there will be increased left atrial pressure. This can cause left atrial enlargement, and also this pressure will be transmitted to the pulmonary circulation, thereby causing increase in pulmonary vascular pulmonary congestion and pulmonary hypertension.
All right. So what is the difference for me, for a normal person to get breathless? Why am I getting breathless?
It depends on the exercise tolerance, ma'am. These patients.
No, even if you run, you will get breathless, right? If you're running fast.
Yes, ma'am.
So is there a difference? So why is a normal person getting breathless while running?
Due to increase in myocardial oxygen demand, and due to reduced cardiac output in MS, and while exertion in exercise, we also will have increased oxygen demand. So to cope.
So that is compensated by increase in cardiac output. Also, yes, the rate and depth of respiration goes up, isn't it?
Yes.
So that is the difference. Okay. Now you said patient can also get chest pain. Why chest pain?
Chest pain and cause may be due to, one is due to the pulmonary congestion, that is pulmonary due to pulmonary hypertension, and also there will be the decreased cardiac output can cause severe left ventricular dysfunction that can lead to myocardial
chest pain. Very good. Any other symptom patient can have?
Hemoptysis due to pulmonary.
That you said already. Patient can have hemoptysis. Anything else?
History of syncope, decreased exercise tolerance, palpitations.
Palpitations. Why palpitations?
Palpitation may in the case of an MS, it may be due to development of AF, then also due to decreased cardiac output, the patient may be getting tachycardia. This can cause palpitations.
Okay, so also in your thing you have to say no history of syncope. That has to come in your history. Okay. So palpitations, no history of palpitations, no history of syncope. Okay. That has to be part of your history. Also, what else? You said exercise tolerance. No, low exercise tolerance, isn't it?
Yes.
Why low exercise tolerance?
Due to decreased cardiac output, ma'am.
So patient can be in failure, right?
Yes,
congestive cardiac failure. So if there is a low cardiac output, then also you can have easy fatigability in these patients, right? Okay, so you said as you, I'll tell you what you missed in this, in your presentation. You didn't talk about any hospitalization earlier. That has to come in your history, okay? And also no history of allergies, no history of coughs, you know, in your past history, jaundice, asthma, addiction, abuse, all these have to come because addiction and abuse can also cause valvular heart disease. All right. So all these have to be part of your history. In your vitals, you said no radiofemoral delay, no, what is that? Something like that you said. But what is more important is apex pulse deficit.
Yes, pulse
okay.
deficit.
So apex pulse deficit is more important. And in your general examination, what you should generally say is, in these cases, you will always take a arterial line, right?
Yes,
so
yes,
you have to talk about Allen's test.
Okay. Yes, ma'am.
Right? So I think somebody is putting on the chat about JVP. She spoke about JVP. She also spoke about, yes, and you didn't speak about embolic. I think you did say about embolic episodes. You did say that, yeah. You have to talk about Allen's test. So what is Allen's test?
To know the patency of the radial artery. In this, we will ask the
patient. Is it patency? Is it patency?
Collateral.
Yes, collaterals. So you have, yeah, ulnar collaterals, right? So how do you do it?
Ask the patient to clench the fist for 30 seconds and occlude both the ulnar and radial artery, and ask the patient to open the hand, then and watch for.
You have to even raise your hands.
Raise your hands and remove the ulnar occlusion, and then look for the
Also, after occluding the ulnar artery and radial artery, I will keep the hand higher up. Then then I will ask the patient to unclench the hand. If there is any blanching, then it is okay. And then I will slowly remove the obstruction of the ulnar artery. Then there should be refilling of the blood vessels within 5 to 15 seconds. In that case, the collaterals are filled.
Usually 3 to 7 seconds it takes. Okay. It can easily fill. Okay. So anything beyond 7, you have to start. You have to do the other side, other test also. I mean, you have to occlude the ulnar and remove the radial. You should do both.
Both, yes, ma'am.
Yeah, you should do both. Anything beyond 7 seconds, you have to do that. Okay. All right. And also, you said about apex on inspection. Apex pulse is visible, but you also have to say where is it visible.
Yes, ma'am. So in the fifth intercostal.
Yeah, so you have to say that, okay? And in your auscultation, you spoke about the murmur, but you did not speak about whether it is radiating anywhere, whether it increases with exercise and decreases with rest. This also has to be part of your presentation when you're talking about auscultation. So these are just few deficiencies which I found, otherwise perfect presentation. All right. So just take care of these things. Now coming to your presentation, your patient of course had only a NYHA grade 2. I'm not going to discuss NYHA grade 2 in this patient. I am saying that this patient is NYHA grade 3. All right. Patient is NYHA grade 3. Okay. So this patient has palpable P2. Patient has JVP raised. Patient is having a parasternal heave. All right. So patient is having everything. So when I'm saying palpable P2, parasternal heave, What am I suggesting?
Patient is having pulmonary artery hypertension
and right ventricular heart failure.
Yes, which means the patient is having pulmonary artery hypertension. Right? So also you spoke about, you said about the first heart sound being loud. Why is the first heart sound loud?
In MS, there is increased pressure gradient between the mitral transvalvular area, which causes the opening of the leaflet to open wide, and the during closure of the mitral valve, it is closed from a higher greater distance. It causes loud
See what you should use. You're right. You're actually right. But scientifically, how you have to talk about this, the first heart sound is loud because of the rapidity with which the right ventricle pressure rises at the time of the mitral valve closure. Okay, so because of the LA pressure is already high, the LV will take more time to accelerate, and the leaflets are still floating away, right? Otherwise, what happens in a normal person? It starts semi-closing, isn't it? Whereas because the LA pressure is already high, the LV can take a
wide open
longer time, right? So the leaflets are still floating. What do you call? It is floating away from the closure. So what happens? Therefore, at the time of contraction, what happens? Because of the transmitral gradient, the valve is still pliable. So then it snaps. So it snaps closure. Okay. So it closes very fast. So it is akin to if you're staying away from the door and you have to close the door like this. What happens? It will bang close, right? Whereas if you're staying very close to the door, you can simply close it like that, isn't it? So it is akin to that. So what does it tell you? When you say that the first heart sound is loud, it also gives you some more information. What information does it give you?
Increased left atrial pressure.
And
it means it gives you information that the valve is still pliable. Okay, there is no calcification. Okay, so so all these are, and probably a good patient for mitral valvuloplasty, probably. Also about opening snap, what is the cause of, what is the
opening snap?
The reason you get the opening snap?
Usually the opening of the mitral or tricuspid valve does not make any sound, but due to increased pressure gradient, also the opening increased flow, the opening of the mitral valve produces a sound that is known as opening snap.
So no, you have to, because you're right, because of the transvalvular gradient, what happens is the subvalvular apparatus is suddenly it's tensing of the leaflet. Okay, because of the tensing of the leaflet and the subvalvular apparatus. So which comes to the next question. You're talking about the leaflet and the subvalvular apparatus. In mitral stenosis, what exactly is the organic problem? How is the mitral valve apparatus affected? I'm talking about mitral valve apparatus, which means everything about the mitral valve.
Mitral valve apparatus comprises of the mitral valve annulus, leaflets with the commissures. Then we have the chordae tendineae and the papillary muscles underlying left ventricle.
They are all the subvalvular apparatus, right? So what happens to the annulus, leaflets?
There will be leaflets, the thickening of the leaflets. First there will be thickening, then commissural fusion will be present, then shortening of the salvular area, the chordae tendineae and papillary muscles, and also the annular fusion will be also fibrosis will cause fish mouth appearance of the mitral stenosis.
So how will you grade mitral stenosis?
Grading, it's mainly on the mitral valve area, then the mild, moderate, and severe. It is classified into mild, moderate, and severe. Depending on the valve area, if it is more than 1.5 centimeters square, mild. Moderate, it is 1 to 1.5 centimeter square. And if it is severe, it is less than 1 centimeter square.
Okay. And what about pulmonary hypertension grading?
Then other criteria includes pressure gradient, mean pressure gradient, pulmonary artery hypertension. The pressure gradient will be in mild mitral stenosis, it will be less than 5 millimeter of mercury, and in moderate 5 to 10, and severe it is more than 10. Pulmonary artery pressure will be in mild, it is less than 30, and moderate 30 to 50, and in severe more than 50.
Correct. Very good. So you said the patient had rheumatic fever in the past at the age of 12, right? So what are the Jones criteria?
Jones criteria include, it is to diagnose the rheumatic fever. It include 5 major and minor criteria. 5 major criteria includes polyarthritis, carditis, Sydenham-sporia, erythema marginatum, and subcutaneous nodule. And in minor criteria, fever more than 38.5 degrees Celsius, then polyarthralgia, then in ECG, prolonged PR interval, and in laboratory investigations, the ESR will be high and CRP will be high. To diagnose rheumatic fever, either present
So what are the features of subacute? Okay, I got it. What are the features of subacute bacterial endocarditis?
In subacute, bacterial endocarditis occurs in a already deformed valve affected by a low virulence organism. The patient will be having fever. Then with the blood cultures will be positive for with the virulent organisms. That is a major criteria. Then major criteria includes blood culture, 2 blood cultures, and minor criteria there will be fever, then immunological signs like Osler's node, road spots, then vascular lesions like
hemorrhage, sphincter hemorrhages, then Janeway lesions, then microbiological evidence of endocarditis.
One culture
Okay. And thromboembolic episodes are much common with subacute bacterial endocarditis. So you said about the rheumatic fever, right? So why should the heart get affected in rheumatic fever?
The rheumatic fever is usually caused by group A beta hemolytic streptococci.
No, but why the heart is affected? I just want to know why the heart should be affected, right?
So, the antibodies react to the self-antigens in the heart tissue. So that's why.
Very correct. It's an autoimmune response, and it is triggered by the molecular memory which is in the heart, right? So it connects. So it So it affects the connective tissue, and then in the heart. So that's why it causes carditis, and arthritis, and things like that. So all these are because of the molecular mimicry which is there. Okay. So come to the, I think part of the pathophysiology you already said, right? So if you see the natural history of progression of mitral stenosis, what happens to the pathophysiology? What is the natural pathophysiology in mitral stenosis?
Normal mitral valve area is 4 to 6 centimeters square. In mitral stenosis, there will be narrowing of the mitral area. This causes mechanical obstruction of the blood flow to the left ventricle, which in turn causes decrease in stroke volume and decrease in cardiac output. Due to decrease in left ventricular filling, there will be developing of a transvalvular pressure gradient. This pressure gradient increases the left atrial pressure, which will passively transmit to the pulmonary venous vasculature, and it causes...
No, because of the mechanical obstruction itself. So what happens? So there will be a back pressure, right?
Yes, increase in LA pressure, increase in pulmonary venous pressure, which in turn lead to pulmonary artery pressure increase, causing pulmonary artery hypertension, which causes right ventricular hypertrophy, right ventricular failure, or tricuspid regurgitation. Also, due to increase in the left atrial pressure, there will be dilatation of LA, left atrium, which in turn lead to thromboembolic episodes and atrial fibrillation. Also due to pulmonary venous congestion, when the pressure increases above the oncotic pressure, there will be interstitial edema, which will causes increase in work of breathing, decrease in the compliance of the lung, causing dyspnea, PND, etc.
Very good, very good. So what happens
No
initially?
No problem on the left side. What about the left side? This is all back pressure.
Yes, ma'am. Forward flow is decreased in, so it causes a decrease in the stroke volume and decrease in the cardiac output.
Very well. So basically, initially what happens with the stenosis of the valve? What happens is initially the LA starts dilating to accommodate the pressure. That's how the LA starts dilating, right? So beyond that, what happens? There is disorganization of the atrial muscle, the bundle, and all that. And then the back pressure, then the pulmonary artery venous hypertension, then eventually pulmonary artery hypertension, then there can be tricuspid regurgitation. All these can happen, and because of the disorganization of the atrial muscle and the bundle, your patient can get atrial fibrillation. Isn't it? Okay. So what is the generally what is the medical treatment? Say, let's say your patient has got atrial fibrillation also. Okay. So what will be the medical treatment in this case?
If the patient is having atrial fibrillation, then I have
No, with atrial fibrillation. NYHA grade 3 with atrial fibrillation.
Okay, madam.
So that comes to your diagnosis. See, when you gave the diagnosis, okay, you have to give a full diagnosis. So you only said that the patient is having pain abdomen and or what do you call? You said pain abdomen, a case of mitral stenosis, the grade NYHA grade 2. That's all you said, and rheumatic, probably of rheumatic origin. That's what you said, right?
Yes,
isn't it? So here you have to say whether the patient had atrial fibrillation or whether the patient is having normal sinus rhythm, whether the patient is in congestive cardiac failure or not in failure. Okay, all these have to come in your diagnosis. Okay, so something also which you missed. So in your diagnosis, B and NYHA grading that you said. So all these have to come in your diagnosis. Okay. So your medical treatment, you said what all? You said the patient will have beta blockers. What else you said?
The patient will be on beta blockers, calcium channel blockers, and if the patient is in failure, then diuretics will be given, and then digoxin can also be given for rate control. And for
beta blocker or calcium blocker or digoxin, it's not all three. Okay, then
in AF, the patient will be also given anticoagulation. Oral vitamin K antagonist will be given.
In AF, what anticoagulation is given? What anticoagulation?
Vitamin K antagonist, warfarin.
Okay. All right.
Then I am making a therapeutic index of INR 2 to 3.
Correct.
What are the other drugs you will give? Anything else you will give? What is the medical management of mitral stenosis? This is what madam wants to know.
In atrial fibrillation, we have to...
no, not just atrial fibrillation. If a patient is coming to you, what are the other drugs you will give?
In mitral stenosis, our medical management should be aimed to the anti-cardiac failure measures like beta blockers, calcium channel blockers, diuretics with or without digoxin. Then in we have to maintain either maintain a normal sinus rhythm or to reduce the rate with the beta blockers or calcium channel blockers, and we have to give anticoagulation. Usually we use vitamin K antagonist warfarin.
And
then secondary profile of rheumatic fever happens.
And then for infective endocarditis.
If the patient is positive for surgery, we have to give infective endocarditis prophylaxis.
Your patient is
so all of them get
no. What are the
infective
guidelines?
endocarditis prophylaxis? What are the latest guidelines?
For infective endocarditis prophylaxis is given in patients with prosthetic heart valves, cyanotic congenital heart disease, or repaired congenital heart disease with residual lesion, cardiac transplant patient, or any previous history of infective endocarditis.
And patient is having periodontal disease. The rest of them do not get infective endocarditis prophylaxis. Remember that. Okay. And the thing is about, see, what are the ones, for example, your patient is having some infection. So presence of infection, anemia, you have to treat anemia in these patients. If the patient is hypothyroid, you have to treat hypo or hyperthyroidism. Okay, all these pregnancy can, see, all these are things which can precipitate and push the patient one level above, one class above, right? So you have to be prepared about all this. So in your preoperative preparation, preoperative optimization, what all you will look for?
Preoperatively, we have to take care.
Patient is coming for lap appendicectomy, right? So
Yes,
how will you do your preoperative evaluation?
With a detailed history and examination, which will in which we have to look for the severity of the mitral stenosis, any complications associated, any other comorbidities. We have to look for the treatment history, what the medications the patient's on. If the patient on beta blockers, or calcium channel blockers or decoxin, we have to we will ask the patient to continue the drugs. And if the patient is on diuretics, and there will be if we are expecting a major fluid shift,
will you do a cardiology referral to this patient? You said everything. Will you do a cardiology referral to this patient?
I will ask for investigations, routine blood.
What all investigation you will ask for?
Complete blood count, including HP, to rule out anemia, and the total count to rule out any infections, and platelet count as a baseline, then RFT as a baseline, then serum electrolytes. If the patient on diuretics or digoxin, we have to know about the electrolytes. Then we have to do an ECG, chest X-ray, and then
what do you find in the ECG?
ECG, first we will look for the rate in the ECG, and the patient also, if the patient is in the sinus rhythm or the patient is in AF, then in mitral stenosis there will be P mitral, that is wide notched P wave in the lead 2, and biphasic P wave in the B1. Then also if the patient is having pulmonary arterial hypertension, P pulmonale can be seen. And if there is also right ventricular hypertrophy, that is predominance of R wave, right axis deviation. These are the changes we see in
RV1 and V1, right? Okay. So you said about X-ray. What are the findings on an X-ray?
X-ray,
there will be decreased cardiothoracic ratio. And then normal or increased cardiothoracic ratio. So then the left heart border will be straightening due to the left atrial enlargement. Then the prominence of the pulmonary conus, and also due to the shortening of aortic knuckle. Then the patient will have
and right ventricular hypertrophy.
Right ventricular hypertrophy. Then double density sign due to left ventricular left atrial enlargement. Then if the patient is having pulmonary hypertension, the patient will be having annular sign, that is the prominence of the upper lobe veins. Then there will be a lower lobe collapse, and calcification of the mitral valve will be seen.
Curly B lines and curly. Right. What other investigation you will ask for?
Echocardiography, ma'am.
What do you find in the echo?
Okay. In it, 2D echo, I can find. I would like to know the mitral valve morphology, like thickening, and if there is any LA thrombus or clot, then left atrial enlargement dilatation.
Finding out the clot, which is better, 2D echo or which examination is better?
Trans
T.
is
T is ideal for finding out the clots. You may not get a good window, right? So what you will find in 2D echo?
For planimetry, assessing the mitral valve area, to assess the in M mode, we can assess the pressure gradient. Then the mobility of the mitral valve, is the mitral valve pliable or not. Then pulmonary artery hypertension, assessing the other valvular abnormalities, ventricular dysfunctions, regional valve motion, and ejection fraction.
Doming of the leaflets. You'll find
doming
the anterior leaflet is like a hockey stick.
Hockey stick
Appearance of the anterior leaflet. And there will be doming of the leaflet. And in Doppler, what will you find?
Increasing the pressure gradient.
Pressure gradient and pulmonary artery hypertension. All these. What is pressure half time? You've heard of pressure half time?
It's grading.
It's for grading mitral stenosis, right? So what is it? It is the time taken for the diastolic pressure between LA and LV to decrease to half the initial value.
Yes, ma'am.
Okay, so based on the pressure half time, you can grade the mitral stenosis as mild, moderate, or severe. Okay, so you will do a 2D echo, and if you find that the patient is having atrial fibrillation, you will also do a TEE in this patient, right? And so, what are the guidelines for non-cardiac surgery? In your case, it is a non-cardiac surgery. What are the guidelines, and what are the predictors of poor outcome? Right?
Yes, ma'am.
So there are certain guidelines for non-cardiac surgery, right?
If the
okay, now one more thing. Supposing the patient is having a pliable valve. I forgot to tell you. So what score is done for this patient to know whether the patient is fit for Wilkins score? So Wilkins score will be based on what?
4 parameters: wall thickening, leaflet thickening, leaflet calcification, leaflet mobility, and subvalvular thickening.
Right. So if the score has to be less than 8.
Less than 9, 8 or 9.
Okay, no problem. So as I told you now, the patient has come for lap appendicectomy. So what are the guidelines for non-cardiac surgery? So what are the predictors of poor outcome?
Poor outcome it depends upon the severity of the mitral stenosis. Severity can be we can know from the history itself, NYHA grading. Then in the examination also, then by evaluating the patient with a 2D echo, we can know about the severity of the disease. If it is mild mitral stenosis, we can proceed with the surgery with the hemodynamic monitoring. Then if it is
one is functional, right? You have to look at the functional status of the patient, isn't it? That is number one. Number two, you have to identify whether the surgery is intermediate
or elective surgery,
elective or emergency, and also whether the surgery is intermediate risk or mild risk or severe risk, isn't it? So any non-cardiac surgery, remember these two are very, very important. One is to know the functionality of the patient. So that will you will be able to tell you by looking at the history, physical examination, and whether the patient is having any dyspnea. Like your patient is superb, no problem at all. Pulmonary artery hypertension is not there. Patient is having no cardiac symptoms. Patient is not having any dyspnea, no chest pain, nothing at all, right? But then I'm talking about a patient who's having dyspnea, a patient is having atrial fibrillation, patient is having chest pain, patient is having palpitations. Okay, so one is you have to look into the functionality, how much the patient can
function.
So you have to see what is the functionality of the patient. You will be doing a breath holding time on the patient. You will be asking the patient to walk and see how much the patient can walk. All right. And secondly, you will look into the risk. Risk is surgical risk. Now your patient is lap appendicectomy. What risk is this? What is the risk?
Intermediate risk.
Yes. Presence of any abdominal surgery or thoracic surgery is all intermediate risk. Okay. All right. So then what else?
If the
in the preoperative period itself, I said you should say that the patient should take proper consent, right? Whether the patient can be put on ventilator, so that consent has to be taken, right? So what else? What other what other risk? Presence of any other comorbidities will add to the risk.
Yes, ma'am.
Isn't it? So you have to see, and presence of RV dysfunction add to the risk, right?
Yes.
So, so now your patient is posted for lap appendicectomy, okay? And the patient, as I said, is NYHA grade 3, all right? And patient is on anticoagulants. Now, how are you going to manage this case once your patient is posted elective for surgery?
Elective, then I will continue the rate control drugs like beta blockers, calcium channel blockers. If the patient is on diuretic, I will withhold the previous night dose and also assess the electrolytes. Then if the patient, as the patient is on anticoagulant, if the patient is on warfarin, then I will ask the patient to withhold the dose for from 5 days before prior to surgery. Then I will bridge him with the injection heparin or a low unfractionated heparin or a low molecular weight heparin. Therapeutic dose for low molecular heparin, 40 milligram BD dose. Then on the day of prior to the surgery, 6 hours prior to surgery, if the patient is on unfractionated heparin, I will withhold the dose. And if the patient is on low molecular weight heparin, 12 hours prior to
it's an emergency surgery, no? Emergency. It's an appendectomy.
I just said, ma'am, it's an elective surgery.
Okay.
So if it is an elective surgery, how are you going to? Okay. Right. You said it correctly. And if it is an emergency surgery, as madam said, how will you go about? Patient is on warfarin. So what will you do?
We will give injection vitamin K and
how much? 10
mg, 10 mg
yes.
Dose with prior to surgery, and we will arrange fresh frozen plasma. Or prothrombin complex concentrated available.
Correct.
Then we can give them.
How much of FFP will you
give? Depending upon the INR.
So coming to INR, how much of INR will you maintain?
Ma'am, for surgeries, we will prefer to have less than 1.5.
About 1.5, not less than 1.5. 1.5, right? So you'll maintain an INR up to 1.5. So you will give generally around 115 ml per kilogram of fresh frozen plasma. But again, it has to be titrated to the INR of the patient. It's not standard, right? You have to titrate to the INR of the patient. Okay. So now what monitoring you will do for this patient? So you've taken the patient inside.
Yes,
okay.
ma'am.
Now what monitors you will attach?
After checking the machine monitor and suction is ready, and arrange the airway equipments, and after keeping the emergency drugs and medications, I also defibrillator in the theater. I will attach pre-induction monitors, ECG, non-invasive BP, pulse oximetry, and I would like to insert an arterial cannula under local anesthesia to the radiolateral. And after post-induction, I would like to do ET CO2 monitoring, temperature monitoring, and urine output monitoring.
Will you put in the central line?
Ma'am, as it is a appendicectomy, we won't be have.
This is grade 3.
Yes, ma'am.
You have to put in a central line in grade 3, right? Grade 1 and 2, if you avoid all this, it's fine. But in grade 3, you have to step up your monitoring.
Yes, ma'am.
All right. Okay. So you have your monitors, and now you have to induce the case. So
Yes,
what are the principles of management of general anesthesia in these cases?
What are your goals?
My hemodynamic goals will be to maintain the normal sinus rhythm or to avoid any tachycardia and avoid any tachycardia. Also maintain the preload with the judicious fluid administration, maintain the afterload, and also any increase in the PVR should be avoided.
Right. All right. So you said that. So first, for one, you said, will you use pre-medication? What pre-medication you will give?
Benzodiazepine, midazolam 1 mg IV should be given to the patient. Under monitoring, we should give because it can cause hypoxia, hypercarpia.
Anticholinergic?
Ma'am, we will avoid that.
Pre-medication will you give?
No, ma'am. No, ma'am. Because it can cause tachycardia, so we can avoid anticholinergic in this patient.
So pre-oxygenation is a must in all these patients.
Yes, ma'am.
How will you induce the case?
After pre-oxygenating for 3 minutes with 100% oxygen, I will prefer to give, as the patient is 60 kg, I will give injection fentanyl 2 mics per kg dose of 120 mics IV. Then I will induce the patient with the injection etomidate 0.2 mg per kg, that is 12 mg in this patient. And after confirming a back ventilation.
Why etomidate?
As it
Why
is a
etomidate?
Etomidate is cardio stable. It won't cause any increase in heart rate or any decrease in hypotension or decrease in contractility of the heart. So I will prefer.
What about propofol? Will you use propofol?
No, ma'am. Propofol can cause hypotension, and so it will be usually avoided in this grade and grade A. And
so hypotension because of sudden fall in SVR. Here you do not want any fall in SVR because it's a fixed output state and it cannot compensate. Same reason why we cannot do an inhalational induction in these patients. So most of the inhalational agents can cause a sudden fall in SVR, isn't it? So, okay, now you say that then what happens? Then how do you give your induction drugs in these patients?
Slow and diluted doses of induction is preferable in mitral stenosis as the cardiac. It is a low fixed cardiac output, so peripheral circulation will be sluggish. So arm to brain circulation time will be prolonged. So I will prefer to give a slow induction in those patients.
Okay. So how will you give fluids in these patients?
Judicious administration of fluids are necessary because it can cause increase. If the patient going to increase in preload, can cause pulmonary edema intraoperatively and decompensation. So I will give maintenance dose of fluids.
So even for lap appendicectomy, you have to give judiciously. Very good. But still the preload has to be adequate.
Adequate, yes.
Okay. Because you're giving lap appendicectomy. Because it is a lap appendicectomy, your preload also has to be adequate. That's why I said CVP monitoring is very, very important in these patients. And you always have to maintain a high normal SVR. So that can be done by giving extra opioids, right? So if you maintain a high opiate anesthesia, you can always maintain the SVR, isn't it? So maintain, you use a high opiate anesthesia, okay? So, okay. Then what other things you will avoid? I said the patient is having NYHA grade 3 with pulmonary hypertension. What all you will avoid?
During maintenance, I will prefer to use oxygen with the air mixture and inhalational agent. I will avoid nitrous oxide in this patient because it can increase the pulmonary vascular resistance and increase in the pulmonary arterial hypertension. So I would like to avoid nitrous oxide.
Then,
yes, you will avoid nitrous oxide. You will
I will
avoid
avoid I will avoid
hypoxia. You will avoid hypercarbia. You will avoid acidosis. Right? So all these can kick up the pulmonary hypertension. So all these, and you also have to avoid hypothermia. Right? Okay. So what about neuraxial block? Supposing the patient is not for lap appendicectomy, open appendicectomy. Will you give neuraxial block in this patient?
Since the patient is in severe MS like NYC 3, I would like to go with general anesthesia so that hemodynamically patient can be stable. If I neuraxial, there will be a sympathetic blockade. This can lead to massive hemodynamic instability. Which will
what about epidural? Epidural combined spinal epidural.
I would like to avoid spinal in this patient, and if the epidural is preferable, I would go with graded epidural.
Your patient is NYHA grade 2. Will you give spinal or epidural?
Ma'am, preferably graded epidural will be, because
you can give a narcotic in the intrathecal space and you can grade up the epidural in your case. Yes, you can do it. Okay, and avoid epinephrine containing local anesthetic agents. These are very important when you're using regional anesthesia in these patients, right? And at any point of time, you have to avoid hypotension and hypothermia.
How will you treat hypotension?
You have to treat them aggressively. Remember that.
What is the drug you give to treat hypotension?
Phenylephrine is preferred because it doesn't cause any tachycardia. So phenylephrine is used.
All right. Now your patient is for MVR. Patient is coming for for open heart surgery. Okay. Now you have induced the case. The patient is coming off bypass now. All right.
Yes.
But the patient, there is the blood pressure is just not picking up. Okay. And the pulmonary artery pressures are very high. That's a tense pulmonary artery. So what do you do now?
Venodilators, Milrin, phosphodiesterase inhibitor, Milrinol can be given.
Yes, you can. Initially, you can give NTG to see whether it is coming down. Otherwise, you can give milrinone or you can give levosimendan. You can give that. Okay, with that, the pulmonary artery pressure will try to come down. But still, the LV is failing. Why the LV is failing in these patients? Once the blood is being returned back to the heart, the LV is not able to take it up.
Mitral recut?
No. See, the LV has been sleeping all the while. Right?
Due to cardiac.
No, the LV, the LV is sleeping all the while. Okay. And myocarditis affects the entire heart. It doesn't affect only one part of the heart, right? Isn't it? So it is a chronic LV dysfunction, which is there, right? And the LV has been sleeping. It has never taken a load. Suddenly you want to give so much of load to the LV. LV is unable to bear that much of load. So it starts failing. So what do you do in that time?
Can dobutamine for increasing the force of contractility?
Epinephrine is the drug of choice. Okay? Epinephrine is the drug of choice. So you have 0.05 microgram per kilogram per minute. You can give. Okay? And the problem in these cases is de-airing. You have to be very, very careful about de-airing in these patients because the LA is huge. Okay, LA is huge, and there could be persistence of atrial fibrillation while coming off bypass also. Remember that. So you have to treat properly with beta blockers if needed. Okay. And anything else? Ma'am, Koshi madam, should we talk about BMV or do we talk about pregnancy? No needed. Not needed.
Pregnancy maybe, because that's important. Pregnancy. Right?
All right. Your patient is pregnant and has come for an emergency cesarean section. Patient is breathless. Okay.
Yes.
So what mitral valve area is 0.9, pulmonary artery hypertension is 70, 65, 70. Okay. And the patient has come for cesarean delivery. What will be your choice of anesthesia?
My plan of anesthesia will
So
be,
I take for granted that you are going to step up your monitoring. So I'm not going to ask you about anything about that. Just give me the choice of anesthesia and why. Yeah.
I would prefer, I'm going for general anesthesia with controlled mechanical ventilation with ethnodecal tube, probably with post-op. I will advise for post-op ventilation also in this patient. Why I'm taking general anesthesia is since in immediate postpartum, the cardiac output, there is a cardiac output can increase for around 80%. So sudden decompensation can occur. So it will be
why it will increase?
Due to auto transfusion of the blood from the the third stage of the so chances of decompensation and chances of heart failure, pulmonary edema is more. So we will manage in GA accordingly. If we are giving a spinal or epidural, there will be sympathetic blockade. So it will be difficult to manage the patient with severe.
So how will you manage that auto transfusion?
Auto transfusion.
Patient goes into pulmonary edema now.
Yes, ma'am. Patient, we will give 100% oxygen. We will give diuretics IV furosemide 40 mg. Then positive pressure ventilation with a PEEP. Then morphine injection IV morphine will be given because it dislodges the blood from the pulmonary circulation to the systemic circulation. Then
very right. So pregnancy is known to aggravate mitral stenosis, right?
Yes, ma'am.
Right. So what are the physiology in pregnancy which actually aggravates mitral stenosis?
And cardiovascular changes in pregnancy include increase in the blood volume around 30 to 40%, increase in the cardiac output around 40%, and decrease in the SVR.
Increase in SVR or decrease in SVR?
Decrease.
Decrease in SVR. So pregnancy causes a decrease in SVR, right? Right.
Then also pregnancy is a procoagulant state, chances of thromboembolism is also high.
Yes, very nice. Very, very well done. Plus the supposing the patient is coming for labor, the sympathetic stimulation during labor and delivery can aggravate the symptoms. So the patient will need labor analgesia.
Yes.
Right? Labor analgesia will actually really help the patient, isn't it?
Yes,
very well done. Very well done. Ma'am, you want to ask anything else?
Thank you. It was nice.
So if the patient is, say, NYHA grade 2, would you want to give general anesthesia?
Ma'am, it's the pregnant patient, ma'am?
Coming for cesarean.
For cesarean delivery.
If it is an elective
patient is able to lie down. Patient is able to lie down comfortably. You want to give general anesthesia or you want to give regional?
Is it an emergency anesthesia?
No, elective.
Elective. I would prefer to give a graded epidural in this patient. GA should be avoided.
Graded epidural will be.
It's not. I
prefer
is graded
epidural. It is not should be avoided, but it is safer to give graded epidural analgesia because of what? Why graded epidural is better?
Graded epidural, we can go up to post-op analgesia also. So post-operatively, we will decrease.
Is that the reason? Is that what we are looking at? Why graded epidural is better?
Decreased sympathetic block.
It is a slow sympathetic block.
So the patient can cooperate well with.
Also, you can control the block, control the segments.
Yes, ma'am.
It's a gradual blockade, right? You can control the segments, right? You can also give CSE by giving a narcotic in the intrathecal area, and you can give a graded epidural. Also, you can give, isn't it?
Yes, ma'am.
Very nice. Thank you so much.
Thank you, ma'am.
Girls, you did very well.
Thank you, ma'am.
And all the best for your exam. And I'm sure both of you all will come back with flying colors. I'm sure you will do that. Very, very well done.
Thank you.
Very well done. Yeah. Just those whatever little things which I told you, small things, that will just add up to your already distinction marks. Okay.
Okay.
Okay. Yeah. Thank you so much. Thanks.
Now they can hope that you will be their examiner. That will be good. Thank you, madam. It was a pleasure.
My pleasure too, ma'am, Koshi ma'am. And I wish to thank ISA Kerala, Binil, Jitin, Dr. Venkatagiri. Thank you so much. Thank you very much for this opportunity. It's my pleasure. So I'll come back next week. No, I'm not done fully. I'm going to come back next week. Yeah, sir. Nazar, sir. Thank you so much for the opportunity.
That was a well conducted exam.
Thank you, sir.
So,
thank you very much.
Okay, thank you all. Binil?
Yeah, this is the last part. We have to wind up today's session. So, Jitin will give his final conclusion.
So we have come to an end of today's excellent academic feast.
Binil. Dr. Giri, please.
Yeah, before that, see if there is any comment from other there, Kameshwara, the senior professors are there. From there, we will, because we have done this for the first time in time, because started in time, every session went on very much in time. We are scared whether it will prolong, but wonderfully it went in time. And
yeah, not
wonderful speakers.